Hello dear students, so I am Dr. Mani Soni here with you for today's live discussion of CBoT. I hope all of you gave this test and let us discuss all the dermatology questions. So the first question here is that which of the following statement about the condition in the image is false? So they are asking about the false statement and here is that image. Now what you can see in this image? So I always tell my student that whenever there is one image based question, you should always look at the obvious things first. So the first obvious thing here is the site is axilla. And what you can see over axilla? Swellings. That is nodules. Okay, so swellings or nodules are present. So these nodules are present over axilla. And do you know any condition where you find this? Yes, you are correct. It is seen in hidradenitis suppurativa. So this is a condition where patient presents with nodules, swellings with interconnecting sinuses where over axilla. Now remember that there are three stages of this condition. In the first stage you will get these nodules or swellings. In the second stage, you will get interconnecting sinuses. And in the third stage, you will get scarring. So, as you all know that sinuses and scarring cannot be treated with medicine. Okay, so here we give surgical treatment. But in the initial stages when there is nodules and swellings, we give medical treatment. Okay, and this medical treatment can be given in the form of doxycycline or isotretinoin, or it can be given in the form of newer drugs like adalimumab. Okay, so let us read these questions, these options. So affects axilla. This is the most common site, though it can involve groin and inframammary area as well. So this is the true statement. Index lesion include dermal and subcutaneous nodules. As I told you, nodules are seen and they are very clearly visible in the image also. The two main associated factors are obesity and smoking. Yes, they have role in this condition, and this condition cannot be treated with surgery. This is the wrong statement because initially we give medical treatment, but in the later stages when sinuses and scarring develops, then we need to give surgery. So the answer here is D. Okay. So I hope you know this condition. This is hidradenitis suppurativa, and here in later stages we do surgery. So that's why the correct answer here is D, which is the false statement. Now coming to the next question, here this is the match the following type of question, and here they have asked about the micro abscesses. The micro abscesses. See, micro means very small and abscesses are small collections of cells. So these small collections of cells are seen in various conditions, like in psoriasis. All of you might be knowing that Monro's micro abscess is seen. So in option D, one is seen. So now we can very easily exclude these two options because D is seen in 1. I hope all of you know this, isn't it? So psoriasis, Monro's microabscess. Then mycosis fungoides, Poutrier's microabscess is seen. So C is 2. Okay. Then dermatitis herpetiformis, papillary tip microabscess are seen. These are small collections of neutrophils which are seen at the tip of the dermal papilla. So B is 3. So obviously answer is A. And pemphigus vegetans, here you will get small collections of eosinophils. So eosinophilic microabscesses are seen in pemphigus vegetans. This pemphigus vegetans is the rarest type of pemphigus, and there is a very simple mnemonic also to remember that M is seen in P and P is seen in M. So Monro's is seen in psoriasis, while Poutrier's is seen in mycosis fungoides. So I hope you answered this question correctly. So answer is A. Moving to the next question. Here they are saying that which of the following condition would you diagnose using direct immunofluorescence microscopy on a patient? And these are the 4 options. Now, do you know what is direct immunofluorescent microscopy? That is DIF. So in direct immunofluorescence, what we do, we look for immunoreactants like antibodies, okay? Now, if you want to see these antibodies under fluorescent microscope, you should have these antibodies in the specimen, isn't it? So antibodies are generally seen in autoimmune conditions, that is those conditions where antibodies are formed. So simply they are asking that among these 4 conditions where antibodies are formed. Okay, so let us discuss these conditions. The first one is granuloma annulare. Now here, as it is very obvious from the name itself, annular lesions are seen, and this is very common in diabetic patients, and generally over dorsum of the hand or any part of the skin can start developing this annular lesion, commonly seen in diabetic patients. Lichen nitidus is a condition where small pinhead sized papules start developing. This can also develop over arm and dorsum of the hand. Mycosis fungoides is a cutaneous T cell lymphoma, but if we talk about this condition, that is epidermolysis bullosa acquisita. See, there are 2 variants. One is congenita. The epidermolysis bullosa congenita is a congenital condition. It is a genetic condition. But acquisita is autoimmune condition. Here antibodies are formed, and these antibodies are formed against NC domain, that is non-collagenous domain of collagen 7. Okay. Yes, so Rakesh Dadarwal is giving the correct answer. The correct answer is C. So correct answer is C, epidermolysis bullosa acquisita. So acquisita is the correct answer. Why? Because here antibodies are seen, and these antibodies are formed against the NC domain of the collagen 7. And when we do DIF, the DIF finding comes out positive, because under this microscope you can see the fluorescent antibodies which are formed in this condition. But instead of acquisita, if congenita is given, then the DIF is negative. So this is one important test to differentiate epidermolysis bullosa congenita, which is a genetic condition, from acquisita, which is an autoimmune condition where antibodies are formed. So answer here is epidermolysis bullosa. So Rakesh Chaudhary have changed the answer to 4. So no, 4th is not the answer, because mycosis fungoides is a cutaneous T cell lymphoma and their antibodies are not seen. They are seen in acquisita variant of epidermolysis bullosa. Okay, so I hope you don't get confused between congenita and acquisita. So congenita is congenital condition, it don't have antibodies, but acquisita can have antibodies. So DIF comes out positive. Now moving to the next question, here they are saying that 15-month-old girl has blisters and red skin with lot of blisters, particularly in the diaper area, limb area, and admitted to the emergency department. So this is a very severe condition. As you can see in the image also, the skin of the child is exfoliating at various places. It is separating. Patient is developing very large blisters. So patient presented to the emergency room, and her skin was easily peeling off, exposing raw underneath skin. So skin is very fragile, it is peeling off. Her family has been recently sick with a sore throat. So there is past history of sore throat. Okay, so some streptococcal sore throat infection. Now her white cell counts are elevated, so probably there is infection. Skin culture was performed, and what is the most likely diagnosis? Okay, so because there is a past history of sore throat, that is streptococcal sore throat infection, and now the patient is developing lot of peeling of the skin, lot of blisters. So this can be a case of what? Yes, staphylococcal scalded skin syndrome, also known as pemphigus neonatorum. Now remember what happens, that when there is a family history of infection or there is a history of impetigo in a child, sometimes patient start developing a complication of this infection. Okay, now this is generally caused by Staph aureus. Okay, so this is caused by Staph aureus. And in this condition, when the Staph aureus infects the skin, the Staph aureus releases exfoliative toxins which destroy desmoglin 1. And due to destruction of desmoglin 1, what happens that the skin starts separating and the clinical picture like pemphigus develops, that is patient start developing lot of blisters as they are mentioned here in the question. And these blisters are very superficial and this is common in neonates. So that is the other name of this condition known as pemphigus neonatorum. So here the answer is staphylococcal scalded skin syndrome. Now this is not Stevens-Johnson syndrome. Why? Yes, one of the student is writing here that, so Augustine and Rakesh, they are saying that answer is A. No, answer is not A. Why? Because remember that the most common etiology for Stevens-Johnson syndrome as well as toxic epidermal necrolysis, in both these conditions, the most common etiology is drugs. Okay, so generally what happens that when the patient takes or consumes drugs, commonly anti-epileptic drugs, and then it develops this separation, then it could be Stevens-Johnson syndrome or 10. But in neonates, the children can have this condition, that is pemphigus neonatorum or staphylococcal scalded skin syndrome, due to infection, and there is history of infection present. So that's why we will think of infective condition like staphylococcal scalded skin syndrome. Okay, so this is not SJS, this is not 10, and this is not pemphigus as well, because in pemphigus generally what happens that there are antibodies which are formed. So when you do direct immunofluorescence, you will get antibodies, but here there is no such investigation mentioned. And second thing is that they are mentioning that there is history of sore throat or infection and there are raised blood cell counts, so that is also suggestive of infective etiology, and skin culture is also sent. So all these are pointing towards infective etiology, and only one infective etiology mentioned in the option is SSSS, that is staphylococcal scalded skin syndrome. Moving on to the next question, here they are saying that 52-year-old man was concerned about the changes in the mole, okay, on his cheek. After evaluation, a skin biopsy was taken. Histopathological pathology is shown below, as you can see here. So if you see under 40x magnification, you can see atypical cells, that is malignant cells. So the nuclear cytoplasmic ratio have increased, and that's why you can see a lot of blue color here. And what is seen, it shows large baseloid lobules with peripheral unnuclear palisades attached to the epidermis and follicles. All these are suggestive of, yes, malignancy. Which malignancy? Yes, that is basal cell carcinoma. Okay, so initially it might present like a mole, okay, but there are changes which occur, so it presents with basal cell carcinoma. And if you do biopsy, you will get this palisading, which is very characteristic of basal cell carcinoma. And they are asking that what are the potential risk factors associated, and there are so many risk factors associated, as you can see in this image, which can be the very fair skin, like in Western countries and European and American individuals. There can be solar radiation, HPV virus infection, and immunosuppression. So all these etiological factors can be there, like this can be seen in these patients, and that's why the answer here is D, though there is no role of aniline dyes in the etiology. So I hope this session was fruitful for all of you. Thank you. Just wait for the next session. So Dr. Sushant Soni will be joining you for pathology discussion.
15 मिनट नहीं कर दिया मैंने।
हाँ
डिले नहीं करो ना इसमें, लगा लिया माइक, लगा लिया।
माइक ऑन है ना वहाँ पे?
हवा से होना।
Okay. So hi, evening friends, evening everybody bache. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So let's start with pathology questions. देखो बहुत ही balanced paper था. इसमें there were about 13 pathology questions, 13 questions हैं, and I want all of you to keep on telling me the answers side by side. मैं इसलिए अगर तुमने पेपर नहीं भी दिया है कोई बात नहीं, I will project the question, I'll give you 10 seconds. अभी जैसे question है, tell me the answer. That is the ideal way to proceed in this. साथ साथ आंसर बोलते जाना before I commit to the answer and we will discuss it. So in an experiment, शुरू करते हैं. Hi evening summer, evening दोस्त. Keep on telling me the answers. In an experiment being conducted, a genetic mutation reduced the cell viability of cell culture line. Cell culture line की viability कम हो गई. So in comparison to normal cells, these cells are smaller in size and have nuclear chromatin which is clumped together. मतलब clumping of nuclear chromatin is a feature of apoptosis. तो इसका मतलब कि apoptosis बढ़ गया. अब देखो इसमें ना दो ही पॉइंट्स में कंफ्यूजन है. बैक्स मार्क करना है कि BCL2. मिक तो इज टोटली आउट. मिक इज अ प्रोटोऑन्कोजीन. मिक क्या है? इट इज़ अ प्रोटोऑन्कोजीन. 3 टाइप का मिक है, सी मिक, एन मिक, एल मिक. सी मिक बर्केट्स लिम्फोमा, एन मिक न्यूरोब्लास्टोमा, एल मिक स्मॉल सेल कार्सिनोमा लंग. ये तो हमें पता ही है. कंफ्यूजन इन दो ऑप्शंस में था, बैक्स या BCL2. दोनों ऑपोजिट हैं. बैक्स इज प्रो एपोप्टोटिक, BCL2 इज एंटी एपोप्टोटिक. एपोप्टोसिस बढ़ रहा है. वाई? एपोप्टोसिस इज इंक्रीजिंग बिकॉज ऑफ जेनेटिक म्यूटेशन इन एंटी एपोप्टोटिक जीन. BCL2 एंटी एपोप्टोटिक जीन में म्यूटेशन हुई, एज ए रिजल्ट ऑफ विच एपोप्टोसिस इंक्रीज्ड. नेक्स्ट क्वेश्चन. आई नो समर एग्जैक्टली, मतलब हम लोग ना वही चीज़ देखने वाले हैं जिनमें कन्फ्यूजन होता है. यू नो दिस टेबल वेरी वेल. एंटी एपोप्टोटिक प्रोटीन्स जिसमें भी एल आ रहा है, BCL2, BCL-XL, MCL1 फ्लिप. ओनली एक्सेप्शन टू दिस इज BCL-XS विच इज प्रो एपोप्टोटिक. बाकी बैक स्मैक डियाब्लो प्रो एपोप्टोटिक है, बिट बिम प्यूमा नॉक्सा सेंसर्स है. यू नो दिस टेबल वेल. नेक्स्ट क्वेश्चन. अब हम आते हैं नेक्स्ट पे कि अ चाइल्ड who has recurring infections since the first year of life. अब ऐसे लिखने की जगह एग्जामिनर ये भी कह सकता है कि the patient is suffering from had 3 episodes of strep pneumonia last year, now presenting with otitis media. मतलब recurring infections since first year of life, hepatomegaly है, splenomegaly है. Now staph infection है and the result showed child's neutrophil ability to kill is diminished. मतलब there is reduced activity of WBC to kill the organism. क्यों? Reduced activity to kill is due to a defect in perfect. I want more people to commit to this. Repeated infections है. Main line क्या थी दोस्तों? Main line थी कि child's neutrophil ability to kill is diminished because of defect in NADPH oxidase pathway. A. There are 3 main pathways of killing: NADPH oxidase pathway, nitric oxide synthase pathway, and lysosomal enzymes. Defect in NADPH oxidase pathway is called chronic granulomatous disease, CGD, which is X-linked recessive in nature. बाकी दोनों diseases, that is ADA deficiency and defect in interleukin-2 receptors, इसे कहते हैं SCID, severe combined immunodeficiency. There is increased risk of infection by catalase positive organisms. Beautifully said अभी, perfect. SCID में एक और पॉइंट पूछा जाता है, ADA deficiency is autosomal recessive versus defect in interleukin-2 receptors which is X-linked in nature. Perfect. Next question. ये तो बहुत ही simple, straightforward सा है. I guess 100% right answers. Pradeep, I'll speak in English, no doubt about this. So this gets us to our next question, that is, which of the following statements regarding transudate is false? Pradeep, if you want me to repeat any point in English in the prior two questions, please don't hesitate to say that. I mean, I'm okay with English, don't worry about it. Which regarding transudate is false? Transudate does not have increased vascular permeability as the main cause. देखो, there are two types of fluid now, exudate and transudate. In exudate, everything is present. That is the appearance is yellow to turbid, specific gravity is high, LDH is high, proteins are increased due to infections and malignancies. Versus transudate, which is a clear colorless fluid, specific gravity is less, LDH is less, protein less, main cause being right-sided chronic heart failure. Next question. Recent NEET PG PYQ also, I want you guys to commit to this. I am not going to speak it, I want you guys to commit. 35-year male, even the microscopy was given, but I am not interested in microscopy at present, complains of hematuria with grade 1 proteinuria. That means it is a case of nephritic syndrome. Now the examiner very clearly told you that on investigation, anti-GBM antibody is present. That actually finishes the question and the diagnosis for me. It is a case of good pastures syndrome. It is a case of good pastures diffuse linear deposits. I will show you 5 immunofluorescence images. I want you to tell the diagnosis in that. Good pastures has anti-GBM antibody. So glomerular basement membrane ke against antibody, anti-GBM antibody. As a result, think of it yourself. GBM is continuous in nature. It is a diffuse linear deposit. That is good pastures syndrome. That is good pastures. Agreed. Next point. Hi, evening friends. Evening everybody, bache. Evening everybody. Next, I want you to commit to this answer. Examiner just told you this is renal immunofluorescence. He did not give you anything else. Diagnosis. Recent PYQ. I always say this कि इसमें ना remember Iron Man 3. Remember this image. जब Iron Man 3 में when the villain shows the brain to the girl, it looks like this. Diagnosis MGN, membranous glomerulonephritis. Diagnosis MGN. Versus, tell me this now. इसका बताओ. Tell me this diagnosis. You need to write this, बच्चे. Again, this is glomerular immunofluorescence. Mostly, this is singly scattered. ये aggregates में नहीं है. This is not present in aggregates. It is singly scattered. Which cells are present scattered in the glomerulus? Mesangial cells. Which cells are present scattered? That is the mesangial cells. That means it is the mesangial deposit. Seen in IgA nephropathy. Or Buerger's disease. IgA nephropathy or Buerger's. Mesangial deposits. And lastly, tell me this. The minute I see this, I am able to make out कि ये aggregates हैं. These immunofluorescence are present as aggregates. This is the lumpy bumpy granular deposits. I know this is too sexy a language. This is not mine. मैं कभी ऐसे नहीं बोलूँगा, I guess. This is what Robin says. Lumpy bumpy granular deposits, giving it the classical starry sky appearance. Seen in PSGN, post-streptococcal glomerulonephritis. So हम लोगों ने ये 4 immunofluorescences, good pastures syndrome, anti-GBM antibody, MGN, membranous glomerulonephritis, MGN, mesangial deposits, IgA nephropathy / HSP, and lumpy bumpy granular deposits, PSGN. Next question. This gets us to the next one, that is ABCD. Rakesh, बच्चे we'll discuss. Okay, so you're from Bikaner, I know. Welcome to the session, no doubt. Next, अच्छा मुझे इसका बताओ.
स्ट्रेट फॉरवर्ड क्वेश्चन है, बिल्कुल टफ नहीं है. यंग प्रेग्नेंट फीमेल, फुल टर्म है. शी सफर्ड फ्रॉम अब्रप्शियो प्लेसेंटे, प्लेसेंटल अब्रप्शन, इमरजेंसी सी सेक्शन किया, बट शी सफर्ड सीवियर ब्लीडिंग फ्रॉम सर्जिकल वुंड्स एंड शॉर्टनेस ऑफ ब्रेथ, विच इज़ हाई. सो देयर वर टू हिंट्स इन दिस क्वेश्चन. एक तो प्रेग्नेंट फीमेल थी, दूसरा अब्रप्शियो प्लेसेंटे था. दैट इज इट प्रीडिस्पोज्ड टू DIC, predisposed to DIC, which will be high fibrin degradation products, FDP. As such, you know कि DIC, PT, PTT के increase, platelet count reduces. Those, all the academic stuff is in English. Don't worry about it. You will not miss out on the academic content. The talk can slightly be in Hindi, but the academic content is in English. Next question. A 5-year-old child is brought with convulsions and skin patches. On examination, there is tuberous sclerosis. It is a nervous disorder. Answer बच्चे, everybody. क्या inheritance है? What is the inheritance? All the nervous disorders are autosomal dominant. नहीं बच्चे, Aravas, I am actually glad that you have said this statement. NEET PG is about cramming things. Not at all. I mean, I am saying this as a fact because firstly, am I eligible to make this statement? Yes, I am. I am saying so because I am from MAMC, UCMS and the names. MBBS, MD Pathology, Hemato-Oncology AIMS. I am from the top 3 medical colleges in India. I have cleared all my 3 papers in the first attempt from general category, and I say it very proudly. And I can tell you, it is not about cramming. The minute हम लोग सोचते हैं ना कि यार रट्टा मार लेंगे क्वेश्चन को बिना समझे हुए, गड़बड़ हो जाएगी. वी कैन नॉट क्रैम अप. आई टेल यू वाई. अब हम इसी क्वेश्चन पे हैं. लेट अस हैव अ लुक एट दिस क्वेश्चन. यू थिंक कि ट्यूबरस स्क्लेरोसिस आई नीड टू क्रैम अप कि इट इज ऑटोसोमल डोमिनेंट. नो. इफ आई एम सिटिंग इन योर चेयर, I will remember that all nervous disorders, all skeletal tissue abnormalities, all colon cancers are autosomal dominant. This is how I will remember. Nervous disorders कौन से हुए? Which nervous disorders? Tuberous sclerosis, neurofibromatosis. Both NF1 and NF2. Both are autosomal dominant. Skeletal tissue disorders like Marfan's syndrome, increased joint mobility, Marfan's, hyperextensibility of skin, Ehlers-Danlos syndrome, brittle bone disease, osteogenesis imperfecta, autosomal dominant. All colon cancers, FAP, that is APC gene mutation, FAP. Next, we are talking about hyperpigmentation around oral cavity with intestinal polyps, Peutz-Jeghers syndrome, 5-year-old child with bleeding per rectum, juvenile polyposis syndrome. All these are NEET PG recent PYQs. They are autosomal dominant. So remember it category wise. Understand it, remember it category wise. Your recall will be much higher. Next, everybody, please give me a thumbs up. Or I know I speak more things and write less, especially in a test and discussion format. Give me a thumbs up or like the video if all of you are comfortable with all the points that I have discussed till now. Everybody, which give me a thumbs up or like the video so that at least I know कि I spoke so much here कि हम लोगों को समझ आया, we understood. Next question. Let's have a look at this. Onset of pheochromocytoma is not associated with perfect, Sub-Zero, perfect. Thanks, really thanks for the kind words. Is not associated with which of the following syndromes? So when I am sitting, even if I don't remember Sturge-Weber, von Recklinson, मुझे नहीं याद, I don't remember. Let's be frank about it. I know Prader-Willi syndrome. I studied Prader-Willi in genomic imprinting. I studied it in genomic imprinting and I saw that it was associated with paternal deletion. Prader-Willi syndrome is paternal deletion and paternal disomy. I know that. We did this in detail and I never mentioned pheochromocytoma with it. We talked about pheochromocytoma in endocrine. When we were doing the high yield questions, we discussed the rules of 10 with pheochromocytoma. They are 10% bilateral, 10% extraadrenal, 10% seen in children, 10% malignant. Pheochromocytoma. Seen in Von Hippel-Lindau disease, Von Hippel-Lindau syndrome, both men 2A and 2B, Sturge-Weber syndrome, neurofibromatosis and familial paragangliomas. This is pheochromocytomas. Next question. Acha, tell me this. Simple, straightforward, 100% right answers. Matlab, no doubt about this at all. 100% right answers. 60 male had GERD-like symptoms for past 4 years. Upper GI biopsy is done. In the GI biopsy also, it is shown to you that the normal stratified squamous is getting converted to intestinal type. That is Barrett's esophagus. This is a case of Barrett's esophagus, which is a pre-malignant condition for adenocarcinoma esophagus. It is pre-malignant for adenocarcinoma esophagus. Barrett's, plain and simple. Next question. Asha, by the time you read this is a very important question. I want you guys to tell me this also. अभी हमारी क्या condition है? I guess majority of us are appearing in NEET PG or the INI exam. We are slightly stuck also at about 110 to 130 correct answers. This is where majority of us are at present. I recently made a video also on this, how to go further if you are stuck on it. That video is gold standard, बच्चे हम सबको वो चीज़ तो देखना ही देखना है. I am saying so because in the end, our target should be 145 plus correct. No doubt about it, and we will reach it. Those of you who are already sitting at 140 plus around corrects, we will target 155 minimum. So हम लोगों को 140 से 155 जाना is extremely tough. But 110 to 130 से 145, we have to go and we will be achieving it together. Do watch that video. Next question, coming back to this. When we are talking about DIC, I am sure you would have read the question. DIC is associated with renal failure. बच्चे multiple microemboli go, disseminated intravascular coagulation. Inside the blood vessels, coagulation is taking place. Multiple microemboli go and get lodged in kidney, in turn leading to renal failure. Next question. Now this was tricky, and before I say it, you tell me. An asbestos factory worker presented with shortness of breath. Radiological examination was given and a diagnosis of mesothelioma was made. So what the examiner is telling you is a previous history of asbestosis and the patient is a known case of mesothelioma now. Which of the following would not be present? Answer, bache. Answer. Mesothelioma is associated with semoma bodies. It is dystrophic calcification. Seen in mesothelioma, it is associated with semoma bodies. It is cytokeratin 5-6, calretinine and WT1 positive. On electron microscopy, it has slender microvilli. Lambe and patle, slender microvilli, they are present. What will not be seen? Asbestos bodies. Asbestos bodies is a feature of asbestosis. When asbestosis has progressed to mesothelioma, I will not be seeing asbestos bodies. This is what asbestos fibers look like. Asbestos fibers, they are dumbbell shaped fibers. इनके ऊपर ये brown pigment आ रहा है ना, brown pigment, that is hemosiderin deposition. Hemosiderin deposition on asbestos fibers leads to ferruginous bodies seen in asbestosis, not mesothelioma. Those semoma bodies nahi. Semoma bodies are seen in mesothelioma, prolactinoma and meningiomas. They are seen. Next question. Now have a look at this. A young boy, now this question was slightly twisted. Young boy had a syncope during football match. That is, he is a young athlete who had syncope leading to sudden cardiac death. Most common cause of sudden cardiac death in young athletes is HOCM, hypertrophic obstructive cardiomyopathy. Examiner gave you this in the question also, that on autopsy hypertrophic cardiomyopathy was found. Even if this statement was not written, suppose ye nahi likhi hoti, then also it was a case of HOCM. Which of the following is false? HOCM is autosomal dominant genetically. It occurs due to mutation in beta chain. Is it systolic or diastolic dysfunction? It is diastolic dysfunction. In an athlete, the heart is pumping extremely well. There is no problem in systole. His heart is pumping better than us. He needs more oxygen than us. Problem is in diastole. It is a diastolic dysfunction, but it is not associated with amyloidosis. Amyloidosis and radiation-induced fibrosis, which it is seen in restrictive cardiomyopathy. It is seen in restrictive cardiomyopathy, not HOCM. Next, simple straightforward question. Simple question. देखो जब भी heart का question हो, whenever we have a question on heart, let's make a simple diagram left and right. Which of the following is not an aging related change? Lipofuscin, aging related pigment gets deposited, which is also called as brown atrophy of the heart. Lipofuscin is golden brown in color, but इसे बोलते क्या है? Brown atrophy of the heart. With aging, interventricular septum bulges towards left. मतलब right ventricular volume reduces, right ventricular increases, left ventricular volume reduces. Interventricular septum goes towards left. So increase in left ventricular volume is false. There are lambal excrescences. Lambal excrescences, these are small thrombi which are present on heart walls. There are lambal excrescences, and it is associated with basophilic degeneration of the myocardium. This is aging related change. The answer was B. Next question. Next, and I guess last question. Samar Bachi, it will come on the app itself. It will be there on the app. Ashal, before I go to the last question, I actually want to ask you guys, this is last 2 minutes with me. How was your paper? Were you able to, how many of you attempted 180 plus questions? See, when you are giving a grand test, it is not only about score. It is not only about how well you did that particular paper. It is also about, it is a practice for the actual exam. How many of you attempted 180 plus? That is what we want. This is the kind of paper that you will be getting in the actual exam also. So attempt more number of questions until you do not know more than 2-3 options. Attempt the question. Rule out options, attempt the question. More you attempt, what we want is higher will be your score. Next, Rosenthal fibers, pilocytic astrocytoma. Fair enough. And this is what it looks like. All these are the Rosenthal fibers. All these are the Rosenthal fibers associated with pilocytic astrocytoma. Lastly, tell me this also. Examiner just told us this is a CNS biopsy. What are you able to see here? Okay. So time management is what we will be learning those. We'll gradually, summer we'll learn that. Koi baat nahi. Being stuck at 130 to 140 is not a bad case scenario. We will be analyzing our GTs and increase our number of corrects. Radhesham, comfortable those. Janshu, comfortable. What do you see here? You are able to see that there is a central area of necrosis with peripheral pseudopalisading of tumor cells. Glioblastoma multiforme. GBM, glioblastoma multiforme. Totally agreed. Totally agreed. So on this note, which is this gets us to our last image. We know these are the perivascular pseudorosettes, that is ependymoma, which is associated with ependymoma. Done. So on this note, needless to say, bestest of luck for your exam. Do well, and we are in this together. Keep on working. Everything is gonna turn out much better than you expect. Thank you, and take care.
पास सही है बता दियो सही है स्टार्ट Hi friends, so now we'll start up with the microbiology and how's the exam gone and how you find the microbiology questions, do tell us. Hi, good evening Sama, good evening Yash, Arif, Jianshu, Kumar, hello, how are you? So start karte hain, let's start up. Let's see the first question. A professor doing a viva asked the students about the mechanism of action by which the toxin of Pseudomonas acts. Okay, which of the following would have been his answer so that the professor was satisfied by the answer of the student. Professor never gets satisfied. First thing is that. So yes, yeah Vikas, hi. Tell me, what is the answer of this question? What you have marked up? Shweta, hi. Arif, hi. Ramesh, hi. चलो अब बात करते हैं रोहन, डोंट वरी. टेल द आंसर ऑफ दिस क्वेश्चन एंड द फर्स्ट आंसर अभी हैव टोल्ड सी. Saurav told C and Heather have also told C. So everybody is going towards C. Yes or no? Is it the answer C? Dr. Payal have told C. Swati have told hello. Yes, please. More answers I want. Ashwin also told C. And the answer is C, no doubt. Okay. So basically, inhibition of elongation factor 2 is the mechanism by which the Pseudomonas exotoxin acts upon. Okay. Exotoxin acts upon, and I already told up in the videos also. Remember this mnemonic, DSP. So what is DSP? Dr. Sonu Pawar. Okay, so this particular one basically acts by inhibition of elongation factor 2. And what is that in DSP? D is diphtheria, okay, diphtheria toxin, S is Shigella, and P is Pseudomonas. Okay, P is Pseudomonas. And let me tell you very frankly that the Pseudomonas, this particular one, is a gram-negative bacteria. Gram-negative bacteria mostly secretes what? They secretes up endotoxin, but these actions are of exotoxin. Remember this. Shigella also is one of the gram-negative bacteria which secrete exo as well as endotoxin, and diphtheria, this particular one, is a gram-positive one, and gram-positive one obviously what they secrete? They secrete exotoxins. Okay, so this is very much done. That inhibition of elongation factor 2 is being done by these three important ones. One is diphtheria, one is Shigella, and one is Pseudomonas. And in them also, their exotoxin acts through this mechanism. Endotoxin is having different stuff, but exotoxin is acting through this inhibition of elongation factor 2. Okay, so basically what happens in ADP ribosylation happens in this particular one, and thereby inhibition of protein synthesis happens. Okay. Hi Rahul. Now, telling about this, can you tell me that where there is an increase in the cyclic AMP, where there is an increase in the toxin action of the cyclic AMP? So cyclic AMP comes up at various places actually. Even the Vibrio cholerae is having the increase in the cyclic AMP. Okay. Along with that, if we talk about the Bacillus cereus diarrheal one. Okay, if we talk about the Bacillus cereus diarrheal one, this particular one is there, and the E. coli, in fact, which E. coli? That is a toxigenic E. coli. This one acts through increased cyclic AMP. Which one? The labile toxin of it. Okay, the labile toxin of this particular one also acts through the increase in the cyclic AMP. Even the anthrax toxin, Bacillus anthracis, as you are telling up, the Bacillus anthracis also, which is a like question which can come that which is a tripartite toxin. So Bacillus anthracis is a tripartite toxin. Vibrio cholerae, Bacillus cereus diarrheal 1, E. coli. These all, in that E. coli also which one? Labile toxin. These all they act through which mechanism? Increase in the cyclic AMP. Is it fine? So this is regarding the AMP which you need to know. Besides that, if somebody asks you, there is an increase in cyclic GMP. So at least two you should remember. And the one are which one? The one are, one of them is your Bacillus cereus emetic strain, the Chinese fried rice one, okay, reheated Chinese fried rice. Yes, you are also right, pertussis. So Bacillus cereus emetic one, this one, along with that, E. coli heat stable toxin. So for both of them, the mechanism of action is increase in the cyclic GMP. And what is GMP? Guanosine monophosphate. Okay, guanosine monophosphate. Okay, so now talking about the D option. So D option is inhibition of 60S ribosomal subunit. Okay, inhibition of 60S ribosomal subunit. This particular one was asked in this FMG exam. Okay, and it can be definitely asked in the NEET PG for sure. So inhibition of 60S ribosomal unit is done by this particular one, that is the Shiga toxin. Okay, or you can say Shiga-like toxin. Fine. So Shiga toxin is secreted by Shigella, and along with that you have this EHEC O157H7. Okay, this also acts through inhibition of 60S ribosomal subunit. So answer to this particular question is C. Okay. Now coming to the next one. Tell me the answer of this one. A 5-year-old girl presents to OPD with complaints of blood in the stool and abdominal pain. The physician sent the stool sample for the microbiological testing. The bacteria isolated from the sample was found to be a late lactose fermenter. Okay, LLF. Yes, anybody? What is the answer of this question? That is a 5-year-old girl present to OPD with complaints of blood in stool. The blood in stool means they are talking about shigellosis. That's for sure. Okay, and they have isolated the bacteria also, and they found it to what? Late lactose fermenter. Okay, late lactose fermenter. Tell me, what is the answer of this? What do you think the answer is there for this particular one? Yes, B. Abhi have told B, Dr. Payal have told B, and the answer is no doubt B. Okay, the answer is no doubt B. That is Shigella soni. Shigella soni is a LLF, late lactose fermenter. Okay, I have already told the Enterobacteriaceae family you need to remember 3 names. One is E. coli, one is Klebsiella, and one is Shigella soni, which are what? Lactose fermenters. And special regarding this is what? That this is a late lactose fermenter. Okay, this is a late lactose fermenter. In 3 to 4 days, it ferments the lactose. Okay, another thing which is important is colicin-based typing. Okay, colicin-based typing. This question can come in AIMS also. That colicin-based typing is done for which particular Shigella? The answer is Shigella soni. Other thing regarding it is that this is the most common cause worldwide of the shigellosis. Okay, this is the most common cause worldwide of the shigellosis. And here only I like to tell you one more point, that after the infection of Shigella, the reactive arthritis is very common. Okay, and if somebody asks you that this particular reactive arthritis is mostly done by which species of Shigella? The answer is Shigella flexneri. Okay, the answer is Shigella flexneri is the one which associates with reactive arthritis. What is that? After the dysentery episodes, okay, after these dysentery episodes, after 2 to 3 weeks, the person who developed them developed pain in the joints. So that is what is termed as okay, very good Abhi. Soni sota rehta hai, late utha. Yes, very right, very right. Okay, so reactive arthritis is number 1 cause is Shigella flexneri, which you need to know. Okay. Now, the famous thing regarding Shigella dysentery also you should know that this is a catalase negative organism. Along with that, you need to know this thing also, that it is having exo as well as endotoxin secretion. Okay. So, slight bit gram-negative bacteria, they are there which secretes both of them. Okay, which secretes both of them. Now coming to the next one. A 6-year-old boy was brought to the medicine OPD with he complains of itching in the perianal region. Okay, become worse at night. NIH swab method. If these hints are there, sufficient hints are there, then the answer is obvious. Which of the following shows the characteristic causative agent? Like basically they have given the eggs and they want to identify the organism with the basis of egg. So can you tell me guys what is the answer of this? A, B, C or D? Yes, everybody. What is the answer here? A, B, C or D in this particular question. Good evening Ankit. Tell me what is the answer of this particular one? A, B, C or D? And Dr. Payal have told answer as D and she is right. Okay. She is right. Answer is this particular one. It is having a plano-convex egg with a tadpole-like larvae inside. Okay, with a tadpole-like larvae inside. And which particular organism we are talking about, guys? Enterobius vermicularis. Enterobius vermicularis. And Enterobius vermicularis is also known as pinworm, threadworm, seatworm, oxyuris. Okay, all these are there. Another important thing regarding this is it comes in the mnemonic NEHA. And NEHA is non-bile stain. So this particular egg is what? Non-bile stain. Okay. NIH method is used to diagnose it. And what is NIH? National Institute Health Swab, which is a glass rod with a tape, and you move into the perianal region of the child. And to that, the eggs there attach off, and then you can see them under the microscope. Okay. So these are there. Along with that, we can have the other ones also. This is, you know which one? Trichuris trichiura. Okay, Trichuris trichiura is, another name is whipworm. You have to identify by the mucus plugs, and that is barrel shape. Okay, this one is hookworm. Okay, having 4 to 5 blastomeres. And this is Ascaris. A well-made egg of Ascaris is the C. Okay, so these are the important ones which you need to focus upon in this particular question. So answer of ours is D. Now coming to this, Rakesh, a 24-year-old male diagnosed with HIV, presents in OPD with dry and non-productive cough with difficulty in breathing. Okay, the examining physician orders a chest X-ray which shows bilateral interstitial pneumonia. Characteristic of which particular organism in the HIV? That is Pneumocystis cerevisiae. Okay, so on the performing microscopy, the following image is seen, and see this image. This is the image. That is crushed ping pong ball appearance. That is being observed in this. Okay, which of the following statements is incorrect regarding the causative agent? Yes, please, answer. Answer of this particular one. What is the answer of this particular one? Yes. C, have told by Shivani. Okay. Anything, and anybody else? What is the answer of this particular question? C is being told by Shivani. Anybody with any other answer here? The causative agent have 3 morphological forms. They can have precis, cyst and trophozoite. Okay, standard treatment is a combination of trimethoprim and sulfamethoxazole. That is the cotrimoxazole. That is the drug of choice, no doubt. The causative agent can be cultured on SDA. No guys, only 2 fellows are there which are in the mycology, but they do not being cultured on the SDA. These are, one is Rhinosporidium seaberry, which is a controversial fungus. They say it's an aquatic protist actually. And the other one is this, that is Pneumocystis cerevisiae. They shows the features of being a protozoa, but the chromosomal studies suggest it to be a fungus. Okay, so it is not being cultured on the SDA. The answer is C, as Ashwin have told. Dipendra, answer is C. This they have asked regarding the incorrect statement. The incorrect statement is this: it can't be cultured actually. Okay, the causative agent has no agrostol in cell membrane. Yes, it doesn't have. Okay, so answer is here what? C. Now, a 24-year-old patient presents to dermatopedy with itchy lesions. Okay. The sample taken was subjected to KOH mount. So, see this thing also. Wherever they will see regarding KOH. So, remember they will ask regarding the fungus. Whenever they put in the exam KOH, immediately think about a fungal etiology. That is also there. Which showed pencil-shaped macroconidia. This was asked in the exam this time, pencil-shaped macroconidia. If you know directly, you know the answer. We are talking about the trichophyton. And along with that, you have small unicellular abundant microconidia. So there are many. Which of the following structures are affected by the constitutive fungus? So in this particular one, they wants to know the name also, and they wants to know this, that which all structures it affects of. So you already know that the trichophyton involves of skin, hair and nails. It involves of what? Skin, hair and nails. Fine. And what about the microsporum? Microsporum M do not involve N. So that is skin and hair. Okay. And regarding the epidermophyton, skin is common to all and it is having nails. So this you already know. M do not involve N. So like that you need to know. So answer is A. Okay. So answer is A. Now coming to the next one. A lecturer taking a lecture on immunology demonstrated to the students about an immunodeficient test. Okay. This question might come in AIMS. Ask students about the test where there is a single diffusion in 2 dimensions. Means a single thing is diffusing. Means antigen or antibody is diffusing up. But the direction is not limited to 1. It is 2 dimensions. Basically, you can't see the 3D. So that's why they say 2 dimensions. Which of the following would have been the most appropriate response by the student in this? Is it Oakley-Fulthoff? Is it radial immunodiffusion? Is it Auden procedure? Or is it Oster-Loney? Okay. So answer to this question is B, guys. Okay. Answer to this question is B, guys. Radial immunodiffusion. And radial immunodiffusion is what? It is a single diffusion. Means antigen is diffusing up in the different directions, that is 2 dimensions, and this in the form of radius, this particular one goes. So that's why termed as what? Radial immunodiffusion. Okay. Now Auden is what? It is a single diffusion in 1 dimension. Okay. It is a single diffusion in 1 dimension, means one thing is moving but the direction is same. So that is termed as Auden. Okay. Then Oakley-Fulthoff is what? It is a double diffusion. Means antigen and antibody both are moving up but the direction is same. That is in 1 dimension. Okay. But antigen and antibody, they are moving and in between there is a agar slab. So they will move towards that. They have an affinity. Then this particular one comes that this is a single diffusion. Okay. This is a single diffusion but the direction changes up. It is 2 dimensions. Okay. Oster-Loney is what? Oster-Loney is double diffusion in 2 dimension. Means both antigen and antibody is moving up but they are moving in different directions. So that is termed as double diffusion in 2 dimensions. That is termed as Oster-Loney. So these names you need to know, and you need to know this thing also, that the famous Ehrlich gel precipitation test which is being done for diphtheria. This particular test is double diffusion in 2 dimension. This is double diffusion in 2 dimension. Is it fine? So the answer to this question is B, guys. Okay. Picorna viridae. Answer of previous one you said A. Huh? Okay. Now coming to the next one. That is the 18-year-old male had a dog bite 2 months back. Presented to emergency department, complaints of altered sensorium and hydrophobia. The probable diagnosis of rabies was made. The image given below shows which particular structure. Okay, so these are the bullet-shaped ones. So bullet-shaped ones is which virus? It is the rabies virus. Negri bodies, they are not seen like that. So they are seen, they are post-mortem diagnosis. Okay, and they are observed on the brain biopsy. And the method by which they are being stained up is Seller's technique. So everybody knows it. So answer to this question is what, guys? Answer to this question is B. That is rabies virus, which is bullet shape. Okay, bullet shape. And this particular bullet shape virus, can you tell me, is it single stranded or double stranded? It is a single stranded RNA virus. Okay. Is it enveloped or non-enveloped? This particular one is enveloped, guys. Okay. Besides that, this is having a negative sense or a positive sense. Guys, this one is a negative sense virus, and negative sense RNA viruses always change to first what? Positive sense RNA virus. Okay. And with the help of which particular enzyme? RNA polymerase. So need to know this also, that RNA polymerase, the negative sense changes to what? Positive sense. Okay. Firstly, every particular negative one goes like that. Okay. So this is there. Besides this, you need to know that what is the speed of this bullet, at what particular one it travels upon. So answer to this is 3 mm per hour. 3 mm per hour is the speed of this particular one at which it goes upwards after the bite. Is it fine? So answer to this question is what, guys? Answer to this question is yes. Answer to this question is what? Yes, please. Answer to this question is B. Okay. Fine. Now talking about this particular question, a 40-year-old male, okay, a 40-year-old male with the severe yellowish discoloration of the skin, that is matlab icterus, jaundice, abdominal pain, vomiting, was admitted to the medicine department, where further workup revealed hepatitis B infection. So that is being revealed that what is the infection about? That is about the hepatitis B, okay, hepatitis B. Okay, and the follow-up shows up serological profile which you have done the ELISA. It shows up this, that HBsAg is positive, okay, HBeAg is also positive, anti-HBc shows IgG positive, okay, IgG positive, anti-HBc. Along with that, anti-HBe is negative, anti-HBs is negative. So obviously this is not vaccination, because vaccination will hang only anti-HBs, okay. This is not acute infection with high infectivity, because what is coming off? IgG. So this you need to know that IgG is coming off. So IgG, if it is coming off, the answer is obviously what? Answer is chronic HBV infection with high infectivity. Okay. And why we are saying high infectivity? High infectivity because HBeAg is positive. And EAG is which antigen? Pre-core antigen. This particular one is which antigen? This is a pre-core antigen. Okay. So this is a chronic HBV with high infectivity. We know now that more than 6 months, if any particular person is having HBsAg positivity, that is termed as chronic hepatitis B. And obviously it is being written in this that IgG anti-HBc is also coming positive in this question. So obviously we are talking about what? Chronic hepatitis B. Okay, chronic hepatitis B. Fine. Now coming to the next one. A 2-year-old child came to the pediatric OPD accompanied by her mother with the complaints of recurrent pyogenic infections. The examining pediatrician suspected complement deficiency. Which of the following would be the deficiency involved in this? So this particular fellow is having recurrent pyogenic infections. So which complement deficiency associated with this? The answer to this question is obviously what? That is the C3 and its regulatory protein. Answer is D in this particular one. Early components of classical pathways C1, C2, C4, they associates with SLE, okay, the deficiency of them. C1 esterase inhibitor, you already know that leads to hereditary angioneurotic edema, okay, hereditary angioneurotic edema, fine. And C5 to C9, because of that, what happens is recurrent Neisseria infections. Recurrent Neisseria infections, they happen in the C5 to C8 complement deficiency, or C5 to C9 you say the MAC deficiency. So answer to this question is what? Answer to this question is D. Okay, that is C3 and its regulatory protein. If they are absent of, the person will have recurrent pyogenic infections. Okay, what the person will have? Recurrent pyogenic infection. Fine. Abhi, like I have missed out on your questions. Co-infection, super-infection is like co-infection is hepatitis B along with hepatitis D from the starting. Super-infection is already the patient is having hepatitis B, over that the hepatitis D infection happened. So obviously means if it is over means that IgG would have been come in the hepatitis B, and over that the infection of this particular hepatitis D happens, super infection. This is the one which is having the maximum fulminacy of 5 to 20%. Okay, so this is there. Now, say like what is the answer of this particular one, guys? The present one which we are discussing up, because I think on the phone the chat have lagged upon. So can you tell me up by saying up hi? Say hi on this. So answer to this particular one is what, guys? D. Now coming to this, another good question. The good question is, a 3-year-old child was brought with the complaints of fever, sore throat and scalariform rash. That is in the, okay, you told her D1. Okay, fine, Rohit. Okay. Fine. Now, regarding this particular one, that is the next one. Yes. Hi, Pyle. Tell me the answer to this. This particular present question you tell. What is the answer of it? Yes. Please tell the answer of this particular question. That there is a fever, sore throat and a rash, and the physician ordered up the lab test for which a throat swab was taken, sent to the lab for the culture, which the following is used as a transport media for the pathogen implicated. Yes. Answer is Spike's media, and very right. Everybody have told it wonderfully. Right? This is Spike's media, and we are talking about which particular organism? We are talking about Streptococcus pyogenes. Okay, Streptococcus pyogenes, a gram-positive cocci, and this particular thing, fever, sore throat, and scalariform rash, that is a typical of this infection. That is the scarlet fever, which is done by this. And to add to this is that the toxin of scarlet fever. Okay, scarlet fever toxin, which is also termed as pyrogenic toxin. Okay, which is also termed as pyrogenic toxin A and C. Okay, pyrogenic toxin A and C. Along with that, there is erythrogenic toxin, that is A and C. These are the names. These particular ones, they are the super antigen. You already know they are the super antigen. And what is a super antigen? The antigen which is super antigen. In what sort it is super? This is like it is not MSC restricted, and it attaches to the V beta domain of the TCR and activates more than how much? More than 20% T lymphocytes, and that leads to what? Shock. Okay. So this is what you need to know regarding it, and the answer to this is obviously Pikes. VR you already know. VR is for what? Venkatraman Ramakrishna Media, Vibrio cholerae. Cariblair is also Vibrio cholerae. Stewart's is for gono and meningo. Okay. Now see this. These types of questions definitely can come in which such a complex life cycle they can give you, and they can ask up regarding the answer. So guys, one thing is for sure, in this they are talking about Cercaria, these particular ones. They are talking about crustaceans, they are talking about Meracidium, okay. All these things they are talking about. Along with that, if you see down here, that is being talked about the adults in the cystic cavities in the lungs. They lay the egg and they are excreted in sputum, okay. So obviously they are talking about something regarding the lungs, and you know that the organism which is termed as lung fluke is which one? Answer is Paragonimus westermani. Okay, Paragonimus westermani. And if somebody asks you what is the infective form for this, guys, the infected form for all the trematodes is Metacercaria. Okay, and what is Metacercaria? Metacercaria is cyst. And what about the cystosomes, which are also the trematodes? For them it is Cercaria. And it was asked in one of the exams, this particular Cercaria is seen in this also. But this is the infective form in whom? This is the infective form in the cystosomes. This is the infective form in whom? This is the infective form in the cystosomes. That is Cystosoma hematobium, Mansoni, okay, and Japanicum. Crab, very right. So this particular one I tell up in the class also with the help of a Paragon slipper. You have like beaten up a crab, and everywhere there is a blood and blood. So that shows up which particular sputum comes in this, red brown sputum or a golden brown sputum. Okay, so we are talking about this. Fasciola hepatica is sheep liver fluke. Chlorochia sinensis is Chinese liver fluke or oriental liver fluke, and facial or busky is an intestinal fluke, which is the largest one. Okay, this is the largest intestinal fluke. Chlorhydritis sinensis leads to carcinoma bile duct, and facial hepatica, as such, the question which was asked in the AIMS exam was that what is the drug of choice for facial hepatica? The answer is triclavendazole. Otherwise, for all of them, the drug of choice is what? Praziquantel. Okay, praziquantel. Is it fine, guys? So remember this particular one, that the crab is being eaten up. That is a cooked or pickled crustacean. This particular one, which contains a metacercaria. Which crustacean? Crab. Fine. So answer to this particular question is what, guys? The answer to this particular question is D. That is the lung fluke. Now talking about this, a microbiologist while working in his lab demonstrated CAM test. So this should be capital. CAM test and a reverse CAM test. Fine. To his students to explain the difference between the two, the CAM and the reverse CAM test are used in diagnosis of which of the following bacteria. So you already know this, that we do it for Streptococcus and Clostridium. The answer is B. Okay, the answer is what, guys, here? Answer is B in this particular one. That is the Streptococcus and the Clostridium. Okay, so this particular for the Streptococcus, which we do the CAM test, it differentiates between the group A Strepto and the group B Strepto. Group A Strepto is Pyogenes, group B Strepto is Eclectia. Reverse CAM in this, that is being used for Clostridium perfringens. For the diagnosis of Clostridium perfringens, we use reverse CAM test, and if you remember off, we have a mnemonic for this, that is termed as senior NTR. Okay, senior NTR, that is Tommy fermentation, Nagler's reaction, target hemolysis, and reverse CAM test. Okay, so answer is B. Now, which of the following rickettsial species is transmitted by the bite of hard tick? Okay, hard tick, and the rash typically starts at the wrist and the ankles and then spreads to the ankles, palms and soles. Okay, then spreads to the palms and soles. Ankles is already there. Okay, it starts at the wrist and the ankles and spreads to the palms and soles. So this typical presentation of the rash, which starts at the wrist and ankles and then comes to the palms and soles, is typically seen in Rickettsia rickettsii. Okay, infection, which infection? Rocky Mountain spotted fever. That is RMSF. Okay, what is that? RMSF, Rocky Mountain spotted fever. And if you remember of that particular table of rickettsial family, epidemic typhus, endemic typhus, Rocky Mountain spotted fever, Indian tick typhus, scrub typhus, okay, all those, rickettsial pox and all. So I've already told up the arthropods also, louse, flea, tick, tick, mite. So that particular one helps here because they are talking about tick. So louse, flea, epidemic, endemic does not there. Rocky Mountain spotted fever is having that particular one, that is the tick. Is it fine? So this is typical of Rickettsia rickettsii, this particular one. Important is this, what does it, this does, Rickettsia prowazekii, it does epidemic typhus, okay, it does what? Epidemic typhus. And about the Rickettsia typhi, it does endemic typhus. And what about the Coxiella burnetii? This associates with Q fever, okay. Why it is termed as Q fever? Because this is termed as Q fever because nobody knows why it was happening before. So everybody was in this query that why is it happening? So that particular thing is termed as a query fever or Q fever. Okay, so these are the various questions which were asked up in the exam, and I suppose now you must be getting up this insight also, like this, the questions will be coming off with the integration fashion. Okay, so they will be giving you the test name, they will be asking the bacteria, they will be giving up this life cycle, and they will be asking up the parasites and all. Okay, and see this question, they have told up a clinical scenario and then they have asked of the media. So like that the questions will be coming up in any sort of exam which is coming off like next or anything. So remember this particular aspect, that this is the way to go for the future exams, and definitely if you have given up this particular CBoT, this is a rehearsal of the main exam, and if you keep on giving up these types of papers, your anxiety level will allay. Okay, you will not feel any sort of anxiety for the main exam, and it's a must recommended from my side that you should go for these CBoTs and you see the difference. I've already talked up to the various students, and they definitely have excelled well after attempting up these particular computer-based offline tests. Okay, so thank you so much from my side. Very best of luck for your future. See you. And once after this particular one. Okay. So bye guys. See you.
Comments. 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 Start. Hello friends, I am Dr. Harmeet Goel, Obs Gynae faculty. I will be discussing the Obs Gynae questions here. So let us begin with the first question, that is secondary postpartum hemorrhage is the bleeding from or into the genital tract that occurs within 24 hours, 24 hours to 12 weeks, 1 month later or after 12 weeks. You can keep on writing in the chat box. Keep on writing your answers in the chat box. Now, why this question has been taken? Because secondary PPH, many of the students, they are confused with the definition. So, first of all, remember secondary postpartum hemorrhage always occurs after 24 hours. If it is occurring within 24 hours, then it is primary postpartum hemorrhage, and where atonic PPH is the most common variety. So what are your answers? So welcome to this session. I can see the correct answers. Rohan, Saurabh, Abhi, Shivangi and others have written it very, very correctly. So correct definition for secondary postpartum hemorrhage is it is occurring after 24 hours to 12 weeks. So students have a tendency to just mark after 24 hours, but up to what time? So within 3 months of delivery, if any hemorrhage is occurring, first of all you have to rule out the delivery related causes. So this is what is the definition of secondary postpartum hemorrhage. Now postpartum hemorrhage, it can be primary PPH or it can be secondary PPH. So primary PPH is of two types. If it is third stage PPH or it is true primary PPH. Okay, third stage PPH is because of the retained placenta. Okay, it is because of the retained placenta. And true primary PPH is postpartum hemorrhage occurring after the delivery of the baby and the placenta, but within 24 hours of delivery. Where if we talk about the secondary PPH, it is occurring after 24 hours and within 3 months of delivery, that is within 12 weeks of delivery. Okay. Now, let us take this few of the single liners. This is again very important. Among all the other subjects, like if I talk about the clinical subjects, the Obs-Gynae is very scoring, and keeping in mind what is the present pattern of the questions, this CBoT session is been designed. So management of third stage PPH. What is that? If whole of the placenta is retained, as you can see in this maneuver. What is this maneuver? So management is always to be done in the operation theatre, and the management is manual removal of placenta under general anesthesia in the operation theatre. But if you are not able to find a plane of cleavage, then what is your probable diagnosis? It can be placenta accreta. If it is placenta accreta, increta or percreta, then there is a Nittabux membrane or the Deciduous basalis, this is deficient. So, the placental channels or the chorionic villi, they have invaded the myometrium. In that case, you will not be able to take out the placenta. So, in that case, you have to go for hysterectomy. Very right, Dr. Shivani, Dr. Ramesh, Dr. Montu, Dr. Dubey. You are all correct. Okay. So most common cause for secondary PPH is always retained bits of placenta. So there may be associated image based questions in that, so which has already been asked in the AIMS PG exam. So you should be able to answer that pattern. Now type of placenta that is responsible for secondary PPH is succinate churita lobe. Succinate churita lobe. Now, next question, which of the following parameters decrease during pregnancy? So, it is again one of the important questions, because many of the time the questions are being asked from the initial chapters which we might tend to revise. So, this is again important. Now, hemoglobin concentration, WBC count, ESR or plasma volume. What is your answer? Yes, you are right, Dr. Shivani, Dr. Abhi, you have written correctly. It is succinate churita lobe, which is an important cause for retained bits of placenta, and it leads to secondary postpartum hemorrhage. That is why it is very important, while you are conducting the delivery, you should not keep the placenta throw in the bucket. You should keep in the kidney tray, and then you should examine for the presence or absence of the cotyledons. So it should be intact fetal membranes that has come out, and cotyledons should be present. It should not be any missing cotyledon. Now, what is the next answer? Which of the following parameters decrease during pregnancy? So WBC count increases, ESR increases. It is a non-specific in this physiological changes during pregnancy, and plasma volume also increases. Plasma volume starts increasing as early as 8th week of pregnancy, and it is reached to 40 to 50% at 30 to 32 weeks of pregnancy. Okay, so hemoglobin initially, hemoglobin also rise to 18 to 20%, but the plasma volume is rising to 40 to 50%. So what happens? There is hemodilution of blood, because hemoglobin rise is less than the plasma volume rise. So I take the reference of Williams textbook, latest edition, 26th edition, and it says overall effect is hemoglobin concentration falls during pregnancy. So whenever such questions are being asked, always remember that net effect you have to write. So answer to this question is hemoglobin concentration falls because of the hemodilution of the blood. Now simultaneously you should be able to remember when do you call it as physiological anemia during pregnancy. Physiological anemia during pregnancy, what are the parameters? Hemoglobin 10 gram per deciliter, RBC count 3.2 million per cubic millimeter, okay, and peripheral smear shows normocytic normochromic anemia. So this parameters is very important to differentiate the physiological anemia from the pathological anemia. Now what is the WHO cutoff limit for anemia in pregnancy is less than 11 gram per deciliter, and according to Indian standards hemoglobin less than 10 gram per deciliter is the pathological anemia occurring during pregnancy. Yes, you are all writing very correctly. Now parameters that decrease during pregnancy and that increase during pregnancy, this you must remember. You can make a chart while you are revising the content. So RBC is rising, plasma volume is rising, heart rate is rising, stroke volume is rising, cardiac output is rising, all clotting factors increases, fibrinogen level is rising, GFR is rising, because there is expansion of the cardiovascular system, expansion of the hematological system. The parameters that fall is the diastolic blood pressure, mean arterial pressure, platelet count because of the gestational thrombocytopenia. And remember, this is an important question, which factor decrease during pregnancy is factor 11 and 13. They may ask these questions in the integrated manner in a long theory pattern. So this session of Obs Gynae is specially added these questions which is based on the INI-CET or like NEET PG pattern. This is just to boost up your confidence. Okay, then we will be adding up in the next CBoT sessions the integrated questions of Obs and Gynae as well. Next question. In 35-year-old pregnant female with hyperthyroidism, which antithyroid drug you should give in the first trimester which should not have any teratogenic effect? So what is your answer? What's your answer for this question? 35-year-old pregnant lady with hyperthyroidism, which antithyroid drug you would like to give? In the first trimester they have asked. I can see some of the correct answers. Dr. Abhi, Dr. Saurabh, Doc, Fusion, Medico, all this, Dr. Shivani, they have marked it very correctly. Always remember the answer is propyl thiouracil because it does not cause any teratogenic effect. So this drug is absolutely safe during pregnancy. Now as far as I remember, they have asked in the AIMS PG as well, what is the antithyroid drug of choice in the third trimester of pregnancy? So what is your answer? In the third trimester, if same options are given, so according to the latest guidelines, it is carbimazole that is recommended in the third trimester. Then they have also asked about the teratogenic effect. So if methimazole is given, it is known to cause teratogenic effect in the first trimester. Okay, so drug. So answer to this question is C, that is propyl thiouracil, which is safe, and if in the third trimester, then the answer is carbimazole. So why methimazole is not being preferred in the first trimester? Because of the teratogenic effect, and they have asked in the INI-CET exam that that image based question on the methimazole. Now induction of labor can be done. Yes. Aphasia cutis, very correct, Dr. Shivani, you have written it very correctly. Methimazole can cause aphasia cutis. Now, that was an image-based question of INI-CET exam. So, induction of labor can be done in all of the following conditions except sometimes, the long lengthy questions, you are able to grasp the answer because there are multiple hints in the question. But when it is asked in the simplified manner, in the single, single statement question, you tend to make mistakes. So, this is one of that question. So, the options are in this question: complete placenta previa, chorioamnionitis, intrauterine fetal death, and preterm premature rupture of membranes. Many of you might not be familiar with the term. This is preterm premature rupture of fetal membranes. That means fetal membranes rupturing before the 37 completed weeks, that is preterm premature rupture of fetal membranes. So what answer do you mark for this question? Induction of labor can be done in all except one situation, which is complete placenta previa. For that you have to do elective cesarean section at 38 completed weeks because lung maturity has been attained. Okay. Till if there is no bleeding, then you can put the patient on, conservative management. If any bout of bleeding can start in the complete placenta previa, your management from elective cesarean section can change into emergency cesarean section. If the pregnancy time is uneventful, then plan the elective cesarean section at 38 weeks. So many students, they tend to make a mistake. If you are asked whether you are going to do a lower segment cesarean section or you are going to do a classical cesarean section, so answer is always a lower segment cesarean section, because we have done plenty of cesarean sections during the PG time and during the SR-ship time. You can cut the lower uterine segment and cut the placenta and take out the baby, because you have to just do it immediately. You should not take it long duration to take out the baby in this case. So answer to these questions is complete placenta previa, while chorioamnitis, intrauterine fetal death, or preterm premature rupture of membranes, you can do induction of labor. If there is any sort of fetal distress or delay in delivery or non-progress of labor, or there is any sort of fever which is occurring, you might switch over to the emergency cesarean section. Next question: what does the following sign of ultrasound indicate? What does the following sign indicates? This question is specially planned for image-based question, and many of the students might not be knowing what is this particular image. Okay, so this image is, you can see the two amniotic sac and there is intervening tissue. So that means there are four layers, two amnion and two chorion. So this is diamniotic dichorionic type of twins, and this particular image shows lambda sign. Okay, this is lambda sign seen in dichorionic diamniotic type of twins. Now what is the type of sign seen in monochorionic twins? It is the T sign which is seen in monochorionic twins. Dichorionic twins have better chance of survival than monochorionic twins. So best perinatal outcome is dichorionic twins. Now, incorrect statement about the given condition is, what is this condition where they have already marked it? This is what they have marked, and some of the students might be confused. For them, just let me tell you, this is what you see the umbilical cord, and because the image is just red in color, so I am just making this blue. Okay, so what is this? What do you see? This image shows a complete placenta previa, transverse lie with complete placenta previa. So malpresentations are common in low-lying placenta. So can this be managed with expectant management if no active labor, active bleeding is present? This is true statement. Fetal surveillance with ultrasound at an interval of 2 to 3 weeks requires the expectant management. Yes, name of the expectant management is conservative management, and that conservative management is called as McAfee-Johnson's management. McAfee-Johnson's management. Tocolytics are contraindicated, And number 4, the given condition requires an indication for a cesarean section. In this image, there are 2 conditions. One is a transverse line, number 2 is a central placenta previa. So it requires a cesarean section, yes. So wrong option to me is the tocolytic agents are contraindicated. Tocolytic agents are not contraindicated. If the bleeding is very, very heavy and uterus is relaxed, then might not you give the tocolytic agents, but when the condition of the patient is been stable, okay, then tocolytic agents can be added to prevent the preterm labor pains. Why do we add tocolytic agents? We add tocolytic agents because we want to prevent the preterm labor pains. So which is the best tocolytic agent? You know, best tocolytic agent or the first line tocolytic agent is nifedipine. Nifedipine is the best tocolytic agent. Now, in this question, I hope it is very, very clear to you. So, they are talking about the McAfee-Johnson's management since it is a case of placenta previa. And mind it, when you're doing a McAfee-Johnson's management, in that case, period of gestation should be less than 37 weeks. Maternal and fetal condition should be stable and there should be no active bleeding, and the fetal heart rate should be absolutely normal. So these are the conditions. Fine. Next. Now after 12 weeks of pregnancy, a 36-year-old primigravida lady arrives for her first prenatal appointment. She complains of nausea, ongoing vaginal bleeding and pelvic pain, an abnormally big gravid uterus with a gestational sac. So while you're reading the question, this is a clinical question and this pattern of question has already been asked in the AIMS and PGI exams when they were taken separately. Now it is INI-CET exam. So they are already giving you hint. 12 weeks of pregnancy, she has bleeding, she has nausea, and it is the uterus is enlarged. That means the uterus is enlarged more than the period of gestation. That is what they are trying to give you the hint. And they have given the image, and in the image you can see the snowstorm appearance. So you have already made your provisional diagnosis. I can see Dr. Rajput, Medico, Dr. Abhi, Dr. Vikrant, Saurabh, you are writing absolutely the correct answer. This is H molar pregnancy, high ditiform mole, because this image is just to help you out. In Obs-Gynae, just reading the question and just marking some of the hints in your mind, you can come to arrive at the correct answer, and images are always there to help you out. So this is none other than high ditiform mole. Now ultrasound image shows snowstorm appearance. Snowstorm appearance. How to differentiate between complete mole and partial mole? That is a very, very favorite question. So correct answer is always karyotype. The complete mole is diploid, 46XX most commonly, and the partial mole is triploid. And the abnormal chromosomes are paternal in origin. Abnormal chromosomes are paternal in origin. This is very important for you to remember because it is the empty ovum which has got fertilized by the sperm. So it can be monospermy or it can be dispermy. So most common GTN developing after H mole evacuation. Friends, always remember it is residual mole which is the answer. Now, choriocarcinoma developing after a full-term pregnancy is always considered as high risk. Yes, you are writing absolutely correct answers. I can read the chat. So, most common GTN developing after an H mole evacuation, it is always a residual mole. Choriocarcinoma developing after a full-term pregnancy is always considered as high risk. Now, identify this image. This question is very, very important. This question has already been asked in the AIMS PG. Similar question has been asked in the FMG exam, and similar question has been asked in the NEET PG. Sometime they can ask you the full maneuver that is called as Leopold's maneuver, or sometime they can ask you just one grip and they can ask you which of the following is the grip. So what do you understand from this image? Image based questions are very, very easier in obs and gynae. You can mark always your correct answers and make it a point that all obs by gynae questions you are able to mark it correctly. Now identify the grip. What is this grip? Yes, you are absolutely right. The answer is the pollic grip. Fundal grip is the first grip. Okay. Umbilical grip is also called as the lateral grip. That is the second grip. Pollic grip is the third grip. And pelvic grip is the fourth grip. Now, when you apply the first grip, that is the fundal grip, the second grip is the lateral grip. Lateral grip. This is fundal grip. Third grip is the pollic grip. Pollic grip is for presentation. Presentation. If you are feeling the head, you call it as cephalic presentation. If you are feeling the feet, you call it as podalic presentation. And the fourth grip you apply is called as the pelvic grip. That is for engagement. Okay. When you apply these grips, what is the name of this maneuver? The name of this maneuver is called as Leopold's maneuver. Name of this maneuver when you apply the four grips is called as the Leopold's maneuver. Yes, Dr. Medico, you are absolutely right. Head is not engaged in this case. Okay, if you apply the fourth grip here in this image. So which is this image? This is the pollic grip, which is the third grip. Fine. Now next, which among the following is most specific chromosomal abnormality resulting in the spontaneous abortion in the first trimester? Always remember, first trimester abortion, most of the time it is the chromosomal abnormality. Chromosomal abnormality or the germplasm defect. So they have asked the specific chromosomal abnormality. If they ask you the most common chromosomal abnormality, then of course your answer is trisomy, and most common trisomy that causes abortion is trisomy 16. But if they have asked most specific chromosomal abnormality, then always mark the monosomy X. Most specific for first trimester abortion is always monosomy X. Just remember that. Yes, you are right. Now, true about the following condition. What is this image? First of all, you should be able to identify the image. This is the HSG image, hysterosalpingography, where a radio-opaque dye is being put into the uterus through a cannula. What is the name of the cannula? Leash-Wilkinson cannula. Leash-Wilkinson cannula. In one of the exam, they have asked the image of the instruments also. So in the next subsequent CBoT sessions, we are going to bring out the questions on the some of the questions of the on the instruments as well. Okay. So this image, what do you think is? So first of all, make your provisional diagnosis. I can see just one cornu of the uterus. So the HSG image shows the unicornuate uterus. It shows unicornuate uterus. Okay. So it is the class 2 Mullerian anomaly. This is true. It is the most common Mullerian duct anomaly. False. It is the anomaly with the best reproductive outcome. False. Best reproductive outcome is arcuate uterus. So best reproductive outcome is with arcuate uterus. Okay. So this is false. It comprises of 30% of the total cases of Mullerian anomalies. That is also false. It comprises only 10% of total Mullerian anomalies. So the correct answer to this question, it is class 2 Mullerian duct anomaly. Okay, and it has got a poor reproductive outcome. So you can revise this part. Classification. Class 1 is Mullerian agenesis or hypoplasia. Class 2 is unicornuate uterus. This is ASM ASRM classification, that is American Society of Reproductive Medicine. Class 1, this is very, very important for you to remember. So I have just given you this table. Class 1 is Mullerian agenesis or hypoplasia. Class 2 is unicornuate uterus, that is our present answer. Okay, class 3 is uterus didelphus, class 4 is bicornuate, class 5 is septate, and class 6 is arcuate. Arcuate uterus has got best reproductive outcome. And class 7 is DES related, that is diethylstilbestrol exposure. Okay, now next question. A 29-year-old married woman is undergoing in vitro fertilization, that is IVF, and due to tubal blockage, she was given gonadotrophic agonist, that is GnRH injection on the first day of the cycle and followed by gonadotropin agent. Usually, remember students, whenever you are preparing a patient for IVF, two types of injections are given for the hyperstimulation of the ovaries. Okay, that is HMG injection, which can be FSH injection and GnRH injection. And remember, whenever and you are observing, this monitoring is done by the transvaginal scan, and to trigger the ovulation, which is the injection that is given? Yes, you are absolutely correct. Injection beta HCG is given 5,000 units, like that is given intramuscular mode. So always remember, to trigger the ovulation, always it is HCG injection, no other option you can read, and there is no second answer, not even a differential diagnosis. To trigger the ovulation, it is always beta HCG injection. Next question, incorrect about the following. Now what is this? This is a female condom. Okay, first of all, try to identify the image. You can see two rings, here one ring, here two ring, and the length of this condom is around 15 centimeters. Okay, and now read the options. What is the wrong statement? Slippage is more common and needs practice. It is more reliable to breakage than the male condom. You already got your answer. It is, the breakage is more in the male condom, not in the female condom. So slippage is more in and needs practice, that is true. It causes more exposure to seminal fluid than male condom, true. Which with perfect use the pregnancy rate is 2.5%, that is true. So the wrong statement here is it gets broken easily while coitus more than the male condom, that is wrong. So breakage is more common in the male condom than the female condom. Option C is it causes more exposure to seminal fluid than the male condom because it is carrying the two rings and this is to be fit in the cervix. So the complete semen is present in this condom as compared to the male condom, because male condom just gets stuck to the penis. So some of the semen content can remain there on the penis. That is why the C option is also correct. Now next question, identify the following investigation for the cancer, cervical cancer screening. You can see the white patches on the cervix. This is none other than VIA. VIA is visual inspection under acetic acid. Visual inspection under acetic acid, and you can see the aceto-white areas. You can see the aceto-white areas. Now, according to the latest guidelines for screening of cancer cervix, when it is a resource-rich countries, then HPV DNA is the screening test. This is nowadays the first choice. Okay, so you can very well rely upon these answers. This I have added up to add on this content to you, because this is very, very important, as I am already working as a consultant gynae in the Cancer Institute, one of the reputed Cancer Institute of Delhi. So I can tell you very, very perfectly what is being followed. So HPV DNA is the first choice, but mind it, in the resource-rich countries. Pap smear is also a screening test, but it needs, like a confirmatory test. Co-testing. What does co-testing means? Co-testing means you're doing pap smear as well as HPV DNA test. HPV DNA test can be done by gene expert technique or other techniques as well. VIA is also, like when there is resource poor country or for mass screening, but this is very cost effective method. This is also a screening method. Now reflex testing. What is this reflex testing? Reflex testing means you have done PAPs. If the test is abnormal, you are doing HPV DNA test. So that is what means a reflex testing. So this slide, please go through. It is very, very important because in the latest pattern of exams, they are going to ask you these terms: HPV DNA test, pap smear test, co-testing, VIA and reflex testing. This is something which is very, very important. Now, 16-year-old girl was brought to the OPD with her mother with the complaints that she has not attained menarche yet. On examination, she is found to have widely spaced nipples. When you got your answer, she has not attained menarche, widely spaced nipples, there is no breast development, multiple pigmented nevi on her body and height is 4 feet 5 inches. What is your diagnosis? So you can make out your clear-cut diagnosis. This is Turner syndrome. This is Turner syndrome. So you have made the diagnosis in your mind. Clinical questions in Obs Gynae are more easy, okay, because there are lot many hints in the question. Now, tell me, which type of congenital heart disease is seen in Turner syndrome? First answer should be bicuspid aortic valve. If that is not given, then next answer is coarctation of aorta, which is given. This is true. There is also, like horseshoe-shaped kidney that can be an associated finding in Turner syndrome. Absence of uterus is a wrong statement. In this case, uterus is hypoplastic because there is no ovarian function. Okay, there is estrogen deficiency. Okay, so streak ovaries, that is also correct. Streak ovaries is also a correct finding. Okay, so I hope all of you have got the correct answers. The absence of uterus is a wrong answer in this question. Fine. Now, this is Turner syndrome where there is a widely spaced nipples and you can see that there is congenital webbing of neck. Karyotyping in Turner is 45XO and you can see, you can get an image of karyotyping. You can see one X chromosome is absent. Now, you can see in this image that there is widely spaced nipples, there is cubitus valgus deformity, there is low posterior hairline and this is short fourth metatarsal. Fine. So this is, like images are always there to help you out. Incorrectly matched pair. What is that? Cystocele, colposuspension, uterine prolapse, vaginal hysterectomy, rectocele, posterior colpoperineorrhaphy, and wall prolapse, sacrospinous fixation. What are your answers in this question? I am reading the chat box. What are your answers? You can keep writing in the chat box. Okay, so I can read the answers here. Uterine prolapse, vaginal hysterectomy is correct. Rectocele, posterior colpoperineorrhaphy is correct. Vault prolapse, sacrospinous fixation, this is also correct. So cystocele colposuspension is a false statement. For cystocele, the surgery for cystocele is anterior colporrhaphy. Anterior colporrhaphy should be the correct answer. Okay. Next, best test for ovarian reserve. So these are all the tests for ovarian reserve. That means number of the resting follicles in the ovary. So ovarian reserve, the best test is AMH, that is anti-Mullerian hormone. This is the best test for ovarian reserve. If its value is less than 1 nanogram per ml, that means it is poor ovarian reserve. That means it is poor ovarian reserve. Okay, so it is cycle independent. You can get a AMH test done anytime in the cycle of the female. This is a very, very important investigation in infertility cases. Anti-Mullerian hormone in the females is produced by granulosa cells after puberty. This is something which is very, very important. So anti-Mullerian hormone is the best investigation. Why? Because its value is not affected by FSH release and it is not affected by feedback inhibition at the level of pituitary. So it can be done any time in the cycle. So this is according to the standard textbook of gynae, that is Novak's Gynecology. Now 23-year-old married female presented with chief complaints. This question has been asked many times. It was asked in INI-CET. It is asked in NEET PG, okay. So, and also been asked in FMG exam, okay. Might not they give the image or they might give the image, that is, but you should be able to understand. So, greenish offensive vaginal discharge, irritation, itching around the introitus and pars speculum cervix is shown in the image. So, from the cervix, what do you see? This is what you see is the strawberry spots, okay. So that means greenish discharge. What is that? That is trichomoniasis, which is caused by a protozoa. So which color kit you will give? You will give the green color kit, okay, because this is vaginitis or vaginal discharge or vaginal infection. So please do revise this color code kits. Kit 1 is grey, that is for cervicitis. Kit 2 is green, that is our present answer. This is for vaginitis. Kit 3 is white, that is for non-herpetic ulcer. Kit 4 is blue, that is for non-herpetic allergic to penicillin. And kit 5 is red, that is for herpes. And PID, it is yellow, and inguinal buboes, it is black. So that's all from this Obs and Gynae session. We will be bringing up more interesting questions, integrated manner, more image-based questions, instrument-based questions will be also added. So all the best for your upcoming exams. And keep on, proceeding for the CBoT next series as well. Thank you.
Hello friends, hope you are doing well. Now we are going to discuss psychiatric question. 5 questions are there and you will see the beauty of psychiatric questions. Even a single word can change the answer. We start with question number 1. A 38-year-old lady has been convinced for 2 years. Whenever questions are asked in psychiatry, always point out duration of illness, 2 years, that her neighbor is watching her using hidden cameras. As a result, she changed the lock and confronted her neighbor. She continues to believe her lie even after an investigator found no proof of surveillance. Means this is false belief, firm belief, unshakable belief. You know the definition of delusion? False, firm, unshakable belief contrary to evidence that is not supported by socio-cultural norm. Means one delusion is there in this patient for 2 years. For 2 years, okay. Now she has no more delusion thought. Hallucinations are not there. She carries on her normal daily activities and employment. Diagnosis very good. All of you have given the correct answer. Persistent delusional disorder. Definition of persistent delusional disorder: if one or related delusion for more than 1 month according to DSM-5 or more than 3 months according to ICD-11. Even if you don't remember the duration, most of the time questions are asked in such a way they give a large duration, just like in this question they have given 2 years. So both criteria are fulfilled. One delusion is there. Diagnosis is persistent delusional disorder. But I will extend the discussion. In persistent delusional disorder, there may be occasional hallucination. Occasional hallucination may be present. Means persistent delusional disorder, hallucination are usually not present, but occasional hallucination may be present. You will give me answer. I change only 1 or 2 words. Look at the screen. I change Rita has occasional hallucination. Yes, Rita has occasional hallucination. Please do comment. What is the answer? Is there any change in the answer? Occasional hallucination is there? Yes, in persistent delusional disorder, one hallucination or related one delusion and related delusion may be present, and occasional hallucinations may be present. The answer would remain same. But in the same question, if I remove this occasional word, yes, I remove this occasional word. Now what is the answer? Means this lady now has delusion and hallucination. You know, delusion plus hallucination more than 6 months. Diagnosis is schizophrenia. In this question, they have given paranoid schizophrenia. This is ICD-10 classification. ICD-10 told that schizophrenia may be of multiple types: paranoid schizophrenia, heavy phrenic schizophrenia, but DSM-5 and ICD-11 has removed these subtypes. This may be a potential question. So ICD-11 updates, questions are being asked. One update, subtypes has been removed. So schizophrenia means schizophrenia. Clear? Very good. Correct answer. To solve clinical question, I will make a flow chart. If clinical question suspiciousness is there, and they say that delusion is present, plus occasional hallucination present, या no hallucination, the diagnosis would be persistent delusional disorder. Clinical scenario is given, suspiciousness is there, delusion is present, plus hallucination is present, both are present for more than 6 months, DSM-5, diagnosis is schizophrenia. Suspiciousness is there, no delusion, no hallucination, only suspiciousness is present since adolescence, then answer would be paranoid personality. So clinical questions are asked. So again I repeat, in this question, if same question is there, then the answer is PDD. If occasional hallucination are there, answer remains same, PDD. If hallucination and delusion both are there, the answer would change to schizophrenia. Second question, second question. By this question, you will remember all the good prognostic factor of schizophrenia. A 48-year-old female was brought to psychiatry OPD because of her abnormal behavior following sudden loss of long-held job. There is stressor. Stressor is present. In this question, there is stressor. After stressor, her family noted that she had developed unfounded suspicion. Means suspiciousness is there. Suspiciousness, maybe delusion, okay? That others were conspiring against her, even though her husband affirmed that there was no basis for such belief, means this is delusion. She also reported hearing voices criticizing her action. Yes, delusion and hallucination both are present. Delusion and hallucination are called positive symptoms of schizophrenia. Positive symptoms of schizophrenia. Delusion and hallucination, question is asked that positive symptoms are due to increased dopamine at mesolimbic pathway. Mesolimbic pathway. Yes, limbic means long. Long means increased dopamine. Yes, positive means extra. Extra symptom, positive symptom due to increased dopamine at mesolimbic pathway. Positive symptoms are there in this patient. She frequently broke down in tears, showing an openly emotional state. Means she is having emotions. She is having emotion. Okay. Neuroimaging, CT, MRI are normal. History of depression is there. Before going to the answer, I will discuss a old classification, T.J. Crow. T.J. Crow gave classification of schizophrenia. This classification is not used nowadays, but we use for the assessment of good prognostic factor and poor prognostic factor. According to this classification, schizophrenia is of two types, type 1 and type 2. Type 1 onset is acute. Type 2 onset is insidious. Precipitating factor present in type 1. Symptoms are positive symptoms. Family history of affective disorder, point it out. Type 1 is having good prognosis, I write here. Yes, type 1, very good evening, Shubham. Yes, good prognosis. So, if onset is acute, good prognosis. Precipitating factor present in this lady, precipitating factor is present, loss of job, good prognosis. Positive symptoms are there, good prognosis. Family history of affective disorder, yes, depression is affective disorder, good prognosis. Emotions are present, yes, in this patient, yes, there was showing openly emotional state, emotions are present, good prognosis. CT MRI normal, good prognosis. Opposite, poor prognosis. Precipitating factor absent, negative symptoms, poor prognosis. Family history of schizophrenia, I will highlight this. Most of time whenever table is there, they say family history present, absent. But in schizophrenia, if family history of affective disorder, good prognosis. If family history of schizophrenia, poor prognosis. Point it out. Emotion present, good prognosis. Absent, poor prognosis. Question. CT MRI, if finding present, this question has been asked in JIPMER, that in schizophrenia, few patient we found that there is dilation of ventricle, lateral ventricle, third ventricle, cortical thinning, and what was the question? Atrophy of medial temporal lobe. Atrophy of medial temporal lobe. Temporal lobe. So if CT MRI finding is there, prognosis is poor. So type 2 is having poor prognosis. Type 2 is having poor prognosis. So in this question, type 2 is having poor prognosis. So answer is C, not D. Now recent update in synopsis 12th edition. क्या recent update है? Yes, I have taken from the synopsis 12th edition. Living in developed country is good prognostic factor? Previously, we used to say, very good evening, Santosh. Previously, we used to say that developing country is good prognosis. Actually, American was so disturbed that all the research we are doing, but prognosis is good in developing country. But they could not understand the prognostic definition in India. In India, what we consider, if a patient is taking food, not fighting anybody, sleeping, he is okay. But in foreign countries, they do consider that the patient of schizophrenia must do his own work. Okay, so this is to simplify and so that you may remember. Means nowadays the definition, they recognize that in India they are using prognostic definition differently. Previously we used to say that schizophrenia has good prognosis in developing country, but latest edition of synopsis, living in developed country or developed country is good prognostic factor. This is recent update. Okay. Female, good prognostic factor. Late onset, more than 45, good prognostic factor. So all these questions has been asked. Next question. Before solving that question, I will make a flow chart. Suppose you find a clinical question on eating disorder. So many questions are there. Okay. Eating disorder. There are two possibilities. Either patient is taking less amount of food, less food, or large amount of food, large food. If less amount of food is being taken, we will search the cause. If patient says that, or we found that in question, we found that patient is not taking food because of taste, because of smell. What I said, due to taste, smell, then it is avoidant, restrictive food intake disorder. Intake disorder. If patient is concerned with body image disturbance, point it out, patient is taking less food because of body image disturbance, and BMI reaches less than 18.5, less than 18.5 BMI reached, according to ICD-11. So if a patient is taking less amount of food, and you found that patient is not taking because of the taste, because of the smell, then it is avoidant restrictive food intake disorder. If patient is not taking food, restricting the diet, if patient is having body image disturbance and BMI goes less than 18.5 according to ICD-11, in ICD-10 it was 17.5, ICD-10. Whatever updates are there, they are potential question. Recently, in last 2-3 years, they have asked few questions on these updates. So you must know. Yes, less than 17.5 or 18.5 according to ICD-11, then you will say anorexia nervosa, restrictive type. If a patient is taking large amount of food, binge eating, जिसे कहते हैं ठूसना, large amount of food being taken, then binge eating. If after binge eating, purging is there, means after taking large amount of food, they are inducing vomiting, then binge eating and purging, then you will search for BMI. If BMI is less than 18.5, then it is anorexia nervosa, binge eating purging type. Point it out. Means if in clinical question binge eating purging is there, you will search for BMI. If BMI is less than 18.5, you will say anorexia nervosa, binge eating purging type. But if BMI is more than 18.5, recently asked question, more than 18.5, then bulimia nervosa. If only and only binge eating is there, no purging, then it is binge eating disorder, most common eating disorder. Yes, हम सभी binge eating करते हैं, most common eating disorder. Now you can tell me the answer. Answer please. Yes. Yes, what is the answer? Yes, 29-year-old executive has had secret overeating episode. Binge eating episodes are there. Yes, she felt guilty but don't purge. means binge eating is there, purging is not there. Her relationship and self-esteem are affected by her overweight. She has history of depression. Yes. What is the most probable diagnosis? Answer is yes, binge eating disorder. So in this question you will remember all these three are more common in female than male. Yes. Anorexia nervosa, underweight. Underweight means BMI less than 18.5 according to ICD-11. Okay. Bulimia nervosa, weight normal or near normal. Near normal. Binge eating disorder, overweight. Overweight. Okay. So answer is C. Next question. A 35-year-old married man present to psychiatrist reporting a persistent and intense sexual arousal by wearing female clothes. Okay. He shares that this practice started in late adolescence. Now, wearing female clothes has become the integral part of sexual experience. Again, before solving the question, I will make a flow chart. Yes, these flow charts are really important. So many questions has been asked recently on these topics and potential topics these are. Okay. So if patient wear clothes of opposite sex, wear clothes of opposite sex. Yes, you will search if patient wear clothes of opposite sex and want to change sex. Want to change sex. Patient says that I am a man trapped in female body. I am a female trapped in male body. Then it is transsexualism. Transsexualism. Very good. Correct answer you have given. Yes, transsexualism. If patient wear cloth of opposite sex just for temporary feeling, don't want to change sex, then it is dual role transvestism. Dual role transvestism means patient would wear just for temporary feeling, don't want to change sex. If wear clothes for sexual arousal. Thank you, dear. Yes, really these questions I have taken from recently asked topic, and these are high yielding topic, and trust me, they are changing a single word, two words, and totally answers are changed. So it is a trap. Not only in this subject, other subjects they are framing question in such a way that they will twist the language and answer would be changed. Just like wearing clothes of opposite sex. If want to change sex, then it is transsexualism. Don't want to change sex, no sexual arousal. I can write here no sexual arousal, only temporary feeling, then dual role transvestism. For sexual arousal, just like in this question, then it is fetishistic transvestism. Then it is fetishistic transvestism. Okay. So in this question, there is fetishistic transvestism, transsexualism, want to change sex, then transsexualism. What is fetishism? Means sexual arousal and gratification by non-living objects. Gender dysphoria is a latest terminology, DSM-5. ICD-11 has changed the terminology. Point it out. Why I am telling you? Because they will give the same question and they will confuse you in the recent changes in the name. In ICD-11, the name has been changed to gender incongruence. And ICD-10, the name was gender identity disorder. Transsexualism is a part of gender identity disorder. So gender dysphoria is a broad term. Okay, DSM-5. So in this question, answer is D. You will remember the flow chart. Yes, whenever we are close of opposite sex, you will remember this flow chart of eating disorder. Yes, then this recent update, synopsis 12th edition. Yes, and this flow chart of suspiciousness. Now the last question, again important, so many questions from the topic recently asked. Autism spectrum disorder according to ICD-11. Yes, according to ICD-11, DSM-5, ICD-11, DSM-5, the name has changed to autism spectrum disorder. Previously, the name was pervasive developmental disorder. Before that, I will explain what is autism. Yes, suppose a patient is doing like this. Child hai, the 3-year-old, 2-year-old child, 3-year-old child, less than 3 years, doing like this, no eye-to-eye contact, means no social interaction, repetitive behavior, no language, no communication, 3 criteria. Previously, we used to say, if you want to make the diagnosis of autism, you should have 3 essential criteria. So, autism means impairment in social interaction, no eye-to-eye contact, no social smile, no attraction towards mother, no emotions for mother, no stranger anxiety, no social development. First criteria. Repetitive restrictive behavior, stereotypic behavior, wringing of hand, head banging, playing with the same toy, arranging toys in a single line. These are stereotypic behavior. Third criteria was impairment in communication and language, but DSM-5 and ICD-11 has removed this third criteria. Please do comment answer. Please do comment answer. Now only 2 criteria are there, autism spectrum disorder. Please, yes, he has his attention fixed. Means they have given the diagnosis of autism spectrum disorder. They want to know what are the essential criteria for autism spectrum disorder. Bright red wrapper in room stress scan. Okay. So this is repetitive behavior, essential criteria. Does not seem to respond to affection, means no social interaction, essential criteria. Child always lining up his toys. Yes, means repetitive behavior, essential criteria. Yes, these 3, 1, 2, 3. Reports that she has weak language development and communication. Language and communication, previously it was criteria for autism, but autism spectrum disorder has removed this criteria. Okay. 5th point, reported that has minor intellectual disability. Intellectual disability, minor. Yes, actually autism, 33% patient of autism have mental retardation, but it's not a diagnostic criteria. So answer is C. Before ending the session, let me summarize. This is very important topic. Recently 3-4 question has been asked. Previously ICD-10 said pervasive developmental disorder, neurodevelopmental disorder include 4 diagnoses: autism, Asperger syndrome, Haller and Rett syndrome. In autism, all these 3 criteria are fulfilled. In Asperger syndrome, language is normal. Question, language is normal. Question has been asked. Haller syndrome, all these 3 criteria are there, but after 2 years, point it out, Haller syndrome after 2 years, means up to 2 years child is normal, then regression occur. Rett syndrome, all these 3 features are there, but after 5 months, normal development, recently asked topic, normal development till 5 months, then regression. If you have seen rat is having very small head, microcephaly. Question. So in long clinical question of Rett syndrome, you will find that there is microcephaly. Yes, 70% patient of Rett syndrome have seizures. Rett syndrome, recently asked question in INI-CET. Yes, X-linked dominant. Recently asked question in NEET. Yes, trofinetide. Recently approved drug for Rett syndrome. Recently asked question. Other than that, question may be asked that Rett syndrome is having MECP2 gene. Mnemonic banaya Mickey Mouse. MEC Mickey, mouse pair of 2. Mickey Mouse, pair of two. Yes, this is mutation, X-linked dominant, more common in females. Okay, let me point out one more thing again. Autism, Asperger syndrome, Haller syndrome, previously these were separate diagnoses. Previously these were separate diagnoses, but now these name has been removed and they are included in a single spectrum. The name is autism spectrum disorder, in which only two basic criterias are there. And the last, autism story mnemonic, autism as auto. How many tires are there in auto? 3 tires are there. So age criteria 3 year. How many criteria of autism diagnosis? 3 criterias were there. Auto is mainly run by male. So autism is more common in male than female. Most of the childhood psychiatric disorder are more common in females. Sorry, more common in male, except Rett syndrome. Again, I repeat, all childhood psychiatric disorder are more common in males, except Rett syndrome, which is more common in female. One question was asked that autism is associated with tuberous sclerosis, Fragile X syndrome, phenylketonuria. How to remember? If auto, tire is punctured, tube will be sclerosed. Tire is punctured, tube is closed. If tube is closed, you will use X jack. Looks like X, Fragile X. And in COVID pandemic, he was keeping phenyl bottle in place of sanitizer. So phenylketonuria. And one more association, congenital rubella. Bella. It is BEL, congenital rubella. This is autism awareness ribbon, may be asked. Thank you. Best wishes for your exam and remain connected. Do attempt all CBoT. Okay, friends? Thank you for patience listening.
Hello friends, how are you? This is Dr. Saravjit Singh, your very own ENT faculty. And I'm here to discuss the CBoT ENT questions that were asked today. If I am audible, loud and clear, please give me a thumbs up. You can see the chat over here given to me. And if you are all able to see me and listen to me, please give the thumbs up so that we can start with the ENT discussion. Okay, so Yes, can I have the thumbs up? All right, let's start with the first question. So, going with the first question over here. Very good, thank you everyone. Let's start with the first question over here. A patient presents to the OPD with facial asymmetry. So, you know, the first thing over here, the question itself tells you that this question is going to be about the facial nerve. With facial asymmetry, dribbling of saliva and drooping of angle of mouth on the left side. Okay. He gave history of trauma resulting in temporal bone fracture few months ago. The diagnosis of facial nerve palsy was made. So, we already have a diagnosis of facial nerve palsy with us over here. All right. You perform certain tests to localize the site of lesion. So, this question, friends, this concerns us with the topo-diagnostic tests of facial nerve. Okay. So, topo-diagnostic test of facial nerve, that's what this question concerns to us about. You perform certain tests. So, what are the topo-diagnostic tests of facial nerve? The topo-diagnostic test of facial nerve, we have the Schirmer's test, right? Okay. Number 2, we have the stapedial reflex test. We have the taste test. And number 4, we have the submandibular salivary flow rate. So, these are the 4 topo-diagnostic tests that we have, and out of them the 3 have been mentioned to us over here. We know that the Schirmer's test over here is normal. The stapedial reflex is present, that means it is also normal, right? The taste of anterior 2/3 of tongue is gone, so that is absent. Now, this test is abnormal. The corneal reflex is absent. So, corneal reflex, that's the terminal branches which is supplying the corneal reflex. 5th and 7th now both are involved over here. 5th we know is the afferent, the 7th is the efferent over here. So, 7th is also involved over here. So, that is the end terminal, the muscular branches of facial nerve. So, there is a facial palsy, corneal reflex is absent, that we can understand, right? So, out of the 4, the 3 topo-diagnostic tests are mentioned. Pranam, Pramod, thank you for everyone. Now, tell me what is the answer to this question. The question based upon the result, what is the site of facial nerve lesion? Before the geniculate ganglion. So, before the geniculate ganglion, I can make it easy for you. Before the geniculate ganglion, so that means it can be segment 1, segment 2 or segment 3A. Horizontal segment we now call it as segment 3B. Vertical segment we call it as segment 3C, and at the stylomastoid foramen, that means just before the start of the segment 4. Okay. So, now based upon this, what is the site of lesion? Now, let's understand a few basics over here about these topo-diagnostic tests. The first basics, you see the Schirmer's test. Now, the Schirmer's test, we see this Schirmer's test. So, this is also known as lacrimation test, and this is based upon greater superficial petrosal nerve, that is your GSPN. Hello Naveen. Hello Naveed. I'm good, thank you. So, it is based upon GSPN, which is supplying the lacrimation. Okay. So, this test is normal, and we know that means this GSPN which is coming from the first genu. So, that means the nerve till first genu is normal. Okay. Now, the second test which was given to us was the stapedial reflex test. So, stapedial reflex test, it was also said to be present. Present means over here, this is also normal. Now, stapedial reflex test, it is supplied by stapedial nerve. Stapedial nerve comes from second genu, and this is normal. That means the facial nerve is normal till second genu, right? Okay. Next, we can see over here the third test that was given to us was the taste test. Now, we know that the taste test is supplied by chorda tympani, and the anterior 2/3 it is supplied by chorda tympani. Chorda tympani comes out just before the stylomastoid foramen. Okay. So, that means this test, as we know in the question, the test was absent. So, this test is abnormal. So, that means injury has taken place. Okay. The injury to the facial nerve, it has taken place between the second genu, right, and the stylomastoid foramen. Okay, and this segment is the vertical segment, that is the segment 3C. Okay, we call it as the vertical segment. You can also call it as the mastoid segment of facial nerve. So going back to the question, what is the site of lesion over here? Okay, so you can see that the site of lesion will be the vertical segment or the segment 3C, or you can say the mastoid segment. Right, am I clear? Shall we move on to the next question, friends? You want to ask me any question, please ask me. Please write in the comments box. I am looking for all your replies, and I want that all these topics, they should be crystal clear to you once I stop this discussion. Okay, so any question, anything that you have, even if I have bypassed that question, I have gone to the next question, just write in the comment box and I'll reply to them. Right? Okay, so that was the first question. Right, so we go on to the next question. If you have any comments, keep on writing. 18-year male, now this is a repeat question. It has been asked multiple times. Why I have given you? Because if you don't know these kind of questions, then you are really in trouble. Okay, so this is a kind of question which has been repeated multiple times in the exam, and it is one of the favorite topics of the examiner. They love to ask about this. All right, so a 18-year-old male is presented with chief complaint of recurrent epistaxis with nasal blockage. Okay, so I always say to my question, can you review the anatomy of facial nerve, all the GYNU? So we'll do that at the end. Right, Rohan? Okay, so we'll do that at the end. So 18-year-old male. Now whenever I say that there is a teenage group plus male plus epistaxis. Okay, so teenage group, male epistaxis, your first diagnosis has to be GNA, juvenile nasopharyngeal angiofibroma. That's a classical thing. Okay, if the examiner says recurrent epistaxis, that's a bonus hint. Recurrent epistaxis is a bonus hint. Okay, if the examiner says nasal obstruction, that is also a bonus hint. So these two are bonus hints. Okay, now the next hint over here which is given to us is a polypoidal mass is seen going from nose to the nasopharynx, completely occupying the posterior choana. So that means the diagnosis of GNA has been confirmed to you. Right? So we have a confirmed diagnosis of GNA. Now what is the investigation of choice? We all know that the investigation of choice is contrast enhanced CT scan. Okay, right? So this is the investigation of choice that has been asked to you. Now remember, we also do MRI. Okay, this MRI is done if there is intracranial extension. Okay, so it is not the investigation of choice. It becomes investigation of choice only when there is intracranial extension. Right? Okay, biopsy, yes, Naveed, you're very right. Biopsy, you have to remember, this is absolutely contraindicated, and sometimes this question is also asked, which investigation you will not do. Right? Angiography. Angiography is also done. When is it done? To know the feeding vessels. So before surgery, sometimes the surgeons, they like to know the feeding vessels. Sometimes even during this before surgery, they may also think about embolization. So they may plan for embolization pre-operatively. 1 or 2 days before that, angiography is done, and at the same time embolization is done to decrease the bleeding. However, nowadays, we do endoscopically, so I personally don't do embolization. Okay, so we try to go for a centrifugal dissection, ligate the vessels, and then go and remove the tumor. Right? Okay, so this is about the GNA. Let's look over here. When you do a contrast enhanced CT scan, what do you get? You get a enhancing mass. Okay, now where is this enhancing mass? How does it look like? Now this is a dumbbell shaped enhancing mass. So enhancing mass means more intake of contrast. Okay, I have not shown the contrast study over it. This is the non-contrast study. But when the contrast will come out, then you will see that this is all white. Okay, so this is a dumbbell shaped mass over here like this. Okay, so mostly it is like this generally. right? So this is a enhancing dumbbell shaped mass over here, right? Now, what do you see over here? Two things. What do you see? Two things. Number one, antral sign. The posterior wall of maxilla is pushed anteriorly. So antral sign or Holman-Miller sign. Okay. And secondly, you see over here, this is pterygomaxillary tunnel. You can see this tunnel over here. This tunnel is very, very wide right now. Okay. So you can see the tunnel. It is very, very wide right now. This is known as Hondusa sign. Right? Yes, Naveed, frog face deformity is seen when this tumor goes into the orbit. Okay, so it pushes the eyeball outwards, okay, and laterally. So there is exophthalmos and there is telecanthus together, proptosis plus this telecanthus. This is known as frog face deformity. Right? Okay, let's go to the next question. Third question over here. 25-year-old female comes to your OPD. So, you know, when you are solving these clinical questions, what you need to do is you need to break them down. Okay, so 25-year female comes to your OPD with complaints of bilateral progressive conductive hearing loss. Right? She gives a history of hearing better in noisy environment. What do you call it, hearing better in noisy environment? Come on, guys. Hearing better in noisy environment, that is known as paracusis willisii. Okay. See, in the question, in clinical questions, keep looking for these hints. If you get these kind of hints, your entire question becomes very, very easy. You know, one word, one hint may solve the entire question. Where do we have paracusis willisii? We know paracusis willisii is seen in cases of otosclerosis. Okay, so this is seen in otosclerosis, right? So we know that this patient is having otosclerosis. What is the clinical history of otosclerosis? Otosclerosis, we know the clinical history. The patient is female, 20 to 30 year age group, presents with bilateral hearing loss, and this hearing loss is conductive hearing loss by nature, right? Okay, and our question satisfy all of this. 25, female, bilateral, conductive hearing loss, and then there is a history of paracusis willisii. On examination, the tympanic membrane appears flamingo pink color. Okay, so flamingo pink color tympanic membrane, that's known as Schwartz sign. That's known as Schwartz sign. Okay, so another big hint given over here, flamingo pink color. So many hints given to you over here. Okay, which of the following can be seen in the pure tone audiometry of this patient? So the examiner has not asked you the diagnosis. He already knows that you must have made the diagnosis. He's asking you another feature of otosclerosis. So otosclerosis topic, if you know completely, you can solve this. What do you see in pure tone audiometry? In pure tone audiometry, okay, see pure tone audiometry in case of otosclerosis, you will have conductive hearing loss. So that means you will have a AB gap. Okay, anything else of importance? Anything else of importance? Yes, guys, you have a dip at 2000 hertz. Now, very, very important thing that I have told you in my lectures of bone conduction. Okay, this is a disease of air conduction, but we have a dip in bone conduction at 2000 hertz. Okay, so dip in bone conduction curve at 2000 hertz. Now remember, there is a similar dip at 4000 hertz. Okay, this similar dip at 4000 hertz, this is seen in case of noise-induced hearing loss, and this is known as Boiler's notch. Okay, this notch over here, this is known as Kerhart's notch, and that is known as Boiler's notch. Right, friends? Yes. Okay, so let's go to the next question over here. During your postings in the ENT department, you are asked to take the history of a patient suffering from quinsy. So we have a quinsy patient over here. The patient complains of sore throat, difficulty in swelling, and earache. Okay, so three things we have: difficulty in swallowing, sore throat, Of course, that will be there, and earache. Which nerve is responsible for this referred pain in the ear? So we know that this earache, this is a referred otalgia, and this referred otalgia is because of ninth nerve, glossopharyngeal nerve. Okay, so this is because of glossopharyngeal nerve, which is, lies lateral to the superior constrictor muscle. Okay, superior constrictor muscle, this forms the bed of the tonsils. Okay, it forms the bed of the tonsils, and this superior constrictor muscle, lateral to it we have the glossopharyngeal nerve. This nerve has a branch known as Jacobson's nerve in the ear, and it is responsible for this referred otalgia. Okay, now remember, there are a few things. If we have anterior 2/3 of tongue, now this question is sometimes asked, so just remember, anterior 2/3 of tongue, what do we have? We have the chorda tympani. Okay, so we have the chorda tympani. We also have the lingual nerve. Lingual nerve supplies the touch temperature sensation. Okay, so this nerve is generally responsible for the referred pain to the ear. Okay, from the anterior 2/3 of the tongue. Tonsils, I've told you. Okay, posterior 1/3 of tongue. Now just remember, lingual nerve also supplies the floor of mouth. So floor of mouth also will go over here. Lingual nerve, that is the branch of the 5th nerve. So this is by the 9th nerve. Okay, tonsils and the posterior 1/3 of tongue. Now in case of larynx, we have the 10th nerve, vagus, which is generally responsible for the referred otalgia to the ear. So remember all this. This is asked in the exam many times. Okay, which nerve is responsible for which referred otalgia? All right. Now, next question. A 35-year-old female complaining of nasal obstruction, crusting, and foul-smelling discharge. Okay, so 35-year nasal obstruction, crusting, foul-smelling discharge from the nose has been diagnosed with atrophic rhinitis. So you already have a diagnosis, friends. Diagnosis is atrophic rhinitis. You prescribed alkaline nasal douching for the removal of crust. Very good. That's one of the treatment. What is the composition? Yeah, so tricky question. These kind of tricky questions were asked this time in the FMG exam. They asked you one step beyond of what you know. So sometimes examiner do this thing. These questions are there. Approximately 10% questions will be teasers for you. Okay, so the teasers means you know everything, but you don't know the answer. Don't worry, they are just to frighten you. Okay, so this question is a teaser because you know everything, the diagnosis is made, you know alkaline nasal douching is there, but you don't know the answer. Okay, so this was a teaser question to you. Even if you don't know these kind of questions, it's perfectly okay. But today I'm going to tell you about this. So what do you use for alkaline nasal douching? You use 3 things: sodium chloride, sodium bicarbonate, and sodium biborate. Okay, so if you know this thing, at least you can rule out this option and you can rule out this option. Okay, so you have to apply some logic. You are at 50%. Okay, so A, B, C, and D. Sorry, the nomenclature over here is wrong. A, B, C, D. Okay, so if you know the answer, if you know what is there in alkaline nasal douching, at least you can rule out 2 options. 2 are left. Then you don't know what to answer, you can mark any of them. You will have at least 50% chances of getting it right. And by mathematics probability, that's a very good chance. All right. So even in teaser questions, yes, you are able to solve them at least 50%. All right. Now over here, this is just a mugging up answer. It is 2:1:1. We put more sodium chloride, twice the ratio, than sodium bicarbonate and sodium biborate. So we make it a alkaline nasal douching solution. Why do we use alkaline solution? Why? Because Klebsiella is not able to grow in alkaline medium, right? So we make the medium alkaline. So that's the answer over here to this question. Hi Tarif. Okay, let's go to the next question over here. Very simple, straightforward question. All you need to remember is the anatomy. A child presents to emergency department with nasal bleeding. You tried to manage the patient conservatively, but the bleeding did not stop. You therefore decided to ligate the artery responsible for bleeding. So which artery do we ligate? We ligate the artery of epistaxis, main artery involved in epistaxis. So which is that artery? Which is that artery? That artery is sphenopalatine artery. Okay, sphenopalatine artery, right? Okay, so let's look over here, shall we? Number 1A, what is this? This is anterior ethmoidal artery. This is anterior ethmoidal artery. What is this? This is posterior ethmoidal artery. Okay, both of these, they are branches of ophthalmic artery. Ophthalmic artery is a branch of ICA, right? Okay, then number C, what is this? Number C we know is sphenopalatine artery. Yes, sphenopalatine artery. Okay, number D, this is septal branch of superior labial artery. Okay, and number E, what is mentioned over here, this is greater palatine artery. Right? Okay, so which artery are we going to ligate? We are going to ligate the sphenopalatine artery. That's our answer to this question. Okay, so C option is the answer to this question. Right? Okay, I hope you are able to understand all this. Please write your comments in the live chat. I'm watching that, and if you have any questions, I'll be happy to help you there. Right? Okay. Next question, a 15-year-old boy taking treatment for depression in the psychiatric department. Okay, so teenage group boy taking treatment for depression in the psychiatric department is referred to ENT for evaluation of childlike voice. You know, when we are children, we all have a high tone, high pitch voice. Okay, when we are all children, we have high pitch voice. And who have high pitch voice in adulthood? Females. Okay, so in children, all of them have the high pitch voice, and in adults, who has the high pitch voice? Females. Okay, so evaluation of childlike voice over here, right? So that means female like voice, right? So that means patient is having puberphonia. Okay, that itself gives you the answer, right? Puberphonia is generally seen in males. It is seen in males who are having some kind of emotional developmental problems, right? Okay, he has this voice disorder for 3 years. On examination, the voice appears to be too high pitched for his age. So this is further defined for you, right? What is the probable diagnosis? The probable diagnosis over here is puberphonia. As I have told you, with the first line only you were able to diagnose it. But, you know, the question may be changed, may be twisted. The question the examiner may ask, what is the treatment? If the treatment for puberphonia is asked, you know, what can you do for puberphonia? You'll first give speech therapy. If the speech therapy doesn't work, then you can go for thyroplasty. Which type of thyroplasty? Type 3 thyroplasty. Right? Spasmodic dysphonia when the muscles are under spasm. Right? So this is a neurological disorder where the muscles undergo spasm. Dysphonia plica ventricularis is another disorder where the vestibular folds, also known as ventricular folds, which were earlier known as false vocal cords, they start taking the function of voice production instead of the vocal folds. Right? Habitual dysphonia when the person is speaking in a wrong way for a very long time. So that's a habitual dysphonia. Right? Okay, I think I have explained all the 4 types of voice disorder that are mentioned over here. Let's go to the next question. This probably is the last question that was asked from ENT in the today's CBoT. A mother brings her 1-week-old infant, so 1-week-old infant neonate, to you with complaints of noisy breathing. Okay, noisy breathing. So noisy breathing means stridor. Generally it means stridor. Okay, that worsens during feeding. Now why will it worsen during feeding? Because in feeding we place the baby in the supine position. Normally we put the child, we can put in the prone position. So we know there is a disorder, I'll come to that. The image of the direct laryngoscopy is shown below. So that's a spot diagnosis, guys. What is this? This is omega shaped epiglottis. Thank you very much for all these thumbs up. Okay, so omega shaped epiglottis. All right, so which of the following is false regarding this child's condition? So what is the diagnosis that you have? Come on. Yes, we all know. The diagnosis is laryngomalacia, omega shaped epiglottis, that is spot diagnosis, laryngomalacia, right? And the stridor in laryngomalacia, it decreases in face down, prone position. So this statement is correct. It is the most common congenital anomaly of the larynx. Even that is correct. Okay. The cry of the child is normal, but crying increases stridor. Okay. Now this is a condition that improves on its own by 2 years of age. So treatment of choice is conservative. Yes, so this statement is wrong. The fourth statement is wrong. Okay, the condition is managed conservatively, right? There is no need for surgery over here. All right, so that was the last question, and the answer now we know is the D. That's the false statement. Question asked was about the false statement, so that is the false statement. So guys, I have done all these things for you. I think the next faculty is waiting. Just a quick revision that you wanted me to do for the first question, that was the facial nerve. So somebody had asked me, okay, Rohan had asked me about, is Rohan here? Rohan had asked me about the facial nerve. Okay, so the question that you have asked me about facial nerve, anatomy of facial nerve, all the genus. So let's remember the facial nerve. Okay, just quick 2 minutes revision. The facial nerve, it starts from the motor nuclei, takes a turn around the 6th nerve nuclei, intracranial segment, segment 1, okay, enters into the ICA, okay, so becomes segment 2, that is the, yes, that is the intrameatal segment, segment 2, right? Okay, it is over here joined by 2 more segments, 2 more nuclei, okay, and they have formed a nervus intermedius. It becomes a mixed nerve, right? And then it goes into the temporal bone, it becomes segment 3, intertemporal segment, okay? So immediately after going, it takes a sharp turn, and this we know is segment 3A. Between these 2 places, this is the first genu. And over here, we know that starts the middle ear component, okay, the first genu over here, and then it takes a sharp turn, another over here, it becomes vertical segment. So this was the segment 3B, the horizontal segment, and then it becomes segment 3C over here. This is the vertical segment. So we can see the second genu over here, right? Okay, so right, Rohan, and then it goes out, it becomes your segment 4, that is your extratemporal segment, right? Okay, so these are all the segments of facial nerve. As I was telling you over here, let's look over here. So we have the GSPN coming from here, that was responsible for Schirmer's reflex. We have the nerve to stapedius coming from here, so that is responsible for your stapedial reflex. We have the chorda tympani coming from here. Okay, so chorda tympani is coming from here, that is responsible for your taste and submandibular salivary flow rate. So this was damaged, this was normal, okay, GSPN was normal, so facial nerve is normal here. Okay, now the nerve to stapedius is normal, so facial nerve is normal till here, but this was abnormal, so facial nerve is abnormal over here. So this is normal, this is abnormal, the injury was in the vertical segment, right? So thank you, Rohan, thank you everyone. Okay, best of luck, we'll keep on meeting, right? Thank you.
हेलो स्टूडेंट्स, सो अब हम डिस्कस करेंगे रेडियोलॉजी क्वेश्चंस आज के CBoT में। रेडियोलॉजी क्वेश्चंस सिंपल से ही थे, सो हम क्विकली ट्रू एंड फॉल्स क्या करेक्ट आंसर है, बाकी आंसर्स करेक्ट क्यों नहीं है, उसको करके आगे बढ़ते हैं। सो पहला क्वेश्चन, अ 28-year-old पेशेंट अराइव्ड विद क्रॉनिक डिस्निया दैट वाज गेटिंग वर्स, हिज चेस्ट एक्सरे शोन बिलो, व्हाट इज द मोस्ट प्रोबेबल डायग्नोसिस। सो इट इज़ अ क्रॉनिक कंडीशन, पहली बात, ठीक है, एंड इट इज़ गेटिंग वर्स। और एक्सरे में हमें टिपिकली क्या मिल रहा है, दीज डायलेटेड रेडियो ओपेसिटी, और उसके अंदर हमें ये वाइट स्ट्रक्चर मिल रहा है। सो दिस इज नोन एज अ फिंगर इन ग्लव अपीयरेंस, ठीक है, एंड ये फिंगर इन ग्लव अपीयरेंस किस में मिलती है, इट इज सीन इन ABPA, ठीक है। सो ABPA इज द आंसर। नाउ क्रिप्टोजेनिक ऑर्गेनाइजिंग निमोनिया, इसमें हमें क्या साइन मिलता है, इसमें हमें रिवर्स हेलो साइन मिलता है, एंड दिस इज अ टाइप ऑफ ILD, ठीक है, और ये हमें CT पे मिलता है रिवर्स हेलो साइन। एस्पिरेशन निमोनिया के लिए कोई रिस्क फैक्टर होना चाहिए एस्पिरेशन का, प्लस उसमें लोअर लोब कंसोलिडेशन मिलते हैं, ठीक है, एंड ईसोनोफिलिक निमोनिया में यू गेट पैची कंसोलिडेशंस, यू डोंट गेट दिस टिपिकल फिंगर इन ग्लव अपीयरेंस दैट यू सी इन ABPA, ठीक है। आई होप दिस इज क्लियर, ठीक है। सो नाउ वी मूव ऑन टू द नेक्स्ट क्वेश्चन। सो 60-year-old man in a severe discomfort was taken into the emergency room. He described having excruciating abdominal pain. His supine radiograph is given below. What is the most probable diagnosis? ठीक है, तो इस एक्सरे को हम अच्छे से देख लेते हैं। इसमें पहली बात, इट इज़ अ चेस्ट एक्सरे। 2-3 इंपॉर्टेंट फाइंडिंग हमें मिल रही हैं इसमें, ठीक है। पहला इंपॉर्टेंट पॉइंट कि वी सी दिस एयर अंडर द डायफ्राम, ठीक है, इसमें भी दिख रहा है हमें। एंड दूसरा इंपॉर्टेंट फाइंडिंग कि ये जो बावल है, ये वाला बावल है, इसकी आउटलाइन हमें अच्छे से दिख रही है, ठीक है। नॉर्मली हमें बावल की वॉल नहीं दिखती है एक्सरे पर, ठीक है, बिकॉज ल्यूमन की एयर ही दिखती है, बट वी कैन वेरी वेल अप्रिशिएट दैट द बावल आउटलाइन इज वेरी वेल सीन। व्हाट साइन इज दिस, बताओ, व्हाट साइन इज दिस, दिस इज अ रिगुलर्स साइन, एंड रिगुलर साइन कौन सी कंडीशन में दिखता है, न्यूमोपेरिटोनियम। न्यूमोपेरिटोनियम बहुत इंपॉर्टेंट क्वेश्चन है PG एंट्रेंसेस के लिए। किसी ना किसी एग्जाम FMG, INI-CET, NEET, PG में हर बार एक क्वेश्चन न्यूमोपेरिटोनियम पे आता है। मोस्टली अगर इरेक्ट चेस्ट एक्सरे देंगे तो उसमें यू विल सी एयर अंडर द डायफ्राम, ठीक है, एंड इरेक्ट चेस्ट एक्सरे इज द इनिशियल इन्वेस्टिगेशन। नाउ इन्वेस्टिगेशन ऑफ चॉइस फॉर न्यूमोपेरिटोनियम क्या होगी, रिमेंबर इट इज़ नॉन कंट्रास्ट CT, ठीक है। जब भी हमें एयर देखनी है, न्यूमोमीडियास्टेनम, न्यूमोपेरिटोनियम, वी हैव टू डू अ नॉन कंट्रास्ट CT, ठीक है। सो आई थिंक दिस क्वेश्चन वाज इजी। टिपिकल साइंस भी मिल रहे थे हमें न्यूमोपेरिटोनियम के। इंटेस्टाइनल ऑब्स्ट्रक्शन में हमें क्या मिलेगा, वील सी एयर फ्लूइड लेवल्स, ठीक है, दैट इज ऑल्सो अ कॉज ऑफ एक्यूट एब्डोमेन, बट उसमें हमें एयर फ्लूइड लेवल्स मिलेंगे, एंड टिपिकली एन एब्डोमिनल रेडियोग्राफ विल बी गिवन, ठीक है। डाइवर्टिकुलाइटिस विदाउट एसोसिएटेड परफोरेशन, डाइवर्टिकुलाइटिस पहली बात, कंट्रास्ट एनहांस CT इज द इन्वेस्टिगेशन ऑफ चॉइस, दैट इज नॉट द डायग्नोसिस दैट यू मेक ऑन एन एक्सरे, ठीक है। एंड एक्यूट कोलिसिस्टाइटिस विद गॉल ब्लैडर परफोरेशन, पहली बात, एक्यूट कोलिसिस्टाइटिस के लिए इन्वेस्टिगेशन ऑफ चॉइस कौन सा है, बताओ कौन सा इन्वेस्टिगेशन ऑफ चॉइस है, द इन्वेस्टिगेशन ऑफ चॉइस इज एन अल्ट्रासाउंड, ठीक है। एंड जब भी गॉल ब्लैडर परफोरेशन होगा, गॉल ब्लैडर डज नॉट हैव एयर विद इन इट, सो इट विल नॉट कॉज न्यूमोपेरिटोनियम। रिमेंबर, न्यूमोपेरिटोनियम इज कॉज्ड बाय हॉलो विस्कस, ठीक है। गॉल ब्लैडर परफोरेशन विल कॉज ascites, विल कॉज फ्लूइड इन द पेरिटोनियम, ठीक है। सो लेट्स मूव ऑन टू द नेक्स्ट क्वेश्चन। A 58-year-old male presents who had a week earlier had a frontal sinus surgery. He had complained to the emergency room about his headache, confusion, and an odd sensation of sloshing in head as he moved. his CT scan image of the brain is given below. What is the most probable diagnosis? Now CT scan is a spotter. कौन सा साइन मिल रहा है हमें? This is a spotter. Yes, the answer is a Mount Fuji sign. ठीक है, Mount Fuji sign. एंड किस में दिखता है हमें Mount Fuji sign? बताओ. Yes, it is seen in tension pneumocephalus. These two tethered frontal lobes, tethered to the dura mater because of increased tension of air within the cranial cavity. This is known as a Mount Fuji sign, seen in tension pneumocephalus. ठीक है. Now let's move on to another question. So it is a bigger question. We'll read it slowly. Following a car accident, a young woman was brought into the trauma center. Pregnancy test came out to the negative. So there is a whole story that is given, and you know this is how a typical INI-CET question is. कि बड़ा क्वेश्चन होगा, आपको टाइम लगेगा पढ़ने में, एंड आपका बहुत टाइम वेस्ट होगा. सो इसमें आप सबसे पहले ना जल्दी से एक बार ऑप्शंस पढ़ लिया करो कि ओके, रीनल आर्टरी शोडोएनेरिज्म, एक्टिव एक्स्ट्रावसेशन, रीनल पेल्विस इंजरी, हेमाटोमा. सो किडनी इंजरी की बात होने वाली है यहाँ पे. एंड उसके अब लास्ट 2 लाइन्स पढ़ोगी तो उसमें दे रखा है कि CT showed an ill-defined area of contrast outpouching during arterial phase in the superior pole of the right kidney, which grew larger during the venous and the delayed phase. So क्या इंपॉर्टेंट पॉइंटर है कि जो आर्टीरियल फेस में आउटपाउचिंग है वो बड़ी हो रही है. ठीक है, तो हम मोटा पढ़ लेते हैं कि जो वैस्कुलर इंजरीज हैं, वैस्कुलर इंजरीज एंड स्पेशली दे बिकम ट्रू इन केसेस ऑफ ट्रॉमा, वो 2 मेन होती हैं. ठीक है, वो 2 मेन होती हैं. एक होता है आपका सूडो एनेरिज्म एंड दूसरा होता है एक्टिव कंट्रास्ट एक्स्ट्रावेसेशन. एक्टिव कंट्रास्ट एक्स्ट्रावेसेशन. सो इनमें से कौन सा वैस्कुलर इंजरी फर्दर वीनस और डिलेड फेज में बड़ा होगा, कि जिसमें एक्टिवली लीक हो रहा है ब्लड. सो एक्टिव कंट्रास्ट एक्स्ट्रावेसेशन मीन्स दैट देयर इज एन एक्टिवली लीकिंग आर्टरी. ठीक है, तो जब आप आर्टीरियल फेज में इमेज करोगे तो मान लो इतना सा ब्लड बाहर लग रहा था. जब वीनस फेज जो कि आर्टीरियल फेज के बाद हम एक्वायर करते हैं उसमें ये बढ़ेगा क्योंकि कंटिन्यूस ब्लीडिंग है. एंड सिमिलरली डिलेड फेज में जो कि हम 3 to 5 मिनट्स आफ्टर कंट्रास्ट इंजेक्शन करते हैं उसमें ये और बढ़ जाएगा. सो इट ग्रोज ऑन वीनस फेज एंड डिलेड फेज. एंड द आंसर हियर इज एन एक्टिव कंट्रास्ट एक्स्ट्रावेसेशन. ठीक है. नाउ सूडो एनेरिज्म क्या होता है? सूडो एनेरिज्म की अगर ये आपकी वैस्कुलर इंजरी है, इसमें से यहाँ पे एक आउट पाउचिंग बन जाती है क्योंकि यहाँ से ब्लड लीक हुआ होगा, फिर वो क्लॉट हो के उसने अपने आप को लोकलाइज कर लिया. नाउ क्योंकि ये लोकलाइज्ड कलेक्शन ऑफ ब्लड है, सो आर्टीरियल फेस में जो इसका साइज होगा वही इसका वीनस और डिलेड फेस में भी होगा. सो सूडो एनेरिज्म डू नॉट ग्रो ऑन वीनस और डिलेड फेज. ठीक है, आई होप दिस पॉइंट इज क्लियर. सो द आंसर हियर इज एन एक्टिव कंट्रास्ट एक्स्ट्रावेसेशन. नाउ कमिंग ऑन टू द थर्ड ऑप्शन, दैट इज रीनल पेल्विक इंजरी. नाउ रीनल पेल्विस इंजरी में आपको यूरिनरी एक्स्ट्रावेसेशन मिलेगा. यूरिनरी एक्स्ट्रावेसेशन मिलेगा. ठीक है, एंड यूरिनरी एक्स्ट्रावेसेशन आप कौन से फेज में देखोगे? यू विल ओनली सी इट इन डिलेड फेज. ठीक है, हम टिपिकली 15 मिनट डिलेड फेज करते हैं जब भी रीनल इंजरी सस्पेक्ट होती है, एंड केवल उसमें यू विल सी यूरिन कंट्रास्ट एक्स्ट्रावेसेशन. एंड हेमाटोमा अगर केवल आइसोलेटेड हेमाटोमा है तो उसमें आपको बिल्कुल आर्टीरियल फेस में यू वोंट सी एनी कंट्रास्ट आउटपाउचिंग. ठीक है, सो आई होप दिस आंसर वाज क्लियर कि व्हाई इट इज एन एक्टिव एक्स्ट्रावेसेशन एंड नॉट अ रीनल आर्टरी सूडो एनेरिज्म. ठीक है, चलो मूविंग ऑन टू द लास्ट क्वेश्चन कि एन 18-year-old मेल विद रीसेंट ऑनसेट सीवियर हाइपरटेंशन एंड एन एब्डोमिनल ब्रूई detected during a routine checkup was referred for an IVU or an intravenous urogram in the radiology department. अब हमें पता है कि नॉर्मल IVU हम लेते हैं 0, 5, 10 मिनट्स पे आफ्टर कंट्रास्ट इंजेक्शन. सो एक बार हम देख लेते हैं कि IVU में हमें क्या दिख रहा है. तो पहली बात कि ये वाली हमारी राइट किडनी की आउटलाइन है, और ये वाली हमारी लेफ़्ट किडनी की आउटलाइन है। ठीक है, जैसे जैसे कि अगर हम दोनों किडनीज को कंपेयर भी करें, तो जो राइट किडनी है और लेफ़्ट किडनी है, सो राइट किडनी इज़ स्मॉलर, एंड दूसरी बात कि इट इज़ नॉट शोइंग एनी यूरिन एक्सक्रीशन, सो नो यूरिन एक्सक्रीशन। ठीक है, एंड क्वेश्चन में क्या दे रखा है? क्वेश्चन में दे रखा है कि इट इज़ एन हाइपरटेंसिव पेशेंट एंड यू सी दैट देयर इज़ एन एब्डोमिनल ब्रूई, मतलब देयर इज़ सम आर्टरी स्टेनोसिस। ना हमें पता है कि रीनल आर्टरी स्टेनोसिस में हाइपरटेंशन भी होता है, यू गेट एन एब्डोमिनल ब्रूई ऑल्सो, एंड आईवीपी पे क्या साइंस मिलते हैं हमें? नॉन एक्सक्रीशन ऑफ कंट्रास्ट, ठीक है, या फिर डिलेड एक्सक्रीशन ऑफ कंट्रास्ट। हम देख रहे हैं कि लेफ्ट साइड जो किडनी है दैट इज एक्सक्रीटिंग कंट्रास्ट, मतलब इट इज़ नॉर्मली फंक्शनिंग, बट द राइट किडनी इज एबनॉर्मली फंक्शनिंग बिकॉज इट इज़ नॉट येट एक्सक्रीटिंग कंट्रास्ट एंड इट इज़ स्मॉलर इन साइज। सो द आंसर हेयर इज अ रीनल आर्टरी स्टेनोसिस। ठीक है, सो आई होप द क्वेश्चंस वर नॉट सो टफ एंड दिस वाज ऑल फ्रॉम रेडियोलॉजी डिस्कशन। थैंक यू।
So let us now discuss some of the important questions which have been asked. Here's the first question, a very interesting question. What is the location of the nuclei which gives rise to the nerve supplying the highlighted structure? Beautiful question. Why? Because in this question, first you have to identify the muscle. And you can see this muscle is going around the trochlea and then it is curving around. That is the muscle of the extraocular muscle known as superior oblique muscle. So now we know the name of the muscle. Then we should know that which nerve supplies this muscle. As we all know, SO4-LR6 is the mnemonic, rest all by the third nerve. So this SO is supplied by fourth nerve, that is the trochlear nerve, right? So now you know trochlear nerve supplies this particular highlighted muscle. Now we should know that this trochlear nerve is coming from where? It's coming from the part of midbrain. Remember, midbrain gives rise to third and fourth nerve. So third nerve comes from the superior part of the midbrain, fourth nerve comes from the inferior part of midbrain. And in midbrain, posteriorly, we have two pair of colliculi known as superior and inferior colliculi for visual as well as auditory reflexes respectively. Therefore, the trochlear nerve you see on the posterior aspect of midbrain comes from just below the inferior colliculus. Therefore, the level at which the nuclei lies for supplying this particular muscle is at the level of inferior colliculus. And if you look at the options, then option number D will be the best bet over here. You can bet your money on this option. Inferior colliculus of the midbrain is where the trochlear nerve nucleus lies, then it crosses inside the midbrain and it comes out just below the inferior colliculus of the midbrain on the posterior aspect. Right? So answer is option number D. Which of the following, next question, is not a content of the marked structure? Here you can see the cross section around the cervical region, and if you look over here, this is basically what they are trying to show us, the carotid sheath. Carotid sheath is formed by all the three parts of the deep cervical fascia, the investing layer, the prevertebral and the pretracheal layer. And the contents of carotid sheath, we should always remember this, are what? In the beginning, we have the common carotid artery. As it ascends up, we have the internal carotid. Remember, the EC is not a part of the carotid sheath. And lying between these two, we have the vagus nerve as well. So at times you have the CC and the 10th nerve, and times you have the IC and the 10th nerve when the CC will bifurcate. EC is not a part of it. If you look at the question, then they're asking you which is not a content, and therefore EC is the answer over here. It's not a content of the carotid sheath being shown over here. Remember this. Also, some extra points are that if you look at the carotid sheath, in its anterior wall lies a loop of nerve known as ansa cervicalis. Point number 1 is this. And on the posterior aspect of this carotid sheath, we have the sympathetic plexus. This also we can have an extra point. Answer over here is option number C. The next question is identify the histological section given below. A question from histology. Remember the last few years, histology and particularly this part of the body, that is the tongue, the histological images are coming. And if you look over here, they are showing some growths out of the tongue which are known as papillae. But which papillae are these? These are papillae which are like thorns or spines having pointed ends without any taste buds lying over there. And these are the most bulky in the anterior part of the tongue. They are known as filiform papillae, right? So these are the filiform papillae without and devoid of any taste buds. Therefore, answer will be our option number B. Looking at the other options, see, fungiform papillae will be like a fungus-like shape over here, and then there are some filiform papillae. Circumvallate papillae are the biggest one, and they have the crypts, and they are this big one with the crypts on the sides of them. And both of this fungiform and the circumvallate papillae will have the taste buds. Folate papillae are leaf-shaped, not in the more in humans, but in animals, and they're on the sides. So looking at all of this, looking at the shape, the answer over here is going to be the filiform papillae. Let's see the next one. Which of the following is not the derivative of dorsal mesentery, or we can say dorsal mesogastrium? Greater omentum, lesser omentum, lino, or gastroclinic ligament. So you understand over here that when there is a gut and when after rotation of the midgut, the foregut also rotates. And the foregut rotates 90 degrees to the right side, like this. So therefore, if you look at the adult or the normal stomach, the lesser and the greater curvature, and these are the duodenum over here, everything to this side, to the right of the stomach, will be actually derivative from the ventral mesentery or ventral mesogastrium. And everything to the left side will be from the dorsal mesogastrium. So what is there on the left side? We have this greater omentum coming down from here. We have between the stomach and the spleen, we have the gastrosplenic ligament. We have between the spleen and the kidney known as the splenorenal ligament, right? We have the gastrophrenic ligament between the stomach and the diaphragm. We have the these are all what? These are all on the left side of the gut. And therefore, these all will be the derivatives of the dorsal mesogastrium. Now, they're asking which is not derivative. Obviously, on the opposite side. Like, for example, here, what we have the lesser omentum. That is not a part of the dorsal, it's a part of the ventral mesogastrium. So, if we look at the options, greater omentum, it is a part. Lesser omentum, yes, this lesser omentum over here is not a part of the dorsal, it's a part of the, as we just saw, ventral mesogastrium. Linorenal and gastrophrenic are, and greater omentum, they are parts of the dorsal mesogastrium. Remember, a small mnemonic also might help you, VDRL. VDRL test for syphilis. So ventral goes to the right side, dorsal goes to the left side. Remember this. Let's see the next one. Which of the following conditions is due to the infarction of the marked structure? Now this structure is showing us the brain over here. And the marked structure over here is around the superior temporal gyrus. This is the superior temporal gyrus. And that is roughly, they are trying to show us the Wernicke's area, the sensory speech area. This area, the sensory speech area, with the Broadband number of 22. And if we talk about the complex, then there will be going to be 39 and 40 as well. Now, what will happen if there's infarction on this side? And this side is actually the left side, dominant hemisphere. This leads to a sensory aphasia, or Wernicke's aphasia, or fluent aphasia, or terms like that. Therefore, the answer over here is what? Anomic Wernicke's, option number B. Wernicke aphasia. Right? Wernicke aphasia is also the fluent aphasia. So, non-fluent cannot be an option over here. It's also fluent aphasia. The non-fluent of Broca's aphasia are same. Right? So, here, answer is option number B. Wernicke's or the fluent aphasia, or we can also call it as a sensory aphasia. That's also in the dominant hemisphere. Remember, left lobe or left hemisphere. Supplied by what? It's supplied by the left middle cerebral artery. Okay, so answer over here is option number B. Remember the areas. Let me show you one more area over here. What's this area in the inferior frontal gyrus? This one over here is the Broca's area, the motor speech area. That can also be questioned with the Broadband number of 44, 45. Let's see the next one. Which is not a branch of the anterior division of the internal iliac artery. Very important. Very important artery is our internal iliac artery. Why? Because this artery supplies the pelvis and the perineum. It is divided into a big branch anterior division and a smaller one known as a posterior division. And remember, the mnemonic for the posterior division is PILS, P-I-L-S. What is over here? P for posterior division, I, L, and S over here. I refers to the iliolumbar artery because the lumbar vertebrae are present posteriorly, so posterior division branches apply logic. L refers to the lateral sacral artery, again sacral lies posteriorly, and S refers to the superior gluteal artery. So only these three branches are branches of posterior division. Now they're asking us which is not a branch of the anterior division. So obviously these three are not a branch of the anterior division. So if we have over here any option, then you can see option number A itself, superior gluteal artery. This option A itself is a branch of the posterior division, not the anterior division, and this inferior gluteal vesicle, these all are branches of the anterior division. Answer is option number A. Okay, so remember the mnemonic over here, PILS, PILS. Posterior division, ILS. Let's see the next one. Which of the following nerve injuries can give rise to the finding given below? What is the finding over here? Let us zoom it. What's the problem over here? The tongue looks okay, the lips fine, the teeth okay, uvula, the soft palate. Look over here, look over here. Let me point out few things over here. Just a second. Look at the elevation in the soft palate. The right side soft palate is sagging down. Look over here. Also, you can see the uvula is being pulled to the left side. It means that the muscles over the left side of palate are working fine. But on the right side, the muscles of soft palate are not working. So what is the nerve supply of the muscles of soft palate? The muscles of soft palate are what? They are tensor palatini, levator palatini, palatopharyngeus, palatoglossus, and musculus uvuli. The nerve supply of the muscles of the soft palate are our pharyngeal plexus. Basically, the 10th or the vagus nerve. The right side muscles are not working. So right vagus looks like a issue over here, the right vagus. And if we look at the options over here, option number D, last option would be the best answer. Remember in the other options, option number like glossopharyngeal, they are basically the sensory nerves. They are the sensory nerves. And left vagus looks okay. Here we have the problem in the right vagus. I've just zoomed it and showed you. Okay. Fine, let's see the next one. Which of the following options prevent the spleen from enlarging downward? A recently asked NEET PG question. So what we have actually is, we have this huge transverse colon, remember. And around the spleen, it goes down as what? As the descending colon. What we have over here is the TC transverse colon and DC descending colon. What is the structure over here? The structure lying over here is what? This is the spleen over here. It's an intraperitoneal structure, right? And this part of the, what we can say is the colon, is lying at the near the lower pole of the spleen, like this. And behind the spleen, what we have, or covered by the spleen, is the diaphragm. Is what is the diaphragm. And also do remember that here is a ligament connecting the diaphragm to the colon. What is that? This is the phrenicocholic ligament, and it is due to the presence of this ligament that when there is splenomegaly, the spleen will enlarge towards the direction of umbilicus or the right iliac fossa, not downwards. It can't go downwards because of the presence of the phrenicocholic ligament. Answer over here is our phrenicocholic ligament. It is due to the presence of the phrenicocholic ligament that when the spleen enlarges, it doesn't go downward. It goes towards the direction of umbilicus. Remember this, very important clinically. Next question, all are important structures present behind the marked structure except. What is the marked structure over here? This marked structure we all should know is the H-shaped suture known as what? Known as the pterion. Behind it lies the anterior trunk of the middle meningeal artery leading to which hemorrhage? Linked to the hemorrhage known as epidural hemorrhage. So there is anterior division of middle meningeal artery. But what is asking you is which does not lie except. So it lies. Anterior cerebral artery itself, if we look at the blood supply of the brain, this cerebral artery, anterior one, lies on the medial surface of the brain. It does not lie on the lateral surface. Therefore, this is the best possible answer over here till now. Let us see the other options as well. Other options, middle cerebral artery, yes, it lies laterally. It comes out from the lateral sulcus, which also lies around this pterion only. So, ciliary fissure is a lateral sulcus. A, C, and D are present. B is not present at this location. Therefore, B is the answer. Right? Pterion, remember, is a H-shaped suture and by 4 bones, which are the frontal, the parietal, the temporal, and the greater wing of sphenoid. 50-year-old male factory worker is hospitalized with a painful mass on the proximal medial portion of his thigh. The physical examination suggests that the mass is protruding through the femoral ring, looks like a femoral hernia, the more common in females. The diagnosis of femoral hernia is made. The arrow structure marked the medial boundary of the femoral ring. So asking us what is the medial boundary of the femoral ring, identify the label structure. Okay, there are so many labels, but we should know what is the medial boundary of the femoral ring. So remember that we have what? We have the femoral artery, medial to it we have the femoral vein, and then we have this deep inguinal lymph node, And you should also know that this is the inguinal ligament, and that turns as a lacunar ligament, goes behind as a pectineal ligament, right? Let me just label it. This is the I dot ligament, inguinal ligament, also known as Popper's ligament. Medial side, this is the lacunar ligament, also known as the Gimbernott's ligament. Posterior behind, we have the pectineal ligament, also known as the Cooper's ligament. And this location over here, this upper part of the femoral canal, that is the location of the femoral ring. And they're asking us what is the medial boundary of the femoral ring, and it is our lacunar or Gimbernott's ligament. Therefore, option number C will be our best bet over here. Option number C, lacunar, is lying in the medial side. Remember, the other name of the inguinal ligament is Popper's ligament, P-O-U-P-A-R-T, and pectineal is also known as Cooper's ligament. And this actually is the site of the femoral canal where the hernia is coming down. And the mouth of the hernia is the femoral ring. And that's the lacunar ligament lying on the medial aspect. Very important surgically, right? A person injured his left elbow. MRI revealed injury to the ulnar nerve and a medial epicondyle fracture. Which muscle from the list below is most likely to become paralyzed? So they're asking basically which muscle is supplied with the ulnar nerve if it gets injured behind the medial epicondyle. Ulnar nerve basically supplies the muscles of the hand, but in the forearm it supplies the FCU and the medial half of FDP. That is the option. FDS no, FCU yes. FCU is supplied by the ulnar nerve, right? Biceps brachii, so FDS supplied by the median nerve, remember. Biceps brachii by the musculocutaneous nerve, and brachioradialis and supinator basically by the radial nerve or their branches, posterior torsion. So mainly it is the radial nerve. So therefore answer is option number B, flexor carpial nares. Percussion across the flexor retinaculum induces excruciating pain in the lateral 3.5 digits of the patient with a history of fall. Understand this. I hope you got the point. Which of the following is relevant to this sign elicited in this patient? So it's a tinal sign where you percuss over here and there's a electric sort of pain happening over here. You're tapping over the median nerve. It's a carpal tunnel syndrome. Therefore, if we have the option, yes, there it is, carpal tunnel syndrome is the answer over here. Other options that don't fit over here. It's a simple case of carpal tunnel syndrome, right? The next one over here, a 60-year-old lady with a history of fracture of the neck of the right femur 9 months ago. Now presents with significant pain in her right hip and leg and is admitted to the hospital. MRI shows avascular necrosis of the head of the femur. Quite possible. Which artery is most likely? So they're asking us in a way that which is the main artery which supplies the head of femur that whose damage might lead to avascular necrosis. And the main artery is our medial circumflex femoral artery. So if the option is one of that, yes, answer is option B, ascending branch of medial circumflex femoral artery. It's a main artery. It's a retinacular branches of the main vessels which supply the head of femur, and damage to these will lead to AV and avascular necrosis to the head of the femur. That is what is asked in this, right? So ascending branch of the medial circumflex femoral, which will form a part of what we can say as the trochanteric anastomosis. They are the ones which will provide the supply to the head of femur, damage to which leads to avascular necrosis, right? So that's all. I hope you enjoyed.
लाइव रियल लाइव लगना चाहिए ना, पानी भी पीऊँगा मैं लाइव में, तभी तो रखा है। ओके गाइस, तो शुरू करें। लेट्स स्टार्ट आवर डिस्कशन ऑफ मेडिसिन। Okay, starting with first question. Just we have tried to add more and more clinical case. So starting with the first question, किसी भी question में first hint is the age itself. So starting with 62-year-old man arrived at emergency department with worsening chest pain for the past 24 hours. 24 घंटे से छाती में दर्द हो रहा है. He described the pain as squeezing and located beneath his breastbone with addition to his left arm. BP is 160 by 94, so BP is quite elevated. Heart rate is 110. ECG reveals ST segment depression in lead V1 to V5. Troponin levels are normal. So first, when you see this type of question, means ECG is having changes. So ECG changes are present. That is ST depression. But markers are normal. Markers means troponin T is given, so markers are normal. So पहले मुझे बताओ क्या डायग्नोस होगा. What will be the diagnosis for this case? What is the diagnosis? Come on. Nadeem, Rayan, Wahid, Shahrukh. Try to answer. क्या diagnosis होगा? Diagnosis could be unstable angina. So it's a case of unstable angina. अब unstable angina का patient है. क्यों? Why it is not MI? It is not MI because markers are normal. So let's see the options one by one. So जब पेशेंट आपके पास आएगा तो आपको पेशेंट को पेन हो रहा है ना, यू कैन सी देयर इज अ चेस्ट पेन. सो नाइट्रेट्स तो आपको देने हैं और एस्पिरिन का भी लोडिंग डोज देना है. सो व्हाट इज लोडिंग डोज? वी गिव 4 टैबलेट्स मीन 75 mg इंटू 4 टैबलेट मीन 300 mg. सो 4 गोली एस्पिरिन की देनी है और क्या देना है? नाइट्रेट देना है. सो दैट इज द आंसर. बट लेट अस सी अदर ऑप्शंस. इनिशिएट इंट्रावेनस हेपारिन. Okay, so understand this. पहले इसको समझो. Why we have to give nitrate? You will give nitrate. When you give nitrate, this will help to relieve chest pain. So patient की छाती में जो दर्द होगा वो कम हो जाएगा. And this aspirin will prevent further platelet aggregation. तो platelet का aggregation नहीं होगा. The aspirin will prevent clot formation. Now coming to other option, IV heparin. So understand this. Nadeem, Gangwar, try to answer. क्यों heparin confusion चला सकते हैं? But again that is the not the initial management. Suppose पहले आपको नाइट्रेट एस्पिरिन देना है, उसके बाद भी इम्प्रूवमेंट नहीं हो रहा है, then we can try heparin. Urgent coronary angiography we can use because sometime we want to see the coronary vessels. हो सकता है ये पेंजिमेटल एंजाइना हो, सो वी हैव वांट टू सी द कोरोनरी आर्टरी स्पाज्म. बट दीज टू थिंग्स कैन बी डन बट नॉट दे आर नॉट द इनिशियल मैनेजमेंट. इनिशियल डुअल एंटीप्लेटलेट थेरेपी विथ क्लोब. अगर ये अगेन दिस यू विल डू व्हेन यू विल डिस्चार्ज द पेशेंट. जब आप पेशेंट को स्टेबल कर लोगे एक बार, वंस यू स्टेबलाइज द पेशेंट देन यू विल डिस्चार्ज द पेशेंट. सो एट होम यू कैन गिव दिस. सो रीड द क्वेश्चन केयरफुली. व्हाट दे आर आस्किंग, व्हाट इज मोस्ट अप्रोप्रिएट इनिशियल मैनेजमेंट. सबसे पहले क्या करोगे? उसका पेन रिलीव करोगे. Am I clear? So answer will be A. B, C, D. These options. So we can also perform these 3 things. Angiography भी कर सकते हो, intravenous heparin भी दे सकते हैं, but they are not initial. Dual platelet therapy कब दोगे? जब आप पेशेंट को स्टेबल कर लोगे, once your patient is stabilized. Am I clear? Okay, moving to next question. Try to answer. A 62-year-old man with medical history of hypertension. So age 62, again old people. Geriatrics question ज़्यादा आ रहे हैं. Type 2 diabetes with inadequately controlled blood pressure despite being on ACE inhibitor. So patient ACE inhibitor ले रहा है, उसके बाद भी BP कंट्रोल नहीं हो रहा है. His blood pressure consists ranges between 150/90 and 160/100 means अभी BP बढ़ा हुआ है. Patient also experience persistent cough. So this is the hint in the question. Okay, so बताओ, try to answer. रोहन, शाहरुख, वाहिद, रियान, नदीम, try to answer. बताओ. So now in this question, suppose what they are asking, patients having persistent cough for few weeks, what is most suitable option? So let's see first option, transition to CCB. We can use CCB, but remember CCBs will not prevent diabetic nephropathy, and CCBs will not have a mortality benefit in a patient who is having heart disease, and that will not prevent heart failure. So CCB और से कुछ क्या नहीं होगा, CCB से डायबिटीज़ की कॉम्प्लिकेशन को आप प्रिवेंट नहीं कर सकते. CCBs will not have any role in preventing heart failure. So that is why it is not the answer. Introduce a thiazide diuretic to the current treatment regimen. Again, thiazide देने से क्या होगा? देखो ACE inhibitor and ARBs, they cause mild to moderate hyperkalemia. If you add thiazide, it can lead to even more. So adding a diuretic can solve this problem. You can add this later, but again, we have an alternate to this. Alternate will be you can start ARBs. Escalate the dose. No, dose इसका नहीं बढ़ाओगे because patient is having persistent cough. So answer will be C. Okay, in the same question, if I ask you, suppose a patient experienced a mild cough, a few episodes of cough, then what we have to do, we should continue ACE inhibitor. Just remember, what we study is, what we teach is, it's better to have some cough than die. ACE inhibitors, remember, there are 4 drugs. ARNIs. ARNIs means it's a combination of sacubitril and valsartan. Sacubitril plus valsartan. They are the best drug in preventing heart failure. Next best choice is still ACE inhibitor, and third best choice will be ARBs. Other than this, I can say beta blocker. These are 4 drugs which can prevent mortality in a patient with heart failure. So अगर ACE inhibitor से persistent cough हो रही है, you can switch to ARBs. If it is like mild cough, you can continue with ACE inhibitors. But we have to give this here because ACE inhibitor and ARBs, they have advantage in both heart failure prevention and diabetic complication prevention. So answer is clear. आगे चलें. Okay, moving to third one. Try to answer. A 20-year-old girl experiencing weight loss. So let's see the question first. 20 साल की लड़की है, weight loss हो रहा है, chronic diarrhea. Receives following pathology report. So let's study the pathology report. Sample taken from the jejunum displays a reduction in structure of villi and increase in size of underlying crypt. So what I mean by this line, this is like a pathognomonic feature. What we say? Reduction in structure of villi means villi. So understand this. Our intestine are like this. Villi, then we can have crypt, villi, crypt, villi, crypt, villi, crypt. So what is happening? Villi की height कम हो गई और crypt का number बढ़ गया. So you can see villi, crypt, villi, crypt. This is what we call this villus atrophy. You can see the height and crypt hyperplasia. तो उसको क्या बोलते हैं? We call this villus atrophy and crypt hyperplasia. Hyperplasia means increase in number. Let's see, read the question once again. So half diagnosis I made in my brain, it could be celiac disease. So let's see. Lamina propria contain notable infiltration of lymphocyte and plasma cells. So diagnosis is now confirmed. It is a case of celiac sprue. So again, a pathology overlap with medicine question. Celiac sprue की biopsy में क्या मिलेगा? Lymphocyte infiltration into lamina propria, and you can see villus atrophy and crypt hyperplasia. So these are the pathological changes. There are no granulomas present. So what I mean by this line? So it means we have ruled out Crohn's disease. No granulomas present. Based on presentation with the following is most probable for this patient. So now try to answer. Elevated level of calcium in the blood. Is it true or not? Try to answer. बताओ ये होगा कि नहीं होगा celiac disease में? Now see, celiac disease is a disease where you will see malabsorption. So in any malabsorption, what will be feature of any malabsorption syndrome? Patient will have diarrhea. So there will be diarrhea. There will be vomiting. There will be abdominal pain. Then there will be, I can say, patient can develop nutritional deficiency. So there will be diarrhea, there will be vomiting, there will be abdominal pain, there will be nutrition deficiency. For example, there will be deficiency of micronutrients like iron deficiency. There can be folate deficiency because jejunum is involved. There can be a B12 deficiency in case of ileum involved. There can be deficiency of calcium, deficiency of vitamin D. So micronutrients will be deficient. So understand, serum calcium levels are not elevated in a patient with celiac sprue, right? So generally, like even sometimes we can see hypocalcemia because there will be calcium deficiency. Normal quantitative stool assessment for fat. So celiac sprue is a condition where you will see malabsorption, means there will be malabsorption of protein, carbs, fat, everything. So stool fat assessment will not be normal. It will be, in fact, you will see more fat in stool. We call that steatorrhea. So fifth feature which I am writing here is steatorrhea. So patient को stool के fat में क्या होगा, normal नहीं आएगा test, it will be abnormal. You can see more fat content. Fat content will be more than 7 gram%. An abnormal D-xylose test. Okay, so first tell me why we do D-xylose test. D-xylose test we do for carbohydrate malabsorption. In celiac sprue, you can see malabsorption of all the nutrients. So this test will be abnormal. A tendency towards excessive blood clotting, hypercoagulable state? No. Again, you will not see hypercoagulable state. So answer for this question will be abnormal D-xylose test. Clear? Am I clear? Nadeem, Rohan, Naveen, Wahid, is it clear? Am I clear, guys? आगे चले, समझ आ गया? Okay, moving to next one. A 40-year-old man diagnosed with septicemia. So let us see the question. 40-year-old man diagnosed with septicemia means patient को पहले sepsis हुई. Sepsis हुई means I can assume like his total leukocyte count will be increased. TLC बढ़ा हुआ मिलेगा. Caused by E. coli. Experience a drop in blood pressure. BP कम हो गया. And is on pressure support for maintaining blood pressure. Means pressure support means patient pressure support. What is the meaning of this line? Means you are using some sort of inotropes. Means patient को NORAD या dobutamine और dopamine और vasopressin inotropes drugs चल रहे हैं. Pressure support for maintaining blood pressure. So basically what we are using NORAD, norepinephrine. He present with stool test positive for guaiac test. Guaiac test is a test for occult blood in stool and skin discoloration resembling ecchymosis. Now understand, whenever we see this line guaiac test is positive, so what I mean by guaiac test to be positive, it means there can be it's a test for occult blood in stool. Then patient is also having ecchymosis, means some red patches in the skin. Laboratory finding include hemoglobin level of 9.2. Hemoglobin is 9.2. Hematocrit 28. Hematocrit 28. Okay, generally how we calculate hemoglobin, if you multiply this by 3, this will be hematocrit. So hemoglobin को अगर आप 3 से multiply करोगे, that will be hematocrit. तो almost बराबर है यहाँ पर. Platelet count of 70,000. Abundant fragment of fibrin and platelets FDP are detected in bloodstream. What is underlying cause of reduced hematocrit? So basically I can say like this, patient is having bicytopenia. Bicytopenia means platelet counts are reduced and hemoglobin is reduced. So patient को anemia भी है and platelet counts are reduced means thrombocytopenia भी है. So what could be the cause for this condition? Try to answer. मैंने आपके सामने पूरा केस रख दिया. First try to answer. नदीम, शाहरुख, नवीन, try to make your answer. पहले कोशिश करो, बताओ क्या होगा. Try to answer. So FPD लिख दिया, इसको FDP लिख देना. Just correct this. It is FDP. Fibrin degraded product. Fibrin degraded product. So what is this case? What do you think? You can see what will be the answer. Diagnose बताओ, पहले diagnose पे जाओ. What you can think? What could be the diagnosis of this case? देखो patient को bicytopenia हो रहा है. Means hemoglobin भी कम हो रहा है, platelet भी कम हो रहा है. तो क्या हो सकता है आंसर? It could be it could be a case of DIC. What is DIC? Disseminated intravascular coagulation. DIC में क्या होता है? Understand this. DIC is something which you can see like it can be a complication of different cancer. So maybe patient is suffering from colon cancer. That's why occult stool blood is blood and stool test is positive. So patient को DIC के चलते. Now just try to understand this question. Whenever you are seeing like this is our blood vessel, this is our blood. Inside the blood vessel, suppose there is formation of thrombus, or I can say microthrombi, formation of small thrombi. These are thrombi, small thrombi, and our RBCs are jelly-like structure. RBCs are jelly-like structure. So whenever these RBCs, they will hit. So whenever RBCs are hitting on any hard or sharp object, understand this RBCs will be cleaved into pieces like this. So RBCs are jelly-like soft structure. If they are hit on some hard or sharp object, then RBCs will be cleaved like this. We call this shearing of RBCs. So RBC shape, you can see this is like amino acid side chain, so this will be removed. And this type of cells will be in the blood vessel. These cells are called broken fragment of RBCs, or we call them helmet cell. Helmet cells or cystocytes. We call them broken fragment of RBCs. Now this could be a thrombus, or I can say it could be any hard or sharp object. Hard or sharp object, and this is this hard or sharp object, it can be something. क्या हो सकता है? This type of anemia. तो जैसे RBC टूट रही हैं, ऐसे थोड़ी प्लेटलेट भी टूटेंगे. Am I clear? This is called MAHA. MAHA means microangiopathic hemolytic anemia. So what are the causes of MAHA? So cause of MAHA means it can be due to ITP, it can be due to TTP, thrombotic, thrombocytopenic purpura, immune thrombocytopenic purpura. It could be due to DIC. It could be due to calcified valve, or I can say any calcified thing in the body, in the blood vessel. Calcified valve. It could be due to some metallic implant. Or in simple language, I can say it could be atheroma, atherosclerosis also. So any hard or sharp object, simple, any metallic implant. So these are the causes of MAHA. Am I clear? So just read this question. So understand this. This is a case of DIC. So what you can see, warm autoimmune hemolytic anemia. Just remember, warm autoimmune hemolytic anemia. यहाँ पर भी, here also you can see anemia. You can also see thrombocytopenia. It is something which is seen more in. So warm is something that is seen more in young female. It is more seen in young female, and it is due to immunoglobulin. Which immunoglobulin? Which immunoglobulin? IgG. So it is something like, so you can remember warm means hot, so young females are hot. Clear? So answer is MAHA. PNH, understand, PNH is a condition where you will see like patient will have episodic, sometime on some night there will be hemoglobinuria. So this is due to, I can say, complement a protein defect, that is a DAF and MIR defect. So basically we have PIG-A gene defect, that is due to DAF and MIR. These are basically your complement proteins, so they are coded for CD55 and CD59. Clear? So बीटा थैलेसीमिया मेजर में जनरली क्या होगा, आपको अनीमिया मिलेगा. FDP is the hint in the question. Am I clear? तो थोड़ा सा डिफिकल्ट था, बट अगेन नॉट दैट डिफिकल्ट. तो अगर आप देखोगे, अबेंडेंट फ्रैगमेंट ऑफ फाइब्रिन एंड FDP मीन्स फाइब्रिन डिग्रेडेड प्रोडक्ट. Fibrin degraded product, that is very important hint, that is showing you what towards DIC. One more hint I can tell you. Let's highlight the hint once again. Skin discoloration क्यों हो रहा है? Because DIC, because of DIC you can see skin discoloration. Then you can see FDP are elevated, platelet count is less. So these are points towards DIC. Am I clear? आगे चलें. Okay, moving to next one. Try to answer. A 23-year-old male arrives at emergency department experiencing wheezing. So young male, wheeze. So whenever you see this word wheeze, first thing which will hit in your brain is it could be due to OPD. OPD means obstructive pulmonary disease. So wheezes are high pitch, I can say, musical sounds which are classically seen in a patient with obstruction, some sort of obstructive lung disease. So wheeze and respiratory distress. During examination, you observe him as accessory muscles to aid in breathing. So patient is using his accessory muscle, right? Then you can notice like his peak expiratory flow rate measures at 45% of anticipated value. He has a record of similar episode in the past. What is the most probable diagnosis? बताओ क्या होगा? What do you think? What is the most probable diagnosis? बताइए. What do you think? Love Rock, Sunny Puri, Vicky, Nadeem. Try to answer. बताओ. Okay, so understand this one by one. If you see like क्वेश्चन में कहीं पर भी वाटरी स्पूटम, क्रोनिक प्रोडक्टिव कफ ऐसा कुछ मेंशन नहीं है. So bronchiectasis is ruled out. Bronchiectasis is ruled out. Again, if you see like if a person like he is very young patient है, 23 साल का है. ये विक्की ये गलती हो गई, इतनी जल्दबाजी नहीं करनी. 23 साल के 18 साल में सिगरेट पीना शुरू करता है इंसान, राइट. सो व्हेन यू स्मोक फॉर 10, 20, 30 ईयर्स, तो तब जाके 50-55 में जाके COPD होती है. तो यंग एज, look at the age, COPD, that's why it's not the answer. Now next two hint in the question. Okay, third thing is like there are no fever, no such symptoms, so pneumonia is unlikely. So answer for this question will be asthma. Now look at the question carefully. Again, it's like a bit INI-CET level type of question. You can see young age, first hint. Patient young है, wheeze हो रही है, right? So this is like what we call this acute severe asthma. Accessory muscle use कर रहा है, and his peak expiratory flow rate is at 45%. In COPD it can be even lesser. And patient is having record of similar episode. बार बार ऐसा हो रहा है ना. Am I clear? So asthma के patient को recurrent attacks आते रहते हैं. So that is why the answer is asthma in this question. Am I clear? So read the question carefully. I know like most of you have marked the answer COPD, but why COPD is not the answer? Because look at the age, and COPD will not have similar episodes. Look at the age and look at like he is using accessory muscle. So most probable diagnosis in this case will be asthma. It's a case of acute severe asthma because patient is using his accessory muscles. We call this acute severe asthma. Clear? Or when I can say when he stop using his accessory muscle, then that type of asthma is called asthma with impending respiratory failure. Okay, next one. Try to answer. Try to answer this question. So let's say this question थोड़ा सा clinical type का question है, बड़े options हैं. So here we have multiple options. I think complete question is missing in my list. So there are multiple choice or multiple correct questions, answers are correct here. So 34-year-old female has come with a history of malaise and fever for the past 2 days with sudden onset of focal seizures. Weakness है, malaise है, focal seizures है, and with secondary generalization. MRI brain in T2 flare is showing hyper intensity. It is not sensitivity, hyper intensity in medial temporal lobe and cingulate lobe. So patient is diagnosed with HSV encephalitis. So diagnosis is already given, herpes simplex virus encephalitis. So here you have to choose multiple answers. Multiple answers are correct. So basically they're asking you what are true about herpes encephalitis. So let's see one by one. First option is nearly 100% of proven herpes simplex encephalitis have MRI abnormalities. Answer, this is a wrong statement. Only 30 to 60% will have positive MRI finding. other patient will have a normal MRI. So this is the wrong statement. So आपको correct choose करना है. Is it clear? Okay, so let's see. CSF, herpes simplex virus PCR may be negative in first 72 hours of symptom. Okay, generally understand this herpes simplex encephalitis. You have to remember two things. First, it is caused by herpes simplex virus 1. And here MRI will have abnormalities in around 30 to 60% of patients. Then how we make a diagnosis? In lumbar puncture, you will see a red color CSF. In LP, you will see a red color CSF. And third thing which you have to remember is like in any herpes, here also we will use same drug. Acyclovir ही आपको use करना है. So DOC will be acyclovir. And very important, this question came in last INI-CET exam. तब भी पूछा गया था, दोबारा पूछ सकते हैं. Like you will see a strange type of seizure here. That is focal seizure with secondary. It's a very rare seizure. So what we see a pattern in EEG. That pattern is called PLED. इसको short में बोलते हैं PLED. Means periodic lateral epileptiform discharge. We call this PLED. So this PLED word is very important. We call this periodic lateral epileptiform discharge. So let's see this. CSF may be negative in initial. This is a correct statement. Lekin generally after 48 to 72 hours CSF PCR if you will do, that will come positive. Let's see next option what we have. We have herpes simplex virus IgM antibody can be detected within the first week of symptom. No. This is not detected in the first week of symptom. So it's the wrong statement. EEG will show periodic stereotyped sharp and slow complex in temporal lobe. इसी को क्या बोलते हैं? इसी को बोलते हैं PLED. Periodic stereotyped sharp and slow complex. What we call this PLED. So this is seen. It's the classical EEG finding. It's a classical EEG finding. Acyclovir is the treatment of choice. Yes. So answer will be 2, 4, 5. Just see this. This could be a multiple choice question. So answer इसका क्या होगा? 2, 4, 5. 2, 4, 5. Am I clear, guys? Is it clear? Naveen? Is it clear? Am I clear? आगे चलें. नदीम, प्रतीक, विक्की. Okay, so here you can see answer will be A, 2, 4, 5. Okay, moving to next one. This is easy. ये easy question है, तो इसको तो बहुत simple है. Try to answer. A 55-year-old male known case of coronary renal failure on twice weekly dialysis. So generally this is like thrice a week हम recommend करते हैं dialysis, लेकिन कई बार patient afford नहीं कर पाता. Sometimes patient can't afford. So अभी ये twice weekly ले रहे हैं. Present to emergency room with acute pulmonary edema after missing the last 2 sessions of hemodialysis. So patient के dialysis चल रहे थे. Now he missed the dialysis. His ECG is done and at the emergency room showing hyperkalemic changes. Following ECG changes correspond to what levels of potassium? So basically they are asking you at which potassium level what type of changes you will see. Am I clear? तो ये आपसे पूछा जा रहा है. तो question easy है. तो let us discuss these changes. So just try to understand this. Normal potassium value, it is 3.5 to 5.0 milli equivalent per liter. So ये तो नॉर्मल वैल्यू है. तो इसमें ECG में क्या आएगा? कुछ भी नहीं आएगा. Am I clear? 3.5 to 5. कुछ बुक्स में 5.5 भी लिखा होता है, बट रिमेंबर दैट 5 अप टू आई कैन से 5 to 5.5 इसको हम बोलते हैं एसिम्प्टोमैटिक हाइपरकैलेमिया. Asymptomatic means generally ऐसा कब होता है? Like sometime whenever you are giving blood samples, so you are clenching your fist tight. So basically it's an artifact. इसको बोलते हैं pseudo hyperkalemia. And sometimes it is seen in patient taking ACE inhibitor or ARB. So it's called a very mild type of hyperkalemia. So here you will not see any changes in ECG. So here ECG will be normal. ECG will be normal. सो अगर आप देखोगे तो 2 ऑप्शन रूल आउट हो गए, रूल आउट, रूल्ड आउट. एम आई क्लियर? इज इट क्लियर? देन यू कैन सी एट दिस वैल्यू 5.5 to 6.5. 5.5 to 6.5, you can see there will be appearance of tall T waves. Tall T waves. And in the value of 6.5, अगर 6.5 से 7.5 की बात करूँ मैं, you can see there will be disappearance of P wave. So there will be loss of P wave. P wave गायब होना चालू हो जाएगी, right? And sometime if I can say, let me write it here. If you see, value will come in a range of 7.5 to 8. 7.5 to 8. Then here you will see there will be wide QRS. Wide QRS. And ultimately the values, when that become more than 8, then you can see this type of pattern. This type of pattern is called sine wave pattern. Sine wave pattern. Is it clear? तो एक बार क्वेश्चन ये भी आया था, लाइक जनरली इन प्रैक्टिस वी सी साइन वेव पैटर्न व्हेन पोटेशियम इज मोर देन 10. जनरली कब मिलता है प्रैक्टिस में? जब 10 से ज़्यादा होता है. तो लेट अस सी दिस सिंपल. पोटेशियम वैल्यू नॉर्मल 3.5 to 5, तो पहले में तो कुछ भी नहीं मिलेगा. इफ़ यू सी सेकंड 4.5 to 5.5, अगेन इट इज़ एसिम्प्टोमेटिक. 5.5 तक गया तो कुछ भी नहीं मिलेगा. हियर आई हैव नॉट, हियर ऑल्सो ECG, बिकॉज नॉर्मल में क्या आएगा? ECG नॉर्मल ही आएगा. 5.5 to 7, if you see this, here you will see tall T wave. So more than 8 will be the answer. तो ये सबका सही हुआ है, right? Am I clear? So sine wave pattern you will see when values are more than 8. आगे चलें. Okay, then try to answer. This is I can say the easiest question. सबसे easy question यही है, मैंने कई बार डिस्कस किया हुआ है. So try to answer easy one. रविंदर, विक्की, प्रतीक. 14-year-old boy was detected to have type 1 diabetes. टाइप 1 डायबिटीज़ में लाइटस हुई 2 months बैक, 2 महीने पहले टाइप 1 डायबिटीज़ हुई. चाइल्ड कैन प्रेजेंट विथ ऑल ऑफ द फॉलोइंग फीचर एक्सेप्ट. बताओ. सो अंडरस्टैंड दिस, व्हेन एवर अ पर्सन इज हैविंग डायबिटीज, सो 2 महीने में क्या क्या सिम्टम होंगे? ही विल हैव पॉलीडिप्सिया. पॉलीडिप्सिया मीन्स पानी ज़्यादा पिएगा. देयर विल बी पॉलीयूरिया, राइट. देयर विल बी वेट लॉस, बिकॉज टाइप 1 डायबिटीज़ है तो वेट लॉस ज़्यादा होगा. पॉलीडिप्सिया, पॉलीयूरिया, वेट लॉस. एंड समटाइम यू कैन सी पेशेंट कैन ऑल्सो हैव पॉलीफेजिया, भूख भी ज़्यादा लगती है. सो फर्स्ट 3 आर क्लासिकल सिम्टम. पॉलीफेजिया इज़ नॉट अ क्लासिकल सिम्टम. व्हाट एल्स? अगर पेशेंट ठीक से दवाई टाइम पर नहीं लिया तो मोस्ट ऑफ दिस पेशेंट हाउ दे आर डायग्नोज, दे विल एंड अप और दे विल लैंड अप इन डीके भी हो सकता है, कोमा भी हो सकता है. डीके कोमा के साथ आ सकता है पेशेंट. बट रिमेंबर दिस न्यूरोपैथी, रेटिनोपैथी, डर्मोपैथी, right? These I can say these complication, neuropathy, retinopathy, nephropathy, these are microvascular complication. They will develop minimum 5 years after diagnosis. Yes, sub-zero, very good. So these 3 complication, patient DK के साथ तो एडमिट ही होता है. Retinopathy is something. Retinopathy, I can say one more, diabetic neuropathy. Then I can say one more, diabetic nephropathy. So these complications will develop minimum, they will develop minimum after 5 years, because after 5 years slowly over time you will see non-enzymatic glycosylated end product, they will accumulate and they will cause the destruction. So answer will be D. Yes, very good. तो आंसर क्लियर है, इसका क्या होगा? D. Okay, moving to next one. Try to answer this. A 26-year-old female, 26-year-old female complaining of constant sense of thirst. प्यास लग रही है. She feels that she drinks more fluid and urinate more often than normal. So polydipsia, polyuria, 2 things. So let us see, understand this. serum sodium is 138, ठीक है, normal है. Serum osmolality is slightly decreased, so this is something which I can highlight. Plasma glucose is also okay. 24 hours urine total volume is 3.5 liter. That's also little slightly more, but ठीक है ये भी. Urine osmolality is less. So this is something which is two things which I am highlighting here. Osmolality is less. Serum osmolality is less. She is suspected to have diabetes insipidus. So suspicious दे दिया diabetes insipidus का. A water deprivation test demonstrate a rise in serum sodium from 141 to 145 and no change in serum osmolality. Serum osmolality में कोई change नहीं आया, sodium में change आ गया. Osmolality of urine over this period increased from 70 to 525. So this is the biggest hint in the question. What will you advise to this patient? Okay, first tell me the diagnosis. What are the differential diagnoses? So let us discuss the DDs in this case. अगर आपको differential diagnosis समझ में आ जाएगा, then you will know the answer. Okay, tell me the differential diagnosis. What could be the possible diagnosis in this case? First, we will think of common cause, that it could be diabetes mellitus. भूल जाओ अभी क्वेश्चन में diabetes insipidus लिखा है, भूल जाओ. It could be diabetes mellitus, right? Now, if you see serum sodium तो normal है, so I cannot say it is SIADH. SIADH will have less sodium, so SIADH is ruled out. So it could be diabetes insipidus, right? Or it could be psychogenic polydipsia. It could be psychogenic polydipsia. So these are three differential in my brain. Now just try to understand this. If you see like this lady is having psychogenic polydipsia or diabetes insipidus. So diabetes mellitus is ruled out. Why? ये ruled out हो गया क्यों? If you see fasting blood sugar is normal. So now this is, we are left with two options. Diabetes insipidus or psychogenic polydipsia. So what you will see? Water deprivation test. Now read this line once again. If you see water deprivation test demonstrate a rise in serum sodium from 141 to 145. It means, and you can see like osmolality of urine is increased. It means she is able to concentrate urine. So that is understand. It means this is not a case of diabetes insipidus. वहाँ पर क्या होगा? She will not be able to concentrate urine. So answer will be psychogenic polydipsia. So let us see. This is the biggest hint. Urine osmolality. Remember, ये किस में बढ़ती है? ये diabetes insipidus में नहीं बढ़ेगी. This will increase all of a sudden after fluid deprivation in a case of psychogenic polydipsia. So let us see amiloride indomethacin. Amiloride generally we use this for lithium induced diabetes insipidus and nothing is mentioned here. Lithium का कोई mention नहीं है, कोई psychiatric disease नहीं है. So these are not the answer. The desmopressin we use in treatment of central diabetes insipidus, again that is also not mentioned. So answer will be psychiatric evaluation. So remember how we'll differentiate. In a psychogenic polydipsia you will notice after water deprivation you will see urine osmolality will have a drastic increase. So this is the hint in the question. Clear? Okay, तो आगे चलते हैं. Next one, try to answer. What you can see? बताओ. What you can see in this case? Nadeem, Naveen, Vicky. बताओ क्या दिखेगा? 54-year-old gentleman present to OPD, 54 age. OPD of medical college with a complaint of shortness of breath and cough for last 2 years. He works in a factory which makes tiles. Tiles बना रही है. For construction industry. So first hint. He has left-sided chest pain and he has been actively smoking BD for last 25 years. X-ray is done. Yes, okay. Answer is correct, asbestosis, but why? If you see the radiographic image, just try to understand this, try to appreciate this. If you you can see this heart border. We call this as shaggy heart border. क्या बोलते हैं उसको? Shaggy heart border. And if you see, sometimes you can see like a whitish patch. This whitish patch, what we call in X-ray, we call this as holy leaf sign. A patient is working in tiles industry. So in X-ray you can see holy leaf sign. And shaggy heart border. Shaggy heart border. shaggy heart border, holy leaf sign. These are seen in a patient with asbestosis and patient is working in tiles construction factory, right? In silica you will not see, in silica you will see nodules, right? नदी में in silica में आपको क्या मिलेगा? Nodules मिलेंगे. It is asbestos. Just remember, asbestos will also increase the risk of bronchogenic adenocarcinoma, and it can also increase the risk of mesothelioma. However, most common cancer will be adenocarcinoma, most specific will be mesothelioma, right? So here you can see the classical X-ray findings. So these X-ray finding आपको X-ray या देखना है shaggy heart border. It's very very important. Okay, now coming to next one. 28-year-old male. 28-year-old male present with 6-month history of bloody diarrhea and crampy abdominal pain. 6 महीने से bloody diarrhea, crampy abdominal pain. Past medical history is significant for psoriasis, for which he was taking topical corticosteroid. Colonoscopy showing continuous involvement of rectum and sigmoid colon and erythema and ulcers. So बस यहाँ diagnose मेरा बन गया. Tell me the answer. Biopsy finding भी पढ़ लेते हैं. Biopsy showing cryptapsis and lamina propria contain a mixed inflammatory infiltrate. So what is the diagnosis? First tell me the diagnosis. Come on. पहले diagnose बताओ, फिर आगे बात करेंगे. पहले diagnose बताओ. नदीम, प्रतीक, sub-zero. Diagnose बताओ. What you can see? Tell me the diagnosis. Yes, very good. It's a case of ulcerative colitis. So basically they are asking you like ulcerative colitis के लिए क्या true statement है, right? Sometime in the terminal ileum transmural inflammation may occur when the whole colon is involved. ऐसा हो सकता है क्या? Transmural हो सकती है, right? But ileum में नहीं होती. So that's why it's a wrong statement. Am I clear? So ulcerative colitis will involve rectum. So most common finding will be proctitis, that is inflammation of rectum, followed by colon. It will not affect ileum. Normal appearing microscopic area is usually abnormal. That could be correct statement. तो मैं इसको रख दे रहा हूँ अभी. I'm not making a choice here. Erythematous fine granular surface with sandpaper appearance is seen in advanced disease. Erythematous fine granular surface with sandpaper appearance. It is seen in mild disease, not in advanced disease. So it's a wrong statement. This is seen, but this is seen in when disease is mild disease. Perianal involvement is common? No. This perianal involvement is common in Crohn's disease. It is common in Crohn's disease. So देखो 3 ऑप्शन गलत हो गए, इसलिए ये आंसर सही हो गया. So answer will be normal macroscopic area is usually abnormal in microscopy, right? So answer for this question will be B. Am I clear, guys? Is it clear? Is it clear? So that is why we take multiple biopsy, right? तो जब आप colonoscopy, endoscopy कर रहे होते हो, you take multiple biopsy in a patient with ulcerative colitis. Just remember the antibody is Priyanka. Okay, moving to next one. Choose the diagnosis based on the given image below. So what you can see in this image? क्या दिख रहा है आपको? First thing is you can see, you should know it is LMN or UMN. इसको कैसे differentiate करेंगे? अब इसको देखो. If you see upper motor neuron अगर होगा, नहीं, ऑप्शन सी कोबल स्टोन नहीं बोल रहा है, राइट? ऑप्शन सी कहाँ है? Option C is not cobblestone. Cobblestone will be a yellowish white calcified area. Option C is seen in mild form. It is not seen in advanced disease. Am I clear? Option C भी मिलता है, इसी में मिलता है ulcerative colitis में, but it is seen in mild disease, not in advanced disease. Okay, first tell me how you will differentiate upper motor neuron or lower motor neuron. So understand this. If you see upper motor neuron disease, if you see it's a UMN or LMN, तो कैसे आप डिफ्रेंशिएट करोगे? अगर UMN टाइप की पालसी होगी, राइट, यू कैन सी देयर विल बी स्पेयरिंग ऑफ फोरहेड. इसमें फोरहेड इन्वॉल्व नहीं होगा, You can see there is sparing of forehead, right? And it will involve, I can say, opposite side lower face area. And if it is element, this will involve full face with the forehead. So अब इसमें आप क्या देख रहे हो? What you can see in this? You can see like a flat nasolabial fold. What else you can notice? You can notice like there is a drooping of eyelids. There is drooping, means there is ptosis. What else you can notice? So this is basically, you can see entire face is involved, and there is like you can see, this is what we call this. इसको क्या बोलते हैं? We call this Bell's phenomena. Sometimes you will see like there is upruling of eyeballs. इसको बोलते हैं Bell's phenomena. तो पहले आप मुझे बताओ, फोरहेड इन्वॉल्व हो रहा है कि नहीं हो रहा है? Forehead involved हो रहा है? You can see forehead involvement. That is why, because of forehead involvement, you can see there is upruling of eyeballs. So it is element. So UMN वाले ऑप्शन को मैं rule out कर दे रहा हूँ. Okay, so some of you might be asking कि LMN में forehead का involvement हो रहा है, UMN में नहीं हो रहा है. क्यों नहीं हो रहा है UMN में? बताओ. Why in UMN forehead is not involved? Because understand, there is bilateral innervation. There is bilateral cortical innervation. दोनों तरफ से cortical का innervation होता है, इसलिए forehead की sparing होती है UMN में. So understand this, whenever we have a patient with facial nerve palsy, so you can see in this case I can see some findings which I am writing here. What you can notice there will be a flat nasolabial fold, right? And you can notice like patient is having ptosis, and you can see there is upward ruling of eyeball. We call this Bell's phenomena. So this is like I can say it's a case of right-sided lower motor neuron palsy. And if you see like this Bell's palsy, which is lower motor neuron, this will affect the entire face. So you can see entire face is affected. Moving to next one. Again, it's very simple, easy question. After undergoing thyroidectomy हो गई. A 45-year-old patient experienced symptom associated with damage to parathyroid gland. So thyroidectomy के साथ साथ कभी कभी क्या हो जाता है? There is accidental parathyroidectomy. अब parathyroidectomy होगी तो क्या होगा? There will be symptoms of hypocalcemia. होगा, am I right? Now there is hypocalcemia. So what you will notice? You will notice hypocalcemia means there will be tetany feature. Tetany means there is exaggerated reflex, which we call these exaggerated reflex. What we call this carpopedal spasm, and sometimes you can see this is what we call this Chvostek sign. So you can notice patient will develop Chvostek and Trossio sign. Chvostek sign and Trossio sign. Okay, let's see option. Increase urine production. Parathyroid, thyroid का इससे कोई मतलब लेना देना नहीं है. So understand there is no relation with this. So polyuria is not seen. So B is the correct answer. Let's see other option. Difficulty passing stool. So after surgery due to like a bad written condition, ऐसा हो सकता है पेशेंट का स्टूल पास ना हो, बट इट्स वेरी कॉमन थिंग आफ्टर सर्जरी बिकॉज पेशेंट इज हॉस्पिटलाइज, वो बेड पर बैठा हुआ होता है, लेटा हुआ होता है. सो कॉन्स्टिपेशन इज क्वाइट कॉमन, बट दैट इज हैविंग अगेन नो रिलेशन विथ थायराइड और पैराथायराइड, राइट. क्रोनिक हाइपोथायराइड कैन कॉज दिस, बट अभी तो सर्जरी जस्ट हुई है तो अभी एकदम से नहीं होगा. Excessive sleepiness, again they are asking complication related to parathyroid gland, not due to thyroid. So excessive sleepiness is also seen in chronic hypothyroidism. So answer will be exaggerated reflex. So Chvostek and Trossio. Okay, try to answer. बताओ. A 35-year-old patient present to OPD with complaint of persistent. So first is hint is age, persistent excessive sleepiness and lethargy. क्लिनिकल इमेज में आपको क्या दिख रहा है? व्हाट यू कैन सी इन दिस इमेज, image reveal classical finding. Abdominal examination indicate no presence of free fluid, and the liver and spleen are non-palpable. Liver spleen palpable नहीं हो रहे. Patient reports a history of regular alcohol consumption. What is the most likely diagnosis? बताओ क्या होगा? What do you think? Try to answer. What could be the diagnosis in this case? Okay, so you can see like what you can notice in this image. In this image, what you can see here, this is like patient is having contracture. We call this a Dupuytren contracture. And in this image, what we can see icterus. Icterus means there is a yellowness in the eyes. What else you can notice? You can notice like this is here. You can see like there is a jaundice. Patient is having jaundice, right? So based on this, and here if you notice, अगर आप यहाँ देख रहे हो ध्यान से, you can see like this angle is elevated, so there is jaundice and clubbing. और साथ में क्या है? Clubbing. So if I zoom these eyes, why I am zooming this eyes? Anyone? मैं क्यों zoom कर रहा हूँ? Because I want to see some KF ring. So KF ring is not visible. Even like we can't see this through naked eye. For this we need ophthalmologist opinion. We have to do slit lamp examination. So what could be the diagnosis? Liver spleen palpable नहीं हो रहे. So understand this. So generally patients having history of alcohol consumption. So it could be an alcoholic hepatitis converting into alcoholic cirrhosis. Hepatolenticular degeneration is Wilson disease. So Wilson वाले कोई feature नहीं है. So there are no neuro-Wilson feature. There are no other features. So only contracture is seen whenever there is cirrhosis. Contracture कब होगा? जब cirrhosis होगी. So this is the biggest hint. Portal hypertension के features क्या होते हैं? There will be esophageal varix. There will be bleeding with hematemesis होगी. Or I can say there will be bleeding in the form of melena. Hemorrhoids होंगे. In Budd-Chiari syndrome also you can see feature of portal hypertension, and here you will see hepatic venous thrombosis. But अगर किसी patient को contractures बन रहे हैं along with the jaundice, contractures they develop very late. They will not develop in early manifestation of disease. So मैंने like I have never seen a patient with alcoholic hepatitis developing contractures. Contractures you will see they are more specific for cirrhosis. So that's the answer will be alcoholic cirrhosis. अब clubbing भी हो रही है, so probability is this is like a patient who is having liver cirrhosis that is converting into HCC now because there is clubbing. nail clubbing हो रही है, इसका मतलब अब cirrhosis से किस में convert हो रहा है? Hepatocellular carcinoma. So answer will be alcoholic cirrhosis. Okay, moving to next one. So try to answer. A young woman was diagnosed with SLE nephritis. Kidney biopsy suggested for wire loop lesion. In which category of lupus nephritis does the patient belongs? तो वायर लूप लीजन है, तो सारी कैटेगरी बता दो मुझे क्या क्या होती हैं. वी हैव टोटल 6 टाइप्स ऑफ लूपस नेफ्राइटिस. सो lupus nephritis. Okay, just this iPad is switched off, so I cannot see your comments. So let me open and see your comments in my phone. बताओ कौन कौन से होते हैं? टाइप 1 कौन से होते हैं? टाइप 2 कौन से होते हैं? टाइप 3, टाइप 4, टाइप 5, टाइप 6. ओके, हु विल आंसर? बताओ कौन बताएगा? यस, कम ऑन गाइस. मोस्ट कॉमन टाइप कौन सी होती है? मोस्ट कॉमन टाइप इज टाइप 4. मोस्ट कॉमन टाइप इज टाइप 4. क्या बोलते हैं टाइप 4 को? यस, विक्की, प्रतीक, सब जीरो, सूरज, ट्राई टू आंसर. क्या क्या होते हैं टाइप्स? टाइप 1 इज मिनिमल proliferative type. We call this minimal proliferative. Type 2 is called mesenchio-proliferative. Yes, type 3 is called focal proliferative. Type 4 को हम बोलते हैं DPGN, diffuse proliferative. Type 5 is called membranous. And type 6 is advanced form. Generally यहाँ पर क्या होता है, पेशेंट को किडनी फेलियर के फीचर आते हैं. Means you will see CKD features. So understand this, type 4 and type 5, these are severe form. So generally most common type diagnosed, and type 1, 2, 3 will have less symptom. तो टाइप 4 इज मोस्ट कॉमन टाइप डायग्नोस्ड एंड इसी में सब कुछ आपको मिलता है. All the classical finding you will see in type 4. What are the classical finding you will see in biopsy? You can see wire loop capillaries. We call this wire loop lesion. Wire loop lesion. What else? Here you will see like everything will be deposited. Antigen, antibody. तो क्या बोलते हैं उसको? ABCD. Right? Manoj, what happened? Yes, minimal mesangial. Very good. Come on. तो और क्या दिखता है? मैंने क्या बताया था? एवरीथिंग विल डिपॉजिट. व्हाट वी कॉल ABCD. एनी बडी कैन डिपॉजिट. इसको बोलते हैं फुल हाउस इफेक्ट. वी कॉल दिस फुल हाउस इफेक्ट. क्लियर? एम आई क्लियर? ओके, कमिंग टू नेक्स्ट वन. तो आंसर क्या होगा इसका? आंसर तो बताओ. आंसर क्या होगा? मोस्ट कॉमन टाइप इज डिफ्यूज प्रोलिफरेटिव. मीन्स आंसर विल बी सी. राइट? Okay. 38-year-old female came to OPD with chief complaint of dryness, bilateral parotid gland swelling and difficulty chewing food. अब ये तो इजी है, इसमें नहीं बोलना है कि नहीं पता, ये तो सिंपल है. बताओ मनोज, रंगेश, सब जीरो. बताओ क्या होगा आंसर? मनोज, डोंट टेक टेंशन. बिना टेंशन के पेपर निकलता है. जस्ट चिल रहो, बढ़िया गाने सुनो, पढ़ते रहो. टेंशन लेने से कुछ नहीं होता किसी का, और सबको कुछ ना कुछ टेंशन तो रहती है. जितना कम सोचोगे बस पढ़ते चले जाओ. नथिंग. ओके, क्या है इस डायग्नोस? क्या है? व्हाट इज द डायग्नोसिस? अब देखो, फीमेल पेशेंट है, यंग फीमेल. डेंटल केरीज. देखो डेंटल केरीज हो सकती है, बट डेंटल केरीज में इतनी प्रोडक्ट स्वेलिंग नहीं आएगी. Behcet syndrome. Behcet syndrome will have recurrent oral ulcers, genital ulcers, positive pathology test and ocular manifestation. ऐसा कुछ भी नहीं दिया हुआ. Keratoconjunctivitis सिक्का, सिर्फ आँख की बात चल रही. It is actually a case of Sjogren syndrome. So diagnosis will be Sjogren syndrome. Why Sjogren syndrome? Because first hint in the question is dry eyes. So there is dry eyes, means there is dryness in the eyes. Then you can see bilateral parotid gland infiltrate. बायलैटरल पैरोटिड ग्लैंड इन्फिल्ट्रेट. आईपैड बंद हो गया. बायलैटरल पैरोटिड ग्लैंड इन्फिल्ट्रेट. एंड व्हाट एल्स यू कैन नोटिस? बिकॉज ऑफ दिस देयर विल बी डिफिकल्टी चूइंग. तो ड्राई आइज, ड्राई माउथ, ड्राई स्किन, ड्राई वजाइना. अब मुझे बता दो नया ड्रग कौन सा है इसके लिए? विच न्यू ड्रग वी यूज टू इंक्रीज, आई कैन से टू इंक्रीज द to improve the dryness? What is the new drug? Cevimeline. This could be a probable pharmacology question in this attempt. Expected question. Cevimeline. Okay guys, so this was all for today's discussion. I hope you made few mistakes, so these mistakes you will not do in the exam. Okay, why not D? Because D is keratoconjunctivitis sicca. It's only dry eyes. Here you can see dry eyes. Keratoconjunctivitis sicca is only a symptom of Sjogren syndrome. Am I clear? Shabina, keratoconjunctivitis sicca means dry eyes. That is a symptom of Sjogren syndrome. Offline coaching, you can come to LN next. I think class is in October. We'll discuss medicine in detail in the new batch. Okay, with this, I'll conclude the session. Thank you so much. Just keep working hard. ज़्यादा सोचना नहीं है. All the best. Bye bye.
All okay? Hello, my dear friends. A very warm welcome to all of you in this CBoT discussion session. So let's start with PSM question. As you can see, the first question is about the MTP Act, in which they are asking that if the pregnancy is of 18 week, whose approval is needed. So I hope you know that now according to new MTP Act, till 20 week, only one doctor approval is needed. So that is single doctor. But if it is between 20 to 24 week, then we need approval of 2 doctors. And if there is congenital anomaly, it is specifically written that if there is congenital anomaly, in that case, even for more than 24 week, we can go for the abortion. Of course, till 20 to 24, if there is rape victim or incest victim or victim of failure of contraceptive, in these 3 cases, we allow the abortion to occur between 20 to 24 week, but only when there is approval of 2 doctors. Now, okay, so till 20 week, 1 doctor. After 20 week, there need to have approval of 2 doctor between 20 to 24. Next question is that a 33-year-old woman with a history of well-controlled HIV receives a pap smear, and along with receiving pap smear, she also get the refill. So pap smear and treatment both are there. So under which this will come? So if it is pap smear and treatment, we all know that when it is secondary prevention, secondary is for early diagnosis and treatment. And because it is early diagnosis and treatment, pap smear is a screening test. So all screening tests come under secondary. They have asked this question also in the past, that a son took his hemiparesis father for checkup, under which level of prevention it will come. So if the hemiparesis father is taken for physiotherapy, then it will be tertiary. But if it is taken for checkup is like a screening test, so it will come under secondary prevention. So definitely there will be secondary prevention, and I hope, yes, Sabina Qureshi, you are right, my dear friend. Sub-zero is also right. And previously also Sub-zero has given correct answer, that less than 20 week, only 1 doctor approval is needed. Very good. Mohammed Anas have a question, sir, PDF kahan milegi? I think it will be uploaded on the YouTube channel on LNext only. But if you still not get it, you can call me. I will make it sure that it reaches you. Okay. Now, next question is, a pharmacologist want to study the efficacy of a new drug in the treatment of diabetes. What will be the study designed to conduct the study? Best study designed to conduct the study. So, because it is efficacy of a new drug in the treatment, so of course the best will be RCT. But this whenever we are comparing new drug with a controlled drug, best will definitely be RCT for it. A study, and I hope you know that in the evidence-based medicine, the first priority is given to meta-analysis, second priority is given to systematic review, and third priority come to RCT or clinical trial. But whenever it comes to comparing 2 drugs, RCT is even better than meta-analysis and systematic review when we are comparing the efficacy. Because in meta-analysis and systematic review, we combine the result. But if it is a new drug, then we are doing it for the first time, so better will be RCT. Now, very good, correct. Next is, a study is being conducted on quality of life after radiotherapy in breast cancer patient. The ordinal data of this study can be represented by. So, there are 2 things here. one thing they have given that it is ordinal data. Ordinal means qualitative data. And for qualitative data, we know there are 4 methods. And when I was in MBBS, I used to remember it like this, that going to bar, okay, eating pie in a bar, because no one eat pie in a bar unless you have smoked marijuana or all, then you can eat sweet dish. Pie is a sweet dish, no one eat it in the bar unless you are high or something. So going to a bar, eating pie in a bar, then drawing map or picture in a bar. These are the work which only quality people can do, okay, or quality crack people can do. So these are qualitative data analysis method. These are quality people can do, so qualitative data. So what are the 4 methods for qualitative data? One is bar diagram, other is pie chart, third is spot map, and fourth is pictogram. These are the 4 of qualitative method. Rest all are quantitative. And because they have used the word ordinal data, so it is definitely qualitative. And the answer will be bar chart, because rest all are quantitative. Okay. And they have asked 2-3 questions from this part in the past. One thing is that this pie chart is also used to explain balanced diet to layman. Second thing is that this in the bar chart there are also component and multiple bar chart. So I hope you know, whenever they are drawing component bar chart, it will be 1 bar and then above it there will be some another bar. So that will be component bar chart. And whenever they are drawing multiple bar chart will have 2 or 3 bars adjacent, and then there will be gap at regular interval. So this is multiple bar diagram and this is component bar diagram, which they can ask. Okay, yes. Thank you, my dear friends, for replying. It was definitely bar chart, and Ragnesh, yes, you are right. These are the 4 method of bar chart. Now, a program was launched to reduce malnutrition in the country with the convergence of various sectors and programs like Anganwadi Services, National Ministry of Health and Family Welfare. Logo of program is given. Identify the program. So this program is definitely PM Poshan, not PM Poshan, it is Poshan Abhiyan. What is the difference between them? See, PM Poshan is the replacement of midday meal. And if you look at the logo of midday meal will have children sitting in a circle and plates will be in their hand like that. Logo will be there. Children sitting in a circle and eating food. And when PM Poshan replaced midday meal, they added one new thing, that along with his school children, preschool children will also get the lunch. Preschool children plus school children, both will get the food. And what is the food that they will get? They will get half of protein and 1/3 calorie which is needed per day. And they can ask that under which ministry PM Poshan is coming. PM Poshan is coming under Education Ministry. So respected Smriti Irani is looking at this work of PM Poshan. Okay. Now, next is what is this Poshan Abhiyan we have? It's an umbrella program और इसकी छतरी के नीचे कई program आते हैं. First program which come under it is definitely PM Poshan which come under it. Second which come under it is the Nikshay Poshan. In Nikshay Poshan, the word is Nikshay. Nik means no and Chay means loss of body, malnutrition. So Chay stand for TB and it is no TB. And for no TB, government is giving some money for the nutrition. How much money? 500 rupees per month. Okay. So this much money is given to sustain their nutritional supplementation of TB patient.
Other than that, in the Poshan Abhiyan, we also have Anemia Mukt Bharat, whose target is to reduce anemia each year by 3%, and there is 6 into 6 into 6 strategy for it. The first 6 are the people who will get the benefit. Second 6 are the benefit that they will get. First are the beneficiary, second 6 is the benefit, and last 6 is the institutional mechanism. So in the recent exam, they have already asked what does 6 by 6 into 6 does not include. So one is institutional mechanism, then there is the beneficiary who will get the benefit. So these are the 3 6. Okay. कुल मिला के बड़ा ही छक्का प्रोग्राम है ये. There is a lot of 6 in it. 6 people will be benefited, 6 benefit will be given, and 6 method will be there to give them the benefit. Okay. Other than that, we can also include Anganwadi program, adolescent program under Poshan Abhiyan. So these are the things which you should know from this point. Next is there is a study where the population was divided into 3 groups. See, whenever you are dividing population into 3 groups and then choosing people from them equally, you are creating layer. Layer means strata. आप परत बना रहे हो, आप कैटेगरी बना रहे हो, तो उसको कहते हैं स्ट्रैटा. स्ट्रैटा मतलब लेयर होता है. So this type of sampling where you are dividing people into 3 groups and then choosing from them is a stratified random sampling. Now, this sampling is best for heterogeneous population. What is heterogeneous population? Heterogeneous population is different from each other. Let's say I want to choose 10 people out of 100 students for a party after the class. Okay. So I can select 10 students by simply putting their roll number and pulling out the chit. So that is simple random sampling. And simple random sampling is best for homogeneous population. Second method of selecting a student is, I want that in that party when we have the 10 children, I am all settled, happily married person with a 2-year-old cute little girl, Prisha. But I want to have more love in the nature, more love among students and everywhere. So I can select 5 boy, 5 girl out of the class. So that means first I am dividing the student into boy and girl, then choosing 5 from them. So that is stratified random sampling. So here, boys and girls are different in terms of sex. So that will be heterogeneous population. So if I am choosing randomly 10 people, simple random. Dividing and choosing stratified random. Systematic random, what I can do is, I can ask randomly, give me any number between 1 to 10. If you gave the random number as 7, I will choose every 7th student. So I am following a system and that number came random. So that is systematic random sampling. Now what is multiple cluster sampling? Multi-cluster sampling has another name known as multi-stage sampling. Sometimes they give you an image-based question where they give you a map. And suppose, let's say I want to know how many students are smoking cigarette in Delhi 11th, 12th class. So to know that, suppose this is the map of Delhi, some map is there. And in that map of Delhi, let's say the map went into a different distorted sap. So let's draw it again. So suppose this is the map of Delhi. And in the map of Delhi, I will choose any 4 area. From this 4 area, I will choose 2 colony each area. And from each colony, I will choose 3 school. I will do the study on these children and I will say this is the data of smoking for the whole Delhi. So, this is multi-stage sampling because what is Delhi? Cluster of people. What is area? Cluster of people. Colony is also cluster and school are also cluster. And I am choosing cluster again and again. So that's why we call it multi-cluster sampling. Okay. And multi-cluster is also multi-stage sampling. So why I draw the map of Delhi? I could have written Delhi. The reason of drawing map is in exam when they ask question, they will give you the map and then a small area from that. That will be multi-stage random sampling. Okay. Now, A 22-year-old newly married female presented to OPD with complaint of fever, with chills, generalized body ache and vomiting. While giving the history, she also mentioned that her period are 14-day delayed. On urine pregnancy tests, she turned out to be pregnant. What is the drug of choice if you suspect malaria in this patient? So first thing is, I hope you all know, here she is in first trimester. And in first trimester, artesunate is contraindicated. So in place of artesunate, we give quinine. There was a very good session of Chote Miya Bade Miya, which me and Dr. Ankur Jain sir used to take together. And in one of that session, Dr. Ankur Jain gave me this mnemonic to remember it very good, that in the first trimester, the female should be treated like a queen. So we are giving the drug quinine. Okay, so first trimester we don't give artesunate, we give quinine. Second point, they have not mentioned the state, but if they have mentioned northeastern state, then in case of northeastern state, the drug of choice will be artemether plus lumefantrine we give. Artemether plus lumefantrine. So if it is northeastern, these two. If it is not northeastern, we give artesunate, but in first trimester we give quinine. And of course, I hope you know that primaquine have 3 contraindication. This is contraindicated in less than 1 year children, infant. It is contraindicated in pregnancy, and it is also contraindicated in G6PD deficiency. So what is the drug we give? Quinine. Very good Sub-Zero, Sabina Qureshi and Rajesh Kumar, Pratik Mishra for replying. I love you, dear friends. Thank you for being with me here and replying. Very good, Sumit Tiwari. Thank you for replying. You are also right. Chalo. Now, next is a patient presented with complaint of polyneuritis, ataxia and mental disorder, mental deterioration. These are the picture which they ask in NEET exam also. This is a classic picture of Goa. Goa stand for global aphasia, I hope you all know. And then there is ataxia. And then there is, what is A? O for ophthalmoplasia. A is ataxia, O for ophthalmoplasia. And these 3 things occur in vernix encephalopathy. And I hope, my dear friends, you know, vernix encephalopathy occur if the person is chronic alcoholic. And in chronic alcoholic, the deficiency will be thiamine. Okay. So, do remember this point. Now, let's say I am that chronic alcoholic who is drinking 1 khamba every night for last 10 years. So, after vernix encephalopathy, I may go into Korsakoff psychosis. And in that Korsakoff psychosis, a very interesting thing will occur that is known as confabulation. Confabulation can be remembered by the mnemonic true lie. So like I will come in the class, I will say that I am coming after 1 hour of jogging. Actually, I just slept and I did not went for jogging. But I am not telling you lie also. So how is it possible that I did not went for jogging and I am telling you that I went for jogging and it's not a lie? It's because due to drinking too much, my mind is so messed up that now I am unable to tell what is truth, what is my dream, what is reality. So that is confabulation, in which patient speak true lie. Sachcha jhoot bolta hai wo. Okay, very innocent patient. And in the NEET exam, they asked 2 questions from thiamine. One was, they gave a classical feature of patient with dyspnea. Do remember it. Patient have dyspnea and patient have pitting edema, feature of CHF, congestive heart failure. So this are in wet beriberi. Dry beriberi will have neurological symptom. These are the symptom of wet beriberi. And in wet beriberi, which enzyme is deficient? The enzyme which is deficient is thiamine transketolase enzyme. And of course, I hope you know, this is due to eating polished rice, this problem occur. So, hello Ajad bhai, hello Sarji, hello bro. Hello, my friend. Next question. Which vitamin is deficient in human milk? Answer is vitamin K. Vitamin K is deficient in human milk. That is why we give injection of vitamin K just after birth. And vitamin C is deficient in egg. Okay. Coming to next question, which is mainly responsible for disinfecting property of chlorine in bleaching powder? Answer is hypochlorous acid, HOCl minus, 1 minus. This has 85% killing action, dishum is done by hypochlorous. So how do you remember it? Very simple. The one with rus is a Hindi word which means juice. तो जिसमें ज़्यादा रस है, जिसमें ज़्यादा जूस है, वो ज़्यादा बैक्टीरिया मारेगा. The one with rus will kill maximum bacteria. Okay? That is the simple way. And I hope you know the steps of chlorination. In the first step, we use Horrocks apparatus to know the amount of bleaching powder which we need to put to kill all the bacteria. And Horrocks apparatus have 6 white tube and blue color indicator starch iodine. After putting that bleaching powder, we wait for 1 hour. That 1 hour is the contact period. In that contact period of 1 hour, this hypochlorous ion kill most of the bacteria. After that, there is a chloroscope instrument which will detect how much chlorine is left in the water, residual chlorine. And minimum residual chlorine should be 0.5. Now, chloroscope had 2 tests under it, orthotoluidine arsenide. Orthotoluidine test detect both free and combined chlorine, just like orthotoluidine arsenide. They both detect free and combined chlorine. The difference is orthotoluidine detect it together. Orthotoluidine arsenide detect it separately. Okay. So this is some important question which they ask from here. Now, HDI focus on 3 basic dimension. Long and healthy life, which is detected by life expectancy at birth. In HDI, it's at birth. In PQLI, it is life expectancy at 1 year. How to remember? It's very simple. PQLI can be thought as L1. So it's already written in it that in PQLI, life expectancy is at 1 year, not at birth. Second thing is knowledge. How we estimate knowledge? Knowledge is estimated by 2 things. One is mean year of schooling, and second is estimated average year of schooling. So that will tell the knowledge. And decent standard of living, this is estimated by per capita income. This is by per capita income. So let's see which one is correctly matched. Of course, the first long and healthy life is not by quality adjusted life here. Quali we do not measure here. What is quali? Quality adjusted life here simply means that let's say you want to get fund for dialysis patient. So you will tell that dialysis had 0.5 quali in life of patient, and by this argument you can ask for their fund. So fund for intervention is taken by quali. Knowledge literacy rate. No. Literacy rate, IMR and life expectancy at 1 year. These 3 are criteria for physical quality of life index, PQLI. Okay. Option 3, a decent standard living, gross national income per capita. Yes, this is what we measure in HDI. This is correctly measured. Long and healthy life, life expectancy at 1 year will be wrong. Life expectancy at birth occur in HDI. Life expectancy at 1 year is for PQLI. And PQLI is 4-letter word, big word. So the range is also big, 0 to 100. HDI is 3-letter word, small. So the range is also small, 0 to 1. Okay. Now, I hope you all have given correct answer. No dear, you did it wrong. None of you gave it right except I think Sumit Tiwari gave it right. So it means this topic looks simple but it can be confusing. Do prepare it clearly and remember the logic is very simple. If you remember by logic, you will remember it and not confuse it. What is the logic? The simple logic is PQLI is for developing country like India. HDI is for developed country, better. So, in which country literacy rate matter? India or UK? Of course, it matter for country like India. UK में तो बच्चा बच्चा इंग्लिश बोल रहा है ना? So that's why we have literacy rate in PQLI, because PQLI is for developing country. Second point, IMR is major for developing country because many infants die, and PQLI is life expectancy at 1 year. So again, you can see life expectancy is 1 year plus less than 1 year die will be in IMR. So they will together form the chain. Less than 1 year in IMI, life expectancy at 1 year in PQLI. But per capita income is measured in HDI. Because for which country per capita income matter? India or Russia? Developing country, developed country. For country like India, only 2% population have 90% wealth of India. So if you are measuring per capita income in India, due to that 2% population, it looks good. If you remove that 2%, per capita income will go down, very low. So per capita income do not matter for developing country. It represent only that 2% population mainly. But in Russia country or developed country where HDI we take, their per capita income matter. So per capita income, mean year of schooling and life expectancy at birth will be under HDI. But literacy rate IMR and life expectancy at 1 year will be in PQLI. I hope you will remember it. You are posted in the COVID ward after finishing your duty. Where will you throw the PPE kit? So there are two types of PPE kit. One is the original kit, which is made up of plastic. White color kit with blue color chain, which was originally launched. And of course, because it is plastic, it will go in red bag. Second kind of PPE kit is what you were made to wear when you were traveling on aeroplane and all. That is made up of surgical mask material. So that is not even a PPE kit. That is just a jugaad. वो temporary arrangement है. This is not, jugaad means temporary arrangement. So that is not a real kit. And of course, like it is made up of mask material, so that will go in yellow. And you understand what is temporary arrangement jugaad, na? Like, I hope you do. And one time there was a video that in UP police is attacking criminal and their bullet was not there. So they were creating sound of bullet from their mouth. Thai, thai, that is jugaad. Jugaad means temporary arrangement. You are making it up. So we do not consider surgical mask material as PPE kit. So PPE kit goes in definitely in red. Red also have the urine bag, and yellow will have the N95 and other mask. Yellow will have the blood bag. Similarly, if there is cotton, it will go in yellow. If there is a plastic wrapper of syringe, because that is a garbage, so it will go in black. Okay. Now, just match the following is the next question. Very good. This time you all are right. Correct, Dr. Sabina Qureshi, Dr. Sadani, both of you are right. And if you are giving wrong answer here, don't at all worry, dear. We should give wrong answer in the class. And because if we do mistake, we will remember it better. So we have to correct in the main exam, not in the class. Okay, it can be wrong, no problem. Now, the government of India is doing these 4 interventions, just match it up. So we just read that NEET means no chai, no TB. So no TB is a program for reporting of TB data and follow up of case. Okay. And this is for not only government hospital but also for private. This is NEET. 99 dots is a secret number which is hidden behind the wrapper of TB drug. So when the patient eat it, they see the number and they have to give a missed call. If the missed call does not reach, government will think the drug is not taken and they will send ASA to the home of the patient, and ASA will ask ki, क्यों नहीं मारा miss call? Why you did not give miss call? So then ASA or the dot provider will ask such question, and maybe next time the patient will give the miss call. So that will help us in increasing the compliance to ATT, and patient will not miss the drug. So that is why correct answer is C. What is Anmol? Anmol have a green color logo of mother and child. It simply means ANM online. Anmol is the software of data entry for ANM. And when Anmol was launched, most of the ANM in the central part of India like UP, Bihar and all, they ask, it's very good sir that you gave us the software. But where will we put it? Where is the hardware? because most of the sub-centers, many 30% of the sub-center of India are without proper electricity and water connection. So computer is not there in every sub-center. That's why they were surprised with the software without giving them the hardware. But in some developed part, this can be a really useful thing. It is for data entry so that high-risk pregnancy can be tracked. What is AM cessation? If you want to quit cigarette, just give a missed call on a number given by government. That is AM cessation. And if you give missed call, government will call you again and again, again and again. Why? So that you quit what? Mobile phone. That's why it is AM cessation. Anyway, people cannot quit smoking so easily, but government is trying that they will be giving call and explaining to them why quitting is easy and why they can do it, why they should do it. Okay. Anyway, quitting cigarette is not a tough thing. It's a very easy thing to quit cigarette. I myself had quit cigarette 43 times till now. Okay. So you can also do it. Okay, so this is the matching. Of course, A is with 1, B with 3. So A1, B3. A1, B3 is in B and D only. Then C is with 4 and a C with 4. So C4. That means only correct answer is B. Okay. Coming to the next question. This is the vaccine vial monitor. You can see the outer and inner ring color is same. So if it is same color, which you can see same color, what we will do with the vaccine? Try to answer. Very good, Dr. Sadani and Sabina Qureshi for replying. If it is same color, what we will do? Same color, we always reject the vaccine. Okay. And if the inner color is light, we use it. If the inner color is dark, we again reject it. And do revise open vial policy also. It simply means that some vaccine can be used up to 4 weeks of opening the vial. They only ask what are the name of those vaccine. Very easy to remember. All tetanus vaccine. All tetanus vaccine, all polio vaccine. You just have to remember 4. All tetanus vaccine, all polio vaccine, PCV and hepatitis B. PCV, Hep B, all tetanus, all polio. Okay, like that you can remember. PCV, Hep B, all tetanus, all polio. What are the tetanus vaccine? DT, TT, DPT, pentavalent. So these are in open vial policy. Then what are the polio vaccine? Of course, you know FIPV and OPV. So these all vaccine can be used up to 4 weeks of opening the vial. Okay. Now next question, which of the following is true about body fat measurement? First thing is, kiski chamdi moti hai? Who have more body fat? Skin fold thickness, sorry. It's body fat measurement they are saying, but they are talking about skin fold thickness measure. So skin fold thickness is made more in female. Okay, because they have subcutaneous layer of fat below their skin. So it is more in female and it's not an invasive method. We measure it by Herpenden caliper. Okay, and skin fold thickness is not invasive. So invasive is wrong, but it is measured by Herpenden, not Harpenden, Herpenden caliper. So it's not invasive, so option 1 is wrong. Sum of skin fold thickness of all 4 sides, normal is less than 4 in boy and less than 5 in girl. It is correct that if it is 40 mm in boy or male, we call it obesity. If it is more than 50 mm in female, then we call it obesity. So these are the cutoff in mm. You convert it in centimeter, it will come 4 and 5. And because as I said, female has more skin fold thickness, so 50 mm is in female and 40 mm is in male. So line 2 look like definitely correct. Now what are the 4 places where we measure skin fold thickness? The best is triceps, second is biceps, but third is not suprascapular. Third is subscapular area. Not supra, but below scapula. And fourth is anterior superior iliac spine. So you can call it suprailiac, that is right. But third option was wrong given. Now, it is more than 1 in women and 0.85 in men. No. This they are talking about waist hip ratio. Waist hip ratio more than 1 in men. Because male have bigger waist. So the waist hip ratio is also bigger in male. So more than 1 in male, more than 0.85 in female. Waist hip ratio indicate obesity. Okay, so it's the opposite is written, and this question has been asked 2 times. What is the cutoff for waist to hip ratio in female? 0.85 is in female, 1 is in male. This is waist to hip ratio. But if they ask waist circumference is more than 102 centimeter in male is obesity, and more than 88 centimeter in female is obesity. So remember, whenever they ask a question about waist, always remember me. Male with bigger waist circumference, male jiska kamar kamra hai, and you will remember male is above. And remember 4 data, 102, 88, 1.85. Okay, so कमर की बात आए तो मुझे याद रखना, बट चमड़ी की बात आए तो मुझे मत याद रखना, वरना तुम सोचोगे कि हिप्पोपोटामस चमड़ी वाला टीचर नो, है ना. Otherwise you will think this skin will be more thick, but skin fold thickness, remember it is female, but waist circumference is male. Okay, in both the cases waist or waist to hip ratio is bigger in male. Chalo, I hope you will remember it. Last question, which of the following is false regarding ASA? So first thing is ASA is not 12th class pass. It is written in 3 places. Thus ASA minimum education is 8th pass. 3 place in recent edition of PARC it is written. But if you will Google it, it can come 10th pass. Because we want 10th pass. We prefer 10th pass. But minimum is 8th pass and written in 3 places. So please trust it. It is the most updated information. It is 8th pass. So why on Google it is 10th pass, you can see. Because Google take the advertisement released by state government. And the state government, they want 10th pass, so they release that statement. And if anyone has to create a question, will he go for Google search or will he create it from PARC? Of course, he will create it from PARC. So trust it, it is 8th pass and there is only 1 ASA per 1000. Not 2 ASA per 1000. That was just a recommendation which was never accepted. So it is 1 ASA per 1000. Definitely, ASA should be between 25 to 45 years during selection. After selection, they can be of any age. But during selection, this should be their age. And they work with Village Health and Sanitation Nutrition Committee to celebrate Mamta Divas, Village Health Nutrition Day. Mamta Divas is generally celebrated once in a month with help of Anganwadi and VHSNC. Remember, VHSNC also prepare Village Health Plan. Okay. And of course, ASA act as dot provider to give ORS iron tablet. ASA also provide condom, OCP. ASA provide Nischay kit. Nischay is a Hindi word which means to be sure of. So ASA want mother to be sure of their pregnancy. So this is urine pregnancy test kit which ASA distribute. Along with that, ASA also distribute dots. ASA distribute drugs of common disease. So these are the, and ASA also distribute chloroquine tablet, artesunate tablet and malaria screening test kit, RDT kit. And RDT kit which is distributed, if it is histidine RDT kit only detect falciparum. Optimal kit detect both falciparum and vivax. Optimal kit have lactate dehydrogenase enzyme. But histidine rich protein kit only detect Plasmodium falciparum. I am telling it separately because it was a question in recent year NEET. So it only detects Plasmodium falciparum. I hope this section of discussion of PSM will be useful for you. If you have any doubt, any question, anything you want to say, please say it here. I would love to listen it from you. Okay. So do tell me what are your doubt or question or anything. Ragnesh is asking, ASA can't afford to give vaccination. Yes, there is 3 work which ASA and Anganwadi worker don't do. So what are the 3 work which ASA and Anganwadi worker can't do? First is ASA and Anganwadi worker don't give vaccine. But still, ASA is paid for every vaccination. So if she don't give And she is not paid for every vaccination. She is paid for every vaccine except three: BCG, Hep B, and OPV 0 dose. So you might think, if ASA is not giving vaccine, why she is paid? Because she paid for motivating the mother to go and take vaccine. Now, why she is not paid for these three? Because these are given at birth. And at birth, mother and mother-in-law are in the hospital. तो आशा किसको मोटिवेट करेगी? ससुर जी को, है ना? There is no one to motivate at the home. That's why ASA don't get paid for these three vaccines. Other than that, ASA and Anganwadi worker both don't conduct delivery. ASA have to assist mother during delivery, but they don't conduct delivery. And remember, ASA and Anganwadi worker, they don't make malaria slide. Who make malaria slide has been asked. So I hope you all know malaria slide is made by multi-purpose worker, which is also known as male health worker at sub-center. And question came that MPW make the slide by active surveillance, passive surveillance, or sentinel. So if we are searching for hidden case, which MPW is searching by visiting every house in the village once in a 14 day, so then this type of hidden case is detected by active surveillance. Passive means patient who come to OPD by themselves. So passive is notified case. And if you mix active and passive, it becomes sentinel surveillance, which include all cases. So do remember it. And this is a very important part to remember. Any other question, you can always feel free to ask it. So there is no question coming. I love you all, my dear friend. Dr. Devendra Singh is saying, liking me. I like you too. Love you, dear friends. Keep rocking. Let me know if there is any way I can help you. Thank you so much.
So hi students, I hope you enjoyed this CBoT, and now we are going to discuss the questions of surgery. So questions of surgery, they were I would say on more conceptual side, and some of them you might have found them a bit you can say easy, and some of them you might have found to be tough. So let us start the discussion, and the first question that we have is a ritual that we have to follow. So question of GCS is there. A patient with RTA, he extends his elbow when a doctor puts pressure on the nail. So that means extension to pain. So when we talk about the extension to pain, you know is what? So we have, if you talk about GCS, obeys command is what? 6. Then localization to pain, then withdrawal to pain, then flexion to pain, then extension to pain, and then you have what? Cadaveric position or no response. So extension to pain is M2. He can talk in sentences but is disoriented. So when you talk about the verbal component, he is confused. And when we talk about being confused, so we say that V is what? 4. He is unable to open the eyes. So eye opening is absent, and when eye opening is absent, we always give a score of what, students? We always give a score of E1. So what is the total score? We have E1, V4, M2. So 4 plus 2 plus 1, that's 7. And this is what is very easy question. Next is, after a farmer is struck by a bull, he was taken to emergency. A primary survey was done. No immediate life-threatening issues were seen. The patient complained of pain in the left quadrant. So for that, FAST was done. FAST also didn't show any abnormalities. However, a subsequent CT was done, and once the patient CT was done, it was found to have contrast blush. What is contrast blush, students? Evidence of bleeding from the minor marginal vessels of the what? Splenic artery or splenic vein. Now this is what is very, very, very important. Since these are marginal vessels, the patient might not be that hemodynamically unstable. So hemodynamically stable patient with contrast blush detected on CT, there is no significant blood. Always remember the first line or the treatment of choice. This is angioembolization. And if angioembolization fails or the facility is not available, you have to go for splenectomy. So angioembolization is the answer that you have to mark. Let us understand one more question. So if you need to understand the question by the keywords, you will save a lot of time. Just see the globus sensation. Now I know that there is something that is food sticking. So this is a question of esophagus. The last is what condition is a complication arising from this. So now the patient visited to outpatient department with heartburn, slightly difficulty in swallowing, that is dysphagia, and a sensation of lump in the throat. He had been taking PPIs but was not provided with a complete solution with this. After undergoing surgery, so now you know that we have GERD and the patient has undergone surgery. So that be a fundoplication. Let us see what type of fundoplication. You have anterior, you have posterior, you have total, or you can say complete fundoplication, that is a Nissen's fundoplication. Now he has experienced abdominal bloating and inability to burp. So this is a condition when the stomach is taken or when the wrap is done around the, you can say around the esophagus. So in this case, the scenario is something like this. So the fundus is taken and wrapped around. So in this case, it is something like this. So it's a complete 360-degree wrap. And when the fundus is occupied, so what happens? All the gas actually accommodates in this part only, and that is why the patient experiences what students? Bloating. So this is what is a classical gas bloat syndrome, and gas bloat syndrome is a complication of Nissen's fundoplication. That's a 360-degree fundoplication. To reduce the incidence of gas bloat syndrome, we might go for a partial Nissen, that is 300 or 310. That is also known as floppy Nissen syndrome, a Nissen's procedure of fundoplication. Now let us talk about a patient who presents to us with such an ulcer. The patient is having the ulcer over the gator zone, so we know that it is suspected to be venous ulcer. And according to the SEEP, you know C1 is what? C1 is telangiectasias or reticular vein, C2 is the varicose, C3 is edema, C4 includes the skin changes like pigmentation, lipodermatosclerosis or atrophy blanchi, C5 is healed ulcer, and C6 is non-healing ulcer. Now at this point of time it is non-healing. How will you classify this on the SEEP? So this is not a healed ulcer, this is a non-healing ulcer. So this is C6. It has a history that it is occurring again. It has healed previously. This is a recurrent. So C6R. This is what is very, 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 very important. Now I would see a CT and you can see a hypocoagulation in the liver with a peripheral rim, and this is what is very, very, very important. So this is a double rim sign, and this is probably of what? Liver abscess associated with amoebiasis. Leave it. Let us understand the question first. So this way, by giving CT, the question became very easy. Male presented to the hospital with fever, right upper quadrant pain, and this is generalized malaise for past 2 weeks. This is a classical history now suggesting of liver related symptoms. The patient has chills and has lost appetite. So you know why anorexia? Because there is a liver abscess. He has recently traveled to a country with poor sanitation. Now this speaks that there is amoebiasis in this patient. So gastroenteritis resulting in liver abscess, and there is tenderness in the right upper quadrant which reveals that now there is an abscess. Now with his temperature also is elevated, the investigation shows raised PTNR because of the liver derangement. Now the picture is shown and which is true about the following condition. So most common organism is you can say E. coli. No, it is Entamoeba histolytica or Entamoeba parasiticum. Water lily sign is seen in C3E. It may be correct, but it is not applicable to this scenario. So CE1 is your, you can say, snowflakes. CE2 is honeycombing because of the what? The daughter cyst. CE3, when the cyst wall and the, you can say, laminated membrane gets detached. So that's a what? Water lily sign. And C4 is a, you can say, wool sign because of the calcification and, you can say, degenerating cyst. So this is not applicable here because this is not that case. So drainage of the content will give anchovy sauce. Yes, this is absolutely right. Praziquintal is not metronidazole, a long-term metronidazole, 800 mg BD or TDS for long-term, 6 to 8 weeks is what is the treatment. If it is not responding or if the symptoms are worsening in between, you will have to go for drainage. And remember, white bore drainage is used because this is thick, not like the uncommon, the unconventional, you can say, abscesses where there is the viscosity is less. So anchovy sauce is always drained with a white bore, you can say, pigtail catheter. Next is, when you are seeing this procedure, what is this? This is rectum and this is mesh rectopexy. And you are fixing it on the ventral surface. So this is ventral mesh rectopexy And you can see the laparoscopic instrument. So this is laparoscopic ventral mesh rectopexy for rectal prolapse. This is also known as de Hood's surgery. So this is de Hood's surgery for this. Thiersch repair is what? Peripheral encirclage that we do, and this is done for the elderly. So this is a perineal approach, not an abdominal approach. So this is wrong. Delorme procedure is when you have a prolapse, you do the mucosectomy and you take bites over the muscle and then just tighten it up. So this is again a perineal procedure. So Delorme, Eltimer, we have a lot of procedures. So serial transverse enteroplasty is for short bowel syndrome, not for rectal cancer, and Delorme procedure is not for the short bowel syndrome, it is for the rectal prolapse. It's a perineal approach. So answer is A in this case. Let us understand one more very important thing. Let us see this. There is a patient with a stone in the mandible, and let us read it. It seems to be a big question. It's very easy. 34-year-old patient present to surgery department complains of recurring pain and swelling in the right submandibular area, especially when she is eating. What is this known as? This is known as salivary colic. The pain increases with the eating or postprandially 2 to 3 hours as the saliva gets absorbed by the, by the gland. So it will again decompress itself, the gland will decompress and the pain will go. She experienced the episodes of swelling and discomfort for past several months, which seem to worsen after consuming sour and spicy food, because they are strong stimulant for the saliva. And the submandibular gland is giving you 70% of the resting salivary flow. So if that gland is blocked, so saliva is produced by the neural stimulus, so the gland gets distended but cannot empty because of the presence of the stone. Now on examination, there was tenderness and localized swelling. Each and everything is that. Palpation revealed a firm mass and the patient reported the pain when the pressure was applied. So this reveals a mass, pain, and these features are suggestive of cyalolithiasis in the submandibular gland. Now, however, the resident noticed her right submandibular gland seemed to be enlarged. NCCT shows a 3 mm size stone. What is the most appropriate management? Now try to understand if the stone is less than 4 mm. We go for Dormia basketing. There is a bit of, upgrade in this. So Dormia basketing, if it is more than 4 mm, you will go for what, students? You will go for ESWL, extracorporeal shock with lithotripsy. If this fails, then you need to check whether the stone is distal to lingual nerve, or it is proximal to the lingual nerve. Students, if it is proximal to lingual nerve, that means if it is proximal, you can go for ductal exploration and extract it. But if it is distal to the lingual nerve, that is the second molar is the benchmark. Remember, when going towards the stone via oral approach, you can damage the lingual nerve, and that is why you go for what? Cervical approach. So shock wave lithotripsy, Dormia basket, submandibular gland excision, both excision of the duct. So students, the best answer here is Dormia basketing extraction, and if it fails, you might go for surgery. Let us understand the next question. 18-year-old male visited to the emergency with pain that initially originated near the belly button and then moved towards the right side of the abdomen. Now you know that we are dealing with acute appendicitis. Which of the following symptoms would not be observed? I'm talking about would not be. So pain in right iliac fossa, yes, this is what? On palpation of the left iliac fossa, this is known as the Ropsing sign. Why? Because when you press on the left, the viscera is medially shifted, and then that medially shifted viscera will again push the right-sided ileum close to the abdominal wall, and that inflamed appendix will touch the abdominal wall and pain will be there. So this is what is very, very, very important. Pain on internal rotation of right hip, this is also possible. Why? Because of the obturator nerve coming close to the appendix. Pain on extension of right hip, this is the same thing. Feeling of emptiness in the right iliac fossa, this is seen in intussusception, not in case of what? Appendicitis. So option C is incorrect in this case, would not be seen. Next is a 45-year-old female with a lump in her breast was reported to present with an irregular shaped, taller than wide, irregular angular margins on sonomammogram, and the surgeon says that there is a 10 to 50% risk. Now try to understand, whenever we talk about the suspicious lesion, they are all BI-RADS 4. BI-RADS 4 is more than 2 to 10% risk, BI-RADS 4B is more than 10 up to 50, and 4C is more than 50 up to what? 95. So what is the answer for this? This is going to be a 4B lesion. This is again very, very, very simple. Next is
A patient presents with, you can say a male patient presented with an X-ray of the lower abdominal pain, increased urine frequency and decreased flow of the urine. The X-ray is shown. Which of the following is incorrect? So you can see something in the bladder, and this is a bladder stone. This is a bladder stone. You know that vitamin A deficiency, vitamin B deficiency, then you can say phosphate deficiency, magnesium deficiency, they are all related. So this is absolutely right. The secondary stones are composed of uric acid. Now this is actually, I have already corrected this part. I have, to avoid the confusion at your level, I have said that, okay, make it primary stone. But still, if you see secondary stones, they may contain uric acid. It's not like that the secondary stones are always uric acid. Secondary stones are mostly phosphate stone, but yes, uric acid might be there. So partially correct, since it was creating problem in the E version of the paper. You will always find that primary stone is there. Maybe in the hard copy you might get this same thing. So primary stones are mostly uric acid, mixed uric acid stone. So okay, is partially right. Can present with hematuria. Of course, terminal hematuria is seen in them. You can refer to my notes. Treatment requires an open approach. No, up to 5 centimeters. We go for cystoscopic litholapexy. Cystoscopic litholapexy. And more than 5 centimeter, we go for what, students? Open litholapexy. So try to understand B and D, both are incorrect in this case, but D is a better option than B, and that is why I would choose always D. Is that clear? Since uric acid can be a component, I will give partial, you can say, favor to B. So D is the answer here. Next is, again, this seems to be a very big question. Let us read it. 28-year-old presented to the doctor with painless lump in the left testicle. So painless lump is considered to be what? Testicular tumors. He reported occasional discomfort in the groin area. On examination, a firm mass was seen. There was no sign of inflammation. Investigation, including the USG, was done, which revealed a solid mass. Blood test shows elevated tumor markers such as AFP is elevated, so alpha fetoprotein is elevated. Beta SCG is and lactate hydrogenase. So beta SCG, lactate hydrogenase. So you are dealing with embryonal cell cancer. A CT scan of abdomen and pelvis was conducted in multiple para-aortic lymph node. You know that embryonal cell cancer or polyembryoma. So what is the management? You will go for excision, and followed by excision, chemotherapy, followed by retroperitoneal lymph node dissection. So this is what is very feasible answer. Yes, induction chemotherapy. Then you check about the lymph nodes. You know testicular tumors are highly sensitive when it comes to the you can say chemosensitivity. So chemotherapy, induction chemotherapy, if you do induction chemotherapy, you repeat the abdominal CT. If you think that there is a persistence of lymph nodes, you go for retroperitoneal lymph node dissection, and after that again chemotherapy and radiotherapy is done. So let us go to the next question. Patient presents with history of persistent fatigue, frequent urination, recurrent kidney stones over the past few months. So we are now dealing with something like polyuria, polydipsia, renal stone. So this is something related to hyperparathyroidism. Let us see. She feels more anxious than usual, unexplained weight loss despite the regular diet. She also reports aches in the bone and muscles, which seems to be worsening. On the physical examination, her blood pressure was slightly elevated. You know, nephrocalcinosis is the reason. Her skin appears to be somewhat pale. The doctor noted mild tenderness in her abdomen on palpation. Her calcium was, this is hypercalcemia, and parathormone is too much. What is your diagnosis? This is primary hyperparathyroidism. This is very important. Remember, why it is not a secondary? Because there is no history of CRF. Why it is not a tertiary? Tertiary happens post correction of CRF. And that is why it is not C and D. Why it is not hypercalcemia of malignancy? Because we are not seeing the malignancy is not proven till now. Malignancy is not proven. So there has to be a proof of malignancy to say that parathormone receptor hormones are elevated in this case. Next is, I would see the image and I would answer that the typical yellow, canary yellow appearance is seen in cons. What is cons? It is nothing but hyperaldosteronoma. And when there is aldosteronoma, the patient will have hypertension controlled by 2 or 3, you can say, antihypertensives. And you can see diuretic is also going on, beta blocker is also going on. Still it is poorly, you can say, poorly controlled. And now what is the diagnosis? Just by seeing the sample, I would say this is hyperaldosteronism and this is a Conn syndrome. Next is, a patient was taken for laparotomy. for acute obstruction. During the surgeon, a gangrenous segment of ileum was done. The anesthetist informed the surgeon that the blood pressure was dropping. Now what to do? You have to do a diameter control. You'll do the resection and do an ileostomy or maybe end jejunostomy, whatever you want. You will not go for definitive anastomosis, etc. So complete the procedure as planned. No, damage control surgery is what we go for. So maybe now we can do a damage control and then we can again go for a repeat surgery if we want. Next is a patient was brought to the burn emergency with a history of bomb blast or post bomb blast. It was seen multiple facial burns with stridor. There are deep partial thickness burns on the torso and the upper limbs accounting for the 35%. Now since there is stridor, I will go for endotracheal intubation. I would go for wide bore access and resuscitation because this is a case of shock. Escharotomy, why will we do escharotomy when there is no need of, when there is no eschar at all? So escharotomy will not be done, and you know that yes, resuscitation with ringer lactate is what is the call. What is this? You are seeing something as keloid. So this is a patterned, you can say, hypergranulation, and this is a keloid. So this is a classical keloid triangle, the deltoid, the sternum and the chest wall. Anyways, let us see. Which is not true. They don't regress. Yes, they extend the boundaries of the original wound. So if you see the wound, how does a keloid grow and how does a hypertrophic scar grow? This is how a hypertrophic scar grows, like you can say a carrot or a radish. But keloids will always grow beyond the, not only they grow above, they will also go beyond the wound margin, and this is what is very important. So more common in dark skin individuals, yes. Collagen, when we talk about, it is wavy, not parallel. Parallel is arranged in hypergranulation. So if it is a hypertrophic scar, it will always be in parallel sheets. If it is a keloid, it will be wavy or interlacing. So option A is incorrect in this case. Next is, a patient underwent appendicectomy on third post-operative day. She develops fever, tachycardia. Her abdominal examination reveals diffuse tenderness. What are you planning? What are you thinking? There is either a leak or an abdominal injury, or this is the case of what? Abscess also. Her CT reveals leukocytosis with left shift. X-ray is normal. CT scan of the abdomen shows a collection. This is a case of pelvic abscess, and this is what is very, 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 very important. So it's very easy to understand the things if you know the clinical, you can say, presentation of the things. So I hope, dear students, you enjoyed this CBoT. Thank you for listening to me.
Hi, ladies and gentlemen. Welcome to the first computerized based offline test discussion of ophthalmology. Here we have a set of ophthalmology questions. I think they're not too difficult, but we'll see. We'll see. I hope you all do well here. I discuss karte hain. To me, your friendly neighborhood ophthalmologist, Shashwat Ray, waiting to guide you through these questions. Let's start. So the first question is, a 53-year-old female comes to IOPD with complaints of difficulty in reading the newspapers and asthenopia. Now, let's look at the diagnosis. Why would a 50-year-old lady come to would have difficulty in reading the newspapers and asthenopia? Is it not? What could it be? Well, the obvious answer first is going to be presbyopia. Is it not? 50-year-old lady. So, loss of accommodation with age. So, most likely presbyopia. And the second line confirms what they are asking is, what is the appropriate power of convex lenses to be prescribed to this patient? Now, if you remember, a presbyopia is loss of accommodation with age, and it starts at 40. So it's not. We all remember. It depends. Some people at 41, some at 45, but mostly around 40. So life begins at 40. And unfortunately, so does presbyopia. And remember, you cannot escape presbyopia. All of us, we have to have presbyopia because it's linked to aging. And we have this particular table here, which you all remember. It's a rough guideline to what is it not. So it starts with 40 and it's about +1. So let's take a look at this table. At 40 years of age, approximately correction diopters is about +1, and at 45 it becomes 1.5, at 50 it becomes 2. I think you should remember this figure at least, that approximately 50, and this is an important figure because it's a half-century landmark, we have to wear around +2. 55 is 2.5, 60 is +3. Remember that it's a little bit here and there. It is not the same for everybody, but it's actually remarkably accurate. Okay. So it may be 1.5 for somebody at 45, it could be 1.25 for somebody, and 1.75 for somebody, but it is very close to 1.5. So if we see, so our question is a 53-year-old lady, so which lies between 50 to 55. So our best answer here, as you can see here, the best answer would be between 1.75 to 2.25. This is the thing, because at 50 we have around 2. So 50 to 50 will be slightly more, or could be 2 also. So this is the best answer because it's not 1 to 1.75. This would be less than 50. 2.5 to 3 would become more, it will tilt more towards 60, and definitely not minus 1.5, because this is a myopic correction. So the answer, the best answer, ladies and gentlemen, is between 1.75 to plus 2.25. So these are convex lenses. That is why I use a number plus, and you remember approximately around 50. If you remember, it's plus 2, then you can work it around this. So that's what an absolutely straightforward question. Next question is not so straightforward, maybe, or maybe not. Let's take a look at that. A 35-year-old woman presents to the ophthalmology clinic with a complaint of drooping of her right eyelid. Dear me, drooping of the right eyelid that worsens throughout the day. Now, does that ring a bell? That worsens throughout the day. Yes, it does, or it should, is it not? She also reports double vision, especially when looking upwards like that. That also should ring a bell. On examination, you note the weakness of her right levator palpi superioris, the LPS muscle, and limitation of upward gaze. Okay, which of the following is the most likely? You don't even have to look at the choice, my friends. We all know, and you all should know, that we're talking about OMG. Oh my God, it is ocular myasthenia gravis. They're not. Why? There's so many hints. Remember, myasthenia gravis, first of all, occurs to young ladies and old men. Okay, so you have this range group of 20 to 40-year-old ladies and 60 to 80-year-old men. Okay, they are the two primary groups who have myasthenia. Okay, drooping of a right eyelid, that worsens. This is the giveaway clue, because remember, this is called as fluctuating ptosis. Okay, it worsens in the evening. And why is that? Because you know that the basic problem is that there are autoantibodies to the acetylcholine receptors. Is it not? Postsynaptic acetylcholine receptors, there's autoantibodies, so they are destroying number of receptors. So there's no muscle, there's no action potential transmitting, so the muscle is not able to contract. And with the passage of the day, as more and more the action potential fails, less and less acetylcholine is being ejected from its synaptic vesicles. So it worsens with fatigue. Okay, so remember, the myasthenia always, the ptosis worsens with fatigue. So typically, as you grow tired, it becomes worse. So therefore, toward the end of the day, the ptosis worsens. And the second complaint is double vision diplopia when looking out. Why is double vision? Because remember, myasthenia attacks all the skeletal muscles, not? So their ocular muscles are all skeletal muscles. They're voluntary muscles, particularly the medial rectus and the superior rectus. They are the first two muscles to be affected by myasthenia. And since they cannot contract, they cannot hold the eyes together, the eyes are not balanced, eyes not balanced, you have diplopia. So the first feature of ocular myasthenia is ptosis. Second clinical feature is double vision. Why particularly upward gaze? Because you're working anti-gravity, so you have to work more. So typically the upward motion is the most difficult for them because they have to contract more. That is why on looking upwards, you can easily diagnose. So if you suspect myasthenia, you ask them to look upwards for some time, and as you look upwards, you will immediately see after a few seconds, as the lid becomes tired, the ptosis immediately is restored. Immediately it comes down because of ocular fatigue induced by looking upwards. Okay, so this is myasthenia gravis, and we diagnose by the famous tensilon test, which you can see here. Look at that. This is the ptosis, and how it improves. We look at the expression also all around, the expression of the forehead and the cheek muscles, which are also myasthenia. You see this looking peculiar, droopy, despondent, a sad kind of expression. But here, if you see, the eyes are wide open, it looks an alert expression. The muscles are contracting, the surrounding nearby ocular muscles are contracting, and they are now not flaccid or droopy. It looks extraordinarily alert and awake, unlike the peculiarly despondent and sad kind of look which myasthenia often gives. Okay. In fact, remember, if you might remember, or if you do not remember, let me tell you, myasthenia is often called the snowflake disease. You know why? It's often called the snowflake disease. You know why? Because like each snowflake is different. Similarly, each ocular myasthenia or each myasthenia gravis is different. Okay? The spectrum is well known, but each patient behaves differently, and sometimes you might be asked that which disease is called the snowflake disease. It's the myasthenia gravis. Very well. Next question is, which of the following statement is incorrect about the pathology shown in the clinical image? Okay, and let's look at the pathology. So you can see this is the iris, and this is the whitish lens, they're looking small and a little wrinkled. On the you can see the wrinkling of the capsule. If you look carefully, and that is, let's look at we need to know what is incorrect here, isn't it? So, small volume of lens and a wrinkled capsule diagnoses it as a hypermature cataract is absolutely correct, because it's exactly what I was saying. When I saw this, I found a small lens with a wrinkled capsule, white colored. So, this is nothing but a hypermature cataract. Okay. An anterior capsule becomes thick due to calcification is absolutely correct. It is also correct because the anterior capsule does become thick with calcification in hypermature cataracts. And capsule is easy to perform due to retinal. This is incorrect. Remember, it is very difficult to perform because of retinal which is blocked. You see, normal capsule rexes, but remember to cut the anterior capsule so that we can take out the cataract and place the intraocular lens is approximately about 5 to 6 millimeter in diameter. Now, this is done easily because we can see the anterior capsule against the glow of the microscope. Okay, so this is called a retroillumination technique, where you can see the capsule against the red glow, and thereby you can cut the capsule like this. But you see, in this case, there is no retroillumination because it's a hypermature case, blocking the rays of the light coming from behind. So you just cannot see the capsule here, is not, because you cannot see the capsule. So it's very difficult to cut it, and that is why we have to perform the stain, which is called the trypan blue stain. We stain the capsule with the blue dye. It's called the trypan blue. So now the capsule is visible for us, and now I can cut the capsule in a central circular continuous rexes like this. Look at that. You see this? This retroillumination, you can see clearly this retroillumination, and you can see this is the edge of the rexes because you can see the capsule right against the glow. But here you see we had to stain the capsule. Look at the bluish color of the capsule. This is the stained capsule with trypan blue, you know, the dye that we use mostly, and of late this dye has been asked quite a lot. Trypan blue, it stains the dye, so you can see the capsule and you can cut the capsule in a central circular continuous rexes. So this is incorrect, and that is the answer, because that is what we need incorrect about. And degenerate cortical matter leaks through the lens capsule. It does. This is also correct because it's the old lens, it's degenerated, and the cortical matter breaks through small leaks in the capsule, and when they're high molecular weight proteins, HMW we call them, they go and block the trabecular meshwork, and this may cause as phacolytic glaucoma. It's not. So this is the mechanism of phacolytic glaucoma, where the high molecular weight proteins, they leak through the capsule, very small micro leaks in the capsule which cannot be seen with a slit lamp, but does go and blocks the holes of the trabecular meshwork, causing open angle glaucoma, which you call as phacolytic glaucoma. So that's also correct. So what is incorrect is C, and that is the answer. Capsule X is easy to perform because first there's no illumination, because there's no retroillumination, so there is very difficult to capture unless you stain the capsule with trypan blue. Okay, so that is the answer. The next question is a 50-year-old female presented with complaints of severe pain, sudden blurring of vision and redness. Now that sounds like an eminence. Severe pain, loss of vision, redness. Identify the pathology treatment given immediately for this pathology. Now remember the question, first you have to identify the pathology, and the answer given and the question asked is the immediate management, not the definitive management, which is different. So immediate is different because we have to restore the condition, and definitive is the final treatment. So if you look at this, so red eyes, and look at the vertically oval pupil, the mid-direct pupil, this is a giveaway diagnosis of acute angle closure glaucoma. This is not. This is giveaway diagnosis of acute angle closure glaucoma because, and the history seems to support it, severe pain, sudden blurring of vision and redness is nothing but acute angle closure glaucoma. This is not. Now let's look at the choice. So it's primary angle closure glaucoma, topical timolol, incorrect, because it's angle closure glaucoma fine, but the answer is not timolol, because topical drugs cannot lower the pressure here. You see why? Because the pressure is so high, intraocular pressure is almost 60 millimeter per mercury. The pressure is so high, it causes something called a sphincteric ischemia. Sphincter of the pupil, the pupil's sphincter, it becomes ischemic and stops responding to topical drugs. So timolol is not going to help here. What is going to help is the second one, which is called acute angle closure glaucoma, where we prescribe IV mannitol, intravenous mannitol. Is not. This is the drug of choice. Why? Because the acute angle closure glaucoma is so sudden, so painful, and IV mannitol works very fast. It's given intravenously, so it lowers the pressure within 30 minutes. So this is the immediate mode of choice. Later on, you can always do a PI or a trabeculectomy or an LI. But right now, the question is immediately for this pathology is this, which is what? Which is IV mannitol, intravenous mannitol. This is the only anti-glaucoma drug that is given intravenously. So it's the fastest anti-glaucoma drug. In fact, we do have astazolamide also as IV form, but it's not available in India. So we give IV mannitol. Acute angle closure glaucoma, topical astazolamide is incorrect. Okay, again, it's not going to work so fast. And bacterial conjunctivitis, it definitely is not. So the answer is B, ladies and gentlemen. The treatment is intravenous mannitol because they have asked for not the definitive treatment, which is the LI or the PI, but the immediate management, which is to lower the intraocular pressure as fast as possible. Very well. And that's exactly what I've written here. Acute angle closure glaucoma and IV mannitol. The next question is a patient is diagnosed with sympathetic ophthalmitis post-trauma to his one eye. Dear me, that sounds a serious condition. Which of the following symptoms true about the sympathetic ophthalmitis? So we now want to find what is true. It is a granulomatous pannivitis is absolutely correct. That's right. It is a granulomatous pannivitis, and so this answer is correct. This is what we're looking for. This is what is absolutely correct here. So this is the answer. Granulomatous true. But let's look at the other also and see if by chance they're also true. Enucleation of the sympathizing eye is the treatment of choice. Incorrect. Remember, you don't enucleate the sympathizing eye. You enucleate the exciting eye. Okay, you don't, kill the messenger who's delivering the bad news. Okay, you enucleate not the sympathizing eye, which poor thing is only sympathizing with you, but you enucleate the exciting eye, the damaged eye. So this is incorrect. Sympathetic ophthalmitis develops in traumatic eye. Incorrect. Remember, sympathetic ophthalmitis does not develop in traumatic eye. It develops in the other eye. The traumatized eye is called the exciting eye, and the other eye, which also gets inflamed, is called the sympathizing eye because it sympathizes. So this is also incorrect. And sympathetic ophthalmitis develops within 1 week of the trauma is also incorrect. Remember, the minimum time required for sympathetic ophthalmitis to intervene or supervene is 2 weeks. That's because 2 weeks is the time required for the antigen to produce antibodies. So before 2 weeks, it's rare to have sympathetic ophthalmitis. Okay, so all of them seem to be incorrect. The only one that we have correct is the granulomatous pannivitis, which I said is the correct answer. That's right. So we have very severe type of pannivitis, which is called as sympathetic ophthalmitis. And here you can see the mutton fat capes. Now you can see the mutton fat capes here, large and round and very, very oily looking, which is a sign of sympathetic ophthalmitis or any granulomatous uveitis. Very well. A 60-year-old hypertensive female presented with sudden painless blurring of vision. On examination, the fundus image is seen. What is the probable diagnosis? And can you see this? Look at this, is a very famous thing. Look at the number of hemorrhages. There are so many of them. You have flame-shaped hemorrhages, you have dot and blot hemorrhages, you have so many kinds of hemorrhages here. And this is only one kind of, such a dramatic picture can only be seen in only one condition, and that is going to be our central venous occlusion, and that also the ischemic variety. Remember, CRVO, we have two varieties. The ischemic variety, where there is ischemia or lack of blood for hypoxia to more than 10 disc diameters. We call this ischemic. But there is also one more called non-ischemic, which is less dangerous, CRVO, and it is obviously less than 10 disc diameters, 10 disc diameters of occlusion and capillary dropout. So it's in the ischemic, the far more dangerous kind of CRVO, that you have this condition, which is called as blood and thunder fundus. Now, this is a blood and thunder fundus, also called as sometimes as tomato ketchup, because full of tomato, as looks at the retina full of tomato ketchup, also called a splash tomato fundus. Okay, so this is an easy one. Remember, these dramatic findings can only mean only one thing. Okay, that you are in the presence of CRVO. Okay, very well. That is not a difficult one, I'm sure. During a fight in the class, one of the students hit the other in the eye, and he was suspected to having an orbital fracture. Dear me. All the following are true about orbital fractures except, okay, now see, now this is a very common thing. If you remember, orbital fracture do happen. It's called a blowout fracture, which is very common, and this occurs, if you remember, because the size of the blow should be bigger than the size of the orbit, is not? So which it is a fist. So if we do suspect of orbital blowout, then we want to know is all of them are true except Diplopia on downward gaze is incorrect. Okay, we'll talk about this. Limitation of upward gaze, yes, that is correct. That is correct. Why? Because you see, the most common fracture in blowout is of the inferior wall, also called the floor fracture. So what happens when the floor fracture like this, the inferior rectus muscle often gets entrapped. Okay, it gets entrapped into the fracture line and it cannot contract anymore. So when you want to look up like this, the superior rectus is pulling it up, but the eyeball is not moving because the inferior rectus is entrapped by the fracture line and is holding the eyeball from moving up, is it not? So definitely has limitation of upward gaze, because for any particular gaze, if you remember, typically the agonist muscle that is carrying out the maneuver must contract, the antagonist must relax. Here, the antagonist is itself, it's damaged by the fracture and is not able to contract at all. So therefore, the patient is trying to look up, but the inferior rectus is trapped and is not able to relax to allow the eyeball to move up. So limitation of upward gaze is definitely important here. Decreased sensation over the inferior orbital rim is correct. Why? Because remember, the infraorbital nerve here, which gets damaged in a blowout fracture. So definitely there will be decrease of sensation here. And step-offs at the inferior orbital, again, yes, step-offs means you can feel it here, you can palpate it here. Sometimes you can see a jagged edge, you can feel it, and there'll be step-like thing, so there'll be a step here, go up a little bit, you will feel another little bit, this you can feel, and go up similarly and feel. So there are these step-offs which can be felt sometimes in a blowout fracture of the orbit, which remember, this is the most common fracture is of the inferior wall or the floor of the orbit. So the answer here, which of them are true except, so all of them are true. Limitation upward gaze, decreased sensation over the infraorbital rim, and step-offs of the inferior orbital, these are all correct. So the answer has to be diplopia and downward gaze. I told you that you have diplopia and upward gaze mostly in the direction where the muscle cannot move. Okay, so that was not such a difficult question. Step-offs, please remember, like a step-like defect, you can feel it on palpating the rim sometimes. You can feel the step-offs, a jagged edge where you can feel this discontinuous bone. Okay, so this is the answer is A, and that you can see here. Look at the blowout fracture. This is the orbital contents herniating down into the maxillary sinus because of the inferior wall fracture here, and this is intact. Okay, so that is why, remember, blowout fractures, the most common is in the inferior wall. And why is that? Because by the lack of support by the maxillary sinus causes the blowout fracture. That's why this is the most common. Okay, and then the next question is a 24-year-old female presenting with a complaint of painless swelling in the eyelid, as you can see it here, which progressively increasing in size. Identify the pathology on the basis of history and the clinical image given below. And the answer here, it's easy. If you see this is nothing but a chalazion. Okay, it's called a chalazion, and it really means a small hailstone. The name chalazion, it means like a small hailstone. You've all seen conditions where it hails, okay, sudden sharp shower, and you can see the hail coming down. So it looks like a hailstone. That's why named chalazion. It's not an external hordeolum. It's not, which is a sty. Trichiasis, it is not. The eyelashes are not turning inward. And entropion is not, since the eyelid margin has not rotated inwards like that. It's not. So chalazion, remember, what is that? Chalazion is basically a chronic inflammatory granuloma of the meibomian glands. Okay, so meibomian glands, they get blocked and the secretion, it accumulates in the duct there. Okay, this is mostly found in the upper eyelid, though it can be in lower eyelid also, but mostly in the upper eyelid. Why? Because the upper eyelid has mostly these meibomian ducts are present, more number in the upper eyelid, about approximately around 30 in the upper eyelid and around 25 in the lower eyelid, simply because the ducts are more, so they get blocked more. In these often young ladies with oily skins, where the excessive sebum or the excessive oil is blocking these glands and they are causing the chalazions. The treatment would be, first we try with hot fomentation, where you take some hot cloth or warm cloth, put it in warm water and put against this is typically called as hot fomentation, where the heat of the water, it tries to melt away the fat. Okay, if this doesn't work, then we go to incision and curettage, INC. Not a drainage, remember, this is not pus, you only drain a pus. This is not a pus, so you do not drain, you curate it out. It's called incision and curettage. And this is a very common phenomenon seen in a lot of my own students who are young and have some of them oily skins. And it is also said to be psychosomatic. That means those of you are warriors, worry a little bit more than the others, and you have oily skins, then you have a very high chance of developing a chalazion. Okay? And with that, ladies and gentlemen, let me thank you for your patience. I do not want to talk anymore. Many of you are already having withdrawal symptoms of this far too long CBoT. Thank you very much and all the best.
Hello, dear students. How was today's CBoT? I am Dr. Anupama, the Physiology faculty at Allen Next, and I'll be discussing the physiology questions. Hopefully, you did not have too much of trouble answering the physiology questions. These questions are actually very commonly repeated topics, both in the NEET PG as well as in the INI-CET exams. So let's discuss them in detail. So let's start with the first question. Now this says, which ion is primarily responsible for the depolarization phase of the cardiac action potential? Now first thing is, what are the two types of electrical activity that you see in the heart? There are two types of potentials. There is what is known as the plateau potential, and number two is what is known as the pacemaker potential. Now, as far as the pacemaker potential is concerned, this is only recorded from two areas, and that is the SA node and the AV node. All other parts of the heart, including the contractile cells, the potential which is recorded is known as the plateau potential. So this is the same as the cardiac action potential. So let us see, what is this cardiac action potential? The resting membrane potential of the cardiac muscle cells is minus 90 millivolts. The cardiac action potential has got 5 phases. There is phase 0, phase 1, phase 2, phase 3, and phase 4. Phase 0 is the depolarization phase, and this is because of opening of voltage-gated sodium channels, which increases the sodium influx. Phase 1 is the early repolarization phase, and this early repolarization phase is due to closure of sodium channels, which decreases the sodium influx. Phase 2 is the plateau phase, and in this plateau phase, there is gain of positive charge through what are known as slow calcium channels. So calcium will come from outside to inside, and during this phase simultaneously there is loss of positive charge, and that is because of opening of potassium channels, and potassium tends to go from inside to out. So if the cell is gaining positive charge and losing positive charge at the same time, there will be no change in potential, and that is what is responsible for the plateau phase. Plateau phase is due to an calcium influx through which channels? Slow calcium channels, sometimes also called slow sodium calcium channels, and there is also loss of potassium through voltage-gated potassium channels. Now these calcium channels close towards the end of the plateau phase, and phase 3 is now the late repolarization phase, and this late repolarization phase is due to only a potassium efflux. The fifth phase, or phase 4, is the hyperpolarization phase, which is because of slow closure of the potassium channels. So these are the different phases. Now the question is pretty simple. It has asked you what is responsible for the depolarization phase of the cardiac action potential. In this case, it is going to be sodium. Sodium is responsible for the depolarization phase. In the pacemaker potential, on the other hand, the depolarization is due to calcium. And this calcium influx is through some special channels, which are known as calcium L channels. They are different from the slow calcium channels of the plateau phase. Calcium L channels are found in the SA node and the AV node, and they are responsible for depolarization of the pacemaker potential. So answer to this question is A, sodium. Let's go on to the next question. It says, given below are the different types of transport systems, all of which follow saturation kinetics except. Now, saturation kinetics will be seen in any carrier-mediated transports. Whenever there is a carrier protein involved, this carrier protein tends to get saturated. And because it tends to get saturated, there is always a maximum rate of transport, which is called TM, transport maxima, which will be seen in a carrier-mediated transport. Now, out of these four options which are given, facilitated diffusion, sodium-calcium antiport, and coupled transport use carrier proteins. So they will show saturation kinetics. The only one which will not show saturation kinetics is simple diffusion. And if I study this graphically, if we take concentration gradient on the x-axis and the rate of transport is taken on the y-axis, we find more the gradient, more the rate of transport. This is what happens in simple diffusion. Transport is directly proportional to delta C. Delta C is the concentration gradient. But in any carrier-mediated transport, what do we see? More the gradient, more the rate of transport, till it reaches a transport maxima. Why does it reach a transport maxima? Because the carrier proteins tend to get saturated. So any carrier-mediated transport will show you a transport maxima. All carrier-mediated transports will show you a transport maxima. So this is the graph for simple diffusion and all carrier-mediated transport. So answer to this question is pretty simple. That is simple diffusion. Simple diffusion does not show saturation kinetics. Let's go on to the next question. It says all of the following are higher in the ICF as compared to the ECF. So let's compare the ECF and ICF. Now when I look at osmolality, the osmolality of the ECF is 290 milliosmoles per liter. ICF is also 290 milliosmoles per liter. The osmolality is same on both sides. But the difference is that the most important osmotically active particle in the ECF is sodium. In the ICF is potassium. So this is a big difference here. And this question has been asked, which is the most osmotically active particle in the ICF? It is going to be potassium. ECF is sodium rich, potassium poor. ICF is potassium rich, sodium poor. This was again a question which came in the last year's INI-CET. Which is the major cation in the ECF? Sodium. In the ICF? Potassium. Which is the major anion? In the ECF is chloride. In the ICF is phosphates and proteins. But phosphates are more than proteins. What is the pH? The pH of the ECF is 7.4, of the ICF is 7.1. Slightly lower pH in the ICF. So once you know these basics, then let's go back to the question. Now it says all of the following are higher in the ICF compared to ECF. Potassium ion more in the ICF. Phosphates more in the ICF. Proteins. Proteins are also more in the ICF. Let's try and understand this as well. So when I look at the ECF, what is ECF? Plasma plus the interstitial fluid. And this is the cell here. This is the ICF. So if I look at the plasma, the proteins in plasma are 6 to 8 grams per deciliter, out of which the most abundant protein in the plasma is albumin. In the ICF, 0 proteins. There are normally no proteins present in the ISF. The proteins in plasma are 6 to 8 grams per deciliter, out of which the most abundant protein is albumin. In the interstitial fluid, there are no proteins which are present. Normally, no proteins are present. In the ICF, proteins are 16 grams per deciliter, so much higher in the ICF, in the intracellular fluid, as compared to the ECF. But the pH, I've already discussed it with you. In the ECF, the pH is 7.4, but in the ICF, the pH is 7.1. So higher pH is in the ECF as compared to the ICF. So this question, the answer is B. Let's see the next question now. It says, given below is a graph which depicts a physiological law of the heart. Which of the following statements is correct pertaining to this law? Now, in this graph which is given, there is end diastolic pressure on the x-axis and stroke volume on the y-axis. So what is this law? This is also known as the Frank-Starling's law. Frank-Starling's law is nothing but your length-tension relationship. Now, what is the length-tension relationship? This says that more the initial length of a muscle fiber, more is the tension generated, but up to a physiological limit, beyond which further increase in initial length decreases the tension generated. Now, when I apply this to the heart, if I take initial length on the x-axis, when I take the initial length of the ventricular muscle fibers are circular. What can increase the initial length of the ventricular muscle fiber? If there is increased venous return, if there is more ventricular filling, if there is more end diastolic volume. More the filling of the ventricle, more the end diastolic volume. So more the venous return, more the ventricular filling, more will be the end diastolic volume, more is the initial length of the ventricular muscle fiber, more will be the tension generated. That is the length-tension relationship. So more the venous return, more will be the ventricular filling, more is the end diastolic volume, which is known as the preload. More will be the initial length, more will be the tension generated. And more the tension generated, more will be the stroke volume, but up to a physiological limit. Beyond which further increase in initial length decreases the tension generated. So instead of initial length on the x-axis, in the given graph is end diastolic pressure, which will be equivalent to the end diastolic volume. More the end diastolic volume, more will be the end diastolic pressure. So, and here on the y-axis is stroke volume. So more the end diastolic volume, more the end diastolic pressure, more will be the stroke volume, but up to a physiological limit, beyond which further increase in the end diastolic pressure will decrease the tension generated. This is the Frank-Starling's law. And decrease in tension generated would mean decrease in stroke volume. So this is the length-tension relationship, or the Frank-Starling's law. Now let's look at the options. It says the extent of diastolic filling in the heart influences the initial length of its ventricular muscle fibers, which is true. And the pressure generated in the ventricle is directly related to the volume of the ventricle at the end of diastolic filling, which is true. More the end diastolic filling, more will be the tension generated, more will be the stroke volume, more will be the cardiac output up to a physiological limit. So this is a true statement. Let's look at B. It says the force exerted against the myocardial cells in the left ventricular wall is linked directly to both the left ventricular pressure and radius. That is in fact the Laplace's law. Laplace's law states that the tension, or the wall tension, not the tension generated, the wall tension, is equal to the distending pressure into the radius divided by 2 into the wall thickness. So yes, it is linked directly to both the left ventricular pressure and its radius, but this is, like I said, the Laplace's law. This graph is Frank-Starling's law. The given graph shows an increase in heart rate in response to increase in atrial pressure. That is in fact known as the Bainbridge reflex. That is not depicted here. The given graph shows an increase in heart rate in response to an increase in atrial pressure. The fourth option is the given graph shows an increase in heart volume in response to an increase in atrial pressure. There is no such relationship. So the answer to this question is A. Let's go on to the next question. It says, in a somatic sensory neuron, the propagated action potential is generated at which of the following places? Now, when I look at the somatic sensory neuron, this is what is known as the DRG cell, dorsal root ganglion cell. Is this unipolar, pseudo-unipolar, bipolar, or multipolar? This is a pseudo-unipolar neuron. Now, what is a pseudo-unipolar neuron? Pseudo-unipolar means when I look at the cell, this is the cell body, it appears it has one process, but in fact, it has got two, a peripheral as well as a central process. So, pseudo-unipolar looks as though it has one process, but in fact, it has got two. Now, when I look at the cross-section of the spinal cord, let's have a look. This is what the spinal cord looks like. There is the butterfly-shaped grey matter. There is a dorsal root. There is a dilatation in the dorsal root, which is known as dorsal root ganglion. The anterior root will join the posterior root to form the spinal nerve. The sensory neuron is the DRG cell. Cell body lies in the dorsal root ganglion cell. This is also known as the first order sensory neuron. Pseudo-unipolar, there are two processes, a peripheral and a central process. The terminal of the peripheral process becomes the receptor, which lies under the skin. This is a somatic receptor. It could be a touch receptor, it could be a pain receptor, it could be a receptor for pressure. Now, when I give a stimulus on the skin, the action potential will arise in the first node of Ranvier. So, action potential arises in what is known as the first or the initial node of Ranvier. And from here now, this action potential jumps from node to node. It jumps from node to node in what is known as a saltatory conduction. It goes first via the peripheral process, then via the central process into the spinal cord. But where does the action potential arise? It arises at the first node of Ranvier, which is closest to the receptor. So the answer to this question now becomes the first node of Ranvier. In the case of a motor neuron, the impulse arises at the initial segment. Right? So this is as far as where does the action potential arise? So remember, for a sensory neuron, first node of Ranvier. For motor neuron, it is going to be what is known as the initial segment. What is the initial segment? Let me just explain that as well. A motor neuron is a multipolar neuron. When I say multipolar neuron, that means it has got dendrites, it has got a long axon, and motor neuron is always myelinated. So the action potential will arise in the initial segment. Initial segment is the initial unmyelinated part of the axon. That is where the action potential will arise in the motor neuron. Remember, the dendrites and cell bodies of a motor neuron do not have sufficient sodium channels to generate an action potential. They can only generate local potentials. So action potential in a case of a motor neuron will be in the initial segment. Let's look at the next question. It says, given below are different tracts passing through the brainstem. All are medial pathways involved in maintaining tone and posture, except. Now, when I look at the descending tracts or the motor pathways, they can be divided into medial descending tracts and the lateral descending tracts. Now, these medial descending tracts, these are meant for control of axial muscles. They are meant for tone and posture. Whereas the lateral descending tracts, these will control the distal muscles like the small muscles of the hand. And these are involved in fine, skilled movements. Now, these lateral descending tracts, the lateral descending tracts are of two types. There is the lateral corticospinal tract, which is also known as the pyramidal tract, and the rubrospinal tract, which is also known as the alternate pathway. And these two tracts, like I said, they supply the distal muscles and are involved in fine skilled movement. But the major tract involved in fine skilled movement is the lateral corticospinal tract or the pyramidal tract. Now, again, an important question which has been asked in one of the recent exams: which extrapyramidal tract behaves like the pyramidal tract? And your answer is rubrospinal. It is an extrapyramidal tract. It is not pyramidal. Anything which is not pyramidal becomes an extrapyramidal, but it behaves like the pyramidal tract. But please remember, the most important tract as far as voluntary movement in humans is concerned is the lateral corticospinal or the pyramidal tract. The medial descending tracts which are involved in tone and posture are: number one, anterior corticospinal tract. Number two, the tectospinal tract. Number three is the vestibulospinal tract. And number four is the reticulospinal tract. And this reticulospinal tract can be divided into two. There is a pontine or an excitatory reticulospinal tract, and there is a medullary or an inhibitory reticulospinal tract. So these tracts are involved in tone and posture. So let's go back to the question. It says, which of the following, all of the following are involved in maintaining posture except. So tectospinal is a medial descending tract, vestibulospinal, and the reticulospinal. The only one which is not involved in maintenance of posture is rubrospinal. This is involved in fine skilled movement. Let's look at the next question. A preterm baby is born with a deficiency of surfactant. Surfactant is secreted by the type 2 pneumocytes. Without surfactant, alveolar collapse at the end of expiration leads to pulmonary failure. Remember, what is the role of surfactant? Surfactant reduces the surface tension and it prevents alveolar collapse. So if there is less surfactant, there is more tendency of the alveoli to collapse at the end of expiration. Which of the following set of changes will be present in the preterm infant compared with the normal infant? So what will happen to the surface tension? If surfactant is reduced, surface tension will definitely increase. What will happen to the compliance? What is compliance? Compliance is nothing but the distensibility of the lungs. And mathematically, we will express compliance as delta V by delta P, change in volume per unit change in pressure. So more the surface tension, less the compliance. So answer to this question is going to be B. Increased surface tension, reduced compliance. The given schematic diagram shows peristalsis. Which of the following neurotransmitters is responsible for anterograde dilatation. Now, in peristalsis, which is responsible for forward propulsion of food, there are different neurotransmitters which are secreted behind the food. Behind the food, it is known as retrograde or also known as ORAD. That means towards the oral cavity. Behind the food and towards the oral cavity, the myenteric plexus neurons secrete substance P and acetylcholine, which cause a ring of contraction behind the food. Anterograde and caudad. Anterograde or caudad. Anterograde would mean in front of the food, caudad means towards the anal cavity. The neurotransmitters secreted by the local myenteric plexus neurons are nitric oxide and VIP, and they cause a relaxation in front of the food. And that is how the food is propelled forwards. So answer to this question becomes pretty simple. This is nitric oxide. Acetylcholine and substance P are secreted behind the food. Serotonin is secreted by the sensory neurons. Presence of food in the small intestine will stretch the walls of the small intestine, stimulate the sensory neurons which secrete serotonin. So answer is A. Let's look at the next question. A road traffic accident patient was brought to the casualty. He was bleeding from his left leg. His blood pressure is 86/60. There is hypotension, hypovolemia, hemorrhage. Pulse was fast and feeble. Which of the following plays the most important role in retention of sodium and water in this patient? ADH increases water reabsorption only, not the sodium reabsorption. Aldosterone increases sodium reabsorption in the collecting duct, and therefore there is increased water retention. Atrial natriuretic peptide decreases sodium reabsorption. On the other hand, RAS, renin-angiotensin-aldosterone system. Hypovolemia, hemorrhage, hypotension, these are very important stimuli which will increase renin. Renin will act on angiotensinogen, and angiotensinogen is converted into angiotensin 1, and then angiotensin 1 is converted by the ACE enzyme, angiotensin converting enzyme in the lungs, to angiotensin 2. Now, angiotensin 2 has got a number of actions. Angiotensin 2 is a very powerful vasoconstrictor. It causes a peripheral vasoconstriction. If it causes a peripheral vasoconstriction, it will increase the total peripheral resistance, and that will increase the mean arterial pressure. Angiotensin 2 will act on the kidney. On the kidney, it, number one, decreases the GFR, helps to maintain the blood volume. It will also directly increase the sodium reabsorption in the PCT and in the thick ascending limb. Angiotensin 2 will also increase thirst. Number 4, angiotensin 2 will increase aldosterone, and aldosterone will increase the sodium reabsorption in the collecting duct. Now, as far as this question is concerned, both aldosterone and renin-angiotensin system appear to be correct answers here. Both are causing a sodium retention. But a slightly better answer will become the renin-angiotensin-aldosterone system, because angiotensin 2 also has got an effect on sodium reabsorption. And angiotensin 2 in turn will increase aldosterone, which causes even more sodium reabsorption in the collecting duct. So a slightly better answer than aldosterone will be RAS. Let's see the next question. A 36-year-old female suffering from hypertension, buffalo hump, dark pigmentation of the skin and mucosa. On further examination investigations, she is diagnosed with Cushing's syndrome due to a primary problem in the pituitary gland. Which of the following hormones is responsible for the dark pigmentation of this patient? So that means In Cushing's, there is a very large increase in ACTH, adrenocorticotrophic hormone from the anterior pituitary. Now, what is responsible for the hyperpigmentation in this patient? Is it going to be ACTH or is it going to be MSH? The answer to this question is ACTH. Please remember, ACTH itself has MSH activity. So whenever normally in normal levels, ACTH is not causing any hyperpigmentation, but in Cushing's, when there is very high level of ACTH, there will be hyperpigmentation, which is seen. Why not MSH? Now, please remember, MSH secretion in humans is almost negligible. MSH is secreted in animals which have got an intermediate lobe of the pituitary. Humans only have an anterior and a posterior lobe. Intermediate lobe of the pituitary is rudimentary in humans. So what happens in humans is POMC, this is pro-opiomelanocortin. This is the precursor of ACTH. POMC splits into ACTH, beta lipotropins, and beta endorphins. What we do not get in humans is alpha or beta MSH. So the best answer to this question is going to be ACTH. ACTH itself has MSH activity. Whenever there is elevated level of ACTH, it will cause hyperpigmentation. Let's look at the next question. A 45-year-old woman has a mass in the sella turcica that compresses the portal vessels, disrupting the pituitary access to hypothalamic secretions. Hypothalamus secretes some releasing and two inhibiting hormones which enter into this hypothalamo-hypophyseal portal system, and these will affect the anterior pituitary, where they will affect the secretion of the anterior pituitary hormones. The question says, which of the following hormones is likely to increase in this patient? So let's see what is secreted from the hypothalamus and how does it affect the anterior pituitary hormone. So from the paraventricular nucleus of hypothalamus, corticotropin releasing hormone increases the secretion of ACTH, adrenocorticotrophic hormone from the anterior pituitary. TRH, thyrotropin releasing hormone, increases the secretion of TSH, thyroid stimulating hormone from the anterior pituitary. From the arcuate nucleus of the hypothalamus, GnRH, gonadotropin releasing hormone, will increase the secretion of FSH, follicle stimulating hormone, and luteinizing hormone from the anterior pituitary. GHRH, growth hormone releasing hormone, increases the secretion of growth hormone from the anterior pituitary. Somatostatin. Somatostatin decreases the secretion of growth hormone from the anterior pituitary. But have you seen this? I've made the action of somatostatin on growth hormone with a dashed line to indicate that the more important factor affecting growth hormone secretion is GHRH, not somatostatin. Number 4 is prolactin inhibiting factor, which is nothing but dopamine. This decreases the secretion of prolactin. So if the hypothalamic hormones do not reach the anterior pituitary, which hormone will show an increase? Prolactin. All the other hormones of the anterior pituitary will reduce. Why will prolactin increase? Because prolactin secretion is normally inhibited by prolactin inhibiting factor from the hypothalamus. And prolactin inhibiting factor is nothing but dopamine. So answer to this question becomes pretty simple. This is prolactin. What about growth hormone? Growth hormone will reduce in this case, because what is the major factor controlling growth hormone secretion? GHRH and not somatostatin. Let's have a look at the next question. The following changes occurred during the course of fever in a 13-year-old girl. So these are shown. So let's discuss this first. Now, as far as body temperature is concerned, there is a hypothalamic set point. Hypothalamus acts like our thermostat. So it maintains the body temperature at 37 degrees Celsius. This is known as the hypothalamic set point. And the body temperature is also at 37 degrees Celsius. Now, what happens when there is fever? Macrophages, which are the first line of defense, they release interleukin-1. Interleukin-1 is a pyrogen, and interleukin-1 now causes elevation of the hypothalamic set point. This hypothalamic set point can increase to, let's say, 40 or 41 degrees Celsius. So this has happened because of interleukin-1. Now, the body temperature is at 37, but the hypothalamic set point has increased, let's say, to 40. So now the body will generate heat to increase its temperature to 40. And which part of the hypothalamus is going to be responsible? The heat gain center of the hypothalamus. So this is what is going to happen at 2. The heat gain center, which is the posterior hypothalamus, this is the heat gain center. It will now cause a peripheral vasoconstriction, non-shivering thermogenesis, and more importantly, shivering. So that shivering will increase the metabolic activity, generate heat, and body temperature increases to match the hypothalamic set point. And this is a very common experience when the fever is rising. There is shivering, there is chills and rigors that you experience. So that is because of the posterior hypothalamus causes shivering. Now, let's say the patient has taken some paracetamol, or as a natural course of the illness, the hypothalamic set point is lowered to 37 degrees Celsius. So the third event is lowering of the hypothalamic set point. It comes back to 37 degrees Celsius, but the body temperature is at 40, higher than the hypothalamic set point. So now the body must lose heat. So how does it lose heat? Sweating. So now the heat loss center, which is the anterior hypothalamus, this now causes vasodilation and sweating. This lowers the body temperature and brings it back to 37 degrees Celsius. So this is as far as your genesis of fever is concerned. So let's go back to this question. So what is going to be the first event? First event will be elevation of the hypothalamic set point. Then number 2 will be shivering, so that the body temperature increases to hypothalamic set point. Number 3 will be lowering of the hypothalamic set point back to 37, resulting in a cutaneous vasodilation and sweating. So my answer is going to be, first event is 3, then 4, then 2 and 1, and that is option B. Let's look at the next question. It says, a 72-year-old man has a stroke. 1 week later, he experiences sudden, uncontrolled, violent flinging and ballistic movements involving one side of the body, which is known as hemibalismus. Hemibalismus is due to a lesion of the subthalamic nucleus. A lesion of globus pallidus will result in athetosis, slow writhing movements. A lesion of caudate nucleus will result in chorea. These are flicking movements. A lesion of the substantia nigra pars compacta, loss of dopaminergic neurons of the substantia nigra pars compacta, results in Parkinson's. So the answer to this question is C, subthalamic nucleus. So these were your physiology questions in today's CBoT. If you have any queries regarding these questions, please feel free to send me a mail at dranupamadevgan@gmail.com. Thank you very much and all the best.
Hello and welcome to the CBoT session 1. We are here to discuss the orthopedic section. I am Dr. Yusuf Ali Tyagi and let's start with the questions. The first question that is there in your questions was like a 63-year-old retired banker presented to the emergency room with the complaint of sudden pain in his right leg. All right. So there is nothing which is specific till this point of the question which is being discussed over here. एक मतलब 63 ईयर का इंडिविजुअल है जिसमें कि देयर इज अ सडन इंक्रीज पेन एंड presented to the emergency room with a complaint of sudden pain in the right leg that made it difficult to bear weight. That means the patient is not able to bear weight on that limb after a minor misstep. मतलब when he was walking up the stairs or when he was crawling down the stairs, then because of a sudden misstep, there was a acute injury which has happened, but that mechanism of injury was not that severe. So a less severe sort of an injury might have resulted in a fracture to that patient. All right. So just till this point of time, whatever comes to your mind is that possibly the patient has sustained a fracture and that fracture is because of a very trivial trauma. It is because of a trauma which is having less velocity, low magnitude. So possibly the examiner is asking a question related to the pathological fractures, because you know pathological fractures are the result of a pathologically affected bone getting fractured because of that pathology, because of a minor trauma or a trivial kind of a trauma. All right. So although it is not yet confirmed, but after reading these two lines itself, there is a sort of a confirmation that possibly that the examiner is asking about a pathological fracture. Now further when we read the question down, then possibly we'll come to know about what exactly the examiner is seeking for. All right. Next what they have written is that the osteolytic lesion and the femur fracture are shown on the X-ray. So when you got the X-rays done, all right, on getting the X-rays done, there was an osteolytic lesion which is clearly apparent over here. And there is a transverse sort of a fracture which has resulted. Now, possibly it is because of, so what is the possible reason for this kind of the injury? If this is the head of the femur, neck of femur, greater and the lesser trochanter. So if there is an osteolytic lesion which was originally presented at that site of the bone, now this osteolytic lesion might have decreased the density of the bone. So it has increased the risk of a pathological fracture to happen at that segment of the bone. So because of the trivial trauma only, it has resulted in the breakdown of the bone. All right. So this is something which we have discussed in all our lectures, that pathological fractures are the transverse fractures. So what are transverse fracture? When the angle in between the fracture and horizontal plane is less than 30 degrees. All right. If this is the fracture line, and this is the horizontal plane. So if it is less than 30 degrees, then it is said to be a transverse fracture. And transverse fracture is because of the extensive contraction of the muscles present around the bone. So if there is an extensive contraction of the muscles, if these muscles, for example, they contract with their maximum force, then they might break the bone at the weakest segment. And the weakest segment over here is the osteolytic lesion segment of the bone, where the osteolytic lesion is present. All right. So now we have already confirmed that the examiner is asking a question related to a pathological fracture. All right. If we read the question back again, that a 63-year-old retired banker presented to the emergency with a complaint of sudden pain in the right leg that made it difficult to bear weight after a minor misstep. So this minor misstep is considered to be a pivotal, a key component in the question, a key hint in the question, that the patient has resulted from fracture, but because of a trivial trauma, a low velocity trauma or a low magnitude trauma. Now, osteolytic lesion and the femur fracture is present on the X-rays. Now, this is already have confirmed that the patient is suffering from a pathological fracture.
Now, there is a possibility of a bone metastasis. Yes, obviously, because the age of the patient is 63 years old. So, it might result in a distant metastatic lesion to a bone because of any other primary organ malignancy. Now, given his history of lung cancer, which of the following statement about this kind of a fracture is false? So, after reading the question, we have realized that the patient has suffered a metastatic lesion to the bone. Now, this metastatic lesion also have resulted in a fracture to the bone. Now, they are asking a question related to a pathological fracture. All right. So, point number one, that these are commonly transverse fracture. As we have already discussed this in the option, yes, pathological fractures commonly are transverse fracture, and this option is absolutely true. Again, if we talk about this, reason is that transverse fracture commonly is the result of an indirect mode of injury where the contraction of the muscles might break the bone. Now imagine if the bone is already weak in this zone, so whatever the indirect force is happening in this weak zone of the bone, it might result in, or it will result in, a transverse pattern of the fracture. All right, so this option is absolutely correct. Now option number 2 is pain does not appear till after the fracture. This option is slightly dicey because in some of the cases, there is a possibility that the patient might not perceive the pain. For example, if the lesion is osteoblastic, if the lesion is mixed, then there is always a possibility that the patient might be symptom free. But in case of lytic lesions, there is always a pain which is preceding these kind of the fractures where the bone becomes weak. Now, what is the reason for this pain? Just try to understand. Imagine this is a bone, all right, and we are talking about an osteolytic lesion over here. Now, this is a weight-bearing segment of the bone. This is a weight-bearing bone. Now, if you bear weight on a weaker segment of the bone or on a weak bone, then the condition would automatically become painful. So, this statement B is slightly dicey. We are not yet confirmed. Let's talk about the other options, but it is considered to be a relatively false option. All right, because they are asking about the false statement. Which of the following is false? Okay. Next option is a bone scan can confirm the presence of the metastasis. Now, all of you know that how to identify that this primary malignancy has metastasized is achieved by a bone scan. So, this option is absolutely true. There is no question about it. There is no doubt about it. All right. And then finally, there is another option that Merrill criteria is used for prophylactic fixation. The most important thing which is often asked in relation to this pathological fracture is Merrill criteria. Now, this is true that Merrill criteria is used for prophylactic fixation, for the decision that whether you should fix the bone or not. Just try to understand. We are not going to discuss the entire Merrill criteria over here. Just try to understand this. For example, if this is a bone, right? This is femur we are talking about. And in this femur, we are having an osteolytic lesion in the subtrochanteric zone. There is a tumorous lesion over here. Now, once you have diagnosed it, there is a possibility that you have to convince it to the patient that, the chances for this kind of a bone to get fractured, even after a trivial trauma, is too high. Then the patient will ask you that, sir, what should I do then? Should I wait for this fracture to happen? Then you have to say that, there is a possibility that if we fix this bone by putting the implant inside, prior to these fractures, that even before these fractures have happened, if we put a nail inside, if we put a plate, or if we put any fixation device before even the fracture has happened, so uske liye, for that you have to decide, and that decision is based on Merrill criteria. All right. So Merrill criteria, yes, it is absolutely true that it is used for prophylactic fixation of the bone. So Merrill criteria is not for making the diagnosis of a pathological fracture. Merrill criteria is for identifying the problem and to decide whether to fix the bone or not. For example, if we take another example, if there is a patient who comes to you, if this is a bone, there is a patient who comes to you with the osteoblastic lesion in the segment of the bone, a small osteoblastic lesion anywhere in the segment of the bone that does not pose a greater risk for, that does not pose a greater threat for pathological fractures. तो वो आप किस पे डिसाइड करोगे? That everything is going to be decided on the Merrill's criteria. All right. So Merrill criteria is to decide whether to fix this bone prophylactically before getting the fracture or not. So if the score is less than 8, for example, then if you can say that the fixation is not required. But if the score is more than 8 or more than 13 in that case, then the fixation is required because it might result in the fracture in future. So Merrill criteria is for prophylactic fixation. So obviously the answer for this question is the same that we were talking about, that the pain does not appear till after the fracture. No, actually this is the answer for this question, B. Why? Because the pain, the condition, the osteolytic lesion, majority of the times, if they are present on the weight-bearing segments of the bone, even if they are not present on the weight-bearing, like non-weight-bearing segments of the bone, they are painful. All right. Even prior to the fracture, the condition is painful. So this option B is the correct answer for this question. Hopefully everything is clear related to this pathological fracture related key clinical question. Coming to the next question, that which of the following condition does not relate to the Sprengel shoulder or the Sprengel deformity? So first of all, you should be knowing that what is a Sprengel deformity or the Sprengel shoulder. Now all of you are aware of the fact that a Sprengel shoulder is a high-lying scapula or the incomplete descent of the scapula. All right. Now in our classes, we used to discuss about that there are 4 conditions in which the picture of the back of the patient is important. One of the condition is winging of scapula. The second condition is Sprengel shoulder. The third condition is the injury to the spinal accessory nerve that results in the asymmetry of the shoulder. And the fourth condition is scoliosis. So these are the 4 differential diagnoses for which you can get the picture of a back of the patient. Now, Sprengel shoulder is an important question, and that is the reason why we are discussing it in CBoT program. Like Sprengel shoulder is incomplete descent of the scapula. All of you are aware, this is just a revision. Like the primary ossification center for the scapula is in the cervical region at 5th week of gestation. Then it descends down to reach the thoracic region. That means the final destination of the scapular primary ossification center during the 12th week of gestation. All right. Now, if there is any abnormality that results in incomplete descent of the scapula, then one of the scapula in the back will be higher in comparison to the other. And this is what is known as Sprengel shoulder or Sprengel deformity. All right. High-lying scapula, incomplete descent of the scapula, asymmetrical scapulae. All right. So they are asking about that which of the following condition is not associated with Sprengel shoulder. So, there are associations like Klippel-Feil syndrome. Yes, Klippel-Feil syndrome is associated with the Sprengel shoulder. What is Klippel-Feil syndrome? It is congenital fusion of, this is something which you already are aware. It is congenital fusion of 2 or more than 2 cervical vertebrae. When 2 or more than 2 of the cervical vertebrae are congenitally, that means since birth they are fused, then it will result in, or it will cause this Klippel-Feil syndrome, and it is an association with Sprengel deformity or Sprengel shoulder. Now, because of this fusion, the neck will become shorter, the neck skin will be webbed, there will be limitation of the movements of the cervical spine, and the posterior hairline will be lower in comparison to the normal occipital posterior hairline. So these are the features of the Klippel-Feil syndrome. Next, a cervical rib. Yes, cervical rib is also found to be associated with this abnormality. Carter-Gunner syndrome. Now, this is something which is exclusively, means it is nowhere related to this Sprengel shoulder. Carter-Gunner syndrome is a ciliary defect, which obviously I am not very much aware of this, but it results in bronchiectasis, it results in chronic sinusitis, because if I do remember, then there is a triad for the Carter-Gunner syndrome. One is bronchiectasis, other one is the chronic sinusitis, and the situs inversus, because it is a ciliary disorder. So it has got nothing to do with the Sprengel's deformity. All right. So obviously this is going to be the answer for your question, because they are asking about that which of the following condition does not relate to the Sprengel deformity. So Carter-Gunner syndrome, basically, if I'm wrong, that you might correct me, that one of the condition associated with this is bronchiectasis. All right. Then there is a chronic synovitis and situs inversus. All right. So it has got nothing to do. So probably this is the answer for your particular question. But before marking the answer down, it is essential to read the other option too. And the last option is renal abnormalities. You know, renal abnormality, diastomatomyelia, the spina bifida, the abnormalities of the ribs, the kyphoscoliotic deformity, all these things are found to be associated with Sprengel or could be associated with Sprengel shoulder. So Carter-Gunner syndrome is the answer for this particular question. So that is the answer. C. All right. So all of you are aware, means this is something which is not new to be asked. All of you are aware of all these conditions, obviously, because we have discussed all these things in details. All right. Coming to the next clinical question, and that is a 7-year-old girl slipped while. Now, this is very, very important from the point of the view that first of all, the age of the patient is provided and age is that of a child, 7-year-old girl, slipped while playing on the monkey bars and fell onto her outstretched right arm. You know, majority of the injuries that are happening in the upper limb are because of a fall on outstretched arm. All right, outstretched arm, there is a fall resulting in the injury to the upper limb. Now, whenever the outstretched arm related injury is provided in case of a child to a question, then do think of an injury around the elbow. And the most common injury around the elbow in these children is a supracondylar fracture. So before even reading the entire question, you probably are ready that possibly the examiner is asking about the supracondylar fracture of the humerus. So first of all, do think about that possibly the question is related to the supracondylar fracture. Achha, the moment you come to realize that the examiner is asking about a supracondylar fracture, then the thing that should come to your mind, the image that should hit you immediately is the distal end of the humerus above the level of the condyles. There is a fracture, that is supracondylar fracture. So this is the frame that should hit your mind. Outstretched arm related injury in case of a child around the elbow, possibly the supracondylar fracture of the humerus. If I say that there is a dislocation of the shoulder, but never in case of a child, this kind of a history would be provided. If I say there could be a fracture of the scaphoid, the fracture around the wrist, the fracture of the hand bones, the fracture of the both bones of the forearm, but outstretched hand related injuries are not provided in those kind of the, in case of a child, these things are not provided. Okay. So the important point over here, a 7-year-old slipped while playing and fell onto her outstretched right arm. So possibly the examiner is asking about supracondylar fracture of the humerus. Now, which resulted in instant pain and swelling? Obviously, because of the fracture, there is going to be a pain and swelling in that region. Now, the doctor noticed that the 3 bony point relationship around the elbow joint was maintained. Now, 3 bony point relationship is maintained. You already are aware of the fact that, you know, what are the 3 components in this 3 bony point relationship? One is the medial epicondyle, the second one is the lateral epicondyle, and the third one is olecranon, the tip of the olecranon. This is medial epicondyle, lateral epicondyle, and the olecranon. Now, if there is a fracture in the lateral epicondyle, then 3 bony point relationship would be disturbed. 3 bony point relationship means that with the 90 degrees of elbow flexion, this is going to create a isosceles triangle. And when the elbow is extended, then they will form a straight line. That is 3 bony point relationship. But in case of a supracondylar fracture, where the fracture is happening above the level of these 3 bony points, so no abnormality in this 3 bony point is going to be observed or is less likely to be observed. But in case of a fracture of the lateral condyle, which might happen around the elbow, there is going to be an alteration. With the fracture of the medial epicondyle, there is going to be an alteration. With the fracture of the intercondylar region, there is going to be an alteration. With the fracture of the olecranon process, that means tip of the ulna, there is going to be an alteration. So, possibly the examiner is asking about a supracondylar fracture because the 3 bony point relationship around the elbow joint is found to be maintained. Now, which of the following is not true regarding this injury? All right, which of the following is not true? Although, just for your practical purposes, actually this is a theoretical question, but for your practical assessment, for your practical approach, you should not go for assessment of a 3 bony point relationship immediately after injury. It has to be done in a complicated fracture which has resulted in malunion, cubitus varus, the gunstock deformity, the myositis ossificans. So all these things are going to be assessed when the fracture is complicated. when the fracture is already having or is following the late complications. It should be avoided. The assessment of 3 bony point injury should be avoided immediately after the fracture. All right. So which of the following is not true regarding this injury? Which of the following is not true regarding this injury? So first of all, what you came to know is that the topic we are talking about is the supracondylar fracture of the humerus. Now, once you are ready with the topic, then everything is going to be flashed in your brain. It has to be flashed in front of your eyes. The first option reads as the anterior interosseous nerve is the most commonly injured nerve. Obviously, you already know the answer that the most commonly injured nerve is the anterior interosseous nerve, which is a branch of the median nerve. And the most commonly injured artery is the brachial artery in front of the supracondylar region of the humerus. All right. S-shaped deformity is seen, yes, because of, once there is a fracture, then on the lateral view, there is going to be a posterior displacement, and because of this posterior displacement, the deformity of the limb, that it will become S-shaped. All right. So S-shaped deformity after supracondylar fracture of the humerus. Now, open reduction internal fixation is done as a treatment of choice. As far as treatment of choice is concerned, the treatment could be done by closed reduction internal fixation, open reduction internal fixation, even by closed reduction and slab application. But yes, it is a component. So, as far as management is concerned, yes, open reduction is also done, but majority of the time closed reduction is achieved. So, we are not going to mark this as an answer. First, read the other options out. Perkin traction is used, Smith-Dunlop traction, and that is not used today. It was used because today we are operating upon the patient and the patient is getting ready for the management. So it is not the Perkin traction. This is the correct answer for your question. The traction which is used for the management or which was used for the management was Smith-Dunlop traction. All right, Dunlop traction, not the Perkin traction. So this is the answer. Perkin traction is not used for the management of the supracondylar fracture of the humerus. These are the named retractions. The Russell-Perkins traction is used for the peritrochanteric fracture, not for supracondylar fracture of the humerus. So hopefully everything is clear related to this particular question. All right. This is a very commonly asked topic. They used to ask a question from the upper limb trauma, and supracondylar fracture of the humerus is their favorite concern. All right. Now, next question, that which of the following statement about osteomyelitis is false? Or which of the following statement about osteomyelitis? All of you know what the osteomyelitis is. Osteo mean bone. It is, so we are talking about the infections of the bone, and they are asking about that which of the following condition is false related to the infection. Now, point number 1. The first bony lesion of the osteomyelitis on an X-ray is seen during the second week of infection. That is true. The periosteal elevation is never witnessed immediately after the infection. It might take some time for its duration. You already know the reason. Like, imagine if this is a bone and here we are having an infective pathology, then in order to contain this infective pathology, the periosteum will get activated and try to confine the expansion of this infection. But the infective organism, if it is fulminant, if it is virulent, then it will breach this periosteal cavity. So there will be another attempt taken by the periosteum in order to contain the organism. So similarly, again the organism will breach this periosteal wall. There will be another attempt taken, multiple attempts taken by the periosteum to contain the organism within the confines of its cavity. But after some duration of time, what is seen is that the periosteum is elevated way beyond the confines of the bones, and that is known as periosteal elevation, periosteal reaction. So this happens, or this will take for some time for its appearance on the X-ray. It is never going to appear the next day or the next to next day, right? So the first bony lesion of the osteomyelitis on the X-ray is seen during the second week of infection. That is true. It takes around 7 to 10 days for its appearance on the normal X-rays. All right. Next is MRI show marrow edema within 24 hours. That means 24 to 48 hours. That is, this option is also true. Now, you know what happens whenever the patient, you are suspecting him to be suffering from osteomyelitis, even before the abscess formation or the collection of the abscess, this marrow edema could be visualized under the MRI within the period of 24 to 48 hours, But the thing is that this thing could be sensitive, but it is not specific, because this marrow edema could be because of injury also. This marrow edema could be because of a tumor condition also. This marrow edema could be reactionary also, non-specific also, and this marrow edema could also be because of the infection. All right. So it is a non-specific kind of a diagnostic evaluation, but when you are working upon a patient of infection, it will help you in starting or in progressing with the management of the patient. All right. So this option is also true, that marrow edema can be visualized on the MRI within the period of 2 days. Next option is that the bone scan. You know, the bone scan or the technetium 99 can confirm the diagnosis as early as 1 to 2 days. Yes, this is also true. That, you know, when you are performing a bone scan, these labeled dye is injected, then it will get accumulated wherever there is hyperemia. And you know, in the earlier phases of the infection, there will be increased vascularity to the zone which is getting infected. And because of this hyperemia, there will be a collection which can be seen on the bone scans. So this is also a specific investigation for relative confirmation of the diagnosis. And then finally, so that means that all the first 3 options are true. So possibly the 4th option is obviously false, but we have to read the option, we have to understand the option. Now, indium 111 labeled leukocyte scan is not very specific. Actually, it is a specific diagnostic tool for making the diagnosis of. So it is considered to be the most specific diagnostic tool. What happens is that you after withdrawing the blood of the patient, you will isolate the leukocytes and you will label them, you will inject this indium 111 and further you inject it further to the patient. Now, because of the increased leukocyte activity, that means leukocytic activities, there will be a collection of these labeled leukocyte in the area, and it is utilized for the accumulation of the inflammatory or infective process that might be going through in that particular region. Just for example, the patient might be suffering from peri-prosthetic infection or peri-implant infection. So how you are going to confirm it? You know, you will label the leukocytes and then you will perform the scans. And when you are going to perform the scan, there will be accumulation which is visualized around this implant. It means that there is a peri-prosthetic inflammation going on. And the reason for this inflammation is infection. So it is considered to be a specific investigation if there is no reason for this inflammation to happen in a patient. All right. So it is not very specific. No, this is not true. That means this is the answer for your question D. Hopefully everything is clear related to this particular question 2 about osteomyelitis. And then finally, that which of the following is not true for the given tumor. They have given you a tumor and the tumor is very easily identifiable. What we can see over here is a bony outgrowth from the metaphyseal region. All right. And it is typical appearance of a osteochondromatous tumor. So first of all, just by looking at the tumor, you have made the diagnosis. The diagnosis is osteochondroma. It is not very difficult to understand that the diagnosis is osteochondroma. So they are asking about osteochondroma. Option number 1, separate medullary canal. You know, the most characteristic feature for osteochondroma is that if this is a bone, and this is the osteochondromatous tumor which is originating from the bone metaphysis, and this is the epiphysis, then the cortex of the tumor and the cortex of the parent bone is actually one. That means it is sharing the medullary canal. There is a sharing of the medullary canal. Both of them are not separate. Imagine if there is a separate lesion, separate medullary canal, separate cortex of that particular tumor, then it is not osteochondroma. The most characteristic feature of osteochondroma is that the medullary canal of both the tumor as well as that of a parent bone is one. All right, there is no separation. The cortex is shared among the two. That is point number 1. There are certain other characteristics finding also, like that the growth of the tumor, it ceases at skeletal maturity. Other specific finding that majority of the time the tumor grows towards the metaphysis, not towards the joint. So these are some specific features of osteochondromatous tumor. Then the osteochondroma can turn into a malignancy. It can turn into a malignant tumor. So let's talk about the other options also. Although this option number 1, that means this potentially is the answer for your question. All right. Next, bursitis is the commonest complication. It is absolutely true. because what will happen if there is a formation of the bursa over it, because of the friction against the deep soft tissues, against the fascia, it might result in the inflammatory changes of this bursa, resulting in bursitis. So bursitis is the commonest complication. Next, increase in the thickness of the cartilaginous cap is a sign of malignancy, is actually considered to be the most sensitive sign of the malignancy, all right? Or you can say that it is the most important sign of the malignancy, all right? It is the most important sign of the malignancy. And finally, the tumor does not grow beyond skeletal maturity. Yes, this is also true until and unless the tumor is getting malignant. When the tumor gets or turns into a malignant one, then there will be a growth of the tumor beyond skeletal maturity too. But in this case, normally the growth of the tumor, it ceases, it stops at skeletal maturity. So hopefully everything is clear related to this particular question, osteochondroma also, all right? Every question which is provided in the CBoT examination from the orthopedic perspective is important for your preparation. And these are the kind of the question that you are getting nowadays. Osteochondroma, already you know that it is a tumor. It is a topic which is in trend today. Osteomyelitis related questions are relatively simpler, but it is always kept in your question. As far as upper limb trauma is concerned, 4 questions they are asking in a single paper, and supracondyla is their one of the favorite questions. Now, Sprengel kind of a deformity, they are asking these questions also, where the patient could be identified by these abnormalities or the deformities, and the pathological fracture, which is a very common problem. You have to address the problem and counsel the patient accordingly in order to manage the patient with a better managing tools. All right. All the best for your future. May you reach the zenith in your life. Thank you so much. Thank you very much.
Hello, my dear students. How are you? So, let's take the biochemistry session here. So, question number 1. A 25-year-old female with the complaints of tiredness, severe hair loss, and the fissures at the angle of mouth presented to a general physician. Her hemoglobin level was found to be 9. On investigation, she was diagnosed with hemolytic anemia, and supravital staining shows the presence of Heinz bodies. So guys, Heinz bodies, we all know they are present in a case of G6PD deficiency, right? The physician suspected the enzymatic deficiency condition and hence sent the blood investigation for whole blood enzyme analysis. Which of the following enzyme deficiency is expected in her condition? So the answer for this question is C. See guys, the most common cause of hemolytic anemias. Okay, if we talk about the enzymopathies, right, with hemolysis or hemolytic anemia. So enzymopathies with the hemolytic anemias, the answers will be the most common being G6PD deficiency followed by pyruvate kinase deficiency. And guys, also the pyrimidine 5' nucleotidase deficiency. Okay, these 3 are the most common causes of hemolytic anemias. Fine. Now guys, we all know that G6PD deficiency, G6PD is a very important enzyme in the HMP shunt pathway, right? So whenever there is a deficient enzyme in the G6PD, तो क्या होगा, decrease in the NADPH production हो जाएगा, right? So if the NADPH production कम होगा तो क्या होगा, तो जो हमारा एक एंजाइम है जिसका नाम है ग्लूटाथियोन, जो एक प्रोटीन है ग्लूटाथियोन, फाइन. So glutathione, which is a tripeptide of 3 amino acids, that is glycine, glutamic acid, and the cysteine. It has SH groups, right, which are binding to the free radicals, right? So glutathione is something which will also decrease. Okay. So active glutathione levels will decrease. So because of this, what will happen? They will be increased in reactive oxygen species or oxidative stress. So there will be high amount of oxidative stress, and guys, this will cause the membrane, RBC membrane damage. Fine. So right now we are talking about hemolysis, इसलिए मैं RBC बोल रहा हूँ. RBC membrane damage and hemolysis. Right guys? Now guys देखो ये जो ROS होता है रिएक्टिव ऑक्सीजन स्पीशीज, ये हीमोग्लोबिन को भी ऑक्सीडाइज करता है और वो जो ऑक्सीडाइज्ड हीमोग्लोबिन होता है उसी को हम बोलते हैं हाइंस बॉडीज. ओके, व्हाट आर हाइंस बॉडीज? नथिंग, क्योंकि ग्लूटाथियोन कम हो गया तो ऑक्सीडेशन हो गया हीमोग्लोबिन का एंड दैट इज व्हाट इज वी कॉल हाइंस बॉडीज. फाइन गाइज. And guys, when the spleen removes these Heinz bodies, from the RBC, there appears the bite cells in the circulation. Okay, like taken a bite of the Heinz bodies, right? So the bite cell will appear. Okay, got it? Fine guys, so that's all about this topic. That is your question number 1, and that is hemolytic anemias. Now guys, malic enzyme is an enzyme which produces NADPH. Isocitrate dehydrogenase cytoplasmic, not the mitochondrial of Krebs cycle, also produces NADPH. Transketolase is also the enzyme of HMP shunt, and it is a test for thiamine deficiency, right? Okay. Moving to our next question. 6-month-old child was born healthy, but her parent noticed that she had difficulty in breathing and appeared weak compared to the other infants. She struggled to feed properly and had poor muscle tone. We say comparison, like, compared to others. Upon examination, the physician noted that she had a weak cry, poor head control, and diminished muscle strength. Her heart rate was slightly elevated, and physical examination revealed that liver and spleen were both enlarged. Enzyme assay was conducted and found to be decreased activity of acid alpha glucosidase. Okay. X-ray of the chest shows cardiomegaly and also hepatosplenomegaly. See guys, diagnosis is already given because they have already mentioned the line. There is a deficient acid alpha glucosidase or acid maltase. Okay. This is an enzyme which is found in lysosomes and it is deficient in the Pompe's disease. So our answer is Pompe's disease. Fine. Okay, remember Pompe's affects the pump. Pompe's affect the pump. Fine. And when I say pump, pump means heart. Okay. Now deficient enzyme, guys, that is called as, actually the common name is acid maltase. But what is the other name? Alpha 1,4 glucosidase. Right. Now guys, when I say heart, right, heart simply means that there are 4 chambers. Fine, there are 4 chambers, so alpha 1,4. And guys, in the Cory's disease, we have an enzyme that is called as alpha 1,6 glucosidase. Okay, alpha 1,6 glucosidase, that is an enzyme in the Cory's disease. Alpha 1,6 glucosidase. So core has 6 packs, right? Core has the 6 packs. So guys, that is our, let's say 6-pack abs, like that. Fine. So Cory's alpha 1,6, Pompe's means pump, pump means heart, heart has 4 chambers. So alpha 1,4 glucosidase is the correct answer. Am I clear? Fine guys. Guys, in this question, though it is not mentioned, but if they say that glycogen is being accumulated in lysosomes, that is the best line to pick for the diagnosis of Pompe's disease. If they say कि भाई Pompe's disease मतलब कौन सा disease है और वो कह रहे हैं कि lysosome, right? Lysosome has the glycogen, then my answer goes to the Pompe's disease. Right? Fine. Now guys, look at this question. Why not von Gerke's disease? Because this patient has, the muscle is affected, diminished muscle strength. Fine. So it's not the von Gerke's disease. Guys, von Gerke's disease, there is a deficient enzyme glucose 6-phosphatase that is not found in muscles, only found in liver. So liver is the only organ affected in the von Gerke's, right? So if there is a question in which the muscles are affected, don't count see how to answer the question that, guys, if the muscles affected in any disease MCQ, then it's not type 1 and type 6 GSD. Okay. Now they mention glycogen in lysosomes, it's only type 2. Simple. Then they mention that there is a abnormal structure of glycogen. then only possible answers are type 3 and type 4, right? Type 3 and the type 4. So abnormal structure of the glycogen is found in type 3 and type 4. So if they say glycogen structure was normal, it looks normal, it's not type 3 and type 4. Cories and Anderson, it's not that. Right guys, so this is the way you can actually answer the MCQs, right? And guys, if the mostly muscles are affected, fine. Muscles affected, then type 5 and type 7. In type 5, it's McArdle's, type 7 is Tarui's. In the Tarui's, guys, there may be hemolysis also, right? Hemolysis is also present in type 7 to differentiate it with the type 5, at least in the MCQ purpose. So, very simple, guys, this question. You can do it next time easily. Identify the transporter A. So, guys, transporter A, because they are showing insulin release. So, that means it's a beta cell of the pancreas. Fine. So, beta cell of the pancreas has GLUT2. So, that is our correct answer. Fine, guys. So, GLUT2. GLUT4 is found in the adipose tissue, muscles and heart. 5 is found in the intestine for the fructose transport. And GLUT3 is generalized, found in almost all the body cells, but mostly in the neurons, right, that we have to remember. Okay, moving to our next question. 21-year-old man arrived with the tendon xanthomas. So guys, whenever the xanthomas are there, always remember that this can be a case of some hyperlipidemia or dyslipidemia, right? Chest discomfort. Further assessment revealed aortic wall stenosis. Biochemical test unveiled random plasma glucose of 146, total cholesterol 370 and LDL 220. Guys, this is very high. Fine. And TG of 100, that's normal. Genetic testing indicated anomaly in the LDL receptor. So they have given the diagnosis already. The physician recommends statins, right? Identify the dyslipidemic pattern. So guys, this is a case of familial hypercholesterolemia. Fine, familial hypercholesterolemia due to the decrease in the LDL receptor. So guys, because this is the autosomal dominant disease, it also runs in the family. Though it is not mentioned here, but if you get a, something like that, father or the brother of the same patient died at a very young age of, let's say, only just 14 years by the sudden cardiac arrest. So that is also a very important hint to the autosomal dominant or the familial hypercholesterolemia and familial CVDs, right? Okay. So guys, अगर LDL receptor deficient हो गया तो obviously LDL का level बढ़ जाएगा. Fine. LDL का level, देखो guys, as per one criteria, anything which is more than 234 highly suggests the diagnosis of, when the LDL level is more than 234, it highly suggests the diagnosis of familial hypercholesterolemia. अब देखो familial hypercholesterolemia ये तो 21 years old है. अगर ये बच्चा होता सिर्फ 9 साल का या 10 साल का, मतलब यंग एज, तो यहाँ पे CVD का सिम्टम्स नहीं होता, सिर्फ xanthomas होते, राइट? ओके, सो xanthomas will be more prominent if it's a case of only a young child less than 10 years of age. But more than 10 years of age, there are symptoms of like CVD are present. Got it, guys? So LDL when it is oxidized, it is a substrate for macrophages. Macrophages, when they take the LDL, they convert into foam cell. And guys, foam cell is the beginning of atherosclerosis. Right, guys? So that is the point. So that is your type 2 familial hypercholesterolemia. Right? Guys, in the familial chylomicronemia syndrome, TG will be high. In the A-beta lipoproteinemia, TG will be almost 0. They should mention it, and HDL should be normal. LDL should be very low. See, LDL is very high. It cannot be. LDL is very high. So, in A-beta lipoproteinemia, LDL is very low. Right? Basically. Okay, guys. Cytosterolemia is a condition which is caused by consumption of the accumulation of the plant sterols. Right? So, it's not a case of that. Moving to our next case. Guys, looking at the, hyperlipidemias, it's a very important topic. And guys, the type 1 hyperlipidemia, when we talk about type 1 hyperlipidemia, that is due to deficient of LPL or the C2, ApoC2 deficiency. Guys, there is mostly high amount of TG and normal cholesterol, right? So, TG, because of high chylomicrons, it will be high. In the type 2 hyperlipidemia that we are discussing, that is deficient LDL receptors are there. So, there is increase in the levels of the cholesterol, right? or the LDL cholesterol. Fine. Or the total cholesterol. Fine. And there is a premature CVD is also present. There is no CVD risk here. It's not known why, but there is an increased risk of cardiovascular disease. Then we have type 3rd. In the type 3rd, guys, we have, ApoE2 expression. Okay. So ApoE2 expression. When I write THREE, so in the 3 we have the 2 E's. So E2 is expressed, right? So when there is a ApoE2 expression, there is an increase in the remnants of the chylomicrons. Okay, increase in the remnants of chylomicrons and the VLDL. Fine. So that is the type 3 hyperlipidemia, where the remnants will increase actually. Okay, normal E is ApoE3, and the E4 expression is associated with Alzheimer's disease. Very important, one more MCQ that I'm giving you here. So guys, remember these 3, right? देखो पहले में LPL में lipoprotein lipase P आ रहा है, दूसरे में LDL आ रहा है, दूसरा, ठीक है, तीसरे में 3 में डबल E आ रहा है, राइट? इस तरह से याद रख लो. एंड गाइज यहाँ पे एक और चीज़ लिख रहा हूँ मैं टाइप 3 में कि कोलेस्ट्रॉल डिवाइडेड बाई TG रेशियो जो होगा दैट विल बी ऑलमोस्ट 1. मतलब कि अगर कोलेस्ट्रॉल इंक्रीज हुआ 200 पे तो TG भी 200 के आसपास ही होगा. तो दैट इज लाइक गिविंग अस ऑलमोस्ट 1 रेशियो. ओके, फाइन. तो और पहले वाले में इरप्टिव ज़ैंथोमास होता है, सीड्स लाइक ज़ैंथोमास ऑन द स्किन. सेकंड में मोस्टली एक्लिस टेंडन वाला पॉइंट याद रखो. एंड थर्ड में गाइस हमारे पास पाम क्रीज ज़ैंथोमास होता है, ज़ैंथोमास ऑन द क्रीजेस ऑफ द पाम, राइट? चलो, लेट्स मूव ऑन टू द नेक्स्ट क्वेश्चन. So during a regular checkup, 3-year-old child displays the signs of hepatosplenomegaly, intellectual disability, significant CNS impairment. Eye examination reveals cherry red spot. Now guys, before proceeding, एक बात सुन लो and remember every time that if someone asks you that the only cause of cherry red spot in metabolic or the lysosomal storage disorder, तो आप याद रखो Tay-Sachs disease. Fine. But Tay-Sachs disease में hepatosplenomegaly नहीं होती. So it's not a case of that, right? So guys, before even proceeding further, मैं आपको एक बात लिखना चाह रहा हूँ कि if there is a hepatosplenomegaly plus cherry red spot, ये दोनों एक साथ present है, तो answer is Niemann-Pick's disease, right? Niemann-Pick's disease is the answer. ठीक है. So child's condition, is deteriorating. The pediatrician suspected a lipid storage, orders enzymes, and sphingomyelinase is deficient. So they have already given the diagnosis, right? Though you will not be that lucky in your actual exam, right? They may not give you the name of the enzyme. You have to actually look and answer. So you have to find the points that helps you in the answer, like I told you in both the questions previously, right? So guys, this question is Niemann-Pick's disease. Okay, fine. See, in the other cases like Gaucher's disease, in the Gaucher's disease, the one prominent feature clinically that you must remember is bone crisis. Means patient is in the pain because of the bone pain, right? Severe pain in the bones. Okay, and they may also mention some other things like, for example, the macrophages who has consumed the lipid, they look like crumpled tissue paper. In the Niemann-Pick's disease, guys, you will be finding soap bubble appearance. Okay, soap bubble appearance of the macrophages who have consumed that lipid containing lysosomes, right guys? Okay, in the Gaucher's I told you 2 things. In the Farber's disease, Farber's is a very rare disease. Till now very few cases have been found till now, right? So Farber's, I don't think they can ask you, but you should know the name of the enzyme deficient, that is ceramidase, right? And these patients present with generally the nodules, okay, on the skin, and hoarseness of the voice. That's not important, you can ignore it. Guys, in the Krabs disease, generally the patient presents with a typical symptom of, let's say, blindness, right? Or a case of cerebral palsy, which looks like a case of cerebral palsy. And there is globoid cells, right? On the histopathology, globoid cells are visible. Okay, so that is a Krabs disease. And guys, in the Fabry's disease, if it is a Fabry's disease, what do you have to look for? In the Fabry's disease, just look for one thing, and that is, urine has high protein, plus there is Mulberry cells and Maltese cross. Urine sediments are Mulberry cells and Maltese cross. Okay. What are the other things I'm writing again? Maltese cross and Mulberry
cells. So these are the two important names that you should remember. Fine guys, okay. So that is your in Fabry's disease. Okay. So I just want to tell you one thing, that how to approach a question in how to remember the things in a case of lysosomal storage disorder like this. So guys, remember one thing, remember the name of disease, name of enzyme, okay, and then remember one unique point. Like for example, what is the special feature on histopathology? Yeah, what is the special feature? Yeah, something like special clinical feature, like I told you, blindness in the Krabs disease, or bone pain, severe bone pain in the Gaucher's disease, right? Okay, and guys, if there is only cherry red spot, they are asking, and the patient presents with a paralytic condition, Tay-Sachs disease. But cherry red spot plus there is hepatosplenomegaly, Niemann-Pick's disease. Got it, guys? Next question. 20-year-old woman visited a dermatologist due to experiencing dry, thickened skin, multiple areas of skin pigmentation. Her skin became extremely sensitive on exposure to sunlight. Okay. So despite trying the tropical treatments, there was no improvement. So, if the doctor suspects that's a DNA repair mechanism defect, what kind of DNA repair mechanism it can be? Fine. See guys, I can make this question more, difficult or more easy, you can say that. That in this question, if we say that patient presents with, a pigmented area, right, with a nodule. And when the nodule was excised and sent for histopathology, it was found to be a case of squamous cell carcinoma, or the basal cell carcinoma, or the melanoma, right? So then now if I ask you then which kind of DNA repair defect it is, then it will become very easy, and answer is nucleotide excision repair. This question is easy because they have given the picture, right? So there is a lots of freckling and sun sensitivity. So that may be a case of nucleotide excision repair or the xeroderma pigmentosum. Right guys? In the mismatch repair, we have hereditary non-polyposis colon cancer as the best answer, right? And in the base excision repair, we have MYH associated polyposis, right? MYH associated polyposis, right? That means the colon, risk of colon cancer is there. But in the mismatch, it is already colon cancer, hereditary non-polyposis colon cancer. Clear guys? Okay. And homologous recombination disorder, right? If it is there, like, repair of the double strand break, then the cases of, ovarian, prostate, and the breast cancers, familial cases. Okay. So this will be a case of familial, ovarian, breast, and prostate cancer. Right guys? So this one is not difficult. It's an easy one. So guys, if I ask you one question, that nucleotide excision repair, if it is defective, why the patient is sun sensitive? Can you answer me? Why the patient is sun sensitive here? The patient is sun sensitive because of the one reason, that is, UV rays, they have one, peculiarity, that what they do when they're exposed to the skin, they causes the formation of thymine dimers. They cause the formation of thymine dimers. Okay. मतलब डीएनए में जो थायमीन होगा, राइट, वो आपस में ही कोई बॉन्ड बना लेगा आपस में, राइट, एंड इट इज नॉट नाउ लिंक्ड विद ए एंड ए. तो पहले ये बॉन्ड था सपोज एटी एंड एटी, लेकिन अब ये बॉन्ड नहीं है, राइट. सो द बॉन्ड इज ओनली बिटवीन द टू टीज, राइट. सो दैट इज कॉल्ड एज थायमीन डाइमर्स, और यू कैन कॉल इट pyrimidine or the purine dimers, but mostly it is pyrimidine dimers. Fine guys. So that is our nucleotide excision repair defect causing the xeroderma pigmentosum, right, and which commonly present with the T dimer formation, and if they are not repaired, this will lead to the cancers like squamous cell carcinoma of the skin, right. Moving to our next question, an infant aged 3 months was taken to the emergency department due to the issues like unresponsiveness to sound, feeding difficulties, irritability. On the examination, sugar was low, ammonia was high. See, whenever I see ammonia high, I will only think of probability of liver failure and urea cycle defects. अब 3 महीने का बच्चा है तो जनरली यूरिया साइकिल डिफेक्ट होगा, लीवर फेलियर तो एकदम से नहीं होगा, ठीक है. ग्लूटामिन हाई है. Guys, glutamine is nothing but also a marker of high ammonia levels, because a question है कि like what is the carrier of ammonia in the non-toxic form. सो आंसर इज ग्लूटामिन, राइट. ग्लूटामिन ही बनता है अमोनिया से, अमोनिया को हम फ्री नहीं छोड़ते, तो हम उससे ग्लूटामिन बना लेते हैं. बट यहाँ पे अमोनिया भी हाई है, मतलब कहीं तो कोई डिफेक्ट है, राइट. Elevated orotic acid and uracil, मतलब pyrimidines high है. So guys, that is 99.9% case of only one thing, that is OTC deficiency, right. So treatment was initiated and no progress was made, and actually the patient will die soon, right. This is the most common X-linked recessive urea cycle defect. Most common also, and X-linked recessive also. Fine guys, so that is your type 2 hyperammonemia. Okay, so type 2 hyperammonemia is our diagnosis, that is deficiency of OTC, right. So it is simple guys. देखो, अगर सिर्फ और सिर्फ अमोनिया होता तो टाइप 1 बोल देता, या सिर्फ और सिर्फ ग्लूटामिन होता तो भी मैं टाइप 1 ही बोल देता इसको, राइट. और कुछ फाइंडिंग नहीं है. बट यहाँ पे इंक्रीज इन ओरोटिक एसिड भी है, राइट. ओरोटिक एसिड भी है विच इज डायग्नोस्टिक, या फिर यूरेसिल है, अगेन डायग्नोस्टिक, राइट. लेस कॉमन होता है और यूरेसिल, ओरोटिक एसिड इज अ प्रिकर्सर ऑफ यूरेसिल, वो कॉमनली होता है ना. क्यों? क्योंकि बिकॉज यूरेसिल बनाने के लिए, यूएमपी बनाने के लिए जो शुगर प्लस फॉस्फेट चाहिए होता है वो इजीली अवेलेबल नहीं होता, इसलिए वो ओरोटिक एसिड पे ही पाथवे रुक जाता है. अब ये पाथवे होता क्यों है? देखो, बिकॉज यू नो यूरिया साइकिल का सेकंड एंजाइम है ओटीसी. अगर ये डेफिशिएंट होगा तो पहला प्रोडक्ट जो है कार्बामाइल फॉस्फेट वो इंक्रीज हो जाएगा. कार्बामाइल फॉस्फेट विल रीच साइटोप्लाज्म, राइट. ओके, ये माइटोकॉन्ड्रिया में इंक्रीज हुआ था, अब ये साइटोप्लाज्म में आ जाएगा. सो कार्बामाइल फॉस्फेट एंटर्स द pyrimidine synthesis, right. So ये जाके pyrimidine synthesis pathway में चला जाएगा. pyrimidine synthesis pathway का rate limiting enzyme होता है CPS2, तो वो bypass हो जाएगा because we already have CP, that is carbamoyl phosphate. So bypass the CPS2. Fine. So once the CPS2 is bypassed, what will happen? They will be increased in the orotic acid. ओके, और अल्टीमेटली यूरेसिल बोल दो या यूएमपी बोल दो, है ना, यूरेसिल मोनोफॉस्फेट. सो गाइस, होप यू अंडरस्टूड द मीनिंग दैट व्हाई देयर इज ओरोटिक एसिड यूरिया इन अ केस ऑफ टाइप 2 hyperammonemia. That is why, right? So very important question. Okay, so again I'm telling you guys, देखो, if in the type 1 hyperammonemia there is increased in only ammonia levels, right. If it is a type 2 hyperammonemia, there is increase in ammonia levels plus there is orotic acid urea, right. In type 3, there is definitely increase in ammonia plus there is citrulline levels are also high, right. Okay, citrullinemia, that will also be increasing. Fine guys. Okay, so guys, in these three disorders we can easily differentiate, right. So it's not type 3 actually, it's called as citrullinemia, right. We don't call it the type 3 hyperammonemia, but we call this as a citrullinemia. Fine. Then we have the fourth one, that is called as arginosuccinate aciduria, right. Arginosuccinate aciduria. So this is due to deficient enzyme arginosuccinate lyase. So what will happen here? Increase in the arginosuccinate levels. So again you can identify here there is a deficiency of arginosuccinate synthetase, right. Arginosuccinate synthetase. Okay, right. So and the last one, hyperargininemia, guys, there will be increase in the levels of arginine, right, due to the deficient enzyme that's called as arginase. What is the name of the disorder? Hyperargininemia. Fine guys. So this is how you can actually answer the questions. And the last one is triple H syndrome. Okay, triple H syndrome. Guys, in the triple H syndrome, the H stands for hyperammonemia. Second H stands for homocitrulinemia, so which is not citrulline. And the third, hyperornithinemia, because there is a deficient in the enzyme that is called as ORNT1. Deficient ORNT1, ornithine translocase, right. Okay, so that's why ornithine becomes high, and ammonia will also be high because ornithine is unable to reach to the urea cycle in the mitochondria to help in the step number 2. Right, guys? So that's all about urea cycle disorders, and that is our MCQ. What is the treatment of urea cycle disorder? You can answer phenylbutyrate, at least one drug that you should know, previous MCQ. 15-day-old neonate's parent noticed his sweet maple syrup-like odor. He also exhibited poor feeding habits, vomiting, irritability, his muscle tone appeared weak, etc., etc., etc. So guys, this is a case of maple syrup urine disease, and the answer is option A. That is branch chain alpha keto acid dehydrogenase. Right? Guys, what is a marker of maple syrup urine disease? There is a allo-isoleucine. Right? So this is considered as a marker of this disorder, that is maple syrup. So there is a disorder of maple syrup in the urine, or the maple syrup is also called as the intensely sweet odor, or we can say the caramel-like odor, right? And this is very strong in actually the earwax instead of urine, right? So rest of the option, homogenesis oxidase, that is a case of alkaptonuria. This is PKU, and this is homocystinemia, right, guys? 40-year-old man arrived with a 10-day-old history of abdominal pain and subsequent weakness. After admission, he experienced quadriparesis along with the tonic-clonic scissors. Neurophysiological assessment indicates axonal polyneuropathy. Urine analysis reveals high levels of ALA and PBG, right? So guys, the pain in the abdomen, right? And neurological features, and ALA levels are high. So this is a case of what? This is a case of acute intermittent porphyria, right? So on and off pain. Fine, guys. Acute intermittent porphyria. So AIP, this is due to the deficiency of the enzyme that is called as porphobilinogen deaminase. Okay. Clinical features are already given: abdominal pain and polyneuropathy and high levels of ALA in the blood, or the PBG in the blood. Fine. So PBG will be high. You can write like this: there is increase in the PBG. And guys, because of the PBG which is high in the blood or in the urine becomes wine colored, right? Wine colored urine, and this urine absorbs light at 410 nanometer. This is the simplest test, and this is known as Soret test, Soret band. Okay, because the graph will be visualized where the peak absorbance of the urine will be seen at 410 nanometers. Okay, guys, most of the time these patients, they have a history of fasting, which is very important. That is the reason we can give actually only glucose as the therapy, and the patient will be all right. So why the fasting causes these symptoms? Because guys, fasting is a process which increases the heme synthesis, right? Okay, fasting actually increases the gluconeogenesis and glycogenolysis, but the same pathway genetic level पे जो एक same pathway है, वही सेम पाथवे एला सिंथेस को भी एक्टिवेट कर देता है. इसीलिए हमें फास्टिंग इस पेशेंट में अवॉइड करनी है. या फिर इस पेशेंट में होगा हिस्ट्री ऑफ सम ड्रग्स, राइट, जैसे कि अल्कोहल, बार्बिचुरेट्स एंड स्टेरॉइड्स लाइक कॉन्ट्रासेप्टिव्स. फाइन गाइस, क्यों? क्योंकि दे इंक्रीज द CYP450 एक्सप्रेशन. अब देखो CYP450 में होता है हीम, और अगर अल्कोहल किसी ने कंज्यूम कर लिया तो हीम सिंथेसिस बढ़ जाएगा. सो CYP बनाना पड़ेगा, बट CYP बनाने के लिए जो हीम पाथवे है वो है डिफेक्टिव. दैट्स व्हाई द इंटरमीडिएट्स विल एक्यूमुलेट एंड विल कॉज द सिम्टम्स, राइट. सो हिस्ट्री ऑफ ड्रग्स होगा. फाइन. एंड गाइस, इसलिए इन द मैनेजमेंट व्हाट यू कैन गिव एक्चुअली हीम इन्फ्यूजन, right? Heme is available as a infusion for these patients. So they have a severe abdominal pain and neurological features, right? And in the investigation, high PBG, and I told you other points, right, guys? Guys, there is one more feature that I want to just tell you here, that in the patients of AIP, there is no, right, in the big, no sun sensitivity. Okay, so this is a porphyria with no sun sensitivity, right? Okay, so that's all about this question. Fine, guys, let's move to our next point. The following Lineweaver-Burke plot depicts which of the following enzyme inhibition. So guys, as you can see, the Km values is not changing, but there is decrease in Vmax, right? Here there is a decrease in the Vmax. So this is a case of non-competitive inhibition, right? In the competitive inhibition, the graph will be something like 0. And so they are having the Vmax is unchanged, right? As you can see, and the Km is increased here, right? In the presence of inhibitor. So that is a competitive inhibition. So this is our answer, option number B. Guys, moving to our next question. So they are simply asking in this question, all of the following are antioxidants except. So guys, we all know that vitamin B12 is not an antioxidant, right? Vitamin C, yes. E, yes. Beta carotene or the provitamin A, yes. Not the vitamin A. अगर यहाँ retinol लिखा होता तो cannot be the answer. Okay, it's a beta carotene which is yes, right? Then guys, there are a lot of other which are not vitamins like polyphenols. Polyphenols में एक होता है quercetin, है ना? मैं एक example दे रहा हूँ polyphenol का जो most of the time हमारे fruits में या green tea में इन सब में होता है. तो ये polyphenolic compounds होता है which are also very very important antioxidant, है ना? एक question भी आया था ऐसा, that antioxidant present in fruits, polyphenols, right? Okay, and what else guys, what else antioxidants we have? Some minerals we consider antioxidants like selenium. Why? Because it is a part of glutathione peroxidase enzyme. That's why, right? Okay, which of the following are not required in PCR? So guys, PCR definitely we need everything except dideoxynucleotides, right? I need strand, yes. Primers, yes. 2 primers I need actually. And Taq polymerase, which is heat stable, yes, I need that. But guys, dideoxynucleotides are required actually in the Sanger's, right? Chain termination. Okay, Sanger's chain termination method of the DNA sequencing. Okay, so where I need dideoxy. Guys, what is a dideoxynucleotide? जैसे मान लो कि ये एक पेंटोज शुगर है with the phosphate present on the 5th and a base like adenine present on the 1st carbon. अब इसमें क्या होता है आपको बताइए कि OH ग्रुप जो होता है हमने सेकंड पोजीशन का तो हटा दिया था तो सिर्फ H होता है और थर्ड पोजीशन पे मुझे OH ग्रुप चाहिए, राइट? सो दिस इज फर्स्ट, सेकंड एंड थर्ड. So why the third position OH group is very important? Because guys, DNA polymerase works in 5' to 3' direction. मतलब कि अगर मुझे एक और न्यूक्लियोटाइड लेना है, राइट, और उसका फॉस्फेट यहाँ से अटैच करना है तो ये OH और ये फॉस्फेट अटैच होंगे, है ना, बाय द DNA polymerase. तो दिस इज कॉल्ड एज 5' फॉस्फेट एंड 3' OH. दे आर मेकिंग ए फॉस्फोडाइस्टर बॉन्ड. तो डीएनए ऐसे बनता है. तो अगर मैं डाइडिऑक्सीन्यूक्लियोटाइड ले लूंगा, मतलब कि इफ देयर इज नो OH ग्रुप हियर, यहाँ पे भी OH ग्रुप नहीं है, अब सिर्फ H ही है, तो देयर विल बी नो प्रोसीडिंग, नो फर्दर एलोंगेशन ऑफ डीएनए, राइट? डीएनए हो जाएगा, सिंथेसिस हो जाएगा, टर्मिनेट, राइट? सो दैट इज व्हाई वी कॉल इट चेन टर्मिनेशन मेथड ऑफ सीक्वेंसिंग. ओके गाइस, so that is like PCR. Guys, PCR में एक और point लिख सकते हैं हम, we need magnesium, right? So the buffer which contains some other minerals like magnesium. Why magnesium? Magnesium is important for DNA polymerase activity. That's why, right guys? Okay. Also remember the steps of the DNA PCR. Guys, in the PCR we starts with first thing, that is DNA denaturation. Then we do the second thing, that is annealing of the primers, and third thing that is called as chain extension, right? Okay, so denaturation, annealing of the denaturation का मतलब होता है separation of the two strands. Okay, then annealing का मतलब होता है to fix the primer, and then the third is chain extension, that is, you know, making the DNA strand. So guys, these are the sequence of the 3 steps, right, which was asked in INI-CET exam. The sequence of steps in the PCR, right? And guys, PCR will gives you to the power n copies in the n number of cycles. So this has also been asked in exams as a point. Matlab ki if you do 20 copies, so to the power 20, that will be more than 10 lakh copies in just 1 to 2 hours, right? 2 hours basically. Which of the following statement regarding the DNA replication is incorrect? So guys, you know, DNA ligase links the DNA, yes, but without spending ATP, no. Ligases belongs to class 6 of enzymes and they need ATP, right? So this is the answer. Looking at the other option, single strand binding proteins like in prokaryotes, they prevents the strand re-annealing after helicase is done its job. है ना कि भाई हेलिकेज ने सेपरेट किया और इसने वापस फिक्स कर दिया, तो कोई मीनिंग नहीं है. Primase makes the RNA primer for DNA polymerase 3 to initiate replication. Yes, right. Primase is actually RNA polymerase, right? Primase. DNA ligase catalyzes the phosphodiester bond formation. Yes, DNA ligase and even the DNA polymerase, they make only same bond, and that bond is called as what? Phosphodiester bond. Right, guys? Okay. So, guys, thank you so much. Okay, and keep revising. Right, you can achieve whatever you have decided, your goals. All the best. Keep practicing. INI-CET is very close. Bye bye.
Hello बच्चों, welcome to the session where we are going to discuss the questions of pediatrics जो आपके पहले CBoT में आए हैं. तो देखते हैं questions क्या आए थे, कम आए थे questions and बहुत simple थे. So let us discuss each one of them. तो पहला question था बच्चों, an 8-year-old male presented with lower limb deformities and frequent complaints of dental abscesses. In spite of having been treated with multiple courses of vitamin D, the physician ordered lab test which revealed calcium of 9.4, phosphate of 1.8, parathyroid hormone PTH जो कि होता है normal, alkaline phosphatase was raised. Which of the following statements is incorrect regarding the probable diagnosis? Options देख लेते हैं. So the most common pattern of inheritance of this disease is X-linked dominant form. The mother of the affected patients may have leg bowing or short stature or fasting hypophosphatemia. Symptoms of hypocalcemia such as tetany and muscle weakness are absent in affected patients. The gene defective in this condition causes an increased level of endopeptidases, which in turn decreases FGF23 levels, which is involved in stimulating renal 1-alpha hydroxylase. तो सबसे पहले हम आंसर देख लेते हैं एंड देन इसको डिस्कस करेंगे. तो इसका करेक्ट आंसर बच्चों क्या होगा? इसका करेक्ट आंसर होगा ऑप्शन नंबर 4. अब ये समझने के लिए, ठीक है, दिस इज द करेक्ट आंसर. अब ये समझने के लिए आपको सबसे पहले इस कंडीशन की पैथोफिजियोलॉजी समझनी पड़ेगी. तो पहले समझते हैं वी डीलिंग विद. लेट अस एनालाइज द क्वेश्चन. इस बच्चे को मेल चाइल्ड है, एक तो लोअर लिम्ब डिफॉर्मिटीज है. लोअर लिम्ब डिफॉर्मिटीज एक छोटे बच्चे में होना, इसका क्या मतलब? सबसे पहले दिमाग में आता है रिकेट्स, राइट? तो एंड इसमें मल्टीपल कोर्सेज ऑफ विटामिन डी दे चुके हैं, फिर भी बच्चे को प्रॉब्लम हो रही है, तो सही नहीं हुई है डिफॉर्मिटी. सो दैट मीन्स समथिंग विच इज नॉट रिस्पॉन्सिव टू विटामिन डी थेरेपी, समथिंग विच इज रेजिस्टेंट टू विटामिन डी थेरेपी, राइट? एंड एक और बहुत पेक्यूलियर प्रॉब्लम है डेंटल एब्सेस. अब डेंटल एब्सेस का रिकेट से क्या मतलब, मुझे भी समझ नहीं आया. ठीक है, देखते हैं. The physician ordered lab test which revealed calcium of 9.4, phosphate 1.8, PTH normal, alkaline phosphatase was raised. तो ये तो पक्का है कि आपका कैल्शियम नॉर्मल है. तो क्या रिकेट्स रूल्ड आउट होगी? नहीं बच्चों, आपको पता होना चाहिए कि रिकेट्स में, चाहे वो विटामिन डी डेफिशिएंसी रिकेट्स, जो आप क्लासिक रिकेट्स की भी बात करो, कैल्शियम कैन बी नॉर्मल. और वो इसलिए क्योंकि पीटीएच इंक्रीज हो जाता है रिकेट्स में. तो कैल्शियम जरूरी नहीं है कि आपको लो मिले इवन इन फुल फ्लोरिड रिकेट्स. ठीक है, तो ये आपको ध्यान रखना है कि कैल्शियम नॉर्मल देख करके आपने ये नहीं बोलना है कि रिकेट्स नहीं है. कैल्शियम आपके नॉर्मल क्लासिकल रिकेट्स में भी नॉर्मल लेवल हो सकता है एंड इनफैक्ट होता ही है मोर और लेस. एंड दिस इज किसके सौजन्य से? पीटीएच के वजह से. क्योंकि पीटीएच जो होता है वो उसका सोल एग्जिस्टेंस आप ऐसे याद करो, इट इज बिकॉज ऑफ द फैक्ट कि उसको नॉर्मल सीरम कैल्शियम बनाए रखना है, उसका काम ही ये है, वो इसीलिए पैदा हुआ है पीटीएच, ऐसे आप याद करिए. तो जब भी रिकेट्स होती है बच्चों को, रिकेट्स का मतलब है डिफेक्टिव मिनरलाइजेशन ऑफ द ग्रोइंग बोन्स. ठीक है, एंड मोस्ट कॉमनली वो होती है विटामिन डी डेफिशिएंसी की वजह से. तो ऐसे में क्या होता है कि विटामिन डी अगर डेफिशिएंट हो, डेफिनेटली सीरम कैल्शियम फॉल करेगा. हम सब ने ये पढ़ा है कि विटामिन डी कैल्शियम के लिए रिक्शा का काम करता है. वो विटामिन डी वो रिक्शा है जो कि कैल्शियम को इंटेस्टाइन ल्यूमन से लेकर के अपने अंदर ब्लड पे और टारगेट ऑर्गन्स पे ले जाता है. ठीक है, सो इसीलिए अगर विटामिन डी डेफिशिएंसी होगी तो कैल्शियम भी लो होगा. तो फिर मतलब कॉमन सेंस कहती है सीरम कैल्शियम फॉल करेगा, बट देन व्हाट हैपेंस इज, क्योंकि रिक्शा अपना काम नहीं कर रहा, बट देन व्हाट हैपेंस इज जैसे ही सीरम कैल्शियम फॉल करता है पीटीएच आपका इंक्रीज्ड हो जाता है, और इंक्रीज्ड पीटीएच क्या करता है, कहीं ना कहीं से कैल्शियम को लेके आएगा। अब वो कहीं ना कहीं किससे लेके आएगा, 3 तरीके से पीटीएच काम करता है। या तो वो विटामिन डी को बोलेगा जा तू लेके आ, अब इस केस में तो विटामिन डी अपनी सीट पे बैठा ही नहीं है, गायब है, डेफिशिएंट है। तो दूसरा तरीका पीटीएच बोलता है डोंट वरी, आई हैव 2 more things in my pocket, 2 more ways in which I can maintain a normal serum calcium level। और वो 2 more ways होते हैं कि या तो वो किडनी में कैल्शियम के एक्सक्रीशन को कम करवाएगा, तो उससे फिर सीरम कैल्शियम बढ़ने लग जाता है, या फिर वो कैल्शियम को खुरेद के खोद के लाता है, कहाँ से, बोन से। तो बोन्स आपकी हाइपो ओस्टियोपिनिक होने लग जाती है, समझ में आ गया आपको, ठीक है। तो इसलिए ओस्टियोपिनिया होने लग जाता है, डिक्रीज डेंसिटी ऑफ बोन्स होने लग जाती है, क्योंकि पीटीएच बोलता है मुझे बोन हेल्थ से कोई मतलब नहीं है, मुझे ये मतलब है चाहे बोन्स के कॉस्ट पे मुझे कैल्शियम लेवल नॉर्मल करना पड़े, मुझे सीरम कैल्शियम नॉर्मल करना है। तो सीरम कैल्शियम नॉर्मल है इस केस में बेटा, तो ये तो कहीं हमको नहीं ले जाता। व्हाट इज वेरी स्ट्राइकिंग इन दिस केस इज कि आपका फॉस्फेट एक तो क्या है, नॉर्मल है। दूसरी चीज आपको जो स्ट्राइक कर रही है कि जो कैल्शियम नॉर्मल यहाँ हुआ है वो पीटीएच के सौजन्य से नॉर्मल नहीं है, समझ रहे हैं आप, मतलब कैल्शियम तो वैसे ही नॉर्मल है, पीटीएच ने कोई ज्यादा काम किया नहीं है। तो मतलब ये तो पक्का है कि विटामिन डी डेफिशिएंसी रिकेट्स नहीं है ये, नहीं तो विटामिन डी डेफिशिएंसी रिकेट्स में पीटीएच आपका इंक्रीज होना चाहिए था, जैसे मैंने आपको अभी सारी पैथोफिजियोलॉजी समझाई। तो ये क्या चीज है, ठीक है। तो अगर फॉस्फेट इतना लो है, कैल्शियम नॉर्मल है, ठीक है, तो नेक्स्ट हमको दिमाग लगाना चाहिए कि और क्या फीचर्स दिए हुए हैं। देखा है कि द मदर ऑफ द अफेक्टेड पेशेंट्स मे हैव लेग डिफॉर्मिटीज एंड इट्स एन एक्स लिंक्ड डोमिनेंट कंडीशन। तो ये एग्जामिनर हमको खुद ही इस इस डायग्नोसिस की तरफ ले जा रहा है, एंड दिस व्हाट वी आर टॉकिंग अबाउट इज हाइपोफॉस्फेटेमिक रिकेट्स, ठीक है। अब हम आप बोलोगे मैम हाइपोफॉस्फेटेमिक तक पहुंचे कैसे, इसलिए पहुंचे बेटा क्योंकि विटामिन डी डेफिशिएंसी रिकेट्स नहीं है, वो हमने रूल आउट कर लिया। नेक्स्ट कैटेगरी होती है विटामिन डी डिपेंडेंट रिकेट्स वाली। तो विटामिन डी डिपेंडेंट रिकेट्स की हम यहाँ पे पॉसिबिलिटी इसलिए नहीं रखेंगे क्योंकि हमें एक और बहुत इंपॉर्टेंट क्लू मिला है, वो ये मिला है कि इस बच्चे को डेंटल एब्सेसेस भी हो रहे हैं। Dental abscesses is a hallmark feature of hypophosphatemic rickets, एक तो आपको ये पता होना चाहिए, ठीक है। दूसरी चीज स्पेसिफिकली सिर्फ लोअर लिम्ब डिफॉर्मिटीज है, हमने कोई रिस्ट वाइडनिंग नहीं बोली, हमने रैकेटिक रोजरी नहीं बोली, ऑल द मोर रीजन कि ये बच्चा एक टिपिकल रिकेट्स नहीं है। एंड विटामिन डी डिपेंडेंट रिकेट्स जो होता है वो यूजुअली आपके लोअर एज ग्रुप में प्रेजेंट करता है, मतलब फर्स्ट 6 months ऑफ लाइफ में। इनफैक्ट फर्स्ट 6 months ऑफ लाइफ में कोई भी बच्चा रिकेट्स करके आए बच्चों, आपने कुछ और नहीं सोचना, आपने स्पेसिफिकली विटामिन डी डिपेंडेंट रिकेट्स सोचना है। तो हमारा तो ये 8 साल का बच्चा है, तो डेफिनेटली ये विटामिन डी डिपेंडेंट रिकेट्स नहीं है, ठीक है। अब क्वेश्चन आता है कि और कौन सी रिकेट्स रह गई, तो और जो विटामिन डी डेफिशिएंसी के बाद नेक्स्ट विटामिन डी डिपेंडेंट रिकेट्स के बाद नेक्स्ट आती है हाइपोफॉस्फेटेमिक रिकेट्स, और हमें क्लूज मिल रहे हैं क्या, एक तो आपका फॉस्फेट लो है जो कि चीख के बोल रहा है कि फॉस्फेट देखो लो है, एंड सेकंड कि इस बच्चे को स्पेसिफिकली लोअर लिम्ब डिफॉर्मिटीज है एंड डेंटल एब्सेसेस है। तो उसकी पैथोफिजियोलॉजी समझ लेते हैं। सो यूजुअली देखो ऐसा आपको सिनेरियो मिलेगा कि मदर को भी देखिए लोअर लिम्ब डिफॉर्मिटीज है, यू कैन सी बोइंग ऑफ द लेग्स, एंड दोनों बच्चों को भी यही चीज है, ठीक है। एंड ये एक एक्स लिंक डोमिनेंट कंडीशन होती है जो कि हमारा फर्स्ट ऑप्शन था, जो कि करेक्ट ऑप्शन था, ठीक है। तो एक्स लिंक डोमिनेंट चीज होती है ये, एंड एक्स लिंक डोमिनेंट की वजह से तुम्हारे मेल्स में तो बहुत ज्यादा, इनफैक्ट मेल्स एंड फीमेल्स दोनों ही अफेक्टेड होंगे। अगर आप ये देखो तो इसमें मेल, एक ये मेल चाइल्ड है और ये फीमेल चाइल्ड, दोनों ही अफेक्टेड होते हैं, ठीक है। स्पेशली इफ द मदर इज अफेक्टेड, क्योंकि वो जो अपना एक्स क्रोमोसोम लड़के को देगी, मेल को देगी, वो डिफेक्टिव वाला एक्स क्रोमोसोम ही देगी। क्या डिफेक्ट होता है एक्स क्रोमोसोम पे वो देख लेते हैं। तो जो म्यूटेटेड जीन होता है हाइपोफॉस्फेटेमिक रिकेट्स में, उसका नाम होता है फेक्स जीन। आप यहाँ देख रहे हो ये फेक्स जीन लिखा हुआ, ये म्यूटेटेड होता है, इस पे क्रॉस लगा हुआ है क्योंकि ये म्यूटेटेड है। सो फेक्स जीन अगर हम फुल फॉर्म लिखें इसका, तो इसका फुल फॉर्म होता है फॉस्फेट रेगुलेटिंग जीन, ठीक है, विद, ठीक है, होमोलॉजी टू एन एंडोपेप्टिडेस ऑन क्रोमोसोम एक्स, ठीक है। तो इससे एक्स क्रोमोसोम में ये बेसिकली शॉर्ट में हम इसको फेक्स जीन कहते हैं, और इस फेक्स जीन का ये काम होता है कि इट प्रोड्यूसेस एंडोपेप्टिडेज। ठीक है, अगर मुझे लिखना पड़े हम ऐसे बोलेंगे कि नॉर्मली ये नॉर्मल फेक्स जीन है, ठीक है, जो कि एक्स क्रोमोसोम पे होता है। इट प्रोड्यूसेस एंडोपेप्टिडेज, और एंडोपेप्टिडेजेस का काम क्या होता है, ये FGF23 को क्लीव करता है। क्लीव करता है मतलब इनएक्टिवेट करता है। अब क्यों FGF23 को इनएक्टिवेशन जरूरी है, क्योंकि अगर FGF23 इनएक्टिवेट नहीं होगा तो आप देख सकते हो FGF23 फुल फॉर्म होता है फाइब्रोब्लास्ट ग्रोथ फैक्टर 23। एक तो 1 अल्फा हाइड्रोक्सिलेज को इनहिबिट करता है। इसका मतलब अगर 1 अल्फा हाइड्रोक्सिलेज किडनी में इनएक्टिवेट हो गया तो आपका एक्टिवेटेड फॉर्म ऑफ विटामिन डी के लेवल्स कम हो जाएंगे। इसका क्या मतलब हुआ फिर, तो FGF23 के दो प्रॉब्लम्स क्रिएट करता है FGF23। एक आपका डिक्रीज लेवल्स ऑफ एक्टिव फॉर्म ऑफ विटामिन डी, ठीक है, एंड दूसरा सबसे इंपॉर्टेंट, इट इंड्यूसेस द लॉस ऑफ फॉस्फेट इन द यूरिन। ठीक है, अब अगर हम वापस अपने इस पर जाएं तो आप ये नोटिस करोगे कि अगर फेक्स जीन की अब म्यूटेशन हो गई तो अब क्या होगा, एंडोपेप्टिडेज प्रोड्यूस नहीं होगा। एंडोपेप्टिडेज प्रोड्यूस नहीं होगा, एंडोपेप्टिडेज कम होगा, नहीं प्रोड्यूस होगा। उसकी वजह से क्या होगा, FGF23 के लेवल्स बढ़ जाते हैं, और बढ़ने की वजह से क्या फीचर्स आएंगे, जो कि हमने अभी ये देखे, ये दोनों फीचर्स आएंगे, एंड हेंस द चाइल्ड लैंड्स अप विद फीचर्स ऑफ रिकेट्स। इस फीचर्स ऑफ रिकेट्स की क्या खास बात होती है, एक तो मदर अफेक्टेड होती है, नंबर 1। नंबर 2, इसमें और क्या क्या खास बात होती है कि लोअर लिम्ब डिफॉर्मिटीज बड़ी कॉमन होती है। जेनुवेलगम हो सकता है, कॉक्सावेरा हो सकता है, जेनुवेरस हो सकता है, मतलब नॉक नीज, बो लेग्स, शॉर्ट स्टेचर होगा, एंड द चाइल्ड विल ऑल्सो हैव abnormalities of maxillofacial region and premature fusion of cranial sutures। इसके अलावा इन बच्चों में यूजुअली डेंटल abnormalities बड़ी कॉमन होती है, और डेंटल abnormalities के नाम पे हम क्या पढ़ेंगे, एक तो जैसे हमने देखा क्वेश्चन में दिया हुआ है हिस्ट्री ऑफ फ्रीक्वेंट डेंटल एब्सेसेस, एक ये कॉमन होता है, ठीक है, इन बच्चों में, और दूसरा इंट्राग्लोबुलर डेंटाइन होता है इन बच्चों में। तो ये डेंटल abnormalities कॉमन होती है इन चिल्ड्रन सफरिंग फ्रॉम X-linked hypophosphatemic rickets। ठीक है, सिम्टम्स ऑफ हाइपोकैल्सीमिया लाइक टेटनी या मसल वीकनेस आर कैरेक्टरिस्टिकली एब्सेंट। व्हाई, बिकॉज कैल्शियम का तो पंगा ही नहीं है, या तो पंगा ही सारा फॉस्फेट का हो रहा है। ठीक है, एंड चेंजेस ऑफ एक्टिव रिकेट्स इन स्पाइन हो गया या पेल्विस हो गया, ये सारी चीजें नहीं देखने को मिलेगी। आपको मेनली क्या प्रॉब्लम कहाँ की मिलेगी, एक तो मैक्सिलोफेशियल रीजन की प्रॉब्लम देखने को मिलती है, ठीक है, लोअर लिम्ब डिफॉर्मिटीज देखने को मिलती है, ठीक है, एंड डेंटल प्रॉब्लम्स देखने को मिलती है। तो जब आपको बच्चों इन तीनों चीजों का कॉम्बिनेशन आए तो आपको X-linked हाइपोफॉस्फेटेमिक रिकेट्स सोचनी है, स्पेशली अगर मदर भी इन्वॉल्व हो रही है। समझ गए, एंड ये मेल्स में ज्यादा कॉमन होता है एज कम्पेयर टू फीमेल्स। ऐसा नहीं कि फीमेल्स में नहीं हो सकती, बकायदा फीमेल्स में भी होगी, क्योंकि X-linked डोमिनेंट है। तो अगर फादर हमारा नॉर्मल भी है और उसने X क्रोमोसोम अपना डॉटर को दिया, ठीक है, तो भी क्योंकि X-linked डोमिनेंट है तो फीमेल में भी एग्जिबिट तो होगा फिनोटाइप एज वेल एज द जीनोटाइप। ठीक है, सो ये चीज हो गई। अब क्वेश्चन आता है कि लैब फीचर्स क्या होंगे, तो सीरम कैल्शियम से मोर और लेस नॉर्मल होता है, पीटीएच भी नॉर्मल होगा, फॉस्फेट ग्रेटली डिक्रीज होता है जो कि हमने देखा, एएलपी इंक्रीज होगा, एंड जो एक्टिव फॉर्म ऑफ विटामिन डी होता है, क्या होता है एक्टिव फॉर्म ऑफ विटामिन डी, अगर हम देखें 125 डाईहाइड्रोक्सी विटामिन D3, ये आपका ऑब्वियसली डिक्रीज होगा। क्यों डिक्रीज होगा, क्योंकि 1 अल्फा हाइड्रोक्सिलेज की जो एक्टिविटी किडनी में होती है जिसकी वजह से ये बनता है, उसको किसने निस्ता नाबूद किया हुआ है, FGF23 ने। समझ में आ गया। तो अगर हम अपना वो वाला ऑप्शंस देखें तो उस ऑप्शन में उल्टा लिखा हुआ था कि क्योंकि अगर हम वापस वो ऑप्शन को, द जीन डिफेक्टिव इन दिस कंडीशन कॉजेज एन इंक्रीज्ड लेवल ऑफ एंडोपेप्टिडेज, तो ये गलत है, इंक्रीज्ड लेवल नहीं, डिफेक्टिव है तो डिक्रीज्ड लेवल आना चाहिए था, और डिक्रीज लेवल की वजह से इंक्रीज इन FGF23 हो जाता है, एंड दिस इंक्रीज इन FGF23 इनहिबिट्स द रीनल 1 अल्फा हाइड्रोक्सिलेज। समझ में आ गया। ठीक है, ट्रीटमेंट क्या करेंगे, ट्रीटमेंट हम इसको ओरल फॉस्फेट देना होता है अराउंड 30 to 50 mg पर kg, साथ में विटामिन डी सप्लीमेंट। और टिपिकली इन बच्चों में विटामिन डी सप्लीमेंट कौन सा चलेगा, आपको पता है, आपको 1 अल्फा हाइड्रोक्सिलेटेड विटामिन डी देना पड़ेगा, उसको हम अल्फा कैल्सीडोल के नाम से जानते हैं। तो इसका मतलब मैं 1 अल्फा हाइड्रोक्सिलेज विटामिन डी दूंगी, ठीक है। अज्यूमिंग कि मेरे बच्चे का लिवर सही है, तो अंदर जाके लिवर में वो 125 अल्फा हाइड्रोक्सिलेज विटामिन डी हो जाएगा, जो कि एक्टिव फॉर्म ऑफ विटामिन डी है और अपना काम करेगा। तो विटामिन डी भी सप्लीमेंटेशन करना है, पर किस फॉर्म में, 1 अल्फा हाइड्रोक्सिलेज विटामिन डी के फॉर्म में। और हमने क्या ट्रीटमेंट करना है, इसके अलावा हमने इसको जूली सॉल्यूशन देना पड़ेगा, जो कि आपको पता है फॉस्फेट रिच सॉल्यूशन होता है। टारगेट सीरम लेवल हमारा होता है अराउंड 3.0 टू 3.2 मिलीग्राम पर डेसीलीटर, ठीक है। अराउंड 30 टू 40 mg पर kg पर डे के हिसाब से हम इसमें फॉस्फेट सप्लीमेंट करते रहेंगे, ठीक है। एंड प्लस विटामिन डी देंगे, जो कि अल्फा कैल्सीडोल होगा, ठीक है। तो ये खास बात होती है आपकी हाइपोफॉस्फेटेमिक रिकेट्स की। क्लियर? चलो अब लेट अस मूव ऑन टू द नेक्स्ट क्वेश्चन। नेक्स्ट क्वेश्चन क्या था हमारा, अ न्यूनेट हु हैज बीन एक्टिव and sucking normally now refuses to feed, becomes lethargic and unresponsive within 48 hours of birth. The pediatrician suspects neonatal sepsis and orders a sepsis screen panel to rule out the same. Which out of the following components are not included under the same? तो एब्सोल्यूट ANC है, एब्सोल्यूट न्यूट्रोफिल काउंट है, या माइक्रो ESR है, या IT रेशियो है, या लंबर पंक्चर फॉर CSF स्टडी है। तो बच्चों ये हमसे क्या पूछ रहे हैं, ये हमसे पूछ रहे हैं कि बताइए कौन सा इन्वेस्टिगेशन सेप्टिक स्क्रीन या सेप्सिस स्क्रीन जिसे हम कहते हैं, ठीक है, उसमें इंक्लूड किया जाता है कि जब भी बच्चा किसी न्यूनेट में सस्पेक्टेड सेप्सिस के साथ आता है, या ठीक है, तो फिर हमें ऑर्डर करना होता है सेप्सिस स्क्रीन। सेप्सिस स्क्रीन का मतलब है कुछ सेट ऑफ 5 इन्वेस्टिगेशंस। तो कौन सी 5 इन्वेस्टिगेशंस होती है, एक तो हम उसमें TLC देखते हैं, सेकंड उसमें ANC देखते हैं, थर्ड उसमें IT रेशियो देखते हैं, ठीक है, फोर्थ उसमें माइक्रो ESR देखते हैं, एंड फिफ्थ उसमें CRP देखते हैं। ये होता है हमारा ऑलवेज रिमेंबर सेप्सिस स्क्रीन। अब इसमें से कई लोग बोलेंगे कि मैम लंबर पंक्चर नहीं सोचेंगे, ठीक है, क्या, व्हाट अबाउट लंबर पंक्चर, व्हाट अबाउट चेस्ट एक्सरे, ठीक है, व्हाट अबाउट एनी अदर इन्वेस्टिगेशन, जैसे कि हम गैस्ट्रिक एस्पिरेट भी कभी कभी उसको भी एनालाइज करते हैं, ठीक है। तो क्या ये नहीं इंक्लूड किया जाता है सेप्सिस स्क्रीन में? बिल्कुल नहीं। सेप्सिस स्क्रीन का मतलब है ये 5 बेसिक इन्वेस्टिगेशंस। तो आपसे ये पूछा गया था कि विच ऑफ द फॉलोइंग कंपोनेंट इज नॉट इंक्लूडेड अंडर द सेप्सिस स्क्रीन पैनल। तो आपको पता है ये इंक्लूड होता है, ये भी इंक्लूड होता है, ये भी इंक्लूड होता है। जो नहीं इंक्लूड होता है वो होता है लंबर पंक्चर फॉर द CSF स्टडी। वो हम रेगुलरली हर सेप्सिस वाले बच्चे में नहीं करेंगे, न्यूनेट में नहीं करेंगे, ओनली जब हमें मेनिंजाइटिस का सस्पेशन होगा तभी ये करते हैं। समझ में आ गया? तो इसका आंसर हमारा हो जाएगा डी। डी इज द करेक्ट आंसर इन दिस केस, ठीक है। एंड सेप्सिस स्क्रीन हम कब पॉजिटिव बोलते हैं? जब इन 5 में से कोई भी एनी 2, ठीक है, 2 या मोर देन 2 अगर पॉजिटिव आ रहे हैं पैरामीटर्स, तब हम बोलेंगे इस बच्चे का सेप्सिस स्क्रीन पॉजिटिव है, ठीक है। ओके, फिर नेक्स्ट क्वेश्चन देखते हैं। ड्यूरिंग अ पीडियाट्रिक्स वाइवा अ स्टूडेंट वाज गिवन 4 स्टेटमेंट्स रिगार्डिंग फीडिंग प्रिंसिपल्स इन लो बर्थ वेट बेबीज बाय द एग्जामिनर, आउट ऑफ व्हिच ही वाज आस्क्ड टू सिलेक्ट द रॉन्ग वन। Which of the following statements would have been chosen by the student that the examiner was satisfied with the answer? तो basically हमने wrong statement choose करना है। मोटा मोटा ये निकल गया है क्वेश्चन में से, ठीक है। तो देखते हैं, coordination between sucking, swallowing and breathing fully matures by 37 to 38 weeks. For preterm born between 28 to 31 weeks, IV fluids are the initial feeding method. Babies with birth weight more than 1500 grams, initial fluid therapy should be 60 ml per kg per day if required, and iron supplementation to be started after 4 weeks of life. तो इसमें काफ़ी कुछ हमने चीज़ें ली हैं फ्रॉम हाउ टू फीड द लो बर्थ वेट बेबीज, ठीक है। बेसिकली उसके बेसिस पे ये क्वेश्चन बनाया गया है। तो कुछ कुछ फंडे आपको पता होने चाहिए, तो हम बता देते हैं आपको, ठीक है। इसमें क्या आपको कंसेप्ट होना चाहिए। तो वी शुड नो कि हम अगर बेबीज मोर देन 1500 ग्राम्स देखें, ठीक है, एंड बेबीज लेस देन 1500 ग्राम्स देखें, तो दोनों में क्या डिफरेंस होता है? दोनों में ये डिफरेंस होता है कि सबसे पहले इसमें आप इनिशियल फ्लूइड थेरेपी को चालू करोगे अराउंड 60 ml पर kg पर डे से, ठीक है, और यहाँ पे आप शुरू करते हो 80 ml पर kg पर डे से, ठीक है। तो ये इतने आपका ये फ्लूइड थेरेपी होता है। वो फ्लूइड का क्या मतलब है, वो आपका एनजी फीड को भी हम रेफर कर सकते हैं, वो हम आईवी फ्लूइड को भी रेफर कर सकते हैं। आईवी फ्लूइड अगर मैंने देना है तो इस हिसाब से दूंगी, और अगर मैंने एनजी फीड में मिल्क देना है तो भी मैं इन दोनों के हिसाब से दूंगी, मतलब डिपेंडिंग ऑन कि मेरे बेबी का वेट मोर देन 1500 है कि लेस देन 1500। सेकेंडली, फर्स्ट 2 डेज के लिए ऑलवेज रिमेंबर बच्चों, ये दोनों में सिमिलर है, हम सिर्फ और सिर्फ 10% डेक्सट्रोज ही चालू करते हैं, ठीक है। दोनों केसेस में 10% डेक्सट्रोज इज द आइडियल फ्लूइड, ठीक है, जो कि फर्स्ट 2 डेज में हम चालू करते हैं। जो सोडियम एंड पोटेशियम है दैट इज इंक्लूडेड, ये भी दोनों में कॉमन चीज होगी, दैट इज इंक्लूडेड इन द फ्लूइड्स, ठीक है, ओनली आफ्टर 48 आवर्स, ठीक है। तो ओनली आफ्टर 48 आवर्स हम सोडियम एंड पोटेशियम इंक्लूड करेंगे। ये भी यहाँ पे भी सेम चीज आएगी, जो कि लेस देन 1500 में कर रहे हैं या मोर देन 1500 में, ये कॉन्सेप्ट दोनों में सिमिलर होगा, ठीक है। और क्या चीज इसमें देखी जाती है कि धीरे धीरे विद द सब्सिक्वेंट डेज, जैसे जैसे दिन बीते जाते हैं, हम अराउंड 15 to 20 ml पर kg पर डे इंक्रीमेंट करते हैं। इधर भी हम इतना ही इंक्रीमेंट कर देते हैं, सो दैट फाइनल तक आते आते, फाइनल का मतलब है अराउंड 7th डे तक आते आते दोनों 150 ml पर kg पर डे तक पहुंच जाए, चाहे वो लेस देन 1500 वाले हों चाहे मोर देन 1500 वाले हों, ठीक है। तो ये तो एक फंडा जो कि हमको पता होना चाहिए। उसके अलावा अगर हम इसको ये देखें कि हम फ्लूइड कौन सा चालू करेंगे, ठीक है, एक हमारा ऑप्शन ये भी था कि हम फ्लूइड कौन सा चालू करेंगे, आईवी फ्लूइड चालू करेंगे, क्या करेंगे। तो दैट ऑल डिपेंड्स अपॉन कि ओरल फीडिंग स्किल्स का मैच्योरेशन कैसे होता है और कब होता है। तो अगर लेस देन 28 वीक्स के बच्चों को देखो तो यहाँ पे बिकॉज इनएडिक्वेट सकिंग एफर्ट है एंड कोई प्रोपल्सिव गट मोटिलिटी नहीं है, तो ऐसे बच्चे में अगर आपने फीड दे दिया, चाहे एनजी से दिया, एनजी का मतलब नेजोगैस्ट्रिक या ओरोगैस्ट्रिक, यूजुअली हम ओजी फीड्स देते हैं, एनजी कम यूज करते हैं, तो ओजी फीड्स देते हैं, ठीक है, ओरोगैस्ट्रिक फीड देते हैं। तो अगर आपने ओजी फीड दे दिया तो ये तो इस बच्चे को एनईसीए हो जाएगा, नेक्रोटाइजिंग एंट्रोकोलाइटिस हो जाएगा, क्योंकि प्रोपल्सिव गट एक्ट मोटिलिटी ही नहीं है। तो इसीलिए ऐसे में क्या करते हैं, लेस देन 28 वीक्स में हम आईवी फ्लूइड्स को प्रेफर करते हैं। फिर 28 to 31 वीक्स अगर हम देखें तो सकिंग बर्स्ट डेवलप, देयर इज लैक ऑफ कोऑर्डिनेशन बिटवीन सक, स्वॉलो एंड ब्रीदिंग, ठीक है। तो इस वजह से क्या होता है कि हम लोग सीधा पैलेडे फीड या ब्रेस्ट फीड ट्राई नहीं कर सकते, क्योंकि आपको पता है पैलेडे फीड में भी अल्टीमेटली बच्चे को सक, खुद की सक अच्छी होनी चाहिए। तो इसलिए अब हम क्या करेंगे, ओरोगैस्ट्रिक या नेजोगैस्ट्रिक फीडिंग करेंगे। एंड ऑफ कोर्स जैसे जैसे बच्चा टूवर्ड्स 31 वीक्स बढ़ रहा है या टूवर्ड्स 31 वीक्स के करीब आ गया है, देन वी गिव ओकेशनल स्पून या पैलेडे फीडिंग का ट्रायल देते हैं कि बच्चा एक्सेप्ट कर रहा है कि नहीं एक्सेप्ट कर रहा है, क्योंकि नेक्स्ट स्टेज हमारी ये है कि 32 to 34 वीक्स के बीच हमने फीडिंग बाय स्पून या पैलेडे करवानी है, समझ गए, क्योंकि इसमें स्लाइटली मैच्योर सकिंग पैटर्न आ जाता है। एंड फाइनली मोर देन 34 वीक्स ऑफ जेस्टेशन में मैच्योर सकिंग पैटर्न आ जाता है, वेयर यू हैव द कोऑर्डिनेशन बिटवीन ब्रीदिंग एंड सकिंग वेरी वेल डेवलप्ड, और ऐसे बच्चे में आप ब्रेस्ट फीडिंग चालू कर सकते हो। तो वेरी इंपॉर्टेंटली अगर हमें याद करना हो तो हम ऐसे याद करते हैं, लेस देन 28 वीक्स IV fluids, 28 to 31 weeks is your orogastric या nasogastric feeding, 32 to 34 weeks is feeding by spoon or palate, and more than 34 weeks, याद कर लो बच्चों, it is more or less breastfeeding। समझ में आ गया? तो एक ऑप्शन हमारा इससे रिलेटेड भी था, ठीक है। ओके, सो लेट अस कम बैक टू द क्वेश्चन। तो क्वेश्चन हमारा ये है कि कोऑर्डिनेशन बिटवीन सकिंग, swallowing एंड ब्रीदिंग फुली मैच्योर्स बाय 37 to 38 वीक्स। तो हमें रॉन्ग आंसर ढूंढना था, तो ये तो करेक्ट आंसर है। फिर फॉर प्रीटर्म्स born between 28 to 31 weeks, IV fluids are the initial feeding method। हमने क्या याद किया है कि लेस देन 28 वीक्स में IV fluids चलते हैं, 28 to 31 में तो क्या चलेगा, 28 to 31 में हम क्या देंगे बताइए, डू वी गिव IV fluids? नो। 28 to 31 में हम NG फीड करेंगे या ओरोगैस्ट्रिक फीडिंग करेंगे, तो ये हमें रॉन्ग लग रहा है, ठीक है। पर हम आगे भी देख लेते हैं। बेबीज विद बर्थ वेट मोर देन 1500 ग्राम्स, इनिशियल फ्लूइड थेरेपी 60 ml पर kg आपको बताया था, एंड लेस देन 1500 ग्राम्स में इनिशियल फ्लूइड थेरेपी 80 ml पर kg पर डे। अब ये हम कैसे याद रखेंगे? इसको याद रखने का एक तरीका है बच्चों कि लेस देन 1500 ग्राम्स का ना इनसेंसिबल वाटर लॉसेस काफी ज्यादा होते हैं, और इनसेंसिबल वाटर लॉसेस ज्यादा होने की वजह से हमें फ्लूइड इनिशियली ज्यादा शुरू करना पड़ता है। समझ में आ गया? आयरन सप्लीमेंटेशन टू बी स्टार्टेड आफ्टर 4 वीक्स ऑफ लाइफ, उससे पहले शुरू नहीं करते, ठीक है। तो ये एक रूल है जो हमको पता होना चाहिए, क्योंकि इनिशियली अगर आपने राइट फ्रॉम डे 1 आयरन सप्लीमेंटेशन चालू कर दिया तो कभी कभी आयरन इंड्यूस्ड फ्री रेडिकल इंजरी होने के चांसेस बढ़ जाते हैं, ठीक है। तो इसीलिए हम आयरन सप्लीमेंटेशन इन द इनिशियल वीक्स नहीं करते, ओनली आफ्टर 1 मंथ ऑफ लाइफ या आफ्टर 4 वीक्स ऑफ लाइफ चालू करते हैं। तो ये भी करेक्ट स्टेटमेंट हो गया, ठीक है। तो हमारा रॉन्ग स्टेटमेंट क्या हुआ, द बी ऑप्शन, दिस इज द रॉन्ग स्टेटमेंट एंड हेंस दिस इज द आंसर ओवर हियर, ठीक है। चलो नेक्स्ट देखते हैं अब। अ मदर ब्रिंग्स हर इन्फेंट टू पीडियाट्रिक ओपीडी फॉर डेवलपमेंटल असेसमेंट, शी वांट्स टू नो एट कॉरेस्पॉन्डिंग एजेस व्हिच सोशल माइलस्टोन्स अपीयर, मैच द फॉलोइंग सोशल माइलस्टोन विद द कॉरेस्पॉन्डिंग एजेस एंड चूज द मोस्ट अप्रोप्रिएट ऑप्शन। बहुत ही सिंपल क्वेश्चन आया था, सारे ऐसे माइलस्टोन्स आए थे जो कि आपको अच्छे से पढ़ाए भी गए हैं। तो देख लेते हैं, वेव्स बाय बाय। तो वेव्स बाय बाय कब होता है बच्चों? यस हमको पता है, ये तो 9 मंथ्स पे हो जाता है, ठीक है। हैज वोकैबुलरी ऑफ 100 वर्ड्स, हमको पता है कब वोकैबुलरी 100 वर्ड्स की होती है, 2 ईयर्स पे होती है। एट 1 ईयर 2 to 3 वर्ड्स की वोकैबुलरी होती है, एट 18 मंथ्स 8 to 10 वर्ड्स की होती है। कैसे याद करेंगे हम? 1 ईयर पे आप याद करो 2 से 3 वर्ड्स की वोकैबुलरी, एंड 18 मंथ्स पे आप याद करो, क्योंकि 8 है यहाँ पे तो 8 से 10 वर्ड्स की वोकैबुलरी, एंड 2 ईयर्स पे 100 वर्ड्स की वोकैबुलरी होती है। एक तो ये चीज, और साथ में 2 to 3 वर्ड सेंटेंस बोलने लग जाता है बच्चा, ठीक है। स्ट्रेंजर एंजाइटी कब आती है? ये 6 to 7 मंथ्स पे आती है। एंड कॉपीज पेरेंट इन टास्क, तो फॉलोज मदर इन हाउस होल्ड, इमिटेट्स मदर इन हाउस होल्ड चोर्स, या फिर हम जिसे कहते हैं डोमेस्टिक मिमिक्री भी कहते हैं इसको। तो हो सकता है आपसे कभी डोमेस्टिक मिमिक्री पूछ ली जाए। तो कॉपीज पेरेंट्स इन टास्क ये होता है 18 मंथ्स पे, तो इसलिए हमारा करेक्ट आंसर कौन सा हो गया? सी ऑप्शन। देखो फर्स्ट का हमारा बी है, 2 का डी है, ठीक है, एंड देन 3 का ए जा रहा है, एंड 4th का सी है। तो हमारा ऑप्शन करेक्ट हो गया ये वाला। समझ में आ गया, ठीक है। चले आगे, चलो फिर नेक्स्ट इज 1.5 month old baby presents to pediatric emergency with respiratory distress and central cyanosis. The examining pediatrician immediately orders an ECG which reveals supraventricular tachycardia and X-ray which reveals the findings given below. Which of the following statement is incorrect with respect to the diagnosis? ठीक है, तो ये हमारा X-ray भी दिख गया हमको। Atrialization of the right ventricle occurs in this disease. Degree of cyanosis is directly proportional to the severity of displacement of the tricuspid valve. On auscultation, S2 is single and loud, and newborns with severe disease may require PG even infusion because of the inability of the right ventricle to function effectively. ठीक है, तो हम क्या किससे डील कर रहे हैं बच्चों? आपको पता है साइनोसिस है बच्चे को, वेरी इंपॉर्टेंटली साइनोसिस है बच्चे को। और जब आप एक ECG पे आपको क्लू मिल रहा है कि इसको सुप्रावेंट्रिकुलर टैकीकार्डिया हो रहा है, तो एक साइनोटिक हार्ट डिजीज होती है जिसमें कि SVT भी हो सकता है, WPW सिंड्रोम भी हो सकता है, राइट बंडल ब्रांच ब्लॉक भी हो सकता है। हमने बड़े अच्छे से पढ़ी है ये डिजीज, और ये साइनोटिक हार्ट डिजीज होती है एब्स्टीन्स एनामली। तो ये क्लू है आपका एब्स्टीन्स एनामली के लिए। एक तो साइनोटिक हार्ट डिजीज है और साथ में SVT हो रहा है, और तीसरा क्लू है लुक एट द चेस्ट एक्सरे। एक्सरे दिस इज अ क्लासिक बॉक्स शेप्ड कार्डियोमेगाली, ठीक है, ये बॉक्स शेप्ड कार्डियोमेगाली हो रही है आपकी, ठीक है। तो फिर इससे आपको पता पड़ जाता है ये एब्स्टीन्स एनामली है। अब एट्रिलाइजेशन ऑफ द राइट वेंट्रिकल होता है, हाँ जी बिल्कुल होता है। अगर हम देखें इसका चित्र देखें तो हमको ये बताया गया है कि जो राइट एट्रियम है, यू कैन सी वेरी वेल, ठीक है, आपका इतना एनलार्ज्ड क्यों हुआ हुआ है? इसलिए एनलार्ज्ड हुआ हुआ है क्योंकि पार्ट ऑफ द राइट वेंट्रिकल है वो आपके राइट एट्रियम में जाके मिला हुआ है, जिसे हम कहते हैं एट्रिलाइजेशन ऑफ द राइट वेंट्रिकल, ठीक है। तो ये चीज होती है। नेक्स्ट हमारा ऑप्शन क्या था इसमें? था द डिग्री ऑफ साइनोसिस इज डायरेक्टली प्रोपोर्शनल टू द सिवियरिटी ऑफ द डिस्प्लेसमेंट ऑफ ट्राइकस्पिड वाल्व। तो इसको आपको पता है कि ट्राइकस्पिड वाल्व नीचे प्रोलैप्स हो जाता है, लीफलेट्स जाकर के स्पेशली द पोस्टीरियर एंड द सेप्टल लीफलेट जाकर के आपकी वॉल ऑफ द राइट वेंट्रिकल में अटैच हो जाती है, ठीक है। ये हमने पढ़ा था एब्सिंस एनामली में। एंड जो भी राइट वेंट्रिकल उस अटैचमेंट के लेवल से ऊपर होता है वो तो एट्रिया में जाके मिल जाता है, एंड हेंस एट्रिलाइजेशन ऑफ द राइट वेंट्रिकल। और जो राइट वेंट्रिकल उसके नीचे बचता है वो ही इफेक्टिव राइट वेंट्रिकल होता है। और जितना ज्यादा डिस्प्लेसमेंट होगा ट्राइकस्पिड वाल्व का, उतना ज्यादा आपको देखने को मिलेगा TR एंड TS, ठीक है। स्टेनोसिस भी होगा और रिगर्जिटेशन भी होगा, और उसकी वजह से क्या होता है कि बिकॉज ऑफ दिस राइट वेंट्रिकुलर फिलिंग इतना अच्छे से नहीं हो पाती, एंड हेंस हमारी कौन सी ब्लड सप्लाई कॉम्प्रोमाइज होगी? यस, यू गेस्ड इट राइट, पल्मोनरी ब्लड सप्लाई कॉम्प्रोमाइज हो हो जाती है एंड हेंस द डिग्री ऑफ साइनोसिस इंक्रीजेस, क्योंकि आपको पता है कि मोर और लेस इसका मतलब हमारा ब्लड राइट एट्रियम है जो कि इतना बड़ा मैसिवली डायलेट हो गया है, अब ये तो नीचे तो वेंट्रिकल में फेंक ही नहीं पा रहा ब्लड, और इसकी क्योंकि क्या है टीआर और टीएस है, और टीआर और टीएस किस लिए, क्योंकि आपका ट्राइकस्पिड वाल्व प्रोलैप्स कर गया है, तो ये ब्लड अब कहाँ जाएगा, ये ब्लड जाएगा आपका लेफ्ट साइड में, और जब लेफ्ट साइड में ब्लड आएगा तो डेफिनेटली बच्चे को साइनोसिस होगा, क्योंकि तो आपको ये पता है कि लेफ्ट साइड ऑफ द हार्ट वाला ब्लड अल्टीमेटली सिस्टमिक सर्कुलेशन में जाता है। समझ में आ गया? तो ये टीआर और टीएस आपको देखने को मिलेंगे एंड हेंस इट इज डायरेक्टली प्रोपोर्शनल, द साइनोसिस इज डायरेक्टली प्रोपोर्शनल टू द सिवियरिटी ऑफ डिस्प्लेसमेंट ऑफ ट्राइकस्पिड वाल्व। ऑन ऑस्कल्टेशन इसमें एक खास बात क्या देखने को मिलती है, अपार्ट फ्रॉम द अरिथमियाज ऑन ईसीजी, ऑस्कल्टेशन पे आपको सुनाई देगा टीआर और टीएस का तो मरमर सुनाई देता है, एक आपको स्क्रैची साउंड भी सुनाई देती है। मैं बता दूं ये क्योंकि पहले आपके किसी क्वेश्चन में किसी एम्स के एंट्रेंस एग्जाम में, जब एम्स का एंट्रेंस एग्जाम अलग होता था, वहां पे ये क्वेश्चन आया हुआ है कि आपको एक स्क्रैची साउंड सी सुनाई देती है, ठीक है, एंड विच रिजेंबल्स, इट रिजेंबल्स पेरिकार्डियल फ्रिक्शन रब, पर होता नहीं है इसमें कोई पेरिकार्डाइटिस या पेरिकार्डियल फ्रिक्शन रब सुनाई देता है, ठीक है, जो कि उसके जैसा सुनाई देगा, बट वो एक्चुअली टीआर और टीएस का मरमर कंबाइंड होता है, दैट इज इट। एक और चीज जो ऑस्कल्टेशन में क्लासिक इसमें सुनाई देती है वो होता है S2 इज वाइड एंड वेरिएबली स्प्लिट, वेरिएबली स्प्लिट, तो वाइड एंड वेरिएबल स्प्लिटिंग ऑफ S2 होती है, और हमारे ऑप्शन में तो लिखा हुआ था S2 इज सिंगल एंड लाउड, तो ये हमारा गलत ऑप्शन हो गया क्योंकि हमसे इनकरेक्ट पूछा गया था। फोर्थ ऑप्शन हमारा था न्यूबॉर्न्स विद सीवियर डिजीज विल रिक्वायर PG1, आई डोंट नीड टू टेल यू, क्योंकि अभी मैंने आपको बताया है कि पल्मोनरी आर्टरी का सर्कुलेशन कॉम्प्रोमाइज्ड होता है, क्योंकि सारा का सारा ब्लड राइट साइड का राइट एट्रियम में ही जमा हो रहा है एंड पल्मोनरी सर्कुलेशन में हार्डली एनी ब्लड जा रहा है। तो आप क्या चाहोगे, आप चाहोगे कि जो डक्टस आर्टरियोसिस है विच इज अ कम्युनिकेशन बिटवीन द एओर्टा एंड द पल्मोनरी आर्टरी वो बंद ना हो, ताकि डक्टस के जरिए ही हम पल्मोनरी आर्टरी में थोड़ा ब्लड डाल पाएं एंड वो ब्लड डेफिनेटली लंग्स की तरफ जाएगा, ऑक्सीजनेट होके आएगा और वो आएगा लेफ्ट साइड ऑफ द हार्ट में। लेफ्ट साइड ऑफ द हार्ट में पहले ही राइट साइडेड डीऑक्सीजनेटेड ब्लड आ रहा है, और अगर हम प्रपोर्शन ऑफ ऑक्सीजनेटेड ब्लड बढ़ा दें लेफ्ट साइड ऑफ द हार्ट में तो बच्चे को थोड़ा बहुत राहत मिलेगा। तो इसलिए जब सीवियर एब्स्टीन्स होता है, सीवियर एब्स्टीन्स का मतलब बच्चा बड़ा साइनोस्ड है एंड न्यूबॉर्न पीरियड में प्रेजेंट कर रहा है, ये तो हमारा 1.5 महीने पे प्रेजेंट किया था, पर अगर न्यूबॉर्न पीरियड में बच्चा प्रेजेंट कर रहा है, स्टार्टिंग PGE1 इज बेनिफिशियल बिकॉज एब्स्टीन्स एनेबली इज एन एग्जांपल ऑफ डक्टल डिपेंडेंट पल्मोनरी सर्कुलेशन। ठीक है, तो फोर्थ ऑप्शन भी सही था। तो अगर हम अपना वापस उस इस पे जाएं, हमारे क्या कहते हैं क्वेश्चन में जाएं, तो हमें क्या देखने को मिलता है बच्चों कि ये वाला जो ऑप्शन है ये गलत है स्टेटमेंट, क्योंकि S2 इज वाइड एंड वेरिएबली स्प्लिट, हेंस हमारा आंसर हो गया C ऑप्शन। समझ में आ गया? ठीक है, चले आगे। ओके, सो नेक्स्ट क्वेश्चन देखते हैं हमारा। A 1-month-old infant is brought to pediatrics OPD with a hoarse cry and prolonged jaundice and constipation. Along with findings shown in the image given below, which of the following statement is true about the following condition? Open posterior fontanelle is a key indicator of this condition. It is the most common preventable cause of mental retardation. History of maternal thyroid illness or anti-thyroid drug use should be investigated. All of the above are correct. ठीक है, तो ट्रू पूछा है हमसे बच्चों इन्होंने, और आपको जो फिगर दिखाया हुआ है उसमें आपको पता लग रहा है एक बहुत ही लिथार्जिक लुकिंग बेबी है, वेरी इंपॉर्टेंटली प्रोट्रूबेंट अब्डोमेन हमको पता पड़ रहा है, एंड अगर आप ढंग से देखो तो आपको ये भी चीज समझ आ जाएगी कि इस बच्चे को अम्बिलिकल हर्निया भी है। ठीक है, एंड बच्चा थोड़ा हाइपोटोनिक भी लग रहा है हमको। ठीक है, तो ये सारी चीजों का जब आपको अलोंग विद डेफिनेटली व्हाट इज गिवन इन द क्वेश्चन कि भाई होर्स क्राई है, प्रोलॉन्ग जॉन्डिस है, कॉन्स्टिपेशन है, तो इन सब चीजों को मिला करके हमारा एक ही डायग्नोसिस बनना चाहिए एंड दैट इज कंजेनाइटल हाइपोथायरॉयडिज्म। ठीक है, अगर हम कंजेनाइटल हाइपोथायरॉयडिज्म की बात करें तो इसमें हमको ये पता होना चाहिए द कॉमनेस्ट कॉज ऑफ कंजेनाइटल हाइपोथायरॉयडिज्म इज थायराइड डिसजेनेसिस। ठीक है, 85% केसेस इसकी वजह से होते हैं। ठीक है, बाकी जो 10% केसेस होते हैं वो इनबॉर्न एरर ऑफ थायरॉक्सिन मेटाबॉलिज्म, दैट मीन्स थायरॉक्सिन सिंथेसिस के पाथवे में कोई ना कोई एंजाइमेटिक डिफेक्ट है उसकी वजह से होता है। ठीक है, एंड देन 5% केसेस होते हैं मेटर्नल थायरोट्रोपिन रिसेप्टर ब्लॉकिंग एंटीबॉडी की वजह से। ठीक है, थायरोट्रोपिन रिसेप्टर ब्लॉकिंग एंटीबॉडी की वजह से, ये होते हैं आपके रिमाइंडर 5% केसेस, राइट। अब ये मैटरनल थायरोट्रोपिक रिसेप्टर ब्लॉकिंग जो एंटीबॉडी होती है, यूजुअली कब हमें सस्पेक्ट करना चाहिए? तब सस्पेक्ट करना चाहिए जब मैटरनल ग्रेव्स डिजीज है, ठीक है, तो मदर को ग्रेव्स डिजीज है तो उसमें ये एंटीबॉडी आपको देखने को मिलेगी, या फिर इसी मदर के जो प्रीवियस बच्चे हैं उनमें भी कंजेनिटल हाइपोथायराइडिज्म हुआ है पर ट्रांजिएंटली हुआ है, सो दैट इज वी कैन राइट ट्रांजिएंट कंजेनिटल हाइपोथायराइडिज्म in the siblings of this child, in the previous siblings of this child. ठीक है, तो इसका मतलब है कि कोई चीज ऐसी आती है इन बच्चों के अंदर जो कि थोड़े समय तक रहती है, हाइपोथायराइडिज्म करवाती है और फिर चली जाती है। तो ऐसी क्या चीज आएगी? डेफिनेटली वो कहाँ से आएगी? मदर से आएगी। थोड़े समय तक रहने का मतलब है एंटीबॉडी जिंदगी भर तो रहेगी नहीं, अगर पैसिवली ट्रांसफर्ड है तो वो फिर थोड़े समय तक, जब तक एंटीबॉडी रहेगी सर्कुलेशन में, तब तक वो TSH का रिसेप्टर ब्लॉक करेगी एंड हेंस बच्चे को हाइपोथायराइडिज्म के फीचर्स आएंगे। समझ गए? तो ये सारे कॉजेज होते हैं आपके कंजेनिटल हाइपोथायराइडिज्म के। एक और बहुत इंपॉर्टेंट कॉज, ये तो देखो कॉमनेस्ट कॉजेज हमने बता दिए और पूरा 100% कर दिया। इसके अलावा मैटरनल ड्रग इनटेक इज आल्सो अ वेरी इंपॉर्टेंट कॉज। ठीक है, कि मैटरनल जैसे मेडिकेशंस, समझ लो मदर प्रीनेटल एक्सपोज टू आयोडीन एंटीसेप्टिक व्हाइल पेंटिंग द एब्डोमेन ड्यूरिंग सिजेरियन सेक्शन, इवन दैट कैन कॉज कंजेनिटल हाइपोथायराइडिज्म। अगर लैक्टेटिंग मदर है और वो अगर न्यूट्रिशन सप्लीमेंट के नाम पे खूब ज्यादा आयोडीन रिच सप्लीमेंट्स ले रही है या फिर सीवीड खा रही है, आपको पता है सीवीड इज वेरी रिच इन आयोडीन, सो इवन दैट कैन कॉज कंजेनिटल हाइपोथायराइडिज्म। या फिर मदर ने एंटीनेटली इन द इनिशियल पार्ट ऑफ हर प्रेगनेंसी व्हेन शी वाज आल्सो नॉट अवेयर ऑफ द प्रेगनेंसी, शी अंडरवेंट सम रेडियोएक्टिव आयोडीन एडमिनिस्ट्रेशन फॉर द ट्रीटमेंट ऑफ मे बी ग्रेव्स डिजीज या थायराइड कैंसर। ठीक है, तो उस टाइम द ट्रीटिंग फिजिशियन जस्ट आस्क्ड हर अबाउट द मेंस्ट्रुअल हिस्ट्री, उसने बता दी हाँ जी मेरे मेंसेस आए थे, एंड आल्सो आस्क्ड हर अबाउट कि मतलब आर यू प्रेग्नेंट फ्रॉम द टू द मदर डायरेक्टली, तो शी सेड नो आई एम नॉट प्रेग्नेंट। सो एंड उस चक्कर में उसको रेडियोएक्टिव आयोडीन एडमिनिस्ट्रेशन कर दिया एंड उस वजह से भी आपका फीटस ने ये ट्रैप कर लिया आयोडीन एंड उस वजह से बच्चे को हाइपोथायराइडिज्म होने के चांसेस हो जाते हैं। ठीक है, तो इसलिए इट इज वेरी एसेंशियल कि जब आप रेडियोएक्टिव आयोडीन ट्रीटमेंट किसी फीमेल का कर रहे हो तो आपको सिर्फ हिस्ट्री नहीं पूछनी चाहिए कॉन्ट्रासेप्शन की या फिर मेंस्ट्रुअल साइकिल की, आपको सीधा प्रेगनेंसी टेस्ट करवा के श्योर हो जाना चाहिए कि फीमेल प्रेग्नेंट है कि नहीं, बिकॉज अदरवाइज द बेबी विच इज बोर्न विल लैंड अप विद कंजेनिटल हाइपोथायराइडिज्म। ठीक है, और कभी कभी मदर के इनटेक ऑफ फ्यू ड्रग्स, कौन सी ड्रग्स मदर एमिड्रोन ले रही है फॉर एज एन एंटी एरिथमिक, और प्रोपाइलथायोसिल ले रही है या मेथिमजोल ले रही है, इवन दैट कैन रिजल्ट इन कंजेनिटल हाइपोथायराइडिज्म। तो ये सारे कॉजेज होते हैं कंजेनिटल हाइपोथायराइडिज्म के जो हमें पता होने चाहिए। तो अगर हम वापस जाएं अपने इस क्वेश्चन में, तो ओपन पोस्टीरियर फॉन्टेनल एंड अ वाइड ओपन एंटीरियर फॉन्टेनल, ये भी एक की इंडिकेटर होता है। ठीक है, एंड ऑफ कोर्स इट इज द मोस्ट कॉमन प्रिवेंटेबल कॉज। अगर आप सही टाइम पे थायराइड सप्लीमेंटेशन चालू कर दो तो ये मेंटल रिटार्डेशन बच्चे का रिवर्स भी हो जाता है। ठीक है, एंड हिस्ट्री ऑफ मैटरनल थायराइड इलनेस तो हमने इसको एलैबोरेट कर ही दिया, तो इसमें क्या करेक्ट आंसर क्या होगा? ऑल ऑफ द अबव आर करेक्ट। ठीक है, नेक्स्ट क्वेश्चन पे, a 10-week-old child is accompanied by his parent for routine immunization. Parents being concerned about the vaccination insist on knowing about what can be the contraindication of administering DPT vaccine. Which of the following is an absolute contraindication of administering DPT vaccine? देखो बच्चों, किसी भी वैक्सीन का अगर एब्सोल्यूट कॉन्ट्राइंडिकेशन आए तो सबसे पहले आप देख लिया करो कि ऑप्शंस में एनाफाइलैक्सिस तो नहीं है। किसी भी वैक्सीन के पहले डोज या प्रीवियस डोज से अगर एनाफाइलैक्सिस हुआ है, दैट इज एन एब्सोल्यूट कॉन्ट्राइंडिकेशन कि आप फर्दर डोजेस उस वैक्सीन के नहीं लोगे। ठीक है, यूजुअली येलो फीवर एंड इन्फ्लुएंजा वैक्सीन के साथ ज्यादा कॉमन होता है एनाफाइलैक्सिस, बट ऑफ कोर्स किसी भी वैक्सीन के साथ हो सकता है। तो एक तो एब्सोल्यूट कॉन्ट्राइंडिकेशन आंख बंद करके याद कर लो, इट इज एनाफाइलैक्सिस। अब हम स्पेसिफिक कॉन्ट्राइंडिकेशन टू द वैक्सीन के हिसाब से चलते हैं। पर्ट्यूसिस के लिए कॉन्ट्राइंडिकेशन होता है अगर किसी बच्चे को डीपीटी लगने के बाद विद इन 7 days एनकेफ्लोपैथी हो गई है तो आगे जाके इस बच्चे को सिर्फ डीटी वैक्सीन मिलेगी। पी वाला कंपोनेंट मतलब पर्ट्यूसिस कंपोनेंट के लिए ये बच्चा नहीं एलिजिबल है। इस बच्चे के लिए पर्ट्यूसिस वैक्सीन कॉन्ट्राइंडिकेटेड है। समझ में आ गया आपको? ठीक है, सो व्हाट अबाउट द अदर 4 थिंग्स, ठीक है, जो कि डीपीटी वैक्सीन के साथ हमें बताई जाती है। कौन सी 4 चीजें बताई जाती है? हमें बताया जाता है कि इन बच्चों को हाइपोटेंसिव हाइपो रिस्पॉन्सिव एपिसोड्स हो सकते हैं। ठीक है, इन बच्चों को हाइपरपायरेक्सिया हो सकता है, एंड हाउ डू यू डिफाइन हाइपरपायरेक्सिया इज एन टेम्परेचर ऑफ मोर देन 40.5 डिग्री सेंटीग्रेड, या फिर फ़ारेनहाइट में लेना चाहो तो एग्जैक्टली 104.9 डिग्री फ़ारेनहाइट, ठीक है, विद इन 3 days ऑफ गेटिंग द वैक्सीन, ठीक है, ये चीज हो सकती है। तो 2 चीजें ये हो गई, एंड तीसरी होती है आपकी परसिस्टेंट इनकंसोलेबल क्राइंग फॉर मोर देन 7 hours, राइट। और चौथी चीज होती है कन्वल्शंस अकरिंग विद इन 72 hours ऑफ वैक्सीनेशन, ठीक है। तो अगर हम इसको लिखना चाहें तो एक तो ये क्राइटेरिया, एक ये क्राइटेरिया, हाइपरपायरेक्सिया का भी क्राइटेरिया होता है, ठीक है, 40.5 डिग्री सेंटीग्रेड या फिर 104.9, ठीक है, और कन्वल्शन विद इन 72 hours ऑफ वैक्सीनेशन। और जैसे मैंने बताया चौथा क्राइटेरिया होता है हमारा HHE, हाइपोटेंसिव हाइपोरिस्पॉन्सिव एपिसोड्स विद इन 72 hours ऑफ वैक्सीनेशन। तो ये अगर 4 चीजें आपको देखने को मिलती है, रिमेंबर दीज आर नॉट कॉन्ट्राइंडिकेशंस। ये आपके नीट पीजी में क्वेश्चन ऑलरेडी आया हुआ है, प्लीज रिमेंबर दीज आर नॉट कॉन्ट्राइंडिकेशंस, दीज आर जस्ट प्रिकॉशंस। क्यों? बिकॉज दे डू नॉट रेकर विद एवरी डोज, नंबर 1। नंबर 2, दे आर नॉट बीन प्रूवन टू कॉज एनी परमानेंट सीक्वल, ठीक है। तो नेक्स्ट डोज अगर किसी बच्चे को इन चारों में से कुछ हुआ है तो नेक्स्ट डोज भी उसको DTWP की मिल सकती है। इट इज नॉट a contraindication, please remember this, ठीक है। you will not switch to the acellular component, so this should be very clear। तो हमारा absolute contraindication कौन सा हो गया? That is the C option। this is the correct answer for the question which was asked to us, right? Okay, next question करते हैं। 8-year-old child accompanied by his mother presents to pediatric emergency with myoclonic jerks. On probing further, mother gave a history that his school performance has been deteriorating for the past few months, and he has a history of fever with rash when he was 1 year of age. Which of the following statement is incorrect about the most probable diagnosis? ठीक है, तो what are we looking at is कि जब आपका अगर हम options देखें उससे भी हमको clue मिल जाएगा। But anyways, जब भी कोई बच्चा हमारे पास myoclonic jerks करके आता है, especially at this age, ठीक है, with a deterioration of school performance and an history of fever with rash, long time back, in fact we have to listen this history, we are dealing with something known as acute sclerosing panencephalitis, SSPE, जो कि मीजल्स का chronic complications होता है, ठीक है। This complication is usually seen usually after the gap of 7 to 10 years, and usually ये मीजल वायरस जो होता है ये जाकर के CNS के कोई सेल में इंट्रासेलुलरली रहने लग जाता है, and after 10 years suddenly becomes virulent, न्यूरोवायरुलेंस डेवलप कर लेता है, जिस सेल में रह रहा होता है उसी सेल को अटैक करने लग जाता है, and hence the child presents with features of SSPE. And remember, SSPE is seen more in males as compared to females. Very very important. And EEG finding, एक typical इसमें EEG finding देखने को मिलती है हमें burst suppression pattern, ठीक है। And usually this is definitely a fatal condition, and the child usually dies within 2 to 3 years of developing SSPE, ठीक है। There is no cure for it, although एक ड्रग है इनोसिप्रीन या इनोसिप्लेक्स जिसे हम कहते हैं, वो हम यूज कर सकते हैं, बट देन दैट इज नॉट द डेफिनेट क्योर। चिल्ड्रन आर नॉट नोन टू रिस्पॉन्ड टू इट एंड दे यूजुअली डाई। सो यूजुअली SSP में अगर हम देखें तो हमें 4 स्टेजेस देखने को मिलती है, ठीक है। तो स्टेज 1 जो होता है दैट इज जस्ट माइल्ड सिम्टम्स होते हैं। माइल्ड सिम्टम्स का क्या मतलब कि आपका इरिटेबिलिटी हो रहेगी, ठीक है। देन बच्चे का चेंज इन पर्सनैलिटी देखने को मिल जाती है, ठीक है। डिट्यूरेशन ऑफ जैसे एकेडमिक परफॉर्मेंस, जैसे कि अभी हमने इस बच्चे में देखा था, ठीक है, तो वो देखने को मिल जाता है। सो दिस इज योर टिपिकल स्टेज 1 प्रेजेंटेशन, ठीक है। स्टेज 2 प्रेजेंटेशन जो होती है बच्चों, वो होती है आपकी टिपिकली मायोक्लोनस से। तो आपका ये बच्चा जो आया है वो मायोक्लोनस करके आया, दैट मीन स्टेज 2 में आया। स्टेज 3 में आपको क्या देखने को मिलता है? स्टेज 3 में आपको देखने को मिलता है लेड पाइप रिजिडिटी देखने को मिल सकती है, ठीक है। फिर कोरियो एथेटॉइड मूवमेंट्स देखने को मिल जाते हैं, ठीक है। तो ये आपके जो अब नॉर्मल मूवमेंट्स होते हैं, ठीक है। एंड साथ में डिट्योरेशन ऑफ कॉन्शियसनेस शुरू हो जाती है, सेंसोरियम डिट्योरेशन चालू हो जाता है, तो बच्चे को डिमेंशिया होने लग जाता है, एंड सेंसोरियम का डिट्योरेशन शुरू हो जाता है. दैट मीन्स द चाइल्ड, ठीक है, कोमा हो सकता है, स्टूपर हो सकता है बच्चे को, डिपेंडिंग ऑन द डिग्री ऑफ इन्वॉल्वमेंट. एंड फाइनली जो स्टेज 4 होता है बच्चों, स्टेज 4 में आपके वाइटल सेंटर्स इफेक्ट होने लग जाते हैं. सो देयर इज सम प्रॉब्लम विद द ब्रीदिंग, हार्ट रेट, बीपी मेंटेनेंस की प्रॉब्लम शुरू हो जाती है. एंड दिस इज द स्टेज जब आपको बच्चे को यूजुअली आपने को देखने को मिलता है द चाइल्ड डाइज इन द स्टेज. ठीक है, तो अगर हम अपना क्वेश्चन देखें, जो हम अभी क्वेश्चन लास्ट वाला कर रहे थे, तो इस क्वेश्चन में हमने देखा इट इज अ कॉम्प्लिकेशन दैट अकर्स 7 to 10 years. बिल्कुल सही है ये तो, क्योंकि हमसे इनकरेक्ट पूछा गया है, तो ये तो सही स्टेटमेंट है. ईजी फाइंडिंग्स तो कैरेक्टरिस्टिक होती है बर्थ सप्रेशन की. इनवॉलंटरी मूवमेंट्स इन द फॉर्म ऑफ कोरोएथेटोसिस और डिस्टोनिया और लेड पाइप रिजिडिटी इज सीन इन स्टेज 3 ऑफ द डिजीज, नॉट इन स्टेज 4. स्टेज 4 में तो आपके वाइटल सेंटर्स इफेक्ट होने लग जाते हैं, जिसकी वजह से स्लोइंग ऑफ द हार्ट रेट देखने को मिल जाती है, एंड मेंटेनेंस ऑफ बीपी एंड रेस्पिरेशन मेंटेन करना बड़ा मुश्किल हो जाता है. एंड ऑब्वियसली द चाइल्ड गोज टुवर्ड्स द फाइनल आउटकम. तो ये तो डेफिनेटली आपका रॉन्ग स्टेटमेंट है. एंड दिस कॉम्प्लिकेशन यूजुअली फेटल एंड द पेशेंट्स डाई विद इन 2 to 3 years. सो हमारा करेक्ट स्टेटमेंट इसमें कौन सा हुआ? द सी ऑप्शन. सो आई होप सबके अच्छे से करेक्ट हुए होंगे. ठीक है, एंड आई होप दिस discussion proves fruitful to you. Keep MCQing. I'm sure you will attain your goal very nicely. Thank you. Signing off. This is your pediatrics faculty at Allen Next, Dr. Dipali Gupta. Bye.
Alright, hi guys. So let's get started with the pharmacology question that was asked in CBoT. I hope the exam went well, and in this session we are going to quickly analyze the question that came in pharmacology. The very first question that we have is a question about bisphosphonate for osteoporosis. Two important things that you should know about osteoporosis. First and foremost, that it is considered as a drug of choice in a patient with osteoporosis. Any age group, any gender, this is the drug of choice in osteoporosis. Apart from that, the mechanism of action that they are going to act by inhibiting the osteoclastic activity. They will inhibit the osteoclast. They actually get deposited in the bone, and after that they will be uptaken by the osteoclast, and they promote the apoptosis of the osteoclast. So mainly you can understand that they are going to inhibit the osteoclastic activity. Now let us read the option that they are pyrophosphate analog. Yes, these are pyrophosphate analog. There are many other drugs that are pyrophosphate, but this is one of them also, right? Inhibit the osteoclastic activity. This is the correct answer. As I have already told you that you have to find out the wrong statement here. They are the one that is going to act by inhibiting the osteoclast. They inhibit rank ligand. Do they inhibit rank ligand? The answer is no, they do not inhibit the rank ligand. Rank ligand inhibitor, a drug that we have, rank ligand inhibitor agent is going to be a drug like your denosumab. Denosumab is a monoclonal antibody that is going to bind the rank ligand. Where is the rank ligand located? So over the osteoblast, if this is one of the osteoblast, over the osteoblast there is something called rank ligand, L for ligand. This rank ligand actually activates the osteoclast. So here we have, if we have an osteoclast here, this is osteoclast. Over this one, there is something called your rank ligand receptor. We are having rank ligand receptor. So when the ligand actually interact with the rank ligand receptor, they will be causing activation of the osteoclast. So activated osteoclast may look something like this with a finger-like projection. This is going to actually bind with the bone, and they will be promoting the resorption, right? So they will take this osteoclast, they are going to take calcium from the bone, and they are going to bring this calcium, excess calcium in the circulation. So very simply you can see here the mechanism of action, even that these bones are actually, this drug bisphosphonate, they are going to actually bind in the bone, and along with the calcium they will also be taken inside, right, the your osteoclast, and this osteoclast they will be promoting the apoptosis of the osteoclast, right? So this is the very quick revision of the osteoclast. So they inhibit rank ligand. Remember, they do not inhibit the rank ligand. Rank ligand inhibitor is your denosumab. Os is osseous, right? Denosumab, it's a monoclonal antibody, remember. Okay, can be given orally or intravenously? Yes, right? So bisphosphonates can be given orally. Yes, we are having injectable bisphosphonates as well. So injectable bisphosphonate like zolendronate, and pamidronate, ibandronate, so they are available by the injectable as well. All the bisphosphonate, the good news is that they are going to end with dronate. So dronates are all known as your bisphosphonates, right? So correct answer for this one is going to be C. Next one that we have is a hypertensive patient is 50, has been on a course of ramipril. Ramipril is what? Ramipril happens to be one of the ACE inhibitors. All the ACE inhibitors are ending with pril, okay? He is taking for almost a decade. Recently reported experiences elevated blood pressure on multiple occasions. Okay, so ACE inhibitor non-responsive. Among the following option, which medication is unsuitable to be prescribed as an additional treatment, which should not be added? Now, what do we know about ACE inhibitors? That ACE inhibitors can actually, the ACE inhibitor as a drug that we know, they can actually increase the level of potassium, and therefore they should be contraindicated in hyperkalemia patient. They should be contraindicated in hyperkalemia patient. Also, they should also be contraindicated with any potassium increasing drug. Any drug that can increase the potassium level, with them they should also be contraindicated. Potassium increasing drugs के साथ भी नहीं देंगे. Apart from that, we also know that ACE inhibitor, they can cause, increase in the level of bradykinin. This increase in the level of bradykinin, it can lead to problems like angioedema and dry cough. What will it call? Angioedema and dry cough. Angioedema and dry cough is something that they are going to cause, right? Now, if you see that the hyperkalemia is one of the problem, remember any of the RAS system inhibitor can cause hyperkalemia. Be it ACE inhibitor, be it your ARBs, be it your potassium sparing diuretic, all of them they can cause hyperkalemia. Now look at this. What are the drugs that we have? Amiloride. What type of drug is amiloride, guys? Amiloride, it's one of the epithelial sodium channel blocker, and this epithelial sodium channel blocker is also one of the potassium sparing diuretic. Spironolactone, it's one of the aldosterone receptor blocker. Metolazone, chlorthalidone, they both are thiazide diuretics. So thiazide diuretics causes hypokalemia, remember, Triamterene, it's also one of the epithelial sodium channel blockers, so that means they are also potassium sparing diuretics. So option 1, 3 and 5 are the potassium sparing diuretic class, right? Aldosterone receptor blocker are also potassium sparing. ENaC blocker are also potassium sparing. So what are the potassium sparing diuretics that I always used to remember? The potassium sparing diuretics that we have, D for diuretics here, is going to be drugs that is remembered by the mnemonic SETA. That is going to be spironolactone, eplerenone, triamterene, and amiloride. So you see, all of them are potassium sparing, that they will increase the risk of hyperkalemia. And if there is a drug called ACE inhibitor that is also causing hyperkalemia, we should be avoiding them, right? So we have option like 1, 3 and 5, that is B is going to be the correct answer in this one, okay? Next one, a patient undergoing arrhythmia treatment experiencing palpitation and chest discomfort, okay? So there is a history of palpitation, some chest discomfort, ECG revealing the presence of TDP, torsades de pointes. One of the cause of torsades de pointes definitely is a QT prolongation. So examiner is asking, among the listed drug, which of the following is least probable cause of this? So what are the drugs causing QT prolongation? In the arrhythmia, remember, I always tell you that in the anti-arrhythmic drug, we have Vaughan-Williams classification 1, 2, 3, 4. 1 is further subdivided into 1A, 1B, 1C. 1A is sodium channel blocker. Along with that, it is also having potassium channel blocking property. The drugs in this class is going to be quinidine. We remember like Queen, Prince and Dasi, they are A-grade people in a kingdom, okay? Quinidine, procainamide and disopyramide. So Queen, Prince and Dasi, they are the A-grade people in a kingdom, okay? Quinidine, procainamide and disopyramide. Apart from this, what about 1B drugs? 1B are going to be lidocaine, tocainide, phenytoin, an anti-epileptic drug है ना, having anti-arrhythmic property, phenytoin and mexiletine. So मैं इसको बोलता हूँ, याद करो ऐसे. Remember like this, that 1B, they always boss around and they are the brave group of anti-arrhythmic drug because they are utilizing majority of the arrhythmias, right? So they always say that we are so good that everyone like to phone me. LI lidocaine, they like to phone me. The mnemonic is like to phone me. Everyone like to phone me. In any case of arrhythmia, all the physician like to phone me, or all the king or queen like to phone me. Hai na? So lidocaine is 1B. 1B group of drug that we know, they are sodium channel blocker, and in addition to that, they are sodium channel blocker. In addition to that,
they are actually potassium channel opener, sodium blocker and potassium channel opener. Now, any drug that is having sodium channel blocking property, what will be its effect on the QT interval? Let us quickly see. Now, this is one of the action potential duration, let us say. In this action potential duration, what we know that if there is any drug that is having sodium channel blocking property, the sodium channel blocking property will lead to decrease in the slope of depolarization. Decrease in the slope of depolarization. If it is going to have a potassium channel blocking, then potassium block, therefore the efflux of the potassium will be slowed down, and this will be leading to increase in the QT interval. So any drug that is having 1A property, that is sodium and potassium blocker, they can cause QT interval. Apart from that, if I compare this one with a drug that is 1B, sodium channel blocker and potassium opener. So if the potassium is opened, then all of them will be rapidly going out. All the potassium will rapidly effluxed out, and this will be leading to rapid repolarization. So this is going to cause decrease in the slope of repolarization. That means there will be decrease in the action potential duration. There is going to be decrease in the action potential duration. So this one is known as your 1B, and this one is known as your 1A. So all the 1A plus class 3 antiarrhythmic drug, class 3 is pure potassium channel blocker, right? So all the class 3 antiarrhythmic drugs like your amiodarone and all, they are pure potassium channel blocker, and they should also be avoided, right? Now, among the listed drug, which one is least probable cause of this one? And amiodarone we know, sotalol we know. Sotalol is a beta blocker actually having 2 and 3 property both. And amiodarone, dronedarone, sotalol, they are all class 3 antiarrhythmic drug. So all the class 3 antiarrhythmic drug, if you are going to see class 3 antiarrhythmic drug, they can also lead to increase in the action potential duration. So they can also cause, QT interval prolongation. So this interval will be something like this. So class 3 ka image, right, you should compare with class 1A. 1A may decrease in the slope of depolarization also, and action potential duration बढ़ गया. Class 3 will be mainly increase in the action potential duration, right? So the QT interval prolongation will be seen there. All right. So what we should see here, that which drug is not having either 1A or 3 property. Okay. So sotalol is 2 and 3 property. So definitely they are going to be associated with the QT prolongation. Lignocaine, what is lignocaine? Lidocaine and lignocaine, same thing. So they are the one that is class 1B. So they decrease the action potential duration. Okay. Quinidine class 1A here, and procainamide also class 1A. So class 1A and 3, you have to remember that class 1A and class 3 antiarrhythmic drug, they can be associated with a QT interval prolongation, right? So in the antiarrhythmic drug, these two will be causing mainly. Right? Let's see the next one. A patient was diagnosed with central diabetes insipidus. Which of the following is the mechanism of action for the drug of choice for central diabetes insipidus? So first and foremost, what is the drug of choice for central diabetes insipidus, guys? The drug of choice for central diabetes insipidus is known as desmopressin. What is desmopressin? Its name is very much similar to vasopressin, right? So they are nothing but the synthetic vasopressin. So vasopressin काम कैसे करता था? How was this vasopressin working? This vasopressin was mainly acting in the V2 receptor agonist. And this V2 receptor agonist will be increasing the aquaporin 2 ka upregulation or appearance at the surface, and this aquaporin upregulation at the surface of the cell, they will be increasing the water ka reabsorption. So ultimately, in a patient with central diabetes insipidus, the polyuria polydipsia symptom can be controlled using this one. So they are not sodium chloride symporter activator, neither they are inhibitor. V2 receptor agonist, as I said, they are V2 receptor agonist. They are all V2 receptor agonist. V2 receptor antagonist, no, they are not V2 receptor antagonist. V2 receptor antagonists are vaptans. V2 receptor agonists are vaptans. That is going to be drugs like your conivaptan, tolvaptan. They are the drug of choice in patient with the SIADH. Conivaptan and tolvaptan. Do remember another question that was asked, that tolvaptan that we have all orally available. This is orally available, and conivaptan, it's IV available. Okay. Next question. And in fact was given tetracycline. So tetracycline usually should be avoided less than this drug should not be given less than 8 to 10-year-old child. 10 साल के नीचे बच्चों को usually avoid करते हैं as much as we can. They can cause permanent teeth staining and bone growth abnormality. So which of the following side effect can be seen? Tendon rupture is actually associated with, guys, fluoroquinolones, that is all ending with floxacin. Ofloxacin, moxifloxacin. Cholestatic hepatitis can be associated with the macrolides like erythromycin. Erythromycin can cause this one. Bone growth retardation, yes. All of the above is a trap here. Many students must have marked all of the above, I can understand, but that's a trap. Remember that. Next question. Which of the following drug is correctly matched? Match the following. Okay, you have to match it correctly. फर्स्ट एंड फॉरमोस्ट जब भी ऐसे क्वेश्चन आए तो यू हैव टू यूज द रूल ऑफ एक्सक्लूजन. 1 to 2 ऑप्शन यू हैव टू क्विकली पिक, एंड 1 to 2 ऑप्शन अगर आपको वो मैच हो जा रहा है, इफ यू आर एबल टू मैच देम, देन गो ahead with the best option that you can find it here. Now, in this one, nevirapine. What we know about nevirapine, that nevirapine is one of the NNRTI, non-nucleoside reverse transcriptase inhibitor. I have told you all the NNRTI, their name has VIR virus. So nevirapine, etravirine, dolavirine, rilpivirine, they are the second generation, है ना? Delaverdine, है ना? Efavirenz, they are all NNRTI. Ritonavir, all the Navi drug क्या होते हैं? All the Navi drug, everyone knows all the Navi drugs are protease inhibitor. Maraviroc is mainly the entry inhibitor. Maraviroc is mainly the entry inhibitor that is going to act by inhibiting your CCR5. Emtricitabine is a nucleoside reverse transcriptase inhibitor. Emtricitabine is a nucleoside reverse transcriptase inhibitor. Now let us read this one. ABCD में nevirapine. What did I tell you about nevirapine? Non-nucleoside. So this will be 1C. As soon as you got one option correct, 1C, I'm telling you how to attempt this question as well. As soon as you got one answer correct, nevirapine is NNRTI, then suddenly these two options are ruled out. So you are only left with B and D. Even if you do not know, let's say you do not know nevirapine is NNRTI, you know ritonavir, navir is a protease inhibitor. So navir is a protease inhibitor, and what is navir? 2 का A. 2 का ए. अब देखिए 2 का ए कितने के साथ है, अगर आप वो उस सिनारियो में देखते हैं, इन दैट के सिनारियो ऑल्सो यू आर इजिली गोइंग टू रूल आउट, यू आर इजिली गोइंग टू रूल आउट 2 इंपॉर्टेंट ऑप्शन. आपको आराम से 2 ऑप्शन आप रूल आउट कर पा रहे हैं, बिकॉज 2 का ए इज सीन ओनली इन दिस 2. 2 का ए कहां पे मिल रहा है? ओनली इन दिस 2 ऑप्शन बी एंड सी. तो यू हैव टू यूज दिस रूल ऑफ एक्सक्लूजन ऑल्सो सम टाइम, है ना. एनीवे, वी हैव ऑलरेडी सीन दैट 2 का ए, सो 2 का ए कहां पे अवेलेबल है? 2 का ए इज अवेलेबल विद द B. So most likely our answer is going to be B. But let us quickly see other option. Maraviroc. Maraviroc is, as I said, entry inhibitor, right? If someone is entering in your house without your permission, मारोगे, मारा इसको, है ना? मारोगे. So that will be D. Emtricitabine, अब एक ही बच गया, तो nucleoside reverse transcriptase inhibitor. So 3 का D, again we already have confirmed that this B is the correct answer. Emtricitabine is a nucleoside reverse transcriptase inhibitor, that is going to be 4 का B. Clear? So at least in this type of question, 1 to 2 option will be very, very simple, and you know this already, that which drug is belonging to which class, and matching the class is all-time favorite of the NEET PG, remember. Next that we are having is a 30-year-old pregnant female in her first trimester pregnancy with history of falciparum malaria. She was started on chloroquine therapy, but there was no improvement in her condition. Which is the treatment, which treatment should be given next? Always remember, if there is any malaria in pregnancy, it depends whether the patient is having which type of malaria. If the patient is coming to OPD and in the first trimester, we are going to use quinine plus clindamycin. Quinine plus clindamycin combination is going to be preferred, and if the patient is coming in second, third trimester, then in that case scenario, artemisinin combination therapy will be used. Artemisinin combination therapy is going to be used, but remember, primaquine will never be given. Primaquine is going to be contraindicated. It's a teratogenic drug. Primaquine will not be given. So quinine plus doxy, so tetracycline, we are not going to give tetracycline in pregnancy. Again, bone growth retardation. Remember, it can be teratogenic effect. Even in the newborn also, we should not be giving them. Quinine, clinda, we have already written. Artesunate, clindamycin, artesunate, as I said, artesunate will be given in which trimester? Second, third trimester. Not in the human model, but in animal model, they have found that this artemisinin combination therapy can be associated with the ventricular septal defect. So second, third trimester we can give. This is a patient coming in the first trimester. Okay. Artesunate pyrimethamine sulfadoxine. Again, as I said, artemisinin combination therapy should not be given in the first trimester. So correct answer is quinine plus clinda. So this is going to be followed everywhere. है ना? अगर वो Vivax बोलता, if the examiner says Vivax, then we are going to give, chloroquine, chloroquine 600 followed by 300 milligram weekly. So loading dose के बाद 300 milligram weekly throughout the pregnancy we will be giving. Once again, we are not going to give primaquine in the Vivax as well. Okay? If it is non-responsive, then again we can follow the same quinine, clinda, first trimester, second, third trimester, where we can give artemisinin combination therapy. Next one, which of the following oral hypoglycemic agent is preferred in a morbidly obese person? Okay, so there is obesity, the person is obese, non-compliant to injectable, so no injectable, he do not want injectable. As soon as you see there is no injectable, you have to find out what are the injectable that we have. Liraglutide is given by the injectable route. They are the GLP-1 analog. Only GLP-1 analog that we have, by oral route is semaglutide. Semaglutide. Now liraglutide is something that is injectable. So liraglutide immediately ruled out ho gaya. With a family history of bladder cancer. If there is a family history of bladder cancer or medullary carcinoma of thyroid. Now, if there is a family history of, in patient with the family history of medullary carcinoma of thyroid, GLP analog should be contraindicated. If there is a bladder cancer history or bladder cancer, remember pioglitazone is going to be contraindicated. Pioglitazone, anything that you PO, you will go to bladder. कुछ भी पियोगे bladder में जाएगा, right? So bladder cancer में usually we should be avoiding pioglitazone. They increase the risk of bladder cancer. So pioglitazone is also something that is ruled out. ठीक है? With a family history of bladder cancer, he also has a history of acute pancreatitis. देखिए 3 problem दिया हुआ है. Obesity है, no injectable, and again pancreatitis. So remember, drugs that can cause pancreatitis, GLP analog can be causing, associated with pancreatitis. The drugs associated with pancreatitis is going to be again GLP-1 analog. So GLP-1 analog के साथ कई सारे प्रॉब्लम है. एक तो pancreatitis बता दिया, medullary carcinoma of thyroid also, and plus injectable is something. Injectable is the preferred route, and they can also be associated with the DPP-4 inhibitor, dipeptidyl peptidase 4 inhibitor. So DPP-4 inhibitor, they can also cause pancreatitis. All right. So sitagliptin, all the gliptins are DPP-4 inhibitor. All the gliptins are DPP-4 inhibitor. So they will also be not given. So the only option that is left is the dapagliflozin. Now examiner asks, what is dapagliflozin? So everyone knows it's one of the SGLT2 inhibitors. Nowadays, this is the next best option after metformin that most of the endocrinologists are preferring, an SGLT2 inhibitor. Okay. A 40-year-old rheumatoid arthritis patient present with a megaloblastic anemia. He was on methotrexate therapy. Now always remember, methotrexate therapy will be decreasing your folic acid or folic acid deficiency may usually there will be megaloblastic anemia. So as a prophylactic modality, we add always and always a drug known as your folinic acid. Folinic acid, also given the name as a leucovorin. Leucovorin. So we are going to give vitamin B9. This was a very straightforward and simple question. I believe all of you must have got this one. We have one more question in pharmacology, right? A drug that is acting by GP2B3A receptor. 2B3A receptor. The correct answer will come to correct answer. But first, let's rule out. Rule of exclusion is always going to be very, very helpful. Clopidogrel. We all know it's one of the P2Y12 inhibitor. It's one of the anti-platelet drug. GP2B is also going to be antiplatelet, but again, GP2B receptor inhibitor will be decreasing the cross-linking of the platelet, because these two receptor 2B3A, they are going to cause cross-linking of the platelets, right? So clopidogrel is a P2Y12 inhibitor. Okay. Rivaroxaban, तो मैंने क्या बताया था? 10A पे बैन लगा लेते हैं. 10A पे बैन लगाने वाले ड्रग, they will put a ban on 10A. Rivaroxaban, Apixaban, Edoxaban, Betrixaban, है ना? So these are factor 10A inhibitors. So they are actually anticoagulants. They are anticoagulants. Ergatroban, they are the thrombin antagonist. Ergatroban, thrombin antagonist. Ergatroban, Melagatran, Dabigatran. So they are all thrombin antagonists. They are all injectable one. And there is one more thrombin antagonist you must have heard about, Dabigatran. What is about Dabigatran that you should know? Dabigatran is orally effective direct 2A inhibitor. Why am I calling direct? Because there is something called indirect also. Heparin, low molecular weight heparin, they are all indirect 2A inhibitor. Okay. Next that we are having is abciximab. Abciximab, it is one of the monoclonal antibody. It is a chimeric monoclonal antibody, and they are mainly they are mainly going to target GP2B3A, and therefore they are going to decrease the platelet cross-linking. They will decrease the platelet cross-linking. So abciximab is the correct answer in this one. Abciximab. What are the other GP2B3 inhibitor apart from abciximab? Abciximab to ho gaya. In addition to that, in addition to abciximab, we are having other drugs like your tirofiban. Tirofiban, GP2B3A, eptifibatide, again GP2B3A. Eptifibatide, they are the GP2B3 inhibitor, right? So these are the questions that were asked in pharmacology, and I think we have a couple of more questions. Sorry about that. We have a couple of more. Which of the following is not a short-acting benzodiazepine? Right? Not a short-acting benzodiazepine. Now, short-acting benzodiazepine, what did I told you? What is the mnemonic that I told you? है ना, लेटो, बाबा लेटो, है ना. So that is known as your lorazepam, estrazolam, temazepam, triazolam, oxazepam. Oxazepam actually is a metabolite of diazepam. Diazepam is the correct answer here. This is known as your midazolam. Diazepam is a correct answer here because one of the metabolite of diazepam is oxazepam. So if the diazepam is lasting for let's say 30 to 40 hours, the metabolite will also be lasting, है ना. So usually with the diazepam, person will always have a side effect called hangover. Hangover का problem हमेशा होता है. बाकी सारे के सारे you can see they are the shorter acting one. They are considered drug that is known as safer in elderly, and not only that, they are also considered a safer drug in hepatic failure patients. Safer in elderly and hepatic failure patients, right? So diazepam is the correct answer in this one. Now this is a long question. Whenever you see long question, don't panic. Smile at the long question because you are most likely going to make it correct. There will be a lot of information in that one. So there is a patient who is scheduled for surgery under general anesthesia. Family history is telling that there is unexplained fever, muscle rigidity. As soon as you see unexplained fever, muscle rigidity and tachycardia, you think about nothing but the malignant hyperthermia. Malignant hyperthermia. So malignant hyperthermia में 3 important question. Which is the drug that is going to have a maximum risk of malignant hyperthermia? That is going to be succinylcholine. Overall in anesthesia, maximum risk is going to be succinylcholine. Then examiner asks which of the following about the inhalational agent that is having maximum risk. So that is going to be your halothane. Halothane in the inhalational. But अगर पूछता है local anesthetic में कौन होगा, तो you can even see lidocaine can also have risk of malignant hyperthermia. Now do remember this, that whenever there is a malignant hyperthermia, you have to stop the drug, and the drug of choice you are going to use is known as your dantrolene. So rest of the thing you can even read it. During the surgery, the patient developed hypercapnia, acidosis, core body temperature exceeding 40, anesthesia. Okay, diagnosis has been given in the later part of the question. Anyway, this is going to be very, very easy. Even if the diagnosis is not given, you should know that this case of malignant hyperthermia. Which is the intervention that should be taken? High dose of propofol. No, there is no point of inducing, giving high dose of propofol in this scenario. You have to stop the drug and you have to treat the condition dantrolene. Rapid infusion of calcium gluconate, once again a big no. Administration of IV succinylcholine, they are going to further worsen the problem because again they are having maximum risk. Prompt discontinuation. What is the rule I told you? Stop the drug that is causing the problem and give dantrolene. So D is the correct answer for this one, right? So this type of question is always very, very easy. All right. So we have one more question. A dose response curve is shown in this one. So whenever you see this type of drug, dose response curve wala graph, we have discussed this a couple of times already. And always remember, we have something called your potency and we have something called efficacy. So मैं usually क्या बताता हूँ? P for potency, P for power. P for potency, P for power. So the most powerful drug will be acting at the lesser dose, right? So potency order always go from left to right. So if you have to see the potency, what are the potent drug that we are having? Potency order is going to be सबसे ज़्यादा potent A होगा, that is this one. Next in the order is going to be this one, that is drug number C. And next in the order will be your drug number B. So the order is going to be something like this. The order is going to be something like this. Okay. Although the effect of A is seen somewhere here, and B is seen somewhere here, and C is seen somewhere here. तो आप देखोगे effect आना शुरू हुआ थोड़ी देर बाद. तो we can say that potency वाले order में A followed by C followed by B. Efficacy की बात करेंगे तो A and B are almost equi-efficacious. अगर मैं efficacy की बात करूं तो A and B are almost equi-efficacious. A or B almost equi-efficacious, and least efficacious is going to be C. Least efficacious is going to be C. I hope it is making sense to all of you. Now, when you are going to compare the effect of two drugs, let's say competitive or non-competitive, always remember potency will be affected by the competitive inhibitor. So whenever there is a competitive inhibitor, they will always decrease the potency. They are going to decrease the potency, and whenever they decrease the potency, always remember what will happen to the graph. The graph is always shifted towards the right side. Graph is shifted towards the right side. In comparison to this, if you are going to talk about the non-competitive inhibitor, they will affect the efficacy. Non-competitive inhibitor, non-competitive inhibitor, they are going to decrease the efficacy. ठीक है, और जब efficacy कम होगा तो यूजुअली मैं क्या बोलता हूँ, efficacy आईफिल टावर. efficacy के नाम क्या है, आईफिल टावर जैसी कोई बात आ रही है, राइट? आईफिल टावर क्यों फेमस है? बिकॉज ऑफ इट्स हाइट, है ना? सो एफिकेसी जब कम होगा तो ऑलवेज रिमेंबर व्हाट विल हैपन टू द graph will be shifted towards the downside. Graph will be shifted towards the downside. Okay, so we have seen this already. Potency, P for potency, P for power. So potency order, right? Always remember the most potent will be on the left side of the graph, and as you move from left to right, the potency will decrease. At any point of time, whenever you forget this one, I always say that take help from the help mnemonic. The right, what is height will be talking about efficacy, and left wala will be talking about the potency. Height will be talking about efficacy, and left wala will be talking about potency. So the most potent will be most less, and as you move from left to right, the potency will decrease, and this left to right shifting of the graph will only be seen in case of your competitive inhibitor. So ध्यान रखिएगा, कंपटीशन में बराबरी के लोगों से होती है. मैं ऑलवेज हमेशा बताता हूं, क्योंकि competitive inhibitor at the high dose it will acquire the same level, है ना? Competitive inhibitor at the high dose it will acquire the same level. So you can check it out, A and B का almost same level हो गया, but usually at the higher dose. But C का same level नहीं हुआ. C is even at the high dose also, C का level नीचे ही रह रहा. That means C is a non-competitive. N for नीचे, N for non-competitive inhibitor, right? So you can easily check the option out. B is more potent than A. Is B more potent than A? No. A का ज्यादा पोटेंसी है. A का इफेक्ट आने में थोड़ा टाइम लगा, बट A का इफेक्ट पहले आ गया कंपेयर टू, है ना, B और C, है ना? सो अगेन दैट्स रूल आउट. C is more potent than A. C is less potent. Huh? C is more potent than B. That is again can be considered. So A, C, B, as I have written here already. B is a competitive, as I said, competitive antagonist, है ना? ग्राफ का हाइट सेम हो सकता है, बट एट द हायर डोज, है ना? सो B is a competitive antagonist, right? So B is a competitive, yes. C is a competitive. C is not competitive. मैंने बोला नीचे आ गया ना, C का ग्राफ नीचे आ गया, तो C is a non-competitive, है ना? C is non-competitive. C is non-competitive. So if you are going to check it out, which of the following is true? The true is only B. B is a competitive. So I hope all of you guys have got this one, and you will be expecting this type of question in the real-time examination as well, right? So I hope that all of you guys have enjoyed the session of pharmacology. Thank you very much. I'll see you guys with more such question in upcoming CBoT. So I really encourage all of you guys to attempt this CBoT, that is computer based offline test, where you are actually going to check your potential and you are actually going to decrease the adrenaline rush which happens during the examination hour. Alright, so your time management, whether you are able to do the question on time or not, whether you are able to have some control on your negative marking or not, everything you can analyze during this CBoT. So CBoT is something that is coming regularly on the LNX. For more such details, you can check out the website, and I'll see you guys in the classes. Thank you very much. All the best.
Hello friends, welcome to the class. In this session we are discussing the questions of the subject forensic medicine that appeared in CBoT 1 exam 24th September, right? So questions are from different topics, and all the topics that are represented in the examinations are those topics जो exam के लिए important है. Okay, time and again we have seen that there is repetitions of questions from these areas in the exam. So let's begin by taking up our first question. Okay, this is a question which has come from a topic of asphyxia, a very commonly represented topic in examinations. पढ़ते हैं question. Question says the image shown below is of a woman who died in her room. Upon neck dissection, contusions were present in the subcutaneous tissue and muscles. So in the photograph here, let's label two photographs. This is photograph number 1. This is photograph number 2. So in photograph number 2, we can see the neck has been opened and contusions are seen in the subcutaneous tissue and muscles. What is the most probable condition? Okay, and then there are 4 options given: traumatic asphyxia, hanging, throttling, ligature strangulation. Now this is one question which has very commonly asked in examination time and again. Okay, let's try and rule out possibilities by looking at the photograph. ठीक है, तो सबसे पहले let's have a very thorough look at the photograph which is given. So if you look at photograph number 1, what we see in this photograph? We see bruising on neck. We can clearly see bruising on neck skin, and then we can see some scratches on skin. Okay, so we can see certain scratches here, we can see some bruising, right? We can see bruising, those which I am encircling, and then there are so many scratches that we can see. And this kind of a combination of certain scratches and circular kind of bruising on the neck is seen in option C, that is throttling. Throttling is manual strangulation, that is strangulation which has been done by compression of neck by bare hands. Okay, if it would have been a case of traumatic asphyxia, as it is given in option A, traumatic asphyxia is a condition where there is weight on the chest wall because of which the lungs cannot expand. So there would not be significant finding of bruising and scratches on the neck. If it would have been hanging, which is option B, or ligature strangulation, which is option D, in both the cases there is generation of ligature mark on the neck. Okay, so these two things are ruled out as they lead to development of ligature mark on neck, and we cannot see any ligature mark on neck, right? Traumatic asphyxia is ruled out because that's a condition which involves compression of chest by heavy weight on the chest wall. So even by exclusion, if you have read asphyxia correctly, even by exclusion आप correct answer बता सकते हो. But a very important finding is given on the neck in the photograph number 1, जिसको हमें याद रखना है. In fact, I have encircled certain bruises on the neck here. Okay, what I wanted to show here was circular bruises on neck in throttling are due to compression by pulp of tip of fingers of hand. So when you use the tip of the hands to compress the neck, the circular bruises that generate on the neck are due to the pulp of the tip of the finger. These are called as 6 penny bruises. These are called as 6 penny bruises. 6 penny bruises are circular kind of bruises which develop on the body because of compression by the fingers. Okay, तो fingertips के जो end से circular bruises बनते हैं body पे, उसको बोलते हैं 6 penny bruises. So we remember 6 penny bruises in this question also. Okay, let's move to question number 2. it's a match the following kind of questions. So we have 4 photographs and we have 4 options. We need to correctly match the options. So let's go through the correct matching of photographs and options. So first one is photograph E shows certain development of white transverse lines on nails. So you can clearly see white transverse lines on nails, and these white transverse lines on nails are called as Aldrich Mees lines, right? Then if you look at photograph number F, it shows cherry red post-mortem staining. It shows cherry red kind of post-mortem staining, right? If you see photograph G, it contains greenish fluid. Okay, it contains a greenish fluid, and in reference to forensic medicine and toxicology, if we talk about greenish fluid, the first thing that comes to our mind is green color urine. Green color urine seen in cases of carboluria. Okay, so it is commonly called as carboluria. Carboluria. And if you'll see photograph H, it shows a peripheral smear showing basophilic stippling of RBC, right? So this is the interpretation of the 4 photographs that are shown in the figure. We have white transverse line, Aldrich Mees lines, cherry red PMS, carboluria, photograph of carboluria, and then 4 is basophilic stippling in RBC cytoplasm. Now we have to correctly match it with the conditions. So first is given as chronic arsenic poisoning. So what do we see in chronic arsenic poisoning is Aldrich Mees lines on nail. Second is cherry red PMS. Cherry red PMS is seen in carbon monoxide poisoning. Okay, so with E there will be correct option will be 1. With F the correct option should be 4. Okay, carbon monoxide poisoning. Carboluria will be seen in carbolic acid poisoning. So with G we go with correct option as 3, and with H, that is peripheral smear showing basophilic stippling, that is seen in chronic lead poisoning, right? So with H we go with 2. So correct answer is E1 F4 G3 H2, which is option A, right? So that is how we correctly match the following figures or photographs along with the options given, right? Next is the injury shown below is typically seen in which of the following. So again a picture based question where a photograph is shown to you. The photograph that is shown contains the photograph of chest and abdomen of a person, looks to be hospitalized because certain wire attachments are on the body, looks to be on the hospital bed. But what's very important in the photograph is presence of this injury, which you can see is kind of oblique on the body. So in the upper half the injury is oblique, in the lower half the injury is transverse. Okay, so I'm going to rub off the diagram, the periphery of the injury which I just created. So you can see it's a oblique running bruise on the chest. Okay. So exactly what do we see here is oblique running contusion on chest and horizontal on abdomen. So what kind of injury or what kind of situation can develop this presentation on the body? It can be seen in cases of road traffic accident, right? What happens in road traffic accident is that this kind of picture can generate as seat belt injury. So this exactly is a presentation of seat belt injury. See, what happens is when a person is sitting in the car and he is wearing seat belt. So who are the people who are expected to be wearing seat belt? There are two people, that is the driver and the passenger who is sitting in the front. Generally people who are sitting at the back, they don't wear seat belt. Okay. So there are two people who are wearing seat belts, both are the front riders of the car. Now if this car meets a head-on collision or a road traffic accident, what will happen? The momentum of the car, which was in acceleration, because of the collision, it will come to sudden deceleration. So there is acceleration deceleration phenomena. So the moment there is sudden deceleration because of the accident of the car, the bodies of the driver or the passengers inside the car is thrown backwards and then suddenly forwards, right? So seat belt, which is present on the front of their body, it doesn't allow the body to be thrown forwards forcefully. So seat belt restrain their body to the seat, and as a result, as the body is thrown forward, because of the restraining effect of the seat belt, there is compression of the tissue beneath the seat belt, and because of this sudden severe compression, there may be generation of bruises on the body, and that's why the bruises are oblique on the body of the person, because if you will see, the seat belt goes obliquely through the chest and then horizontally through the abdomen for its insertion, right? And that is why when the compression effect happens, there is development of oblique bruise on the chest wall. Okay, the only difference is going to be that in cases of driver, the oblique bruise will go from right shoulder towards left groin, because our country is a right hand side driving country. So a driver will be sitting on the right hand side, so his seat belt will move from right shoulder towards left groin, and front seat passenger, this person will also be wearing the seat belt, but the orientation of the bruise will be different. So the oblique bruise here will go from left shoulder towards right groin, right? So the difference of the orientation of the bruises can help us identify who could be the driver or who could be the front seat passenger in cases where both the people develop bruising on the body due to seat belt compression. Right. There is one also interesting finding which is given as an option in this question itself, that is option number C, stampede. Now stampede again is a situation where a person has fallen down onto the ground and there are people who are running over his body, and because of the people running over his body, there could be development of bruises because of the shoes or the foot of the people who are running over his body. But in that case, the orientation of the bruise is not going to be the linear orientation starting from shoulder towards the groin. It could be haphazard or whole chest area being involved with the bruise along with the upper abdomen because of violent running of many people over his body. So stampede, which is an example of traumatic asphyxia, because people will be running on the chest wall of the person who has fallen onto the ground, and thus there will be trauma to chest wall, right? That's an example of traumatic asphyxia. That will normally involve generalized bruising all over the chest wall along with the upper abdomen, right? And in the photograph we can see a very demarcated linear oblique bruise on the chest due to seat belt compression effect. So that's how you can differentiate between the bruising of stampede and seat belt compression. Okay, let's move on. Next question says, a married woman died in unnatural conditions in the 3rd year of her marriage. Her parents complained of continuous demand for dowry from her. Okay, so that's an important finding which is given here, continuous demand for dowry. Okay, her autopsy is conducted. All given legal provisions are applicable in this situation except. Okay, so basically the question wants to know your knowledge or whatever you know regarding the legal provisions around the concept of dowry. Okay, so whatever is not applicable, that can be struck out. But in this situation, it is very clearly given that the female has died, right? The female has died and an autopsy is being conducted. So it is not a situation where a dowry demand has been asked where the female is still alive, and that creates a bit of a doubt in the mind of a question solver, because we have section 302 IPC as choice number A, which is punishment for murder, right? Then we have 498A, 176C and 304B as choices. So let's take all the choices and let's see what is the choice that we can exclude. So if we say 498A IPC, it's an IPC which punishes for coercion for dowry. Coercion means torturing a female for obtaining some money or any other property from her. So if husband or any relative of the husband is coercing a female for gaining some money or any other gain from the female, 498A is applicable. So we can say 498A IPC is applicable in cases of dowry situations. Then we have 176 CRPC, that's magistrate inquest. Now in cases of dowry death, magistrate inquest happens, right? In fact, if we recall our knowledge regarding inquest, magistrate inquests happen in 3 situations, 3 mandatory situations. One is dowry death, second is exhumation, and third is custodial deaths, right? So even 176 CRPC is also applicable to this situation. And then one is 304B IPC. This is a direct IPC which provides punishment for dowry death. Okay, so 498A is coercion for dowry and 304B is punishment for dowry death. Right, so we need to remember three very important legal situations which are applicable in cases of dowry: 498A, 176 CRPC, and then 304B IPC, which means the exception in this case is option number A, section 302 IPC. Section 302 IPC punishes for murder. Okay, dowry deaths are always not murders. Okay, for the want of dowry, if a female was constantly tortured, if the female was constantly humiliated, and after a period of time she, committed suicide, that's not murder. But still, the IPCs of dowry are applicable, right? And that is why we say that 302 in this situation is not applicable. And by the way, in this question, why do we call it as a dowry death? Because the female was still in the third year of her marriage. And what does the law say? That any female within 7 years of her marriage, if she dies of unnatural circumstances, and there are people alleging that during the tenure of her marriage she was being tortured for want of certain money or dowry, then it should be treated as dowry death unless it is proven otherwise, right? So any female dying within 7 years of her marriage due to unnatural circumstances, it raises suspicion according to the provision of law. Right, let's move to our next question. Next question is very straightforward question. Voyeurism is defined as, voyeurism, also known as peeping Tom. It is defined as sexual gratification by watching into the privacy of individuals. Okay, also known as peeping Tom, commonly exhibited by males on females. Okay, commonly done by males by watching into the privacy of unsuspecting females, right? A female is changing clothes in her private, kind of enclosure. She is not otherwise suspecting that somebody may be watching her. If somebody has made any kind of arrangement so that he can secretly watch her, that's voyeurism. She may be in her house and somebody is secretly watching her, that's voyeurism. She may be in a common enclosure like a female gym where all other girls are there in the locker rooms and somebody has secretly, made any arrangement of watching the female there, it's voyeurism. So all these kind of things are called as voyeurism or peeping Tom. This is a sexual perversion. It's an abnormal sexual behavior called as sexual perversion or sexual paraphilia. Does not involve any sexual intercourse with that female. As you can see, the person is only watching her, right? But that breaks law because voyeurism is a punishable act in Indian IPC, and the punishment is given in section 354C IPC. So it's a punishable act under section 354C IPC, right? Let's move further. A patient presented to OPD with burns of soddened skin appearance along with clear line of demarcation and lines of vesicles running down the body. Okay, what is the most probable cause? Okay, So what we have is, let's say there is a person and he has been impacted by something. Let's draw a body. Right? So there is a person who has been impacted by something where there is burns of soddened skin appearance. Soddened skin appearance means wet. Soddening is wet. Okay. With clear line of demarcations between skin and the burnt area. So we can say that the burnt area is probably something like this. So this is the burnt area. In the lower limb also there could be a burnt area like this in a linear pattern. Okay, this could be the burnt area. And then we can see a clear line of demarcation between the burnt area and the normal healthy skin. Okay, and the line of demarcation is running down the body. So something has fallen on the top of the body and it has gone down towards the body. So what can be this kind of a substance which could have fallen on the top of the body and then going down onto the body? Because you can see here it is written lines of vesicles running down the body, which means some kind of a fluid has fallen on the top half of the body, and when something falls which is fluid, it runs towards the base or down the body. And if this fluid is hot, what will it do? It will burn the skin also, right? So we have a choice of option B and option D, because burn due to moist heat, which means fluid could be there, or burns or chemical burns could be there, right? Now, in chemical burns, we tend to have hardened skin appearance because of the eschar formation. Whereas in the question, it is given that the burns are soddened, which means they have a wet appearance. Soddening happens because of the body parts immersing in water or fluid for a long time. So soddening kind of an appearance is seen in moist heat. That could be due to any hot liquid. So correct answer here is option B, moist heat. Right. Next question. A dummy bullet is fired from the rifle confiscated as weapon of offense. Okay, a dummy bullet is fired. This bullet needs to be matched with the bullet recovered from the dead body. What matching will identify the rifle as the weapon of offense? So question is very clear that an autopsy has been done. From that autopsy, a bullet has been recovered from dead body, and simultaneously police has recovered a probable weapon of offense. Right? Now what needs to be done is to be seen that whatever bullet has been recovered from the body, could that bullet have been fired from the recovered weapon? So if that bullet would have been fired from the recovered weapon, then they can say that the recovered weapon is the weapon of offense. How do the scientists do it at forensic science lab? They fire a dummy bullet, or they make a dummy fire from the recovered weapon. Now they have the dummy fired bullet and the bullet which has been recovered from the dead body, and they match the findings on both the bullets microscopically to see if the findings match. So how these things are done? So the first matching which is done is called as primary markings on the bullet. The primary markings on the bullet come because of the rifling that is present in the weapon. This come due to rifling in the weapon. So consider two separate weapons who has similar rifling in their barrel. So when you shoot through them, the bullets which are coming out from their barrel will have similar primary markings on their surface because the extent of rifling in their barrel is same, right? So primary markings which are due to extent of rifling in the barrel cannot identify which is the weapon of fire. On the other hand, there is also development of something called as secondary markings on the bullet. So what are secondary markings on the bullet? These are due to extent of metallic fouling present in barrel of the weapon. Now again consider two weapons, both of them having same primary marking because the extent of rifling in their barrel is same, okay? But both the weapons are held by two different people. One person shoots with it probably every day. The other person may be using this weapon once in a week. So one weapon is utilized every day and the other weapon is utilized once in a week. Whenever these weapons are utilized and a shot is made from them, every time there is lot of smoke which travels through the barrel towards the outside. Along with smoke, there is lot of metallic particles also because the bullet contains lot of metals. So those metallic particles also are coming out of the barrel. During the process of transit of these metallic particles along with smoke, there are very high chances that some metallic particulate matter gets deposited in the barrel of weapon itself, okay? So consider one person who is shooting every day. In his barrel, the metallic particulate deposition will be higher than the person who is using once in a week. In the person who is using once in a week, the metallic particles getting deposited in the barrel are going to be lesser. This metallic particles depositing in the barrel of the weapon is called as metallic fouling. Now, subsequently when a bullet is shot, this bullet which is traveling through the barrel of the weapon, because of the extent of metallic fouling in the barrel, the bullet has certain friction marks on its surface called as secondary markings. So, in cases of even the primary markings being the same, because the rifling is same in the barrel, secondary markings are going to be different because secondary marking depends upon the metallic fouling of the barrel, which subsequently depends upon the usage of that weapon, right? So if we can match secondary markings on the body of the dummy bullet with the secondary markings which are present on the bullet which has been recovered from dead body, we can say that the weapon which has been confiscated by the police is the weapon of offense. So correct answer here is matching of secondary markings on the bullet. So question was asking what matching will identify the rifle as weapon of offense? The option is matching of secondary markings due to metallic fouling of the barrel. Right, next question. Match the following events after death with their timeline. Okay, so what do we see in this question is certain post-mortem changes and we need to match when a particular post-mortem change is observed. So the first one is primary relaxation of muscles. After death, the first thing that happens with muscles of the body is that they are primarily relaxed, and the time period of primary relaxation of muscles is approximately the first 2 hours after death, which means primary relaxation of muscles will match with H, first 2 hours. Okay. Then second is disappearance of rigor mortis. When we talk about rigor mortis, you need to remember rule of 12. First 12 hours after death, rigor mortis develops and peaks. Next 12 hours, that is 12 to 24, rigor mortis remains in the body muscles in varying intensities. Some muscles have more, some muscles have less, but it is present. Next 12 hours, that is 24 to 36, rigor mortis gradually disappears from body. So disappearance of rigor mortis will be 24 to 36 hours, right? Then that is marbling. Marbling is a feature where we have development of violet color lines in the vascular territories of the body, and we can see development of marbling at the earliest in 36 to 48 hours. So when a dead body starts to develop marbled appearance, we say that the person has been dead at least for 36 hours. Automatically fixation of post-mortem staining, which is the fourth choice, only one option is left, which is the correct option also. Fixation of post-mortem staining is seen in 6 to 12 hours. Okay. So we have one which is pairing with H, right? 2 which is pairing with G, 3 which is pairing with F, and 4 which is pairing with E. So 1H, 2G, 3F, 4E. That's the correct matching, right? Right. With that, we come to the end of this discussion. I'll see you in discussion of CBoT 2. Keep lined up, keep on giving your examination, keep on preparing to the best of your ability. Bye.
Hello students, I hope you had a good exam. So let us discuss the questions which were asked from anesthesia. The first question which was asked, an elective cholecystectomy is being performed on a 52-year-old patient who has a history of smoking and asthma with mild airway obstruction. All can be used for intraoperative monitoring except. Options are electrocardiography, invasive blood pressure monitoring, pulse oximetry and capnography. Now, electrocardiography, this is a mandatory monitor. So, irrespective of any comorbidity or any type of surgery, we have to attach electrocardiography. Then, pulse oximetry, this is again a mandatory monitor. So, it's again a mandatory monitor. Now, capnography is again a mandatory monitor. So, 3 in this question, the option is mandatory monitor. So these 3 though we have to attach. Now invasive blood pressure monitoring is not indicated in this surgery. For invasive blood pressure monitoring, you need to have a patient who is hemodynamically unstable on inotropes and all, and you need such kind of surgery in which we are expecting a huge blood loss. So this is a lap elective cholecystectomy in which we are not expecting a huge blood loss, nor this patient is having any hemodynamic imbalance. It's an elective planned surgery. So there is no question of putting invasive blood pressure monitoring in this patient. So answer is invasive blood pressure monitoring. Got my point? Okay. So this was our first question. Second question.
A 42 years old man collapses at neighborhood gathering. A BLS trained bystander started CPR after calling emergency medical service. An automated external defibrillator was attached and bag mask ventilation was started with CNE technique, right? So ambulance came, they had a bag valve mask and they started CPR and they started bag valve mask. So in this question, which is for a cardiac arrest patient, the question is on bag valve mask, not on compression, etc. So bag valve mask was started with CNE technique. The CNE technique is technique how to give a good hold and produce a good seal for bag valve mask ventilation, right? Which is false statement for bag valve mask ventilation, bag and mask ventilation. Option 1. C is formed by thumb and index finger around the body of mask. What is CNE technique? CNE technique is a technique by which we create a very good mask seal for positive pressure ventilation. Thumb and the index finger is on the body of the mask, so I am making a C. And my lower other 3 fingers are on the bony prominence of the jaw. So C and E and C, this is C and these 3 fingers are forming E. And with thumb and the index finger, I am trying to create a seal, and with lower 3 fingers, I am lifting the jaw again to make a good seal. So what are the options? C is formed by thumb and index finger around the body of mask. Correct. 3rd, 4th and 5th fingers apply to lift the jaw to maintain seal. Correct. The 5th finger should be placed on soft tissue. Never, no finger has to be placed on soft tissue. The fingers has to be placed on the bone, not on soft tissue. If I put on soft tissue, it will create obstruction. So this is the false one. D, the thumb and index fingers are responsible for maintaining tight seal. Yes, with thumb and index finger, we press the mask and try to create a tight seal. So in my video on bag and mask ventilation, I have shown the technique in a very detail. Okay, so this was our second question. The answer is C. Coming on the third question, the doctor wants muscle relaxant that acts fast and recovers quickly after minor procedure to prevent persistent muscle paralysis. Which muscle relaxant is of shortest duration? So this question they have asked muscle relaxant of shortest duration. Okay, so if I see this in the options in this, then mevacurium is the shortest acting neuromuscular blocker. Mevacurium, the duration is 18 to 20 minutes. This is the shortest duration. Okay. Atracurium is, let's say we have neuromuscular block according to duration of action, short duration, intermediate duration and long duration. Atracurium is intermediate duration, that is for 35 to 45 minutes. Rapacuronium is of short duration, but not shortest. Shortest is mevacurium. Mevacurium has shortest duration. Okay. Raucuronium, again intermediate duration. Okay. So if very quickly I tell you about duration of action, so neuromuscular blocker is divided into aminosteroid and benzyl isoquinoline. In aminosteroid, pancuronium and pipicuronium is long duration. In benzyl isoquinoline, tiotipo-curare and doxycuronium is of long duration. In aminosteroid, vecuronium and raucuronium intermediate, and in benzyl isoquinoline, atra and cis-atracurium is intermediate. And in aminosteroid, rapacuronium is of short duration and benzyl isoquinoline, meva is of shortest duration. Among all, the shortest duration action is of mevacurium. Okay, so remember mevacurium has shortest duration of action. Okay, this was our third question. Now coming on the next question on central neuraxial blockade, a very commonly asked topic of exam. A woman who is 38 weeks pregnant had mild asthma, seeks advice for doctor how to manage the labor pain. She wants a labor analgesia. The doctor advised epidural anesthetic for her condition. Which of the following would you inject? So they're asking exactly by showing this image, where would be the epidural injection given? We normally put a catheter for labor analgesia. Okay, so this is a scenario in which where you would put the epidural injection. So if you see the image, now what are the structures we pierce to reach the epidural space? We pierce skin, then we pierce subcutaneous fossa, then we pierce supraorbital spinous ligament, that is the ligament above on the spine. Then we pierce interspinous ligament, interspinous, the ligament between the spine, and then we pierce ligamentum flavum, ligamentum flavum, and then we reach the epidural space. So last layer to get pierced is ligamentum flavum, right, to reach the epidural space. So this is the spinous process. On it would be the supraspinous ligament, in between would be interspinous ligament. So I pierce skin, subcutaneous fossa, then supraspinous, then interspinous, and then I pierce the ligamentum flavum and I reach this space. This is my epidural space. Okay, so D would be the answer, right? In which area I would inject my local anesthetic? D would be the answer, right? So I would inject my local anesthetic outside dura mater in epidural space. Okay, I would pierce more inside. I would pierce the dura mater, then arachnoid mater, and then I would reach subarachnoid space. Okay, okay. Next question. A 27-year-old female has a history of severe PONV, post-operative nausea and vomiting after surgeries. The anesthesiologist wanted to modify her anesthesia to reduce the risk of PONV. So all the drugs which precipitate PONV we would avoid in this patient. She is now scheduled for laparoscopic cholecystectomy. The laparoscopic procedure again more prone for PONV. Which of the following drugs should be avoided? So methylprednisolone, steroids, they have antiemetic effect. Propofol, the only anesthetic agent which is antiemetic. Nitrous oxide, it is proemetic, precipitates nausea, vomiting. Droperidol, antiemetic. So nitrous oxide would be the answer. Okay, so methylprednisolone is antiemetic effect, has antiemetic effect. Propofol, only IV anesthetic with antiemetic effect. Okay. Nitrous oxide, precipitate nausea, vomiting. Droperidol, antiemetic effect. So answer is nitrous oxide. Okay. So these were the 5 questions which were asked, right? I hope you had a good exam and you had a good score in this exam. Thank you.